We will start now. First of all, I would like to welcome all our dear speakers today, more than 35 speakers from 8 countries. Our dear attendees, thank you so much for joining us in this second part of the International Trauma Webinar. Today is the International Day. We will start with a recorded workshop from Professor Gamal Hosni, the ex-president of the Egyptian Orthopaedic Association and the ex-president of the Assami International. Then we will have a speaker, Professor Sofiane Al-Khalal from Tunisia, and then the Indian session, more than 20 speakers from all over India, eminent stars from India for 5.5 hours. Then we have the UK session starting with a live workshop on the proximal femoral fractures using the short and long gamma nail, and then the Indian the UK session, and then the session from Poland, Germany, and Ireland, and we will finish with a Canadian session live webinar from McMaster University. Professor Waleed Kishta will make a live workshop on the very important subject, which is osteotomies around the head. I hope you a very fruitful scientific session, all my dear colleagues. Now we will start with the first presentation. It will be a workshop, recorded workshop from Professor Gamal Hosni about the external fixation of proximal femoral fracture. Dr. Michael, please.
Dr. Mina.
Dr. Mina, please, can you start the sharing the workshop? Yes, Dr. Hassam El-Exir has started sharing the external fixation workshop. Please go ahead. The voice, Dr. Hassam, can you raise the voice?
The voice is better now?
Can you raise it? Start from the beginning and raise the voice. No voice.
Talk about the frames, which is quite.
Please raise the voice to the maximum.
This is the maximum now. This is the maximum, Dr. Mohamed.
Okay, start it, please.
Dear colleagues, today we are going to discuss the external fixation of the proximal femur, the tips and tricks. Why external fixation is not popular in fractures? Because of the stability. We always talk about the frames, which are quite unstable. Also, when we see the cases, you can have reduction, unstable reduction. Also, they always talk about standard external fixation. There is no standard external fixation. So I think the companies and some people, they design a frame And they won't fix all the fractures with this frame. And this is not applicable. And I will show you how to fix the proximal fractures. And we put the frame last, not first. So our technique is not frame first technique, because the problem comes if you apply What are the indications of external fixation proximal femur? We can use it in proximal fractures, in open fractures, osteoporotic fractures, firearm injuries, infected fractures, infected non-union, and these are examples. You can use it not only as a temporary fixator, but you can use it as a definitive fixator. Like this case of trochanteric and subtrochanteric fracture, explain them during the workshop by putting the wires, doing pulling or moving the fragments like this case. And this is an example of the closed reduction technique of this method using serrated wires, half pins in different directions. Infected fractures. If you have failure of internal fixation, like this case, you have failure of DCS, you can apply external fixator in the direction of the neck. Infected non-union, same. The methods of fixation of the proximal femur. Wire or half pin application first. We put wires or half pins first. The methods of fixation, number one, serrated wires, chance pins, cannulated chance pins, Elashhab wires, joint bridging. And these are the example of the serrated wires. We push the serrated wires in the direction of the neck till they hold the subchondral bone. Multiple wires, 2, 3, or 4 millimeters. And here also the same method, 2 chance screws. You can use chance pins in this one in the direction of DCS. And this is a cannulated chance pin. You can put a wire in the direction of the head and neck, and then you put cannulated wire. And also you can have Elashhab wires from the front to posterior, severe osteoporosis. You can palpate the anterior supiliac spine, and remember that the vessels lies 2 centimeters medial to the anterior supiliac spines. So you go lateral and put your wires from anterior to posterior and take care of the sciatic nerve also in severe osteoporosis. Bridging fixator, you can do crossover like this. Also, we can use the closed you can do closed reduction techniques. And this is an example, trochanteric fracture over the proximal half pin, 1 week after removal of the dislocated infected total knee prosthesis, and debridement and temporary external fixator, but the patient had this trochanteric, subtrochanteric fractures. And severe osteoporosis and infection, and the patient is very fat. So remember that you can have the cantilever effect if you apply only half pins. So we have to use the subchondral bone for fixation. So we use the multiple threaded wires technique. And this is how to apply them under image intensifier. And this is the half pin. As you see here, we use multiple threaded wires in the direction of the neck and traction to close the gap. Then more wires and half pins in different directions to increase the stability, like this patient. And this is the picture after application of the frame. So we don't talk about the frame. We talk about the method of close reduction. We talk about the methods of fixation. And this is with follow-up. As you see, the follow-up, complete union of the trochanteric fracture. So, in conclusion, our technique is called frame loss technique. That means we apply the half pins, the wires, and finally we put the frame in the direction we want. And the closed reduction of fracture. It's a very important principle. If we talk about application of external fixation of the proximal femur, the proximal femoral fractures in the saw bones. Thank you. Good afternoon, dear colleagues. Today I'm going to discuss how to speak about the frame and how to have a fixed frame for each case. And this is the real problem. Because if you have a fixed frame, it's very difficult to fix the proximal femur. Today I'm going to discuss how to fix it in the opposite way. That means frame loss. We apply the frame as the last step of the operation because the frame is not that important. What's more important, how to fix the proximal femur, whether you have fracture femur, trochanteric fracture, subtrochanteric fracture, or you have non-union, 5 methods. It's not one method like they discussed to you, that you have to have 2 half pins above and 2 half pins below in a fixed fixate or something like this. This is not true. This is not practical. I'm going to tell you the tips and tricks of the fixation of the proximal femur using 5 methods. The first method is the serrated wire method. You can use serrated wire, 2, 3, or 4 millimeters wire. We have serrations for about 1 centimeter near the tip of the wire. And this is the first method. And usually when you put the wires, we put them in the direction of the neck. You see, this is the direction of the neck. We can put 2, 3, 4, 5, 6 wires. And you can put them in the fracture neck femur and induce the reduction. The same you can do it for trochanteric fracture. The second method is using the half pins, like this one, solid half pins. And the solid half pins, you can use them in the direction of the head and neck again, like you put the lateral position, and then you apply the half pin in the same direction. The fourth method, you can use half pin in this vertical from the trochanter that way, like DCS. And you can use any combination together. So you can use serrated wires, half pin that direction, another pin this direction, and so on. The fifth method, sometimes you cannot have enough fixation in the proximal femur. You apply supraacetabular half pins. So we have 5 methods of fixation of the proximal femur. Then you apply the frame. You can apply Elashhab frame, you can apply any type of frames after you do the reduction. Which type of tables you use? You use a translucent table, but you don't need to have a traction table. You can use a traction table, but usually I don't need a traction table to thin one. And you put it here in the subtrochanteric area. And you take the direction of the neck. This is the direction of it. Put another one. Remember, just to counter or you can use image ability, so you need more and more stability.
Dr. Mina, please, I think there is a problem in connection. Can you stop and Dr. Hussam will share it from his side? Dr. Hussam, would you please share from your side?
لا مش حس.
Dr. Hussam?
Yes, Dr. Mohammed.
Please share from your side.
Okay, sir.
Chair with sound, Dr. Hussein. Chair with sound. When you press the chair, you will find chair sound.
There is no sound, Dr. Hussein.
Is it clear, sir?
لا ما فيش sound.
No sound.
Okay. Can you raise the sound, please?
So first one.
Start from the beginning of the workshop, not from the slides. From the beginning of the workshop. ارجع سنة بسيطة ورا from the beginning of the workshop. Dr. Hussain, can you start?
From here, Dr. Mohammed?
Yes, that's good.
Is the sound good now?
Yes. No, it's not good. The voice is not good.
The voice?
The first step is the first step using the serrated wires like this one. This is the thin one. Here, and some mechanical area.
الصوت مش باين يا حسام.
مش باين. تمام. خد ثانية.
The voice is not clear.
I'm trying.
No. So voice is not clear. Stop, Dr. Hussain. Stop.
Okay.
Dr. Mina, can you try sharing from your side, please, again?
Urdu.
Yes, please. Raise the voice, please.
And you take the direction of the neck. You see, this is the direction of it. Put another one. This is one of them. When do you stop? I usually stop at the subchondral bone. Remember, some patients with trochanteric fractures or neck fracture, neck femur, they have very osteoporotic bone. So you have to go till you catch with the serrations like this one. You see, this is the second one. You take the anteversion. You can use image intensifier. This is the second one. Third one. This is 2 millimeters wires. We use the third one, and you use the third. You need stability, so you need more and more stability. Again, this is, you see the third one. We can go below this, and you change the direction, and this is. So this is the third one. Now we are going to use 4 millimeters wire with the serrations like this one, and we go from, again, yes. So we have 1, 2, 3, 4 points of fixation. This can be enough. In many cases, if you have a neck femur, if you have, put a wire here. So this is the first method. The first method is to apply serrated wire technique, where the serrations stop in the subchondral bone. Now you can pull to induce compression. The second method is to use the half pins, the 6 millimeter half pin. How to use the half pins? Again, under image intensifier, you can put wire, and with the 6 millimeters half pin, you can put the half pin in the direction of the head and neck. Again, yes, this is the first one. And we can use a second one. So you can have 2 half pins in the direction of the neck. You can have more if you want to. The neck is wide, you can have more. So this is the second one. So the second method is to apply 2 Shan's screws. The third method, you can put one of these wires like DHS, then you introduce the cannulated half pin. The fourth method, we are going to use the Shan's screws or the half pins in the direction of the DCS. Like this. So it's about 90 degrees. Yes. Why we use it that way? Because sometimes you need to have more proximal fixation, because there is a problem with this area, because the patient has, you have removed external fixator before, so the patient has many holes here. So this area is very difficult, and perhaps you are going to have subtrochanteric fracture. So you need to have very proximal fixation. So you can apply it in that direction. How to apply the half pin in that direction? First, you introduce a wire in front of the bone, as you feel it, just in front of the bone, under the image intensifier. And now it's in front of the bone. We leave it just like this. This is in front of the bone. Give me now with the drill bit. We go the same direction like the drill bit in the middle of the trochanter, like this one. We'll go through the middle of the trochanter, and we go with the drill bit in the same direction. And this way, you can change the angle of anteversion. We knew the angle of anteversion from this wire, the superficial wire, so it's about 15 degrees. Yes, so you can move it up and down to correct the anteversion. Then you go with the drill bit. You see, you went through the bone. Then we remove it. Then manually, you introduce your Shan's screw. Take care that sometimes it's a very soft bone. So it's better to avoid too much heat. So we go manually, bit by bit. You see, it's okay. See the whole length. Till we finish the serrations. Yes, we finished the serrations. Take care, you need long serrations. That means you need 6 centimeters, 6.5 centimeters, 7 centimeters. So you have a big length. It's longer than normal. So you need to have half pins with longer serrations. It's not just 3 or 4 or 5. If you manage to fix this in that direction, 90 degrees direction, or the direction of the neck, you can use both. In some cases, we used both of them. In some cases, we can use wires and this half pin and chin. And I will show you on the slides. You can make any mixture. As I've told you, you can have very good fixation of the proximal femur. Because the people, they always complain that it's very difficult to fix by external fixation the proximal femur, and they warn you from fixing the proximal femur if you have osteoporosis. This is not true. For every problem, you need a solution. Now this is the fourth. I've told you the 4 methods of fixation: using the serrated wires till you reach the subchondral bone, using half pins in the direction of the neck, using cannulated half pins, using half pins in the direction of DCS, like this one, any combination. The 5th method, if you have rare problem of the proximal femur, you can add supraacetabular fixation. And I will show you how to fix the supraacetabular area. The supraacetabular area is very important. It's good, it's hard, it's easy to apply, and you just have an image, and you can put your half pins in this direction. So you can augment the fixation of the proximal femur by adding supraacetabular half pins. And I will show you an example how to use the supraacetabular half pins. This is the acetabulum. This is the acetabulum. Give me a wire. Feed if you are. Again, the patient is lying down, supine position, and you see this is the supraacetabular area. And under image intensifier, you just push your wire to give you an idea about the direction of the supraacetabular area. And after you put your wires, you can use the half pins. Give me the half pins, the Shan's screws. And you can, in the same direction, put, you see, you stop before, just at the second cortex. You see here, this is the second cortex removed. You can put 2 or 3 half pins, and this is very good fixation also if you have a fractured acetabulum or a fractured pelvis. And you can put another wire, you see here. Again, yes, okay, that's enough. So this is the 5th method of fixation. So we have 5 methods of fixation. This is the real operation, not the fixator. The problem comes, the people talk about the fixator, and have to, it's not a standard fixator. After you finish application of the wires and half pin, you design the fixator according to this shape. according to this shape. Coming to the distal femur, you can use 2 half pins, show me just 3 half pins or whatever, vertical to the bone. Yes. Another half pin. So this is the distal femur and this is the proximal femur. So you can use 2 half pins in 2 different directions and so on. For each chance screw, you have to do the drill bit first. Show me the drill bit. And then when you use it, you can apply manually. This is the real operation. At last, we apply the fixator. Show me that. So we have arches, something like arches. You can use small arches, big arches, like this one. Like you see, this arch can be applied to this half pin. And you can apply at the Ranco cube. You can, a bigger one, just, you can use Ranco cubes if you want, put more. But if you have this direction, what to do? Then you post mail, 3 holes or 4 holes, yes. You can use this post mail or قابض على الهاف pins. Post mail and the half pin fixation bolt, you can put it in any direction you want. So you can rotate it. The half pin fixation bolt, you can rotate it to fix it that direction. So you can change the direction anytime you want. This is for the proximal femur. For the distal femur, you can use another arch in the proximal femur, you see, and you can fix them together. Give me another arch. See. So if it is, you can put it that direction and this in that direction and put the links in between. Or in this direction and that direction, put it in between. You can put another arch in the proximal femur. So in conclusion, you can treat fracture neck femur, trochanteric fracture, subtrochanteric fracture, cases of malunion of the proximal femur, non-union of the proximal femur, infected non-union of the proximal femur. You can apply external fixator and you can use the closed reduction techniques using the external fixator. You don't have to do any open reduction, it's all closed. You start the operation with the fixation of the fragments with 5 methods, serrated wire technique, half pins in the direction of the neck, cannulated half pins in the direction of the neck, half pins or Schanze screws in the direction of the DCS, or you can apply also supraacetabular fixation. Proximally, it's easy and there's no problem. After you finish, you apply the frame, any frame you want. I'm not going to talk about circular fixator or unilateral fixator or Elazarov or ortho, whatever you want, any type of fixator you want.
Thank you so much, Professor Gamal. And I apologize for some technical problems in the start of the video of the workshop of Professor Gamal Hosni. So at the end of the webinar, we will repeat the workshop of Professor Gamal Hosni again at 12 a.m. after the finish of the webinar of Professor Waleed Kishta from Canada. Now, our next speaker will be my dear professor, Professor Sufyan Al-Qallal from Tunis. Professor Sufyan is the head of AO chapter in Tunis, in Tunisia, and the SICOT delegate in Tunisia. Professor Sufyan will speak about limits of anterior approach of the head. Professor Sufyan, you are very welcome, sir.
Thank you very much. Thank you very much. I'm very happy to share this experience with you. It's usually a great pleasure for me to meet friends from, particularly from Egypt, from all over the world with this webinar. Then I will share my screen. Second. You are okay now?
Not yet, sir. It's not shared.
It's shared.
No, it's not shared, sir.
Dark.
Yes. Full screen, please, sir.
Just a second, yes.
Thank you so much.
Is it okay
Yes,
now?
Yes, sir. Thank you.
Okay, perfect. It's a great pleasure for me to talk with this webinar with about the hip surgery, and I will explain the limits of the anterior approach of the hip, since it is, I say, if I can say, it is a little bit fashion that we are talking today about the anterior approach of the hip. And the limits, like fears, are often an illusion. Why? Because there are a lot of misconceptions. Some of surgeons will say it's a little bit more difficult, you have less exposure. It's a little bit more difficult, yes, in the beginning of your curve, but you don't have less exposure. It's more difficult to expose the femur, but not the acetabulum. Yes, it's a minimally invasive.
Right. A very good morning, good afternoon, and good evening, ladies and gents. I'm Vikas Kanduja, consultant orthopedic surgeon in Cambridge, UK, and also one of the founders of SICOT Pioneer and the president-elect of SICOT. And it's indeed a pleasure to welcome all of you logging in from various corners of the world into the webinar. Now, in this COVID world of non-contact domains, we've certainly embraced digital competitiveness at SICOT with the launch of SICOT Pioneer. Through this platform, we've done over 74 events, and I've had over 100,000 views from 110 countries around the world. So big thank you for joining us and following us as well. Now, today's webinar is the first webinar from the Computers and Enabling Technologies Committee, and I'm ever so grateful to Karthik Bhagishetty from Imperial, London, who's the chair of the committee, and also Suresh Sivanathan, our treasurer from Malaysia, the vice chair of the committee, along with the stellar faculty from all around the globe who've given up their precious time for this webinar. And I'll let Karthik and Siva introduce them to you in a minute.
Definitely, yes.
We'll try and make this as interactive as possible, so please do post in your questions. And if you can't join us today, then you'll have access to this webinar on our on-demand platform. Once again, a big thank you to all of you, and hope you enjoyed the webinar. Over to you, Karthik and Suresh.
Thank you, Vikas. Our first speaker is my dear friend and colleague, Benedict Braun, who is an orthopedic surgeon at the University of Tübingen, and he is also the chair of the Smart Digital Solutions Task Force from the AO. He has done a lot of work on fracture monitoring. And without
the second limits of
I'd like
other
to
misconception
ask Dr. Brown to start his talk. Thank you very much.
It's easy only
so thank you, Suresh, for the kind introduction, and thanks for having me to share our first surgical experience with the AO fracture monitor.
And how to manage
these are just my disclosures. Keep in mind, I am an AO person. I do chair the task force at the AO Foundation, and I am the PCI for the fracture monitor going to market study. What do I want to talk to you today about it? So first of all, what is the fracture monitor? Then I'll give you a brief clinical background on the system, and then I will share what I was invited to share, the clinical experience that we had putting in the first two systems.
You need a very good bone stock.
The AO fracture monitor is basically, on a very top level, is a strain gauge with a battery and a Bluetooth sensor housed in a little metal housing that can be screwed on to various plates. Currently, only femoral plates and large frac plates by DPS and the 41 medical biphasic plate. And this sensor can record the
I think in such case, for example, if you wanted to revise the right hip, which is the prosthesis, it is not difficult to go for the anterior approach. You just have to understand how to put your cup, and I will show you later on how to expose your acetabulum. In the left side, you need a CT scan. You cannot go for a dysarthrodesis of the hip without a CT scan, and you have to plan your surgery. If you want an anterior approach, you can plan it, but you need a CT scan for the approach and how you will put your cuts, and mainly on the femoral neck. Then with CT scan, you can solve your problem. Then you need observation of the course of practice, definitely. Then this approach has assets. You need a supine position. It's very easy for CR. It's much more easy to control your hip pair up by the C-arm with the anterior approach, since the patient is on supine position. It's an easy exposition of the femoral neck without moving the lower limb. You don't need to do external rotation, internal rotation like posterior approach to internal rotation. And you have a very good exposition and control of acetabulum. It's a really real approach for the acetabulum. You see the acetabulum in front of you. And this approach, it is not mainly invasive. In some cases, it could be extensile, and you can broaden the spectrum of your indication of the anterior approach. Then you need more rational views of the problem and rediscuss the limit of anterior approach about patient morphology, hip architecture, and what about revision cases. These are the main issue that you have to manage them when you are planning an anterior approach of the hip. This is the position. The patient shape, definitely when he is not very obese, it is on supine position, but the problem is if you have BMI more than 35 and muscular and stocky patients, but in this position, you see, it is very easy to get in the hip. This is an obese patient for anterior approach. Usually when you have a very obese patient, they are obese by their belly. But in the anterior part of the hip, the exposition is not difficult, and don't have a lot of fat. You see here, you don't have a lot of fat. It's almost normal. Believe me, there is less fat than the posterior approach. If you are going for posterior approach for this patient, maybe you will have between 10 and 15 centimeters of fat. But in the anterior approach, on the anterior part of the hip, usually you don't have very high thickness of the skin with the fat. Then the thigh is very large. Changing position of the limb is very difficult. And the problem is the abdominal apron, and you can track on this apron by the adhesive band. Then even for very obese patients, the anterior approach is not contraindicated, and it could be managed. And you have to examine your patient, and you see the quantity of fat that you have on the anterior part and how you will manage the anterior approach of the hip. Then you see here, for example, this is an obese patient, difficult non-specific and difficult positioning on the lateral patient for this case, for example. Mainly, you can go for Ardeng, for example. You told me that Ardeng in the lateral approach is a little bit easier, but you see the thickness of the fat in the posterior approach. If you are going by posterior approach, you have a lot of fat, then the hip will be very deep, but the anterior approach in that case could be easier. And the localization of fat is much more posterior than in anterior. And usually they are not stocky. The obese patients are not stocky. Then you don't have a very high thickness of the muscles, and they are not very strong. They are not retracted. Then you can go for these patients in an anterior approach and have an approach which is a little bit more extensile than the regular one. What the literature say about the obesity of patients. In the largest available series, there was no difference in deep infection rate between the two approaches, between posterior approach. And the results suggest that the anterior approach may be a credible option with excellent functional and radiographic outcome in obese patients. And obese patients may have significantly high reoperation rate, mostly due to wound, which is more frequent in the posterior approach than in anterior approach. Then for the obese patients, you don't have more risk in the anterior approach. Second point is the stocky patients, men mainly, muscle, stocky. You have definitely a little bit a difficult exposure, but how to solve it? You solve it by general anesthesia and neuromuscular blocking agent. What about the table? I have done only one, which is really very like this one, which is a stocky, but we didn't need a table. We don't need a special table for the anterior approach. And for this patient, he want a surgery of anterior approach, which is very stocky guy. And they have the same problem with this type of obesity, but I think it is very important. You see here, for example, there is a lot of fat in that part. And then you don't have a lot of problems to approach the hip by the anterior one than the posterior when you have the quantity of fat is more important. And then the risk of infection is higher. Then you can approach this patient. Then when you go for, once you have chosen to go for the anterior approach, then I said, patient morphology, then now we will see the hip architecture. What about the hip architecture in the anterior approach of the hip? And the problem when you have destructive arthropathy of the hip, then you have protrusion of the femoral head, and it is a little bit more difficult to retract. But I don't think there is more difficulty to retract it than the lateral approach. In the posterior approach, definitely it is much more easier for these cases, but the anterior approach, it is not very difficult. And this is the bilateral destruction of the femoral head. You have legless exuberancy. There is no contraindication in this case for anterior approach. Then, but the only pitfall is to decrease the femoral, decrease the offset. You need a good femoral release in the proximal part to restore the offset of the hip, but you can approach it by the anterior approach, and it is very important to release this part. It is very, very important. The part which is important when you go for anterior approach to release, it's up to the cut. You have the cut here, and to release all these parts, and you will feel how the femur will go up when you go with your retractor. What are the other advantages of the anterior approach? You can go for simultaneously anterior total hip arthroplasty by for the two hips by the anterior approach. It is the anterior approach is the optimal approach to have an optimal management of leg length discrepancy, because you have the two legs in front of you, and you can manage better the leg. It is the best way to manage the leg length discrepancy by an anterior approach, and you can do the bilateral total hip arthroplasty in the same surgery. Another case of protrusive arthropathy, you can go, as you said, for anterior approach. It is very important to release the anterior superior part of the hip. You will do the osteotomy on site. You can in situ osteotomy of the femoral neck, or for the other people will go for transtrochanteric approach, but I think it is not really necessary. You can do your cut here, release the supra part of the great trochanter to retract the femur posteriorly, and then you will expose your acetabulum. And this is the case. We go from the anterior approach. This is a supine position. You have here the femur. You have here the femur. You have the anterior part of the acetabulum. This is what you see about the femoral neck. We will cut only this part, and you see the exposure that we had later on. When you have the exposure of the acetabulum here, you have very, very good exposure of the acetabulum. We put the head on site, and we rimmed over the head. We didn't extract the head because there was almost an arthrodesis of the femoral head. Then we retracted the femur, which is posterior here, and under C-arm, we ream the femur. Without the inferior part of the acetabulum, you have the reamer here, and here you have a acetabulum, and they have the previous head, which is here, and this is the result of the arthroplasty. You see here it is almost healed. You have the bone which is complete here, then you had a cemented cup with uncemented stem. Other difficult cases, which are some of the limits of the anterior approach, is the hip dysplasia and dislocation, mainly in Crow 3 and Crow 4. It is not really a contraindication, but you have to do an anterior extensile anterior approach, which goes tease the anterior part of the iliac crest, and it will be a little bit more extensile until here. And you will release all the superior part of the femur to cut the femoral, to cut the neck here, take out the femoral head, and you go down progressively till you have the exposure of your acetabulum. And this is what they say in the literature. DDA yield good short-term outcomes for total hip arthroplasty with subtrochanteric shortening osteotomy for Crow 4 dysplasia, and the anterior approach is delayed for 2 implants. For all these cases, they have an osteotomy here, but it is not really a contraindication for the anterior approach. This is the case that I have shown you previously. This is the templating of the hip. We planned where to do our acetabulum. And this is the exposure of the hip. This is the neo-acetabulum here. We go under C-arm. It is very easy. It is the best way to control in such cases because the patient is in supine position and the control of the acetabulum is very good. You see exactly in front of you the acetabulum, like here, and then you ream under C-arm, and definitely you will put your cup in a good position under the control of the C-arm. You have femur here, and you have the result here. Then we grafted the femoral head in the superior part as a buttressing for the cup, and you have a good positioning of the cup in Crow 4 case. This is the second case, the second hip. You see here, this is the exposure. This is the release of the proximal femur here. The acetabulum is here. You see it just in front of you. This is the graft, which is here. Then this is the result, femoral, the cup, and the dysplastic hip. What about revisions? This is a case of revision as explained before, but he had even the other hip with the anterior approach. You have a CT as we planned, but you see here we have to revise the cup, but in the other part you have a good trochanter here. And then you can do your cut, which is over here by the anterior approach. Then you have just to expose the greater trochanter, and this fossa is very, very important. This is your landmark. And then you go for your femoral head, you cut here, and then you will put your acetabulum, your cup in the other way. This here is to show the extension, and I will show you, this is the positioning of the patient and the left part of the arthrodesis. And this is the landmark under C-arm. This is the reaming of the head. This is the stem. This is the hip. And this is the result of the total hip arthroplasty by anterior approach after the arthrodesis of the hip. Another case which is a little bit difficult too, because he had a gunshot on the hip. The problem here is that you have a lot of fibrosis in this part, but you have to release until this part. As I said, your landmark, the main landmark is here. And then to release all this part down, and then you expose your acetabulum. You see the head here, which is not healed. And this is the previous approach with the leg length discrepancy. This is the exposure. You have your acetabulum here. We are controlling this retractor, which is here, and the anterior, this retractor is this one. And you have the limits, then you see the center of the acetabulum is here. Then you have to ream under C-arm. You see very nice acetabulum here, and this is the result of total hip arthroplasty. Then about revision, easy extraction of the implant. The CR may help you. This is the other case. This is the previous approach of the hip because she has a dysplasia of the hip, which is in childhood. This is the hip, the previous hip. This is the revision. We remove the cup. We put a Kerbal cross. Then we in such case, we come back. In such case, when you have cement in the distal part, and mainly in young people now, you can remove only the proximal cement and do a short stem. Then this is a video that can show you the extraction, and this is you see here. Then we grafted the acetabulum, and then we put shorter stem. This is another case. You have the acetabulum, the piece which is an acetabulum. This is the extensile anterior approach. You can go to the iliac crest and you go this way. And you go down here with the serratus. And this is, I will show you the video. And then this is the positioning of the cross. And this is the result. Then this is when we put, this is the revision. You see the cup, very, very nice exposure of the hip. And this is the result of the x-rays. Another case with a previous posterior approach of the hip, and with plates which are posterior, fracture of the acetabulum. And the main contraindication for the anterior approach are these cases when you have very big loss even on the acetabulum, and mainly for the femur, because it's difficult to go very distally in the femur when you are doing a revision. And if you have to approach till this part, it is much more easier to go lateral or posterior. These are the limits. Then to go for the learning curve is a little bit long. As I said, the key is how to do your release in proximal part in the acetabulum. I have shown you that there is no really contraindication for all cases, even for the revision. The thing is just you have to manage which patient, which approach, and which type of procedures. Then you have to the selection, and to how to climb this tree is very important. It depends on the shape that you have. Thank you very much.
Thank you so much, my dear Professor Sofiane El-Khalal from Tunisia, for this very, very interesting presentation, sir. If we have any questions to Professor Sofiane, I may ask you please to answer it by writing, sir, because we have to start the Indian session. Now our next session will be the Indian session, the eminent Indian session, with more than 20 speakers from India, more than 20 eminent speakers in the hip surgery from India.
Vikas will be the next.
Yeah. First of all, I would like to thank my dear friend, Dr. Srinivas Kampamti, for arranging with me this session. Many thanks to you, Dr. Srinivas. Our first speaker will be our eminent speaker, Professor Vikas Khanduja from India, the president of the SICOT International. It's a great honor to be with us, sir, and thank you for being with us, sir. Thank you so much.
All the best for Vikas.
Thank you, sir. Professor Sofiane, would you please stay with us to welcome Professor Vikas?
Yes.
Thank you so much, sir.
Thank you very much indeed for the kind invitation, both Srini, Sofiane. It's lovely to see you here, Sofiane, and Professor.
Thank you very much. Vikas is very famous. He is president-elect of the SICOT. He is in the Hip Society, International Hip Society, and very active in the hip surgery and mainly in preserving hip surgery, and now he will talk then for the femoroacetabular impingement, and he's really mastering in this subject. Thank you. Thanks, Fikas, to be with us.
Thank you very much indeed for the kind invitation. And once again, thanks, Srinivas, for allowing me to actually present this. So for the next 15 to 18 minutes, I want to take you through all you wanted to ever know about femoroacetabular impingement. Bring you greetings from our biomedical campus in Cambridge. And it's a special year for us because we are celebrating the 35th anniversary of the first hip arthroscopy that was done in this institution by my mentor, Ricky Villa. So we're delighted to host you if you ever wanted to visit. And these are my disclosures. None of them are particularly relevant to this talk. So what I want to cover is what exactly is femoroacetabular impingement? How does it present? How is it managed in 2024? And what are the advances and direction for future research in this area? Now, this paper basically changed the way we think about the hip. And for every hip preservation surgeon, this is basically the start of their career. This is Gans and his colleagues from Switzerland talking about femoroacetabular impingement as a cause of early osteoarthritis of the hip. So whatever we saw in our textbooks as the classical pistol grip deformity was not actually a pistol grip deformity, but a morphological abnormality called femoroacetabular impingement, potentially leading to arthritis. If we go back into the history, then the first descriptions of morphological abnormalities come from 3000 BC. And it's only in 1999 when actually Gans described femoroacetabular impingement that you've actually got more than 4,000 papers being published on this area. And the growth of hip arthroscopy secondarily has been immense, of over 727% in the last decade, and projected to be over 1,400% by 2023. That is in the UK. Now, what exactly is FAI? FAI is essentially, in simple terms, a painful contact between the femoral neck and the acetabular rim, which occurs within the physiologic range of motion of the normal hip. And that's as simple as that. And the problem could be on the acetabular side, where you have a protrusio or a retroverted acetabulum, or it could be an anterior overgrowth, and that's called the pincer. It could be on the femoral side, where you've got a proximal femoral deformity or an abnormal anatomy, and that's called the cam. Or it could be because of overuse of a normal hip, for example, in a gymnast or an athlete. So here you have a perfectly normal or a spherical femoral head there. You can see on the AP and the cross table lateral. But if you look at this image, on the AP, you may miss it, but you need a good cross table lateral to see the excess bit of bone there, causing the cam type of impingement. Now, you may wonder what this little bit of bone or that excess bit of bone can do, but here you are. You've got that excess bit of bone, which then abuts against the labrochondral junction there. And over a period of time, you will see that that labrum gets torn and the articular cartilage starts peeling off in front of the hip joint, leading to arthritic changes in the hip. So that's what a cam type of impingement will do for you. And you can see this in the open surgical dislocations of the hip. Here you've got an increased offset, the cam, and here you can see the resultant effect on the articular cartilage and the labrum, where it's completely peeling off. We've done some work into who develops the cam, and it's essentially, majority of them are male athletes, which will display the cam morphology, and it develops between the ages of 11 to 14, especially if these youngsters are loading their hips heavily, playing rugby or football. So that's the genesis of the cam. Now, the pincer abnormality, on the other hand, the best way to think about it is the pincer grip of the crab. And what's happening here is, you will see in this video, you've got a retroverted acetabulum or an anterior overgrowth. And when the patient would flex the hip up, it would actually, the head neck junction would hit the edge of the acetabulum earlier on in flexion. And then that repeated contact onto the labrum causes calcification over a period of time. So less space for the femoral head neck junction to move, and then you start developing a contractile lesion posteriorly, and then that leads to arthritis of the hip joint. So that's usually seen in the middle-aged females. So here you are, that's the normal hip joint, that's the cam, that's the pincer with the acetabular problem, and there you have mixed with a bit of both. Now, how do these patients present to us? Most of them are young adults. They present with groin pain with the classical C sign. They may have rotational injuries and mechanical symptoms, catching or locking, and limitation in rotation, especially in flexion. And they also have the positive impingement sign, which is flexion, adduction, and internal rotation will cause pain. So when you have symptoms, clinical signs, and diagnostic imaging put together, then it becomes the femoroacetabular impingement syndrome. Now, in terms of investigations, what you need is a plain AP radiograph and a cross-table lateral, like so. Otherwise, you'll miss the cam abnormality there. And we've started getting better at actually assessing how we read our AP radiograph. So you can see the crossover sign there, the figure of 8. And you can also see the ischial spine sign, which basically tells you that this acetabulum may be retroverted. And then on the MRI scan, you will see that you've got the bump there. You can clearly see the acetabular labrum and the articular cartilage. It will show you all three. But the game changer has been the CT scan. Now, the CT scan will show you the anterior inferior iliac spine, the femoral head, along with the femoral head neck junction. You can see the femoral version, you can see the acetabular version, and you can see exactly what's going on onto the ischiofemoral space as well. So that clearly tells you exactly what is happening in terms of impingement, both on the intra-articular and the extra-articular aspect of the hip. So the CT scan, the 3D recon, is really a game changer in our investigations. And then we can get planning tools like this from the CT scan to plan our resections, exactly how much is required to be taken off when we do arthroscopic intervention or otherwise. A diagnostic hip injection is important to tell us whether the pain is coming from an intra-articular source or an extra-articular source. And if the patient does not improve with these injections, then we get our
Professor Vikas? Dr. Srinivas?
Looks like he got disconnected. So he is actually in Turkey at the moment.
He's in Turkey.
So
I think he's disconnected, I think.
Yes. Shall we wait or let me just try and contact him, sir.
Okay.
His talk was actually brought forward because he said he had a flight in an hour's time back to London. So apologies for that. It looks like his connection is disconnected. Messages are not going through as well.
We can move to the next speaker, okay?
Yes, if he joins later, can we continue?
Yes,
and
yes,
finish his speech? Thank you.
Of course.
So, actually, I have had a small introduction for the speakers. So Dr. Vikas Kanduja was the first speaker. Next up is Dr. Professor Abhay Elhens from Jodhpur in Rajasthan. He's a professor of orthopedics. He's going to play a video of THR in acetabular fractures for 15 minutes, followed by a panel discussion of different scenarios and management of each. The panel will consist of hip and pelviacetabular surgeons, Dr. Mez Acharya from Bristol, Dr. Ashok Raju from Hyderabad, and Dr. Yoshi Pratama from Indonesia. Dr. Abhay, please. Thank you.
Thank you, Professor Mohamed. Thank you,
Thank you so much, sir, for being with us. Thank you so much.
Thank you for the invite. It's a pleasure to be here. And how we've actually tried to, mold this particular session of 45 minutes is that I'll do a short 6-minute video, and we've got some really interesting cases. So we're going to start with Mez putting up a case, and then I will put up a case, and then Mez will take it up with another case. And then if there is time, I will do another case. So we've got lots of cases. So we thought that it would be better to discuss cases rather than do solo monologues. So I just walked through a video, a very interesting one. 1 second.
Apology. Dr. Vikas Kanduja has rejoined. Actually.
Yeah, so we can let Vikas finish his talk then.
Yeah.
Apologies, okay. The dropped, guys. Shall I continue later, or Abhay, do you want to?
You please finish. Please finish, Vikas. Continue.
Okay, sincere apologies.
Not a problem. Please.
Can you all see the screen now?
Not yet, sir.
Okay.
Hi, hello everyone. Can you hear my voices?
Hi.
Okay.
Yep.
Yes.
Okay, perfect. So I was on this slide. Essentially, surgical technique would involve improvement of the joint mechanics, which would be correcting the head-neck offset and addressing the soft tissue. In terms of offset, you're basically taking away the excess bit of bone that comes along with the cam or the rim recession with the pincer, and then addressing the labrum with debridement repair or reconstruction, and addressing the chondral damage at the same time as well. Now, we used to do this with open surgical dislocation, the trochanteric trip osteotomy, and for some cases, complex cases, we still need to be actually doing the same. So you can see the pincer there and the cam there being taken off with an open approach, but all this can now be achieved arthroscopically. So here you are with the scope in the joint, and you can pretty much like shoulder surgery, do the labral repair with the suture anchors, and then address the chondral damage, pretty much like knee surgery, and do the microfracture. And the pincer impingement can be addressed with high-speed burrs like so, and the cam impingement through the peripheral compartment, taking away the excess bit of bone through these 5.5 millimeter shavers, ensuring that you have a good head-neck offset and good clearance at the labrochondral junction there, as you can see. So all this can be achieved arthroscopically now these days. And you have intraoperative tools like the hip check on fluoroscopy, which will tell you exactly how much you've resected and whether you've actually got the alpha angle back to normality. Now, what about the outcomes of surgery? So all of this happens arthroscopically. First, ran 2 randomized controlled trials, which have compared arthroscopic intervention versus physiotherapy for patients with FAI and no arthritis or tonus grade 1. And both of these trials, Fashion and Fate, published in high impact factor journals. We contributed to the second one with Oxford, the Fate trial, show that essentially arthroscopy does better than physiotherapy in the shorter term in patients with FAI and no arthritis or grade 1 arthritis. We've taken this to the lab as well and biomechanically seen that if you accurately excise the cam lesions, then basically you're restoring the normal peak joint stresses, contact stresses in that joint through a technique called discrete element analysis. So not only through randomized controlled trials, but also biomechanically using DEA as a surrogate marker, you can see that if the surgery is done perfectly, then there is a good chance that you will prevent arthritis in these patients. And then finally, what's the real world saying? And the real world is the registry data. That's what we have in the UK. Over 10 years now, and we've got over 22,000 pathways in there. And you can see that with over 100 surgeons contributing, that's what's happening to the FAI patients in the shorter term. So we use a specific score called the IHOT-12, which is a young adult hip specific outcome tool of 12 questions. And you can see that jumps from 32.8 to 56.7, which is a fairly good increase on the MCID, which is 13 points. We've recently published data from 5,000 patients from our registry. You can see that 2/3 of this patient are doing well, but 1/3 are not performing well. And that's the real life data. Now, that's what you need to be careful about, that all the patients do not improve after this surgery. So you need to make sure that you stratify and you pick your winners. If you want to take one slide home from this whole talk, and this is the slide that you need to pay attention to. This is not only for FAI, but I think for everything. Eventually, your excellent outcomes are going to be dependent on three things. The first thing is the patient. Does the patient have the morphotype to improve? The morphology. Can you actually make that morphology better? And then finally, it's your technical ability. Do you have the technical ability to actually make that morphology better and make that patient better? So before making that decision to operate, you need to ensure that these three factors are considered appropriately. So patients with hypermobility, with mental health issues, who are not going to actually bind to your 16-week program, post-op program, are not going to get better. In terms of morphology, if they've got grade 2 arthritic changes, if they've got edema or cysts, those are the patients morphologically are not going to get better. And then patients who've got significant amount of retroversion or more than 30 degrees of anteversion, again, they are not going to have good outcomes. And perhaps you need to be thinking of an osteotomy in those patients rather than arthroscopy. So our whole research program is essentially based around outcomes of surgical intervention and a non-surgical intervention in these patients. So we're looking at stratification of disease and outcomes. We're looking at surgical precision, navigation and robotics, and then looking at muscle strength and how much that has to play in basically any sporting or any surgery involving arthroscopy. Because if you start off with a poor muscle strength preoperatively, it's quite likely that you're not going to have a good outcome. And mental health. So 6 PhD students looking at various aspects on improving outcomes. And the other thing that we focus on is a structured hip arthroscopy training program with a fellowship for 1 year, then simulation training and cadaveric skills training, along with mentored independent practice once you become a consultant. And all these 4 are required to make sure that you land up becoming a good hip preservation surgeon. And based on this philosophy, we've had trainees and visitors pretty much over the last 18 to 20 years from all around the world. So that's it in a nutshell about femoroacetabular impingement, the outcomes, and where research is going. If you need more information, then these are 3 good sources worth reading. But I'd end with this statement. That is a quick anecdote here. Second year of my training in Royal London Hospital, a young chap comes in his mid-20s with groin pain. I look at his x-rays, examine him. Pretty normal looking x-rays. We didn't do a costable lateral in those times. And I basically said, go have some physiotherapy and you'll get better. But now, obviously, if that same patient comes in, I'll have a lot more to offer him. So certainly what the mind does not know, the eyes will not see. Important. Thank you very much for your kind attention and apologies for the technical glitch in between.
Dr. Chitorsa.
Thank you. Thank you very much, Vikas. Thank you very much. That was a great talk. We don't have any questions from the delegates as yet. I would like to ask one question from my side, if that's okay. Is there a strong demographic and cultural component for FAI? How common is it? You think it is in India compared to European nations?
I think that's a very good question. There is definitely no doubt that the Caucasian population has a lot more of this. And generally, we see a lot more hip arthritis than knee arthritis here. And that probably is due to the fact that a lot of them get involved in rugby and football in their early ages. And that's how they are loading their growth plates and developing it. The second issue, which we are looking at now, is does squatting, the way we squat in the Eastern world, does that actually prevent you from a younger age in having and developing this morphological abnormality? Plus, cricket is more prevalent in that part of the world rather than rugby and football. We'll have to wait and see when rugby and football actually get more of an impetus in India, whether actually patients start developing FAI there. But this seems to be what's going on. Clearly, much more in the Caucasian world than in the Asian world at the moment.
What is the longest available follow-up in literature with the open and arthroscopic management?
That's again a very good question. So we've done a systematic review on this, comparing all the three approaches: the mini open, the arthroscopic, and the surgical hip dislocation. Longest follow-up is about 12 years now, coming up to 12 years. And even arthroscopically, you're getting 10-year follow-up papers coming out now.
Thank you.
Yep.
And how about in athletes? How helpful is it in athletes?
So again, we've done some work on this and published on this. The return to play for one season post-intervention seems to be in the high 90s. Okay. And the sole determinant is actually how much of articular cartilage damage you've got in the hip joint. As long as you are scoping a hip or doing a hip which has got not a significant amount of articular cartilage damage, then you are onto a winner.
Thank you very much. Professor Elashhab, do you have any questions?
No, thank you so much, Professor Vikas, for being with us. It's a great honor for us, sir. Thank you so much.
Thank you.
Thanks a ton for the kind invitation, and Abhay, sincere apologies for pushing you a few minutes behind. Apologies.
Thank you so much.
Not a problem at all, and have a safe flight back. See you soon.
Thank you. Cheers. Thanks. Bye.
Bye.
Thank you so much, sir.
Yeah, so good evening, and thank you so much, Professor Elashhab and Dr. Neeraj, for this lovely invite. And before we walk on to what we are actually going to talk, what a galaxy of stars you've collected today for a great international hip webinar. So this is the four of us who are going to be discussing on the nuances of total hip arthroplasty post-acetabular fracture. So that's me. I am a professor at the All India Institute at Jodhpur. Mez is a professor of orthopedics at the North Bristol Trust in the UK. Yoshi works at the Fatmawati General Hospital in Jakarta in Indonesia. And Ashok, again, is a brilliant hip and pelvis surgeon at the Citizens Hospital in Hyderabad. So all four of us have interests aligned to hip and pelvis. So how we are going to run through this next period is basically we're going to be doing the video first on the total hip arthroplasty for acetabular fracture, and then we're going to walk through a couple of cases. So this one is a 37-year-old lady sustained her injury in a road traffic accident. For 4 years, she was untreated for her fracture, and that's what we see a lot of, unfortunately. Had very poor outcome scores and a hip which had gone inside and intrapelvic. So if you were to actually assess this hip according to the classification systems that are available, you would put it into upper prostate.
Or presentation is
see your screen, actually.
Excuse me?
I'm not able to see your screen.
Your presentation is not seen.
إذا موجوع كثير الناس بتثبت لأنه كأنه في شعر بالكوع.
1 second.
لا أتل على كوع.
Can you see the presentation now?
Yes.
Is it visible now?
Yes, now we can see.
Okay, sorry for the glitch. So what we're going to talk about initially is a 37-year-old lady sustained injury in a road traffic accident, untreated for 4 years, and had significant functional disability because of the injury that she's had. And if you're actually going to see and assess this hip, you would actually put it into a laparoscopy to see whether the hip has gone intrapelvic or an AOS type 3 defect. A pretty severe injury to have, and a pretty severe injury to be walking with for almost 4 years. And that's what we see, unfortunately, a lot of in the Indian subcontinent. So this lady, when she came to us, had a significant issue, and we offered her a total hip arthroplasty. And the way we go about doing these hips is we choose the posterolateral exposure for the hip. And what is important in this exposure is that because it's an intrapelvic hip, it's like a grade 3 protrusio. So the sciatic nerve is very anterior. So one has to be careful and keep the hip extended as much as possible and the knee flexed, and take care of the dissection through the muscles around the hip. And a lot of times one needs to do an in situ cut to make sure that we're able to access the acetabular socket inside the hip. A very good technique sometimes would be to do a small osteotomy of a sliver osteotomy of the posterior wall. And once we've done that, you need to assess the hip, and you need to prepare the bed and take off all the debris from the hip and the granulation tissue that may have formed. And once you've done that, the technique is pretty much like we do for a standard protrusion. What is most important here is to do build up bone and build up biology, and that we did using an impaction bone grafting technique. So we used a mixture of the ortho and the allograft, and we use this bone mill to prepare the ortho and the allograft, and we mix it, and we use about 4 grams of vancomycin along with the graft. So we sized up a wire mesh. And what we normally do is that we put an impaction. There is always going to be a membrane inside the hip. So we put in graft there, put in a wire mesh, and then put in another sandwiched it as a layer with another layer of impaction bone grafting. And this is how the acetabular socket look like. And a lot of these hips have reasonably good column support to take the cup. So if I had to do this hip today, I would do a cementless cup. But this lady had cost issues, so we did a dual mobility cemented cup for her at the time. The important bit to get a good acetabular socket and a very good regeneration of what we're doing is to impact the allograft very, very well. And that is basically how we're going to be able to build bone. So we sandwiched the wire mesh between the layers of the ortho and the allograft composite, and kept on hammering it till this time we recreated a hemispherical shell in the acetabular socket. And then we did a trialing of the cup, the dual mobility cemented cup, making sure that we're in the correct abduction and inclination for this particular case. When we were happy, we took it off, and then we proceeded to cement in the dual mobility cup into the acetabular socket. A very important thing is the basic cementing technique that you use, and you have to be careful that you take off and don't leave any residual cement back behind in the inferior part of the acetabular socket. We make sure that we pressurize the cement well so as to get a good micro interlock between the cement and the graft or the host bone. And then we put in the final cup. Making sure that the abduction and inclination is as we want it, removing all the inferior extra cement, making sure in our trialing that there is no impingement, and then we used a Corel stem The stem part of this procedure was pretty standard. Check the hip for shock and stability through the range of motion across the board, and it was a standard closure for the hip. So this is what the hip looked like, and this lady is now 5.5 years post her index surgery and is a very happy patient. So I'll stop here now, and maybe we can take any questions that are there along with this for this particular video session now, and whatever else is there once we are doing the case discussion session. So can I request Mez to start off with your case first? And if there are any questions, Dr. Srinivas, we can take them now.
Nothing from the delegates, actually. You can proceed.
I've just got a couple of technical questions, if that's all right. Just so to see what people are doing. So from your point of view, when you've got a hip like this and you've got a protrusio type hip, you've mentioned, the sciatic nerve can be lying in an abnormal position or very close. Do you do anything to try and release the sciatic nerve? So my question really is, do you take the glute max off tendon as routine to try and release the sciatic nerve? That's the first question.
Yeah, so routinely, if I have a difficult hip, I would like the G-max to go more as anterior as I could so as to increase the visibility on the hip. And these are cases where I would take off the G-max insertion from the gluteal tuberosity so as to I can anteriorize the entire digastric sleeve and get a better view of what I am going to be working, the area that I'm going to be working on.
Yeah, absolutely. So, that's a good technical tip to do that. And then second question with regards to the impaction grafting and the size of your chips. Do you have a particular preference for size? Would you use a combination of sizes?
Yeah, so I use a combination of size, and we use the fresh frozen allografts, the Exeter technique, and we have a fresh frozen allograft bone bank. And we use a 3 to 4 bone chips, which we really impact hard, and we mix it with the allograft, the milled bone, which we have from the bone mill. So we mix the auto allo into a composite, put in vancomycin, and basically the key is to impact it so much that it actually builds a wall. So when you've done enough, you do a little bit more, and it should look like a wall before we actually go in and either do a cementless cup or cement in a cup inside the established socket.
Fantastic. And then one final question, just leading on from that then, do you have a cutoff limit for size of defect where you'll consider impaction bone grafting or not? So say 4 or 5 centimeters of a defect, would you still consider impaction bone grafting for that?
Yeah, so what I would do today as a standard is basically the columns may be a little deficient and the rim may be a little deficient, but we'd always have good enough support. So I would first trial in my acetabular component to where it really needs to belong. And once I have done that, I basically assess as to how much is the defect. So I really don't have a big landmark as to say that this is what I will impaction graft and this is what I won't. But if I have a 2C defect, I would impaction graft it because I have pretty much the columns which are intact, and they will take a standard cementless cup very, very well.
Perfect.
So, I have a question, please, sir.
Yes, sir.
Dr. Rafi, please, sometimes if I have a large defect, I take all my precautions and put the graft and impact the graft. But sometimes during impaction of the cement, some cement may extrude inside the pelvis. How can you deal with such a case, sir?
So if I'm impaction grafting into my acetabular socket, that's exactly what I'm trying to avoid. And essentially, I'm going to be trying to build a wall of impaction graft before I actually cement my dual mobility cup or a liner into a shell or an anti-protrusio ring into the cup. But I need to build a good enough wall so that my cement does not extrude in. And what you realize here is I did a sandwich. I did a grafting first on the original membrane. put in a wire mesh just for some kind of stability, and then impacted and put in more graft inside again, and then just kept on impacting till such time I had a hemispherical socket. So making sure that the cement does not go inside. But if it does, it usually will not cause a lot of harm, but that's something I would like to avoid most times.
Can I put in a word?
Yeah, please.
Yeah, the impaction, what you're talking about, has to be significantly firm and hard, so that there are no free fragments which fall off from your impaction. I think
absolutely. So the key is it should look like a wall.
Yeah, but they should interlock with each other and they should not fall off.
Absolutely.
So that doesn't allow the cement to go in. Yeah.
So can we go ahead and do our cases now?
Yes, please.
Yeah, so we have, I think, 34 minutes to do our cases. So we'll start with Maz first.
Everyone happy? Can you see that?
Yes, we can see that.
Perfect. Okay, thank you. Abe, thank you so much for allowing me to be part of this webinar, and to Srinivasan and Dr. Elashhab as well. Thank you. So I'll start with a case. So this is an interesting case. So 76-year-old female, she's got a few comorbidities, so diabetes, diverticulitis. She had her right hip replaced in 2002. And then 9 years later, she had pain in the right hip. And so she went on to have a revision. So she had a revision, and this was her initial post-op X-ray. And you see that from August 2011. There's a drain inside you. And you look at the op note, and the op note says that the floor was thin. And so they put some graft into the floor, and then got some press fit for an acetabular component, and used screws to augment that as well. So she managed to mobilize protected weight bearing, but 2 months later, this was her X-ray. So if we just go back one X-ray, we can see it's a slightly different view, but it looks as if maybe the acetabular component has migrated to some degree at this point in time. So the question really is to the panel now then, before we carry on, is what would people do at this stage? Would you protect the patient, protect weight bear the patient? Would you carry on weight bear as tolerated, or would you do anything different? So let's ask Ashok then.
Yeah, I think from the first X-ray to the second X-ray, definitely there's loosening. There's migration of the cup. And I think the apex of the cup is in the defense. So I would definitely go ahead with the revision here.
You'd go for a revision now. And Yoshi, are you online?
Yeah. Okay, so I agree with Ashok. So from the first X-ray and the second X-ray, we see that there is some migration on the cup, so there is some loosening on the cup. But one thing that I want to know first is whether there is any infection on the cup, because sometimes the loosening itself can be mechanical, can also be caused by infection. So the first thing I do is check the lab and also do some aspiration just to make sure whether there's any infection of the cup. If there's no infection, maybe I'm going to proceed as well with the revision.
Fantastic, fantastic. So work up, make sure there's no underlying infection, and then think about revising this because there's cups on the move. Okay, so very good. And I think it's really important about the infection workup. All samples, I am told, from the initial revision were negative. Anyway, so they didn't do what you guys suggested. So I agree with you. I would have gone in and revised it at that stage. But this is what happened. So another couple of months later, she has more pain in that hip. You can see that there's some broken metalwork now, and that the cup has migrated further. So now we've seen two serial X-rays where there has been migration of that component, and the patient's in pain. We get a CT scan, and you can see these ghost 3D scans, and you can see that the cup has completely flipped. through quite a large angle, and it's migrated. It's not quite intrapelvic yet, but it's almost there. Further CT scans just showing that again. You can see some of the graft behind the cup. You can see there's a big defect now in the acetabulum. So this is what I'm thinking. I'm thinking this is a significant defect, a significant bone loss. At the moment, I'm thinking it's a 3B defect, but I think there's a high chance of there being a discontinuity here as well. And so I'm just trying to formulate my plan and how I'm going to try and manage this patient. And I completely agree with all of you that you do workup, you do the labs, you do an aspiration or a synovial biopsy to make sure that there isn't any underlying infection there. And so this was my plan. We did all the workup for the labs, and that was all negative for infection. So this is what I was hoping to try and achieve. So I was going to think about doing an extended posterior approach. I was going to remove the components and then assess the acetabulum for a discontinuity. And this is exactly what I found. So there is a pelvic discontinuity. So the question then, again, to the panel is, what do you do? How do you manage your pelvic discontinuity? So let's start with Yoshi then.
Okay, so basically, in my practice, when I found that some pelvic discontinuity, the first thing that we should do is bridging the superior and inferior hem pelvis. So basically, you can use some plating, or you can use some implantic and like the cage as well to bridge the superior and inferior part, and then put your cup in. And also before that, you should put some graft in order to make sure that the bony healing is quite good. Okay, maybe that.
Very good. And Ashok as well?
Yeah, I think I would agree. I would go through the extended posterior approach. I find a discontinuity. I think if I have a good, decent bone stock in the posterior column because of the discontinuity, I would plate it first to make it a little simpler. I have a posterior intactness of posterior part. So now I know that I have a point fixation at the posterior point and the superior part, but I think the anterior part is lacking because of the severe defect. So how do I solve that defect? I know that the anterior part defect, I am sure there's a huge defect. Even if I put a graft, I think it's going to push in. So I have to prevent that graft from going in. So I would put a mesh and put a graft to do that. But I still know that the anterior part is a little, it's not continuous. I think I would put a cage because I think she's pretty osteoporotic and I can't just leave the graft and the mesh over there. I would augment it with a cage and put a cemented cup into it.
Fantastic. Bay, anything to add? What are your thoughts? If you've got something to add, fine, but what are your thoughts on distraction technique?
Yeah, so a couple of things. First, in the workup, I would definitely add a CT angio to anything going inside an intrapelvic, because I want to know where I am and where the shell is in terms of where it's sitting inside the socket. That's one. Secondly, a 74-year-old with a diverticulitis, with a diabetes, if you're going to, the options are, we've either had a pathological acetabular fracture on day one, which has got missed, and that is the reason why the lady has, the cup has gone in, because for a cup to sit comfortably with 2 screws in and then to start walking in, she's either had a pathological fracture on day one, which has got missed, or this is like an acute pelvic discontinuity. And the basic principle of the acute pelvic discontinuity is that you've got biology there. So if you just put in a fulcrum and put in a posterior pelvic plate, then you can actually do a couple of things. So you could do a cage and a cemented liner into the cage, or you can do a jumbo cup and with a distraction technique, and you can actually put in the largest size cup, which the discontinuity will take. So the distraction is a good technique in the discontinuities. However, it is more advocatable for the chronic pelvic discontinuities, but you could still do it for the acute discontinuities. The important thing here is that not to destabilize the discontinuity too much, and put in graft there so that you can get some healing, and then basically get your compression at the rim and the on the columns with the largest size cup that the hip will take, and get a good primary fixation, because that is going to last. And we know that if we're not able to do that, if the quality of bone is not good, which it can be in an elderly with diabetes, with sclerotic bone, then my go-to would be a cage with a liner. But the point is that we're looking at 9-10 years, and we would need to come back.
Yeah, great. So exactly right. And the points that I was trying to get out of the discussion is that because acute and chronic discontinuities are very different. And you've just got to be aware of that when you're managing these. Okay, so I'll just go on to how I manage this case. So that's exactly what I was trying to do, trying to connect the top part of the acetabulum to the bottom part, and then managing the 3B defect. And we've just heard from our panelists various different ways of trying to manage that 3B defect. And you do what works for you in your institute and what you have experience with. And so this is what I did. So I did exactly that. So I plated the posterior column with 2 plates to give me that continuation between the top and the bottom. And then I used 2 T-Mars augments and cemented them together and impacted them into that defect, into that 3B defect, and then a further shell onto that with some screws. And so these are the post-ops, and you can see that there's that big combination augment into the floor of the acetabulum. And then you can see that cup on top of it as well. So these are the immediate post-ops. And this is her 9 years post-op. So she's got a little bit of lucency around the greater trochanter on the right side, but actually that acetabular reconstruction has held firm. There's been no further migration. She's done really well, and she's happy with her construct. So that's her there. Thoughts from the panel?
Amazing work. And excellent reconstruction, and the longevity of the hip is just justifies all the principles that we've just discussed.
Yeah.
Just one question from the delegates. He wants to know more about the distraction technique.
Mez, all yours.
Yeah. So a good question. I don't tend to use the distraction technique. I tend to use compression. So because I do a lot of pelvic and acetabular work, I will compress the upper part to the lower part with plates. The only caveat to that is if you've got a significant segmental bone loss. So if you've got a significant segmental bone loss, and for me, that's probably about 4, 5, 6 centimeters. If you've got that degree of bone loss, then I think you're going to have to bridge the gap in a different way. And for me, I don't use distraction, but I would probably use a custom type implant for that. Going back to what Abe said, and the question was about distraction technique. So for distraction technique, you keep impacting or keep trialing a cup, which the largest cup you can get into that defect. And if you think about it, if you've got an acute discontinuity, there's nothing there's no fibrous tissue, there's no soft tissues to hold those two parts together. So it's just going to keep going. Whereas if you've got a chronic discontinuity, you've hopefully got a bit of fibrous tissue, you've got the rest of the soft tissue structures, which are going to hopefully stop that large cup from exploding further. And so you've got to be aware, if you're doing distraction, then most companies will have a cup up to about 70 millimeters or so. And you've got to get the bigger cups in. So you can get a cup of 80 millimeters or up to 80 millimeters. So get those extra cups in, because these defects just keep going sometimes. And my issue is that you get to a size 80, you don't have a bigger cup than that. What do you do next? And so for me, I don't tend to use distraction. I'd rather go to a custom. But thoughts from the rest of the panel?
Yeah, great points. I think we've done a lot of the discussion here. And just a very quick word, chronic pelvic discontinuity is where you are looking at distraction more than the acute discontinuities, for the same reason that you said that you need to have granulation. So when you put a distractor with a pin at the 12 o'clock position and on the skim and you distract, so you're distracting peripherally and you're trying to compress the discontinuity centrally. So that's basically the principle, and that essentially will get you to spring in the largest size cup into what the actual biggest size of the acetabular socket will be. So great case. I think we can move forward now, and I think we have time for one more case.
Your case, Abhay?
Yeah, just share screen, and it's something that very interesting one. So that's a 68-year-old male. He was getting down from a moving train when he was visiting his daughter very close to where we work. And this is the injury that he presented with. And if you'll all agree, a very quick word of what exactly is the kind of injury we're looking at. Maybe we'll start with Ashok. Very, very quick point in a minute, I guess.
Yeah, I think I'm not sure about the posterior injury, but it looks more likely to be an anterior column with a posterior hemitransverse kind of a fracture with a component of pelvic part also.
Yeah, so very rightly said, we've got something opening here in the pelvis on the contralateral side. We've got a segmental anterior column with something going behind as well. And it's got comminution inferiorly as well. So we did a CTs, and this was something that we would normally do a fixation for, an open reduction and internal fixation. And a very quick word, Mez, do any of these injuries make a case for an arthroplasty at any point in time? So an elderly patient with an acetabular fracture, what quickly in your book makes a case for an arthroplasty?
Yeah, so very good. So there are fracture characteristics. So if you've got we know there are certain fractures that don't do well. So if you've got a fracture, a transverse posterior wall with comminution, with impaction on the acetabular side, impaction on the femoral head side, you've got a patient who's over 60 years old, you've got a dislocation. If you have all of these factors are poor prognostic indicators. So for these particular fractures, there is a vogue. And for me, in my book, they are, if they're fit enough, a candidate for a total hip replacement. I agree. But with this particular case, I think there are two components of the injury. So we just need to be aware that we need to stabilize the pelvic ring and deal with the acetabulum, but you may deal with them separately.
Absolutely. Perfect points. Yoshi, would you like to add something? So would this patient go to fixation in your book, or would this patient go to replacement in your book?
Okay. Finally, in my practice, I would like to do the fixation first in this case, because imagine if we try to fix the cup in this kind of acetabulum, I can imagine that my cup is going to migrate. Can you hear my voice?
Yeah, we can hear you. Please go ahead.
Okay. So, I can imagine I try to put my cup in, especially if it's smaller cup. The anterior part of the pubic symphysis may not go well. It might be crushed into because of the intensity of the bone itself. So yeah, in my case, I think I'm going to do fixation in this case first, trying to get as good as reduction.
Right. So Yoshi's take is that open reduction, internal fixation, and a delayed arthroplasty, if at all. Very quick word of whether acute total hip arthroplasty Mez for this patient and Ashok, or an open reduction internal fixation and a delayed total hip arthroplasty, what would you do? Your thoughts on this, one line.
Yeah, I think it's a high velocity injury. I would not dare to do anything in terms of arthroplasty at this moment. I would fix the pelvis first, and I might, based on the condition of the patient, leave it or do a simple fixation to get it back the things in place. I would not.
Okay, so fixation and a delayed arthroplasty, if at all, needed as and how needed, right? Right. And Mez, any quick word from you, this patient?
Yeah, sure. So for me, really two options. One is to fix all from the front, though, and not put any metal work at the back if I'm thinking of an arthroplasty later. So that's the first thing. Or my preferred option, I may still try and do an acute fix and replace. You see, with this particular fracture, there's significant head damage, there's significant articular damage, and actually, the technique we use is a dual approach. So we'll use an anterior intrapelvic approach. We'll stabilize the pelvic ring, but an anterior intrapelvic approach, buttressing that quadrilateral plate, and then doing a posterior approach, fixing the posterior column, and then reconstructing the two columns, the anterior and posterior column, and putting a multi-hole cup in there. So I think, it is challenging, but I think it is an option.
Right. Great points there. So primarily you can look at acute fixation and delayed arthroplasty, or fixation and arthroplasty at the acute stage. The important things to assess here will be that the head, if they have a damage, if they have a cartilage loss, if there is a segmental combination of the columns anteriorly or posteriorly, you've got severe marginal impaction in an elderly, yes, you are actually looking at an acute fix and replace as a go-to option as well. But fixation and a delayed arthroplasty is pretty much what we would do if the head was reasonably good and the cartilage injury was not very significant. So this is what we had. And this patient came to us in 2 weeks. I'll finish in 5 minutes. Yeah, so this is what we had. Now this patient develops tachypnea, shortness of breath, drop in saturation. What do? This is what he has. Does this change the way you look at this injury now? Very quickly, Yoshi. Very, very quick thoughts. How does this change the way you're looking at either fixing and replacing, or fixing and doing a delayed total hip if needed?
Okay. In this case, if the patient condition is
she's got embolism. She's got a submaximal embolism.
I'm just gonna do the fixation only and delay.
Okay, so when do you do the fixation? So what do you do now?
Okay, so send the patient to the ICU and monitor whether the condition is better. If the condition is quite good, maybe if the patient does not have any polytrauma, I'm gonna delay until 3 weeks after the injury.
Okay, great. So deal with the embolism and give them the prophylaxis or acute therapeutic embolization, therapeutic anticoagulation, and wait for this to die down before you want to do something, right?
Yeah.
Okay.
The
only
other
thing is consideration of a filter.
Okay, great. So the patient gets a filter, and we'll come to that. So would any of you want to do acute fixation now, or would all three of you would like to wait? Very quick answer from Mez and Ashok.
Okay.
Wait or proceed?
Hemodynamically stable or unstable?
Hemodynamically largely stable, but yes, saturation has dropped to 90, 85s, 80, waxing and waning saturation, and elderly patient.
I may percutaneously fix the back because I think you need some stability of that pelvis, whether you do it now or whether you do it in a few days. I think if this patient deteriorates further, we may have lost the opportunity. So if the anaesthetist will allow me to, I'll fix the posterior pelvic ring percutaneously and then see how they go and think about coming back for the anterior ring.
Great. So delay your definitive fixation. Just do whatever basic minimum is allowed, and that too Yeah, okay, I'll just finish. And whatever you will do is basically based on the basic condition of the patient, right? So because we are losing a little time, we did actually, I'll tell you what we did and then your comments to finish. So we did an IVC, we did an anticoagulation, waited for the thrombus to die out, gave it 2 to 3 weeks, put in an acute filter before we did anything, and did a 2-stage procedure. So we fixed the pelvis because we did not want micromotion on the cup once we did a cup, and we shifted to an acute arthroplasty or a delayed acute arthroplasty in this situation because we had already lost time because this patient was now almost 4 weeks since the acute injury. And in stage 2, we went in, did an impaction bone graft, did fix the posterior column with a plate, and did a dual mobility cup and a cementless stem. So that's what we did. And this is the patient at 13 months of follow-up. He's healed, he's walking, he's all good. Your thoughts and comments, quick comments for 1 to 2 minutes before we finish and hand over the session back. Anything different you would do, anything critical that you would make a point in this patient? Starting with Ashok, please. Very quick comments, Ashok.
Yeah, in a combined pelvic establishment, pelvis comes first. I feel that is one before you contemplate arthroplasty or fixation. I think that is one of the most important things. And stability of a patient, clinically if it's stable or not, that has to be a priority in combined pelvic and establishment fractures.
Okay, anything different you would have done here? Any critiques on this? Very quick one-line comment before we move on to Mez and Yoshi and finich.
Yeah, no, I think I would have done the same way because I would have fixed the pelvis at the time of percutaneous fixation of screws to stabilize the pelvis so that his critical condition, one of the factors would pelvis. So stabilizing the posterior part in the initial period itself would have been better, would have been more...
So to summarize our take-homes on this case, I think if you have a pelvis and acetabulum first, deal with the pelvis. If you have an acetabulum, then look at the individual case. If there are pointers to do an acute fix and replace, that's a viable option in an elderly. Otherwise, you could do a fixation and leave it to a delayed total hip. If you're doing an acute fix and replace, you've got to basically look at leaving your total hip arthroplasty approach virgin and do your fixation elsewhere. And if you've got a pulmonary embolism, you've got to deal with that. And, you'll have to do a disaster DCO rather than an acute management. Would that be a good take home for everyone? Anything you want to add? Mez, Yoshi, Ashok?
Yeah.
Okay, thank you so much. I think we can stop sharing and hand over the session back to our moderators. Thank you so much, Dr. Srini and Dr. Elashhab.
That was an excellent session. Thank you very much. Great cases and great discussion of the cases. Next up is Mr. Mez Acharya from Bristol. We have seen him in the panel discussion. He's talking on open reduction of high energy femoral neck fractures. Mez, to you, please. Thanks.
Thank you. Thank you, Srini. Just... 1 second, just trying to share my screen. Can you see my screen yet?
Not yet.
Not yet, sir.
Yes, starting. Yeah, we can see now.
Not this one. I'm really sorry about this. For some reason, my correct talk hasn't loaded up. Can you see that now?
Is that a PDF document?
No.
What we are seeing is a browser, actually.
Oh, yeah. Let me just stop sharing and I'll try and share again. Bear with me. Oh, that one. Is that better?
Yes, this looks like.
Okay, fine. Sorry about the glitch. So open reduction of high energy femoral neck fractures, and this is how I do it. You know, there are different ways of doing this, but I think it's a challenge that we all face. Maybe not that common in certain scenarios, but when we do have a patient with a high energy femoral fracture, there are certain things we just need to be aware of. And so these are usually motor vehicle accidents, high energy. They affect the younger people. The management guidelines are still controversial. You know, when should you take this patient to theatre? What should you do? How should you do it? All of these finer intricacies of how you manage these patients can be controversial. And the thing we've got to bear in mind is that the complication rates in these fractures are high, so anywhere between 10 and 80%. And so this is what we want to try and avoid, and this is what we're worried about. So this patient had a femoral neck fracture treated with cannulated screws, and we see that 18 months later, they have significant avascular necrosis and some chondrolysis, and actually has pain. So they're going to need some further treatment. And this is what we want to try and avoid. So how can we minimize the risk of AVN? Well, try and get them to theatre as soon as you can. And some studies say within 6 hours. You can obtain an anatomical reduction, whether you can achieve this open or closed. You want to achieve stable fixation. And then there are some papers there which talk about capsulotomy, decompressing that hip joint or not. But for me, it's really all about obtaining anatomical reduction and achieving stable fixation. What's the other thing we want to try and avoid? Non-unions. And we know that there are certain fracture characteristics, so a Powell's 2 or a 3, or where you have comminution, they can be associated with a higher rate of non-union. If you have malreduction or poor fixation, again, they can compromise your reduction, fixation, and lead to malunion or non-union. So how can we decrease the risk of non-union? Again, anatomical reduction and stable fixation. So the rest of the talk is now going to concentrate on how I achieve reduction and stable fixation. And so we're going to go through 2 or 3 cases and try and illustrate that. So this is a 21-year-old female, road traffic collision, isolated injury to her right hip. And so there's her AP pelvic radiograph. You see she's got a significantly displaced intracapsular neck or femur fracture on that right side. There's some comminution inferiorly, medially as well. This is her lateral X-ray. Again, difficult to see, but there's significant displacement there. So she gets taken to theatre, and this is a traction view. So put her on a traction table, and this is putting lots of traction through that right hip after trying various reduction maneuvers. There's no improvement. So for me, this requires an open reduction. And so this is how I do it. This is the kit that I ask my theatre team to get ready, and this is what I want. So I usually use some Asnis 6.5 millimeter screws for my fixation. I think about Hohmann retractors because I want to do an open reduction. I think about using 3.2 threaded pins to gain my reduction. I need an assistant because there's usually 2 things going on at once. And then I try and augment or hold my fixation with a small plate, an anterior plate, so whether it be a compact foot, compact hand, or an EVOS type plate. So let's just run through this. The setup and approach, I usually use a traction table with image intensifier. Over the anterior part of the hip, I make sure I've prepped and put the drapes further round. And then I use a 2-incision technique. So I use the Smith-Peterson interval for my anterior reduction, and then my lateral interval for my fixation. And so this is what it looks like. So the VAN is the vein, artery, and nerve, and you can see how I've outlined the incision for my Smith-Peterson interval. And that's what it looks like. So the anterior incision for the reduction, lateral incision for the fixation. So going back to this patient then, this is what I did. So an anterior approach, Smith-Peterson, the Hohmann retractors either side, and then those two 3.2 threaded pins as joysticks to gain that reduction. And the first thing I'd then do is put a posterior wire in to hold that reduction. You can see now I've contoured a little anterior plate, and I've drilled through and I'm measuring the length of those screws. I've put 2 screws in now, further wires where my screws are going to follow. And so that's what the fixation looks like. A little plate, anterior, inferior, along that calcar, and then stable fixation. Try to spread that apart as much as I can. And that's her lateral. Those were the incisions. And that's her at 3 months. That's her at 4 years post-op. Pain-free, mobilizing well. Case number 2, 28-year-old male, road traffic accident again, high-speed collision of 120 miles an hour. The left leg is shortened, externally rotated, and there's an open wound over the left thigh now. So look at this fracture. Left proximal femur, highly comminuted, multifragmentary, quite vertical as well. That's the lateral, again, comminution. And there's a femur fracture, an open femur fracture below it. So that really complicates things. And so that's what it looks like completely. So we've got to think about managing both of these injuries now. And he's young. So this was my plan. Radiolucent table, retrograde nail after debridement washout of the open fracture, and then transfer the patient to a traction table, fracture table, and an open reduction, just as I mentioned previously in the case. And so here we go. There's my retrograde nail, and I've left it purposefully short so that I've got space for my instrument and my fixation for the proximal femur. That's the lateral, showing that there's significant displacement. And then again, my kit is the same. So I tell my theatre scrub staff that this is what I need. And my setup and approach is the same. So again, 2 incisions, anterior and a lateral. And again, those 2 3.2 threaded pins have gone in to try and use as joysticks to gain that reduction. And you can see I've achieved a pretty good reduction now, considering how comminuted it was. And then my anterior plate, and again, 3 screws. And that's him there. And then the last case, again, a combination of injuries. So this is a 40-year-old female now, road traffic accident again, multiple injuries. So she's got some rib fractures, she's got a pelvic ring injury, and she's got a displaced intracapsular necrofemur fracture. And she comes in at 10 a.m. in the morning. So this is her CT scan. She's got a lateral compression type 2 pelvic ring injury with a crescent fracture at the back, rami fracture at the front, and a comminuted displaced femoral neck fracture. So again, things to consider when fixing this, closed versus open reduction, thinking about approaches and sequence of fixation and how you're going to maintain that reduction and fixation. So for me, this was my plan again. So I was going to stabilize the posterior pelvic ring first. I was then going to perform an open reduction of the hip with my 2 approaches. reduce the femoral neck with a little plate, and then stabilize it with screws. And then I was going to go ahead and stabilize the anterior pelvic ring. So again, just some intraoperative images, fixation of the posterior pelvic ring initially, and then a traction view. And you can see that there's still significant displacement. So this, for me, requires an open reduction. And then similarly to how I've said before, so the Smith-Peterson interval, gain my joysticks to get that reduction, hold it there with that little plate, and then further supplementary screws to aid fixation. And then I came back and put an anterior, so I finished the femoral neck, and then I went on to put an anterior pelvic infix to stabilize the anterior ring. And that's her post-op x-rays there. My CT scan, all of my pelvic and acetabular fractures. So this shows a pretty good reduction of that femoral neck as well now. So in conclusion, you know, for me, a fracture which is displaced in the younger patient requires fixation. And if you aren't able to achieve closed anatomical reduction, then this for me requires an open reduction. And I have a low threshold for the open reduction. I use the 2 incision technique, Smith-Peterson interval, a lateral incision. I use a mini plate and screws to hold my fixation at that calcar level, and then supplement my fixation with screws, cannulated screws. Thank you.
Thank you very much, Mayor. That was a great presentation with very good cases. We have a couple of questions. One is, if there is a comminuted fracture with bone gap, do you use bone grafts?
Yeah, great question. So I tend not to use them in the acute setting. Okay. Yeah, I tend not to use bone grafts in the acute setting. I have used bone grafts delayed for malunions, non-unions. Yeah.
And do you use, what about DHS with derotation screw instead of hip screw? And could you
absolutely. So this, so this last case you can see was a case where I used a sliding hip screw. So I agree. I think a DHS with a derotation screws is a possibility. My only thought on that is that you've got one that slides and one that is static. So you've got 2 devices which are working slightly differently. And that's why I tend not to use them. That's reason number 1. Reason number 2 for me is that I want spread for fixation. And so I think I can get that with 3 or 4 screws. You saw some of the cases there, most of them with 3 screws, but I try and get as many screws as I can. So I may even use 4 screws sometimes.
Okay. Thank you. Please stop sharing the screen. Sure.
Thank you very much. Thank you for the opportunity.
Thank you very much. So next up we have Professor Vijay Kumar from, he's Professor of Orthopaedics at AIIMS New Delhi. He'll be talking on THR in ankylosed hip. Over to you, Professor Vijay Kumar. Thank you.
Okay. Yeah, good evening to all. Can you see my screen?
Yes, sir. Professor Kumar, you are very welcome, sir.
Yeah. Good evening, Professor Elashhab. Nice to see you.
Thank you so much.
Good evening, all. Greetings from India, from New Delhi, and a happy Republic Day to everybody. So we had our 75th Republic Day today.
Yes, well, if you allow me, please, I want to congratulate our dear Indian professors and colleagues for the happy Independence Day.
Thank you, sir.
Thank you. So, well, thanks a lot to Egypt Orthopaedic Association and Professor Mohamed Elashhab, especially for inviting me to this webinar. Well, I'm going to talk on basically total hip replacement for fused hips, which is quite common in our part of the world. Well, the most common cause of hip ankylosis in India is ankylosing spondylitis. But in addition to this, other inflammatory arthritis, also post-tubercular cases, post-septic arthritis cases also land up into a hip ankylosis. Post-traumatic arthritis also results in ankylosis, but not a bony ankylosis, but it's a stiff hip. And surgical arthrodesis are rarely seen nowadays. Well, a fused hip is a very challenging situation. Most of these ankylosing spondylitis patients or inflammatory arthritis patients are young, and in many of fused hips, it's not the pain, it's the problem related to the function, posture, and walking and locomotion. That is the problem. They have challenges with respect to positioning the patient on the OT table. You need to be there. The chief surgeon need to be there. At AIMS, we have had, a couple of fractures. In these patients, their patients are osteoporotic. So, one time I remember we broke the neck of the other side of the hip, while positioning the patient. So you have to be very gentle and be there while positioning these patients on the OT table. Component positioning is a challenge because of the spinopelvic issues with these patients. And moreover, once you do it, these patients sometimes don't regain the full range of motion as is seen in other, hip replacements done for other etiologies. There is a very high incidence of ectopic bone formation as well as re-ankylosis. Preoperatively, one needs to get X-rays, especially of the cervical spine done. A full anesthesia workup is required. You need to get a pulmonary function test done. The whole spine X-ray is required in most of these patients because sometimes, there might be an Anderson lesion. So if it is there, then, you need to take opinion of your spine surgeon, and maybe that requires precedence over your hip replacement. We have had a case in which, there was a fracture of the spine post total hip replacement, which we did not, anticipate and had not seen before. We did published it also. Other than that, sometimes the spine is quite deformed. They have big kyphosis, and sometimes, you need to do a spine surgery first. So if any spine osteotomy is required, that needs to be done first, then hip replacement, unless the hips are so badly deformed that it is not possible to position the patient on the table even for a spine surgery, then maybe a hip replacement may be done. Otherwise, a spine osteotomy should be done prior to a total hip replacement. Right? Preoperative templating is of utmost importance. It tells you where to put the cup, the size of the cup. Exposure is a little difficult. Most of us are, do posterior approach, but in these patients who have abduction and external rotation deformity, maybe a direct anterior approach, if you are conversant with, is a good choice in these patients who have got who are fixed in, abduction and external rotation. Otherwise, you can go ahead with a posterior approach. The sciatic nerve is very close. You need to be cognizant of this fact. Once you have exposed it, you expose the pubofemoral arch. That will give you an idea where to do the osteotomy. You would require to release Gmax in most of these patients, and sometimes adductor release is also required. If you only do posterior approach, then there are combined approaches also described in which you go positioning the patient laterally, and you can go to a combined approach, go anteriorly, do an osteotomy, and come back posteriorly and do the hip replacement thereof. So this is a small video. So once you have exposed the hip, you see the pubofemoral arch, you feel for it. And now you need to be very careful, expose it gently, and you can use saw. And while using the saw, you have to be careful that you don't, cut the anterior column specifically, especially in patients who are externally rotated. This interval is not so good. Here in this patient, we could see easily because it was not in so much of external rotation deformity. So you need to be careful and use a smaller saw bone. Once you have released the other cortex, use a sharp osteotome to just cut it. And once you have, and at this time, be gentle with it. Ask your assistant not to rotate the hip. Just let the hip lie where it is, because once it breaks, it will just break like that. And your osteotome has to be sharp, otherwise you will fracture the other cortex. So once this is done, you can then take the definitive cut on the femur side using the template for the stem, and then the femur side is usually straightforward. Then coming to the acetabular side. So initially after exposure, the first reamer, you have a plate of bone. So you just need to make the cup there. So the first reamer is straight going down, And here you have to be careful that you don't damage the column. Use the smallest reamer size, slowly increase the size of the reamer. You need to appreciate after doing 3 or 4 reamings, you would start once with your direct straight reamer, you would start seeing some soft tissue in the fovea. That means you have reached the true floor. Then slowly increase your size of the reamer. You may use intraoperative help in terms of imaging such as radiographs or fluoroscopy. We always have fluoroscopy available when we are doing these cases. There is a technique to drill a hole in floor to assess the bone thickness also, but most importantly, you always see the soft tissue in the fovea, and then you come to know that you have reached the true acetabulum. Do not over ream. You preserve both the columns, and you save the superior, this column of bone here. That's from 10 o'clock to 2 o'clock. This helps you, prevent your putting your cup in too much of vertical orientation. And don't be hesitant to use fluoroscopy, especially when you're doing these fused cases. Because if you don't, you might end up putting a cup too lateral. And the second issue is that in most of these patients, especially in ankylosing spondylitis, they have got a kyphosis. So the hip is opened up. So if you see in a kyphosis hip, it is pointing anteriorly. All right. So basically it is stuck sitting in terms of spinopelvic issue. So you have to be careful and, put your cup in less anteversion. So this was described way back in Tang also. A and B are the normal hips as we see, whereas in Angspond or fused hip who have got kyphosis, so it is C or D, it is in hyperextension basically. So if you see your x-rays also, the x-rays will show operator foramen which are elongated, right? So you need to be careful and put your cup in less anteversion in these patients, because if you, as has been shown here, because if you place your cup in using the anatomical landmarks, you would end up in, anterior dislocation of the hip. And this is another study recently published by CMC Vellore, in which they have found that most of these patients with ankylosing spondylitis were found to be in a position of stuck sitting, around 64% of their patients. And here, you need to reduce your anteversion of your cup. As far as the choice of implant is concerned, most of us use cementless implants. And nowadays, you should have a lower threshold to use dual mobility in patients who have got severe spinopelvic deformities, and we have been using modular stem like SROM also, which helps us bail out of these situations when we are anticipating some sort of postoperative dislocation, or we are not very sure of the placement of the components. So just few examples. So this was a fused hip in which a standard total hip replacement was done. This is another hip in which a fused hip post-septic sequelae, I think, in which another, and here we used SROM. The advantage of SROM is, if a patient later on requires a revision for instability, you can just, and if it's on the stem side, you can just take out the stem and change the version. So sometimes because they have associated deformities also, and this is an interesting case which came to us. Somebody had done osteotomies on both sides for a fused hip, and it broke below here. So they came with this sort of non-union. This was the time that the patient came to us. Somebody had put in a locking plate, still it did not heal. And if you see here, the good part was I don't have the CT scan, but there was a fusion between the lesser trochanter and the ischium also. So, you need to be careful for that also. So when we opened up, we had to, in addition to doing a neck osteotomy, also, do an osteotomy here. And we used a strong stem with a long stem along with the plate and a lot of bone graft. And this went on to unite. So we did one at a time in these patients. Normally in ankylosing spondylitis, we do bilateral together, but this patient we did first hip, the fracture side, and then again after maybe 3 months or so, we did the other side. So another example of a fused hip, another one. And this is in which a dual mobility was used, a bilateral hip done at the same sitting, a fused hip, another dual mobility. So in addition to, these patients don't have pain initially. However, you need to consider these patients that they might start having some pain post-operatively also. Osteoporosis is a problem, so you need to avoid over-reaming. You can use hand reamer instead. You can use the reamer in counter rotation technique also. Avoid, blunt force while, you're hammering the cup. On the femur side, you should do all the soft tissue releases, anterior capsulotomy. as well as, you should carefully ream and broach in all of these cases. Another example in which, in an angst case, while hammering the cup, we broke the acetabulum and, we had to plate it in prop. So the good, you need to recognize, once you are aware of it, then only you will recognize these things. And if you have anything, you should always have plates and wires with you while you're doing these patients because of the osteoporosis in these patients. Another patient in which wanted to do a bilateral together, but we started on the left side, and if you see introp, I don't have the introp images, but while hammering the cup, the resident hammered it with brute force, and the cup really we fractured the pelvis. So we had the graft, so we grafted it and put a gription cup and did one first side, and then we waited it for it to heal, and then we did this is healed on this side, and then we went ahead and did the other side after 6 weeks or 2 months. Another patient in which, there was a calca fracture. So, here it was, we used a circlage wire to take care of it. So one needs to be careful while doing these patients, they have osteoporosis also. Dislocation is another problem because of the, spinopelvic issues. So you need to put your cup in proper version. In addition to this, sometimes the femur, you tend to put the femur in exacted anteversion also, so you need to be careful for that also. There might be impingement of the prosthetic neck or greater trochanter posteriorly, especially patients who have got persistent external rotation deformity and there is a contraction of the soft tissues. So this is another couple of examples. These are quite old X-rays in which we had early dislocation. So another important thing is to counsel these patients that, they might be, they may initially have good range of motion, but, there is a tendency for them to lose motion also. This is because of re-ankylosis. Very high rates have been described, and heterotopic ossification also. And it is, we should start some sort of prophylaxis in terms of endomethacin for these patients. To conclude, these are challenging patients. You need to preoperatively plan, especially you need to get all the X-rays done, especially X-ray of the whole spine. A pre-anesthetic checkup is of utmost importance in this pulmonary function test. Most of them have bilateral fused hips, so you tend to do both of them together because of the difficult anesthesia. Also, your surgical technique has to be meticulous, and you need to do some sort of postoperative prophylaxis for your heterotopic ossification. I thank you for your attention. And, these are the most grateful patients. I should mention that, once they have restored mobility, they are they are really, really very, very grateful to you. I thank you for your attention.
Thank you so much, sir.
Thank you very much, sir. Please stop sharing the screen. Thank you. Do you have any questions, any of the panel? No questions from the delegates, actually. If not, we'll move on to the next talk. So the next up is Professor Shivakumar from Madurai, from the state of Tamil Nadu in India. He has been past president of Orthopaedic Association of the state and is a consultant and chairman of Preeti Hospitals, Madurai. Professor Shivakumar, please. Thank you.
You're muted.
Unmute yourself, sir.
No. That's not. Yeah. Yeah, that's something. Yeah. Yes. Are you able to see?
The presentation has not started yet, sir.
Are you able to see now?
We can see your screen, but the presentation has not started. Can you double click again on it?
For me, it's sharing, sir.
Okay. So we can see your screen, sir, but not the presentation.
Yeah.
Yes, now we can see, sir.
Yes, sir. Yes, sir.
Good evening. Happy to share my topic on this Independence Republic Day with a special thanks to Dr. Srinivas and Dr. Mohamed. Thank you, sir. I think this topic is more easier, simpler, at the same time a very common scenario which everybody should be understanding. And the concepts of it, like the fractures around the hip, when to do a primary THR and the acute fractures, the concepts, the decision making, and the a few techniques will be focused on this lecture. So the acetabular, the fractures around the hip will include the acetabular fractures, head of femur fractures, neck femur, and intertrochanteric fractures. And first, coming to the acetabular fractures, you all know pretty well that the OR, open reduction internal fixation, is the standard of care in acetabular fractures, with the post-traumatic arthritis mounting up to 44% and the conversion rate up to 22%. But in practice, commonly, we almost have all the patients of acetabular fractures, some or other, in a delayed way. Earlier, they come for total hip replacement. So up to 50 to 80%, they come for total hip replacement. These are the risk factors for arthritis after fixing the acetabular fractures, like persistently subluxed head, acetabular impaction, femoral head cartilage lesions, displacement more than 2 centimeters, age more than 40 years, anterior hip dislocation, and involvement of the posterior acetabular wall. They covered very well in the first session. And the indications, the absolute indications for primary THR will be an elderly patient with communicated acetabular fracture, severe articular cartilage injury, persistently subluxed head, neglected fracture dislocation with risk of AVN, thin and compromised posterior wall or column with risk of fixation, distorted anatomy, bone defects, and acute pelvic discontinuity. The implant choices will be highly porous coated multi-hole, revision cups, dual mobility cups, acetabular augments, cage, and fixation implants like plate and screws also will be required in the OR. So the cup placement, when coming to the cup placement in acetabular fractures, the cup placement has to be in such a way that we have to find an intact articular surface to place the cup, and there should be a good bone stock to fix the screws. So whether to put the screws or without screws, whether we are going to place the cup or whether we are going to place the cup with plate and screws, that is going to be the discussion as far as the acetabular fractures are concerned. So this is a small paper regarding the mapping of the stable articular surface, where around 130 acetabulum were studied, and they found that most of the cases, 70% of the cases with the acetabular fractures, the dome was intact. And 40% of the acetabular fractures, there was the posterior area with the bone stock was intact. So this is the paper to show that, and this is the picture to show most of the cases with the gluteal and sciatic pillars. That is, that these pillars are good for fracture fixation. A CT will be able to direct you to understand the bone stock, and you may be able to go for a screw placement in these pillars. Ideally, 4 screws are required, 2 above and 2 below the equator, and inferior screws will be very useful in preventing the abduction angle failure. So, cup without fixation, still it is possible with posterior rim fractures, and the goal is to fix the cup between the subchondral bone attached to the anterior inferior spine and the ischium. Sometimes the cup can be placed in the posterior wall fractures without fixation. And this is the picture to show that a good AP cap is sufficient. And these are the posterior wall fractures, just to show as an example. A cup with additional fixation will be required in cases where both the columns are involved, where there are associated fractures, T-shaped fractures, transverse fractures. All these cases may require an additional fixation and will require an additional fixation with the plate. And then you may have to go for a cup position. And this is the surgical approach. The technical point will be the posterior approach. You have to use the femoral head to achieve the spherical socket and aim for 1 mm press fit with a highly porous coated multi-port cup. The dislocation rates are higher in acute acetabular fractures. So it's better to increase the anteversion 5 degrees more. So that's a technical point, and defects can be managed with bone grafts taken from the femoral head. It's a case example, a case with the T fracture with the neck of femur fracture in a 70-year-old male, and the patient has been done, because no other option, the patient has been done a plate fixation and the THR has been done. So this is another case, a 46-year-old male where the patient has been done a posterior fixation but failed, and the patient came to us 4 weeks following the surgery. And this is the case, and we can, as the CT, in the CT, you will be able to see the implants. Some implants are there in the acetabulum. A large butterfly fragment is there in the superior aspect of the acetabular wall, which is displaced, and there's a persistent subluxation also. So in this case, it's always better to go, and you have to try to revise. So in that revision, you may not be able to retrieve the acetabular articular surface and bring back to the position by the end of 4 weeks. So here we were not able to do that. So we excised the portion of the fragment, and the head was, see, here we were not able to bring back to the position. You all pretty well know beyond 10 days to 12 days, it's going to be very difficult for the posterior acetabular wall with the fragment. So we have removed that. We have removed the head also, and this head will be shaped based on the defect. A figure of shape, a figure of 7 or figures 6 or whatever it is, you can shape it based on the defect, and then you can put the graft, the femoral head, and you can put the screws, and you can achieve a good acetabular wall using the femoral head. Will be removed, and the final fixation will be done. So this is about the fixation. After you can debulk the head. And you want to cut this portion from there? You have to debulk it. This is the post-operative X-ray of the patient. Coming to the neck of the femur, the indications for THR, I think everybody knows, but what is important is the older patients, active patients with no cognitive impairment, no major medical comorbidities, they are good patients for THR. And Gordon's type 3 displaced, type 3 and 4 displaced fractures, pre-existing arthritic changes, fractures with the combination, and severe osteoporosis. These are the indications. Of course, fixation versus THR. This article gives a good result with the THR group, where the reoperation rate is less than 4%. And in fixation group, the reoperation rate is 47%. And this is the flow chart to show that any undisplaced fracture, neck of femur, we have to go for a fixation, whereas those patients displaced fractures more than 60 years, it's better you go for a replacement, either total hip replacement or bipolar hemiarthroplasty. So this is a case where there is no comorbidity, a 60 years old female, the patient is walking well, the surgery has suddenly fallen down, you'll be able to see the good cortices in the proximal femur. So in this situation, it's better to go for a THR, and THR is indicated in acute situation like this. This is the case with osteoporosis, with the diabetes mellitus, and bronchial asthma. So this patient already has undergone a total hip replacement on the other side, and there are some papers and scientific evidences to say that those patients with a neck of femur on one side is likely to develop a neck of femur on the other side, even though treated for osteoporosis. So such cases will require a THR again. So this is another indication. Total hip versus hemiarthroplasty. No significant differences in the short term. Hemiarthroplasty has advantage of less operative time, low initial cost, and less chance of dislocation. So THR should be considered in patients with more life expectancy. So THR, now coming to the THR for intertrochanteric fractures. Intertrochanteric fractures, the internal fixation remains the gold standard always. But there are certain situations where you are seeing a lot of excessive collapse, loss of fixation, cutout or cut through of the lag screws, and complications associated with delayed weight bearing. So in situations where you have severely comminuted fractures of trochanters in the elderly, pre-existing severe arthritic changes in the hip, severely osteoporotic bone that is unlikely to hold the internal fixation, and basic cervical neck of femur fractures. I think this fracture will not be insisted, but here, what in our experience, what we have found, and after going through the literature, we have found the basic cervical fractures have increased collapse, and there is an increased implant failure rate and a non-union rate of 5%. The implant failure rate is somewhere around 45%. So in such situations, if we are able to do a primary THR, it's always better. So the stem options for THR will be a standard cemented stem, standard uncemented stem, distal loading stem, calcar replacing stem. And the greater trochanter needs reconstruction in trochanteric fractures because failure of reconstruction of the greater trochanter will lead on to an abductor mechanism failure and dislocation. So greater trochanter can be a single fragment comminuted, but with one or more fragments completely comminuted, coronally split. So these are the various implants or choices to be used, either cerclage wires, cancellous screws, cables, and trochanteric fracture fixation systems can be used to fix the trochanter. These are the case scenarios, almost a basic cervical fracture with a comminution. We have gone for a cemented THR, and this is another basic cervical where we have gone for a cemented long stem bipolar. And this is a patient where the basic cervical has failed implant because of the failure of the biology. We have gone for a calcar replacement stem with cerclage wires. So calcar reconstruction, IT and cervical fractures. So it's better we go for whenever there is a calcar deficiency, we go for either a calcar replacement distal loading stem, or we also go for a bone graft, which will be able to peg this calcar or the inferior aspect of the neck into the medullary canal, and we may be able to ream it to produce a stable proximal fit. So this is the example to show the bone taken from the neck to give a good snug fit for the proximal fit. So, and again, we also do the piriformis sparing approach in these trochanteric fractures for the hip, and external rotators are properly repaired, capsule is being properly done, and SS wires will be holding the trochanteric fractures. These are the precautions we take in trochanteric fractures, so that the dislocation rate is very less. The fourth area of the fractures around the hip will be the femoral head fractures. Femoral head fractures, you all know there are 15 4 types, of which type 3 and type 4 are very important, with the head with the neck and head with the acetabulum. So here we may have to go for the replacement, especially in elderly patients with the femoral head impaction and pre-existing arthritic changes. So this is a case very typical of the femoral head fracture, where you will be able to see a head fracture with a dislocation with a posterior wall fracture. So this is the attitude seen. You will be able to see a deficiency of the femoral head, and you will be able to see some fragment within the acetabulum. and the limb is in internal rotation and adduction. So this is the same case. The head fragment was not allowing a close reduction of the fragment. This patient is a 92-year-old gentleman. So this patient was studied by the CT. CT is a beautiful investigation of choice to see the fragments within the acetabulum. It's not a small fragment or incarcerated fragment. It's a big fragment, and it may not allow you the reduction. So this patient, after that, we went inside and found that there's a huge posterior wall deficiency. At the same time, fracture. At the same time, the head also was deficient. So the patient was done excision of the head. So you'll be able to see the defect in the femoral head, and from the posterior wall. So for this patient, the patient was done a fixation, and with a plate, and then the patient was done a acetabular cup placement, and a total hip replacement was done. So the take-home message from the acute fracture scenario and the THR is in acute scenarios, replacement is reserved for elderly patients, severely comminuted fractures, osteoporosis, and the fracture pattern determines what decision you are going to take. So those patients' fracture patterns where you feel that the prepared screw fixation will come with a poor outcome, it's better to go for a replacement. So replacement, it can be a one-stop solution for complex fractures, which allows early mobilization with better functional outcome. Thank you. Thank you for the Indo-Egypt chapter for giving me the opportunity to present. Thank you.
Thank you very much, sir. Please stop sharing your screen. Thank you very much for the presentation. It was excellent. It's a big topic, I know, but very well covered. Thanks a lot. And there are no questions. I think we are running out of time as well. So we'll move on to the next talk by Dr. John Mukhopadhyay. So he is a consultant orthopedic surgeon at Paras HMRI Hospital, Patna in India. And I know this is also a big topic, but it's just an outline. Fractures of the hip, an outline. Over to you, Dr. Mukhopadhyay. Thanks.
Thank you, Srinivas, and good evening, everybody, and Professor. We are going to, basically, the topic is fractures of the hip, an outline, and I am going to really concentrate on the neck femur fractures because I know hip fractures could mean many things, but in the interest of time, I'm going to basically talk about fracture neck femur. And the learning outcomes of this talk would be the assessment of femoral neck fractures. We need to outline indications for internal fixation versus arthroplasty, describe reduction and surgical techniques for internal fixation, and describe potential complications after treatment for femoral neck fractures. I know some of this has been covered, but you must understand that hip fractures are a major healthcare problem. It affects mainly the elderly, but also affects the young. They are usually low energy fractures related to osteoporosis, but what one must be aware is that the incidence is huge. There are almost 1.7 million hip fractures annually. It has the typical bimodal distribution, females more than males in elderly. And the fact that they may have had a previous fracture is not uncommon. In the younger patients, it's usually a higher energy trauma. And the incidence under the age of 50 years in the Western literature is as low as 3%, but I think it's much higher for us here in India. One must be aware of the vasculature and how this is affected in the femoral head. And this is the cause for avascular necrosis in some of these fractures. Remember the bony structure, you have the primary compression and tension trabeculae and the secondary trabeculae, which are laid down according to Wolff's law. And there is a progressive loss of these trabeculae with age and osteoporosis. And this was brought out by Singh et al. In 1970. Coming to the classification of these fractures, you have the AO or the Mueller classification, where these are all 31B fractures, and then they can be further subdivided into B1, B2, and B3. The classification most commonly used is probably the Gardner's classification, where type 1 and type 2 are relatively undisplaced fractures, while the type 3 and 4 are significantly displaced fractures. The Powell's classification looks at the angle that the fracture line extends to the horizontal, and the steeper the angle, the greater the chance for displacement and the greater the risk of failure of fixation. What is important is the perfusion of the femoral head correlates with the stability of the fracture. So an undisplaced stable fracture would have less chances of going into AVN, while a displaced unstable fracture would have a high risk of AVN. It's important to get the diagnosis right, and usually you would get an AP and lateral view of the hip, the AP view of the pelvis and a lateral view of the hip, and also an AP in slight internal rotation. This is important in those with very minimally displaced fractures, and what you don't want to end up with is a patient with hip pain who presents with these x-rays, and 2 weeks later, that's what they come to you with. So this is something you need to avoid. And therefore, if you have an elderly patient or even a younger patient with an injury around the hip, with pain in the hip, and the x-rays look normal, I think today one would get an MRI or a CT to make sure that you're not missing a fracture which is not visible on the x-rays. The management, again, really depends on whether the patient is young and physically fit or whether he's elderly or not. Okay, so in the young, you want to do urgent reduction and fixation. The quality of reduction is critical, and you must have a low threshold for open reduction. And this was brought about by, sort of mentioned by Dr. Acharya in his talk. While in the elderly, you have to plan early surgery after medical optimization, and you have to decide between fixation and replacement. So the timing of surgery in the young is urgent, okay? Ideally not in the middle of night, but when optimal conditions are available. While in elderly, you want to get medical optimization and try to operate within 48 hours, as there are a number of studies which show that they have better results with that. Now, the choice of treatment could be internal fixation, and usually cannulated cancellous screws are the ones that have been most commonly used in the past. There is an indication for a screw with a side plate, like the dynamic hip screw. And today you have some more recent methods of fixation, which I will go through. And for arthroplasty, the option is between a hemiarthroplasty, which could be unipolar or bipolar, or a total hip arthroplasty. So what about conservative treatment? There have been studies, especially from Scandinavia, about conservative treatment for valgus impacted fractures of the neck of femur. And this is a possibility. This is a patient who actually did well with conservative treatment, but this was because he refused surgery. Otherwise, we tend to put in a couple of screws to fix the fracture so that you do not risk displacement of the fracture, and this is known to happen. Once you have a displaced fracture, the choice of treatment depends on the general and biological conditions. Can the patient tolerate failure? You have one chance to get it right in some of these elderly. So you don't want to do it unless you're sure that your fixation is going to work. So you have to choose between internal fixation and arthroplasty. And in the elderly with displaced fractures, it would usually be an arthroplasty. If you're planning to fix it, you need to reduce the fracture. You have to have a low threshold for open reduction. So try a closed reduction, maybe once, maximum twice. And then if you can't do it, you must go on to an open reduction. Okay, if you have to do an open reduction, what are your options? You can do the Smith-Peterson approach, which was again shown by Dr. Acharya earlier in his talk, or you can do it with the anterolateral approach with the Watson-Jones. The advantage being in that is that you can do your fixation through the same approach, while in the Smith-Peterson's approach, you need to do another approach for your fixation. However, for basal neck fractures or for very subcapital neck fractures, the Smith-Peterson approach gives you a better visualization. whatever you do, it is important to get your reduction so that your angle of your screw is right. You can't afford it to go in a different trajectory. So you must get a straight trajectory even on the AP and the lateral with your screw fixation. Now, what do you use if you use cannulated screws? I think the most common method that is followed is an insertion of 3 screws which are parallel in an inverted triangular configuration. Okay, so this is what is most commonly used. You would use a 3-screw method in an inverted triangle position such as this. The other option which has been commonly used in the past is a DHS with a cannulated screw for a derotation screw, which is what is probably preferred in the older patients if you're planning internal fixation. Now, what are the problems with the cannulated screw? So the moment the bone is not very strong, there will be some back out of the screw and the whole implant with the head can toggle, or in osteoporotic bone, the head can just go off the screws once the implant backs off a little bit. So that's the basic problem with the cannulated screws. People have even suggested 4 screws in where there's posterior comminution. Today, we would probably consider something with a side plate if there is posterior comminution. That it doesn't heal in adequate time. So here's a fracture fixation which has been done reasonably well. However, you can see with time how there's collapse, and this goes on to heal, but you can see by the time it heals, there's a significant shortening and a reduction in the lever arm of the abductor mechanism. So it does not bode for very good function in that hip. And this is what you want to avoid with other methods of fixation. And today there have been various methods of fixation which have been tried. One of them is the use of the so-called Powell screw, where you compress with the 2 screws and then put a screw across to the calca. And this is possible if it is a very vertical fracture line, which if it's a really subcapital fracture, this is not possible. But we've tried to do something like a Powell screw, where we've used 2 screws to compress the fracture and another screw obliquely going down to the inferior part of the head. And in this particular case, it did quite well. So this is the initial postoperative X-ray, and this was the follow-up. You can see she's done well with a good function as well. So this is a 2-year follow-up with her doing quite well with this fixation. The other method which has been propagated, especially in the US, is the use of this medial calca plate. And this was again shown by Ms. Acharya. And this is not something we use very often. There's one case where we used it, and this was a very unusual type of fracture dislocation of the hip, where we had an acetabular fracture involving both columns, plus a posterior fracture dislocation, where we had to go back, do an open reduction, fix the posterior column. So at the same time, we put in a sort of a plate on the medial side of the neck, as you can see there, and we use this sort of parallel screws plus a screw at a different angle to prevent excessive collapse. And this actually went on to heal quite well. This is about a 2.5-year follow-up on him. And he is now 8 years down the line and he still hasn't come for a hip replacement. Another method which has become quite popular is this BDSF technique, which is described by Filipov, where one screw is put at a very acute angle from low down in the shaft onto the upper part. So again, something we've tried, very successful in this case, as you can see, but not uniformly successful. I think the risks of AVN, etc., still remain the same. They're related to other factors such as the quality of reduction, the time since the injury, and the initial displacement of the fracture. There have been some newer techniques which have come off late, including the Targan fixation system and the Conquest FN system, which again allows some collapse but not excessive collapse. These two have not yet come to India, but the new kid in the block, which is the AOFNS screw, which is the femoral neck system, is there, and this is something which we've used a fair amount of times already with reasonable results. It also has its failures. You can see here this patient with a neck femur fracture. This is the position at reduction. This is the implant assembly. Relatively small incision. You need to get a good fixation, and then this goes on to heal quite well. Again, as I mentioned, this is the follow-up at about 2 years with this patient still doing quite well. Of course, you need to get good reduction, and it's not always possible by closed methods. And in this particular patient, we had to do an open reduction. Here we do a Watson-Jones approach. And again, you can see as we get onto the capsule and inside the capsule, you can see how the hematoma rushes out of the place. And then you need to use various methods to get your fracture reduced. You can see the fracture from there. Put in your provisional K-wires. And in this particular case, again, we use the FNS. And this you can see has gone on to heal well. Coming to the elderly, I think, as I mentioned, the choice is between fixation versus arthroplasty. If it is an older patient with a displaced fracture, most of the recent papers support arthroplasty because otherwise there's a high failure rate and reoperation rates after fixation. And this has again been mentioned in the previous lecture by Professor Shiva Kumar. The advantage of the arthroplasty is that it allows immediate weight bearing, eliminates avian and non-union, and significantly reduces the incidence of reoperation. However, there are some disadvantages that you have a slightly greater infection rate, more blood loss and a longer operative time, and possible increase in early mortality rates. And of course, if you get infection, it is a disaster. The issues that crop up here are hemiarthroplasty versus total hip replacement, bipolar versus unipolar, or cemented versus uncemented. I think some of this has been covered, especially hemiarthroplasty versus THR. I think patients with who are very fit and have a long life to live, and you have a fracture which is displaced, which is unlikely to succeed with fixation, you might opt for a THR, including patients with pre-existing hip disease, etc. Okay, now monopolar and bipolar, I think we've been using bipolar for a long time. However, the costs of the monopolar are less and probably do reasonably well over a period of time. However, a lot of recent papers have said that the bipolar is probably the best way. Cemented is now today considered much better than uncemented femoral stems in these patients because they are usually elderly and the bone is not of a very good quality. So cemented gives a better result and allows you to walk much earlier with full weight bearing, and it also reduces the risk of periprosthetic fractures or intraoperative fractures. You need to avoid complications with cements, and I think you have to make sure that the patient is adequately perfused and oxygenated before you start using your cement. Ensure the cement is adequately cured. Make sure you use lavage and decompress the shaft with a tube, and use a cement stopper to get good cement pressurization and cement from distal to proximal. So in the elderly, the decision making is if the fracture is displaced or not, how young and active is the patient. Operating sooner is better once the patient is stable, and must manage any coagulative problems. So all these factors need to be taken into consideration before you make your decision on what to do with these patients. So the take-home message is you need to achieve anatomical reduction if fixation is planned. Young patients require timely surgery, which means not emergent but urgent, with anatomical reduction and stable fixation. Older patients need early predictable mobilization. So you have to decide between arthroplasty and fixation and make sure that these patients are medically optimized before you do your surgery, but try to do your surgery as early as possible. Thank you for your patient listening.
Thank you very much. Thank you very much for the excellent presentation with all the new techniques on fixing the neck of femur. There are no questions on this one. We are also short on time. Let's move on to the next talk. We have a series of 3 pediatric hip talks. First one by Dr. Manoj Padman, is a consultant pediatric orthopedic surgeon at Fortis Hospital, Gurgaon, and Rainbow Children's Hospital, New Delhi. Dr. Manoj Padman, please. Thank you.
Good evening. Can you see my slide?
Yes.
Yes. Yeah. Good evening, everyone. It's a wonderful initiative by the Egypt Orthopaedic Association. And I thank Srinivas and Professor Elashhab for this opportunity to kind of interact on this platform, talking about everything A to Z of the hips. An ambitious initiative. So my remit here is to talk about pediatric femoral neck fractures, just focusing on acute fractures. And during the course of this talk, I'll take you through a little bit of epidemiology, how common or rare it is, the anatomy with relevance to its blood supply, which is always a dreaded complication, avascular necrosis, classification and how it helps management, and when managing these, what are the factors that as a surgeon under your control, what are the complications that one needs to be aware of, and finally I'll round it up with a few tips in terms of tips and tricks to avoid various pitfalls. So they're fairly rare injuries. Of all pediatric fractures, it's less than 1%. If you look at hip fractures as a total, it's again, just 1% of all adult hip fractures. They're mostly associated with high energy trauma and therefore associated with other systemic problems as well. You can have other abdominal trauma, pelvic trauma, which can kind of influence your timing of intervention. And there is no doubt there is a greater potential for complications and poor outcomes. So the critical thing in terms of complications is an understanding of the blood supply around the hip. It changes as a child from the newborn till the physis closes. And depending on where the fracture line runs, it has impact on how the blood supply is affected. As you can well understand through this illustration, a proximal fracture is likely to disrupt all the blood supply. Any fracture line very close to the physis is likely to disrupt the critical retinacular vessels. And there is a clear physeal watershed. It's a medial circumflex, which is the main supplying vessel. But none of these vessels which run through the metaphysis cross the physis. In addition, even if there is no disruption to the vessel, sometimes minimally displaced fractures can have a significant capsular hematoma, which can cause a tamponade and which can kind of disrupt the blood supply as well. Classification, it's a time-tested classification. It's one of the oldest classifications in orthopedic trauma literature. And depending on, it's a simple anatomic classification, and depending on where the fracture line runs, going down from 1 to 4 is from physeal as it extends down to the intertrochanteric region. 1 being transphyseal, 2 transcervical, 3 it's further down the base, cervical trochanteric, and 4 is intertrochanteric. Now, this classification has a direct bearing on how the outcome is. Transphyseal fracture, sometimes associated with a dislocation, is very rare, and it's usually seen in much younger children, infants and younger children. Beware proximal femoral epiphyseal, which you may see in neonates, and beware of this happening in birth injury. And sometimes it may present as a consequence of a septic hip. But the critical thing is there are very high complication rates associated with it simply because of the location of the fracture line and its impact on the blood supply. One needs to bear in mind, someone who's not familiar with this sees an X-ray like this, which is in a much older child, and you see there is malalignment at the physeal level, and thinks of this as a fracture. This is not a fracture. This is a slipped capital femoral epiphysis. Type 2 is much more common. It's a commonest type. It's usually in slightly older children and often associated with high energy trauma. And complications are directly linked to the degree of initial displacement. So it's really not in your hands at the time when it presents. Complication rates of the order of, in the literature, is about 16 to 75%. This huge range of complications is because of the relative rarity of the injuries, or most of them are case series and things like that. Type 3 is a cervical trochanteric fracture. It's the second most common type. It's again in older children. Complications are relatively rare in undisplaced fractures. So in addition to the vascular disruption, as you go further down to the trochanter, you have problems with union and you can have coxa-vara as well. Type 4 is of all the 4 types is the best prognosis. Again, most of the complications are related to malunion producing coxa-vara rather than avascular necrosis. So when you discuss management, investigations is fairly straightforward. You need adequate X-rays, which are orthogonal views. You want an AP and some sort of a lateral view. Sometimes when you suspect an occult fracture or incomplete stress fracture, you may need advanced imaging like an MRI, but by and large, you don't need it. Other modalities are very case specific and not to be kind of recommended in routine practice, CT scan or an isotope bone scan. It's only in the context of atypical fractures or pathological fractures. Looking at management as such, there are three specific areas that I would like you to focus on. Patient factors. Age has a bearing of how these fractures end up, because it's got a direct relation to prognosis, complications, or outcome. The choice of your surgical technique is involved, namely it's what implant that you will use, and often you'll have to supplement that with spica. But that's not under your control. Injury factors, again, are not under your control because this is how the child would present. What is the fracture type, the extent of displacement, or the initial displacement, or the time elapsed treatment. Realistically, only when the child comes under your hand, you can kind of influence the time. But otherwise, if there is a delayed presentation, these are factors really not under your control. So it boils down to essentially surgeon control factors which have a bearing on the outcome. And when I take you through this, one is timing to intervention. There's no clear evidence, and we extrapolate the evidence from adult fractures in the younger in the young adults, and the convention is to treat it as early as possible. But it may not be so easy because some of them are multi-system traumas, polytraumas, and sometimes the delay is influenced by the overall condition of the child, and you may be forced to kind of delay your fracture neck intervention. In terms of reduction, that's directly under your control. You need to kind of use appropriate equipment, radiolucent table. You really can't fit them onto a fracture table. Closed where possible, but open reduction is you do not hesitate to kind of open up the fracture to get as anatomic a reduction as possible, especially for fracture types 1, 2, and 3. There is very little acceptability range, less than 2 millimeters translation and less than 5 degree angulation with no rotation. You can use adjuncts while you are opening up these sites, because once you do a capsulotomy, the tamponade gets relieved. You can also joystick into the femoral epiphysis to kind of align the fracture, but do not hesitate to kind of open if you need to achieve an anatomic reduction. Fixation, again, is directly under your control. Stable fixation is much more important than physeal sparing fixation. There's always a fear that if you violate the physis, it'll end up producing growth plate damage and consequences, and therefore the surgeon ends up creating an unstable environment, which has been shown time and again causes more problems. So transphyseal screws may be necessary for type 1 and 2, definitely, and occasionally in type 3. Type 4 and some type 3s, you will need a screw and side plate construct, which means there has to be something along the lateral femoral cortex. Smooth pins are to be used in really small children where the screws are too big to be used. So this is a table which kind of illustrates, gives you an overview of how they are to be managed. So it's age-specific management. In the really small ones where you can't put a screw, use smooth wires. Older children in the types 1, 2, and 3, cannulated partially threaded screws. This is by and large your workhorse for most of these fracture fixation. When it moves on to the cervicotrochanteric and the intertrochanteric especially, you need a side plate construct. One critical thing not to be forgotten, however much your fixation is stable, in the smaller children, you need to kind of supplement them with spica. Okay, that's something which needs to be borne in mind. Complications, avascular necrosis, I alluded to. Coxa, which can be a consequence of malreduction or asymmetric growth arrest. Premature physeal arrest, again crossing Coxa or LLD, depending on the age at which the intervention was done. Non-unions, infection, and chondrolysis. Avascular necrosis being the dreaded. I draw your attention to a few literature reviews which have looked at several risk factors which have a bearing on producing complications, especially avascular necrosis. It's the most common complication and it's devastating. The risk factors which have been identified through several articles is the degree of initial displacement. As you can imagine, the more displaced the fracture, the higher risk for avascular necrosis. Fracture types more proximal, which is type 1 and 2, have a much higher risk. In the older children, again, there is some correlation that they produce avascular necrosis that is directly related to the level of trauma, the level of force which has produced the trauma. Delayed intervention has, again, some correlation, 24 hours and more has been shown to have some direct influence on in the incidence of avascular necrosis. There are 3 types. They are relatively rare injuries, so there's not a lot to comment about the prognosis when it happens. Usually it is evident within the first year after fixation. There is some role about if you strongly suspect that there is an element of avascular necrosis, whether intraosseous bisphosphonate can be injected into that pre-collapse. This is based on some evidence from the study of Perthes disease as well as adult AVN. Now, if I can take you through the pitfalls which needs to be avoided, there's a summary of how to manage these fractures. Misdiagnosis. It'd be surprising the number of times these fractures get missed. One is because of other distracting injuries, because some of them present with major multi-system trauma, or sometimes it's relatively low energy, and you can have child presenting with thigh or knee pain, and nobody has evaluated the hip. This was unfortunately a case which presented to my own hospital, presented with knee pain, was sent back from the ER because the treating ER doctor had evaluated the knee with an X-ray and said that it was soft tissue injury. And 6 weeks later, she presented to the outpatient department with this fracture. So it's not uncommon. Mistaken diagnosis. And so here is, as a general rule, these fractures are high energy injuries. So if you see a very displaced fracture with relatively low force, as in this particular instance, a child who stumbled and fell, presented with hip pain and ended up with this fracture, which shows not just a fracture, extensive neck resorption. So this is not a traumatic fracture. So this is a pathological fracture. And this ended up subsequently on evaluation to be a non-Hodgkin's lymphoma. So you need to bear in mind that hip fractures can occur with minor trauma, which are pathological, and therefore the primary disease needs to be factored in, which can be a metabolic bone disease, cystic lesions, fibrous dysplasia, infection malignancy, and Langerhans cell histiocytosis. These are the common things. Perils of conservative management, they really have no role unless it is a truly undisplaced incomplete fracture. Like, for instance, this is an intertrochanteric fracture. The fracture line is incomplete, and certainly there is no amount of displacement. This does well with a conservative management. As opposed to this was an undisplaced fracture, but the child had a lot of metabolic problems, and it was initially treated conservatively for stabilization of the metabolic condition, and 10 months down the line ended up as a non-union. So as soon as the metabolic condition is optimized and there is no higher risk for anesthesia, these need to be treated surgically. So conservative management in fracture neck of femur has very little role. There are a few myths that open reduction is linked to poor prognosis. Absolutely no. Anatomic reduction, whether you achieve it by closed or open, that's a critical thing. For fear of open reduction, if you accept a non-anatomic reduction, then that's likely to be a worse outcome. There is a fear of the physis because any implant going across the physis is imagined to cause a greater risk of growth arrest. However, the bigger problem is compromised fixation and inadequate stability. So stable fixation is much more important, and if that means crossing the physis, so be it. Technical errors, usually inadequate reduction and inadequate fixation. A couple of cases. This is a relatively undisplaced fracture. You have enough amount of femoral neck to put screws well short of the physis, very well reduced and very well fixed, and goes on to heal without a problem. As opposed to this particular case, you can see it's a transcervical fracture, so there is not enough hold in the femoral neck. But the surgeon chose to go across the physis, but as you can see, this is a varus reduction, and it's just a matter of time. Varus and the rotational profile is not correct as well. This is bound to fail, and this can have catastrophic sequence. So these are technical errors which one needs to avoid. You need to get it as anatomic as possible. That's the critical thing. Adjuncts which can help you in terms of getting a good outcome, early intervention. So once it comes to you, if the overall condition of the patient is stable enough, intervene. Capsular decompression has been shown, even if you do a closed reduction and fixation, capsular decompression has been shown to help you in reducing avascular necrosis. The critical thing is biomechanics. Mechanical stability is the key, and this would apply not so much in primary fractures, sometimes late presenting fractures. Let's say, the case which I showed 6 weeks down the line, which are like not exactly fresh fractures, and you need to get your biomechanics right. Putting graft across or a fibula strut is not the solution to that because it's a mechanical problem. So you consider all your parameters here. They are presenting delayed. There is a potential for compromised vascularity. It's a vertical fracture line. You need to see how you're going to reduce it and how you're going to achieve it, how you get a stable construct what sort of implants are you going to use. And here it's much more important to kind of reduce the shear stress across the fracture line by converting the fracture line to a more horizontal fracture line. In this particular case, we didn't open up the fracture site at all. You don't need to get your biomechanics right, and they go on to heal very well with a valgus osteotomy. This does not apply so much for primary fractures, but the slightly delayed presentations, you will need to make a call. That's 4 months down the line. She's gone on to heal. She's now more than 6-7 years since the initial surgery. The implants have come out without any untoward problems. Where biology is poor, and if they're late presenting, and if there are issues, grafting is an adjunct, but almost always needs a supplemental spica. The story does not end with fixation. The spica is necessary in the younger child, as I alluded to. However much you feel confident about your fixation, protect it with the spica. Progressive weight bearing after evidence of radiological union, and usually they can return to activities by about 3 months. Screws are removed because we don't like to leave them in and around the joint in children, and they need to be followed up until skeletal maturity. Certainly, avascular necrosis one can't rule out until about 12-18 months, but you want to look at the impact of growth arrest and things like that. So you need to follow them up at least till they are about 12-15 years. To summarize, it's a rare injury with potentially devastating complications. Some of the factors are not under your control, but there are certain surgeon control variables which you need to be aware of. Injury patterns influence the outcome, and so you don't have any control over it. Recognize the surgeon control variables, and if I could say 2 specific points which need to be reinforced, if I had one single take-home message from this, it's anatomic reduction, whether it is closed or open, and stable fixation. Thank you for your attention.
Thank you very much, Manoj. I think there's one question. If you can answer that online, please. We have overshot the time now. We'll move on to the next presentation. Can you please stop sharing? Thank you. The next talk will be Dr. Mandar Agashi from Mumbai. He's Director of Children's Hip Preservation Clinic. He will be talking on slip capital femoral epiphysis. Dr. Agashi, please. Dr. Agashi, are you there?
Yeah, just one sec. I think there's some problem with the sharing of the screen. Just give me 1 sec. Sorry. Dr. Srinivas, sorry, can you just go to Dr. Rujuta Mehta if possible? I'll just come back because there's some issue with the sharing.
Okay, we'll move on to Dr. Rujuta Mehta. She is a consultant pediatric orthopedic surgeon at Nanavati Max Super Specialty Hospital and Jaslok, and she'll be talking on DDH. Dr. Rujuta, please. Thank you.
At the outset, I'd like to thank the organizers for inviting me in the middle of the who's who of hip every day. Is everybody able to see my screen?
Yes, please.
Thank you. So, a lot of talk will happen about the adult hip here, and literally THR is a very, very popular branch. But I'd like to begin my talk with this tribute to Dr. Dholakia, who was the father of arthroplasty surgery in India, who said that unlike a prosthetic arthroplasty, in which we need to function only for a few decades, a dislocated hip in a child needs to last a lifetime, and thus its treatment should be taken with a great deal of seriousness. And particularly so, I think, in our countries because it is commoner in the girl child. We'll try to cover some ground here. We may not be able to go into all details, but broadly, I'll be talking about what to do with the pre-walking age group and what to do when they come in the late presenting age group, that is beyond 1.5 years. So now we all know that DDH is actually a huge spectrum of disorders, and we know it could be right from a small subluxation to a very well-established dysplasia. And while looking at the history, I think what in recent years has really gained a lot of limelight is the history of swaddling. While all the other factors are pretty much known, one thing which is very surprising is that the incidence in India certainly seems to be high, maybe because of practice of swaddling. And we all know the other risk factors, so we will not go into detail, but suffice to say that it's not enough to just look at an X-ray or just look at a sonography and say that, oh, it's a DDH and it needs to be treated with a Pavlik harness. You need to go into all the details of the clinical history. A bit of a word about safe swaddling practices. I think this is something which all NICUs, all pediatricians, all primary healthcare workers and family members need to be really counseled about as to a potential hip dysplasia, which definitely gets worsened by this tight extension and adduction swaddling, which is done for neonates. And in the first 6 weeks, it's very crucial that we allow the developing hip to remain in something like the hip spiker position or in the Pavlik harness position, where the femoral head then articulates with the developing acetabulum, and as the child kicks, it remodels and molds the acetabulum in the correct way. For those of you who are interested, we have already published this in the JOIO. And let's look at clinical presentations. So we know that there are asymmetric thigh folds, a shorter thigh on that side if it's a unilateral hip, decreased abduction of the hip, and these are the signs which present. But in a very small infant, beware of the painful hip, which may be a septic hip actually mimicking a DDH, especially when the baby is crying only while changing diapers. Even low rates of sepsis can be a septic hip sequelae, or a septic hip which will mimic a DDH. And in infants, of course, you will see many more signs where you will see a widened perineum as well and tight adductors. As the hip remains more unreduced, we have more and more manifestations. But these are soft signs, really is speaking, because you can have very chubby babies having a lot of thigh folds, and it depends on how you keep the the thighs, how you pull them together. So instead of that, what is really important to remember is that if you have, especially in a unilateral hip, when you compare it to the normal side, if you have a restriction or a limitation of the abduction in flexion, then that is absolutely pathognomonic, and that should alert the pediatrician or the examining nurse to get a pediatric orthopedic consult. Again, Galeazzi sign, this is once the hip is really totally out, it is completely subluxed. If it's unilateral, you will get to see that particular side of the knee, which is lower in the AP sort of projection. And in the lateral projection, it will be a bit, because the hip has migrated higher. But what is very confusing very often is the Galeazzi sign and the asymmetrical thigh fold. So be careful while you're interpreting this. And if you do see an asymmetry, please ask for an X-ray. Beware of the potential DDs here again when you see a delayed ossification of the capital femoral epiphysis. As you may see that again would be a septic hip mimicking a DDH. The two tests which, however, will really clinch the diagnosis are the Barlow's test and the Ortolani's test in the infant. Barlow or Barlow is like the way I like to say it in Hindi, so that's easier for our postgraduates. It is a provocative maneuver, and the Ortolani or bringing it in test is a test of reducibility. So just to quickly show you, that's the Barlow maneuver being performed in the older child, and that's again you can see the Ortolani where the hip is going in the unilateral child. Similarly being performed here on table. These are tests of reducibility which you can check on table. And this needs a little bit of practice. You need to be gentle. You need to do one hip at a time and just see how less fingers you're using. Because for a big examiner and a very small infant, you can easily push the hip out if it's subluxable. Again, we spoke about some of these signs, and I'm just again showing it to you to impress on the fact that even in an older child, you will get more and more manifestations. If it's a big child who's already walking, you may be able to palpate the mass in the gluteal region, and the femoral head may be felt there. But classical clinching gait is rather the painless limp, which is seen in unilateral cases like in this child up here, or the classical bilateral waddle if it's a DDH hip, which is out on both sides, and the exaggerated lumbar lordosis. In some very late presenting children, if there is a long-standing untreated DDH, you will even see a limb length discrepancy of about 1 to 2 centimeters, and all the other signs are always there. You will see along that wasting also. Now, very often we tend to now, before 6 months of age, only look for sonography. And a lot of people find that it is a little confusing and you need to know the sonoanatomy. So if to simplify it, it's very easy to say that imagine your PBH X-ray view and the sonography film, just turn it upside down and you will see that then this kind of mimics the Hilgenreiner's and the Perkins lines and shows the capaciousness of the acetabulum. And if your femoral head is not fitting in the socket there, then that's a true DDH. There are many parameters on the sonography which also need to be identified, but that I think we can reserve for some other day. Yeah, so that is quickly to show you a subluxation and the lateralization. So that's how a normal PBH should look. And there are several signs. You can see the Shenton's arc, the Hilgenreiner's, Perkins, and the acetabular index. And this is more for postgraduates to know. So what do we do? Let's deal with it pre-walking age. First birth, 6 months, we look at using the Pavlik harness with a very close monitoring. If that does not succeed or fails at 6 months, then you move on to a closed reduction, a hip spica cast, which may be anything between 6 to 18 months that you may actually get a good closed reduction. In cases where you have a very tight adductors which are obstructing the reduction, you may be able to do a tenotomy, sometimes even later, up to 1.5 years, but provided the child has a lot of laxity. Whereas after the walking age, it's usually open reduction, 1.5 years onwards. You need to do the arthrogram on table. Even if you have an affording child who's done an MRI, I think the arthrogram gives you a very good roadmap on table to see what is obstructing the reduction. You may have to add additional procedures like the VDRO and acetabular coverage depending on how shallow the acetabulum is. So let's look a little bit closer about the Pavlik harness. This is how comfortable the children can be. It's a cloth device. It's important to maintain the hips in 90 degrees flexion and 40 to 60 degrees abduction. Monitor it every week for rashes and skin problems, and also monitor it with the sonography post-reduction in a Pavlik harness and every 3 weeks. And then at the end of 6 to 8 weeks, you can start weaning them off. And these are the kind of beautiful results you can get with a Pavlik harness. You cannot even make out which hip was dislocated at birth. So in short, this is a closed reduction protocol. If we should not succeed with a Pavlik harness, then this is how we would be proceeding. We add the adductor tenotomy. If you get a good concentric reduction in a good safe zone, we confirm it with the arthrogram. I'll show you some pictures in the coming slides. Depending on the medial dipole, and if it's stable, we go ahead and give a spica. If it's unstable, then you will switch over to an open reduction there. So some clinical examples, an arthrogrypotic child with a failure of Pavlik harness, as you can see, very high riding hips out there. And before we proceed, remember whatever method you choose, whether it is the Pavlik harness, closed reduction, spike, or open reduction, you must get the hip reduction in this safe zone, which is marked by green, that is 40 to 60 degrees of abduction and 90 degrees flexion. And this is how even in the spica after closed reduction, you should keep your hips. Very often we find that after closed reduction, if you want to confirm and make sure that whether the hip is in or no, we find that it's very difficult to visualize the capital epiphysis here. And at such times, we can do CT scan, single slice through the triradiate. What it can give you, there are measurements described in it in terms of Shenton's arc and lateralization as well. And acetabular indices also can be measured. When all this does not succeed, we obviously have to move on to open reduction. And it is very well known that there are extra as well as intra-articular reductions. All of them have been listed here. We will not go into the details, but we'll take it and as the cases come. So on arthrogram, if you see, this is what is happening. That is an anteverted hip with a hypertrophied labrum. This is your ligamentum teres over there and a clear indentation. That's your shallow acetabulum. Then you have to move on with an open reduction. To show you the same obstacles on MRI. That's a shallow acetabulum, flat acetabulum over there. Lot of tissue in the pulvinar. An anteverted hip excessively anteverted, hypertrophy of the pulvinar fat. Is the ligamentum teres, which is tight and blocking the reduction. That's an inverted labrum causing an hourglass constriction here and some effusion there. The iliopsoas, which again invaginates into the capsule and causes the hourglass constriction. And that's a pseudoacetabular in very, very high riding hips. So surgical indications, as we already spoke about, is this is the way we would do it. Remember all these safe zones, these are the most important take-home messages from here. And quickly to run you through the steps, we usually prefer the anterior incision for the summerfield incision for an DDH. There are descriptions of the medial open reduction, but there are many issues with it in terms of potential damage to the blood supply, and especially if it's a very high riding hip like this, approach itself may be difficult and you may not be able to get it into the acetabulum, and you may not be able to visualize the acetabulum completely, as well as if you need a coverage of the acetabulum, then through the medial approach, it's very difficult. So this is very straightforward. This is the strategy that we utilize for getting the hip in when you do a open reduction. And this is important. I would like to stress upon this, that most important factor is clearance of the acetabulum. After that, you have to ensure that the hip is contained and there are no barriers to the reduction. For the coverage, we will think about whether if it's capacious, then depending on that, there are many types of acetabular osteotomies that can be done. If there is adequate, if there's too much rotation and anteversion, then you need to do a shaft derotation. And basically, depending on how bad the case is and how late the case has come, you have to do a combination of all these procedures and ensure soft tissue stability. So that's to show you the position on table and the approach. We infiltrate saline, and those are the structures that we encounter, the sartorius, the rectus, and the iliopsoas. Then you do a splitting of the iliac crest, go into the abductor capsule interval, go right into the joint, and that's the kind of thickened hypertrophy ligamentum teres that you can see. Once everything is cleared, you also look at all the other acetabular structures and even the transverse acetabular ligament if it is getting in your way. Measure the version, derotate adequately, and then proceed with your your capsulorrhaphy. The steps are described here, but we will not wait too much on them for lack of time. Shortening is to be done if you have a very high riding in hip or you have a very tight reduction on table. So you check how once your femoral head is reduced and you've done your osteotomy, how much overlap is there between the femoral fragments, and then slightly snug fit, you do an osteotomy, derotate, and put in your plate. So this is to show you how you do it on table. While you're doing this, make sure that you have transfixed your hip and secured your reduction, and then go ahead. And using 2 K-wires, this is how we like to mark how much we are going to derotate. And at the end of it, we should get 2 parallel K-wires to make sure that you have derotated adequately. Or performing acetabuloplasty, if you still have an acetabular index above 2 years of age, greater than 40 degrees, or a big gap between the femoral head and the unossified acetabular margins, like if it's uncovered, you insert a dura and see. If you can really insinuate it, that means that it needs coverage. And first finish your capsulorrhaphy almost like a vest in pant closure, like a snug fit, and then go ahead with your acetabulum. And that's the kind of result that you can get. Post-operatively, keep the spica for 4 weeks, change it again under anesthesia with gentle mobilization, and then change at another 4 weeks and put in a brace. And then with a posterior spica shell, start mobilizing them in the first 23 hours for 6 weeks and 18 hours daily for the next 6 weeks. And those are some of the clinical examples. And that's how good you can get with good range if it's done on time. That's again algorithm summarizing everything that you need to know about an open reduction of the DDH. If those who are interested, we can selectively pass on these slides to the organizers. And no method is free of its complications, and all the more so for the hip. You could have a redislocation if you not derotate adequately. You could have a lateralization, which leads to a gradual subluxation if you have not cleared acetabulum well. If you've not been gentle in your dissection, there is always a risk of an AVN or a stiff hip, and beware of the infection. And if you've shortened too much, you would get a limb length discrepancy. So I would like to stop this talk at this juncture by also adding to the fact that now India has its own DDH care pathway. For those of y'all who are interested, y'all can scan this QR code, and it's for those of you who would like to copy it from the screen, it's given out here. What we have done is, with the help of 13 organizations and BC Children's and I'm a Hippie Foundation, worked it out as to, with every immunization visit, how the pediatricians can actually pick up DDH and refer to us early. And if that happens, we are surely going to see less and less of open reductions and more of public harness reductions. Thank you.
Thank you very much, Dr. Rujita. That was a great talk. There are a couple of questions I would request you to answer on the chat box. We'll move on to Dr. Agashi's talk. Thank you very much. One request to the speakers to keep the time, please. Thank you.
Yeah, thank you, Dr. Srinivas. Am I audible and is the screen visible?
Yes, we can see. Thank you.
Yeah. So thank you, Dr. Srinivas, for inviting me for this webinar. I'll be talking to you about something which is very important in today's age for adolescent hips, which is the slip capital femoral epiphysis. Slip capital femoral epiphysis is one of the commonest adolescent hip disorders, with the varus and posterior slippage of the capital femoral epiphysis. In it, I'll be talking to you about 10 tips about this condition. We diagnose the condition. Sorry. First and foremost, we should be able to diagnose this condition well, and we should not miss the diagnosis. So if you have an obese child with knee pain, always remember that the problem doesn't lie with the knee, but the problem lies with the hip, as the child may have a slip capital femoral epiphysis at the top. So always get a pelvis with both hips X-ray done in every case of suspected slip capital femoral epiphysis. There are many associated conditions with it, such as Down syndrome, hypothyroidism, Cushing syndrome. So always see to it that you get an endocrinologist involved prior to fixation of your slip capital femoral epiphysis. Important is to classify. First is the temporal classification, which classifies it into pre-slip, slip, acute, chronic, and acute on chronic slips. But this does not predict the risk of AVN. What does predict the risk of AVN is the functional or the loaders classification, which says that it is stable if it is able to bear weight, and it is unstable if the child is unable to bear weight with or without crutches. And this has a direct correlation to the risk of avascular necrosis. That is, in stable slips, the risk of avascular necrosis is less than 1%, while in unstable slips, it is between 10 to 60%. We should also classify the slip as per the Southwick's classification into mild, moderate, and severe. We should then understand it is basically a slow type 1 physeal injury, which is between the proliferative and the hypertrophic zone of the anterior periosteum is stripped. And because of this has a large rounding to femoroacetabular impingement and degenerative joint disease. We should plan this. For this, I'll just go for 2 cases. This is a 15-year-old male with left hip pain since 3 months, which was with no significant history of trauma. And the child has just mild pain with restricted squatting. He's able to sit cross-legged. And as you can see that he has an out-toeing gait on the left side. So this is a common condition which leads to an out-toeing gait on the left side with an external rotation deformity and a positive Dremann's sign. As you can see on the X-ray, this child has a clean sign which is positive and a Southwick's angle of about 30 degrees. So this is a chronic, stable, mild slip as we described earlier. But why do these X-ray findings lead to such gait and clinical findings? Well, if you can see the hip, this is what happens in slip capital femoral epiphysis. It is a slow type 1 physeal injury with a lot of callus, and that leads to prevention of internal rotation, and thus the child walks with an out-toeing gait. What happens when a similar hip pathology progresses further? So this is a slightly young child, 12-year-old boy with left hip pain since 6 months and right hip pain since 3 months. And this abnormality has been increasing over time. He's unable to sit cross-legged and squat. And as you can see that he has a severely impaired gait. He's walking almost like a robot, and he almost doesn't have any hip flexion. You can see that he has external rotation deformity of almost 40 degrees, and his flexion is restricted only till about 20 degrees. You can see that he has a very severe slip on the left side and also has a moderate slip on the right side. Again, why should these findings lead to such gait and clinical abnormality? Basically because here what happens is that the slip becomes so severe and the neck becomes so shortened, and this leads to a restricted flexion. And there's this big anterior bump which causes it. And that is the main pathology here in a very severe slip. The other side, because of the coxara, there is significant abductor shortening, and that leads to Trendelenburg gait. So a severe slip leads to an outgoing and a Trendelenburg gait. And at this stage, what are the treatment options? Well, the goals of treatment first should be delineated, which is to prevent further slip progression, restore proximal femoral anatomy, and to prevent the complications of avascular necrosis and femoroacetabular impingement. These are the options which we have. In situ pinning is the gold standard which has been used for time immemorial. It basically means that you don't have to reduce the slip, you just have to fix it as is in situ. So this is how it is done. Usually a single screw is enough. It is gold standard for mild to moderate slips. It's a percutaneous technique with a very low operative time. The treatment is based to prevent the slip and the deformity. And this is a long 8 year of follow-up of a slip. Now an adult did not have any issues at that time. Contralateral pinning can be done in endocrinological abnormalities with very high BMI, or when it's a very young child with more than 2 years of growth left. Is there any method for close reduction? Well, this is the old-fashioned Ponseti method. And there are some people who do this gentle reduction or incidental reduction or serendipitous reduction. Now, these things should not be done. What you can do in an acute and chronic slip, which is an acute reduction and then pinning, by a method known as the Parsh method. So what exactly it is? It is a method where you reduce the slip to a level prior to the acute episode. So if you have such a slip, which is a slow growing process with a callus here, and suddenly the child falls down, and he then has an acute on chronic slip. So what you do is this, you reduce it to a level of chronicity. You don't reduce it completely, and then you fix it. Now this is what it is. You can see that this is an acute on chronic slip. You can see that there is a posterior callus. You reduce it partially and fix it. Now this has a very low chance of AVN, which is only about 5%. The other option is you can do an in situ pinning with an anterior open osteoplasty or arthroscopic osteoplasty. This decreases the chance of femoroacetabular impingement. Or what you can do is you can do an anterior approach, a done or a cuneiform osteotomy. You shorten the femoral neck like so and fix it. However, the treatment of choice over time has changed. This was what was done in the 1960s, but this has led to a very high chance of AVN. What happened was the treatment of surgical dislocation was started by Professor Gans in the early 2000s. And this led to this landmark paper of capital realignment by the modified Dunn method, which improved the safety of the Dunn subcapital realignment with surgical dislocation approach. This is a very robust approach where you do a trochanteric osteotomy, a trochanteric flip osteotomy. You expose the entire retinacular flap, you release the callus posteriorly, and then you shorten the neck and fix it with one screw or two screws and a few K-wires. Relocate the femoral head and fix the trochanter back. This is what is known as the modified Dunn procedure. A brief photo, I think Dr. Professor Trika is going to describe the safe surgical dislocation method, so I'm going to be quick. A lateral approach is used, a digastric flap is used for the trochanteric osteotomy. After the dislocation, you can see that there is a severe bump here. You release the retinacular flap, you do the osteotomy by this method, and then you relocate it, keeping the femoral head blood supply intact. You can see that the femoral epiphysis is relocated, but the head is still bleeding. This is the same patient. You can see that the head is relocated perfectly well. And this is at 1 year, showing excellent healing with no AVN. However, you should remember that this should be an extremely technically demanding procedure. It should be done only in unstable slips in a very good operating room where the staff is familiar and prepared for this procedure. We still don't know whether it should be used in stable slips or not, and it should definitely not be done in the middle of the night with non-orthopedic staff. We are happy to say that this is the first paper from India which we have published, our series of 30 hips for modified done osteotomy. This is the result of one of the patients. This is a severe slip showing excellent healing at 4 years. Thus, finally, to summarize about slip capital femoral epiphysis, the 10 tips. Remember to diagnose it. Don't miss an adolescent who complains with knee pain and start doing knee x-rays. The problem lies with the hip. Diagnose the associated conditions which may be Down syndrome or hypothyroidism. Classify it according to the various classifications of severity, stability, and chronicity. Understand the pathoanatomy and plan and know the goals of treatment. Know about in situ pinning, the method of in situ pinning, especially in mild to moderate slips. Know about the method of Parsh method, which is an acute reduction to the level of chronicity and then pinning it. Strictly avoid the close reduction or the serendipitous reduction. You should never attempt close reduction in a slip capital femoral epiphysis. In case you have to do an anterior open reduction, do it by the Dunn method. And know about the accurate and the safe method, which is the Gans modified Dunn method. Thank you so much.
Very much, Dr. Very good talk. We have currently no questions on this topic. We'll move on to the next talk. It's actually by Dr. Shiv Shankar on 10 commandments, how to get good results with PFN. He's a consultant orthopedic surgeon at Iyer Orthopedic Center, Solapur, and past president of IOA. He's actually traveling at the moment, and he sent me a video. So I'll play the video. So can you see the video?
Good evening.
We can see it, sir.
Outset, I would like to thank Professor Mohamed Elashhab as well as Dr. Srinivas Kambapati for having me here in this international HIP webinar. The topic I'll be talking will be 10 commandments, how to get good results with PFN. A very busy slide. I'll be taking each and every point in the subsequent slides. The first and foremost is good position for a easy entry. The surgeon should be comfortable while operating. Normally, the fracture gets very well reduced in abduction, but when the surgeon adducts to pass the nail, the fracture opens it to varus. So that's what normally happens. Here you can see the fracture is well reduced. On adduction, the perineal post prevents the further adduction and acts as a fulcrum to open the fracture superiorly into varus. So what I advocate is keep the perineal post eccentrically against the normal side ischial tuberosity by taking a small sandbag below the normal ischial tuberosity. In this eccentric position, the nailing will be easy. When you adduct the limb, there will be almost 60 degrees of adduction possible without the perineal post coming in the way to open the fracture into varus. This is called as banana position. In this position, the surgeon can easily pass the nail from the top. So keeping the perineal post eccentrically by shifting it to normal side ischial tuberosity. In the reduced position, I always fix the fracture usually with 2 KVs which are very anteriorly placed. Once fracture is fixed, then you can manipulate and adduct the limb to your convenience and pass the nail medial to the tip of the trochanter or medial to the base of the trochanter in this fashion. And this almost 60 degrees of adduction is possible, and the surgeon will be very comfortable to pass the nail in this position. The second point is good anterior reduction. A widely displaced fracture in 2007 I was operating. You can see that by using a Steinman pin, I pushed the neck down, then fixed the fracture, then made an entry in this patient and did the nailing. So getting a good anterior reduction is very, very important. How I do is normally I pass a Steinman pin into the fracture site and push the one which is lifted up and pull the one which is depressed. So by manipulating the Steinmann pin, you can get the anterior alignment. Once the alignment is good, then you fix the fracture with K-wire and then go ahead with the nailing. So getting good anterior reduction is very, very important. When you don't fix the fracture, then when you try to do the nailing in abducted position, it is difficult. Once you fix the fracture, it is easy for you to do the nailing in adducted position. So the surgeon will be very, very comfortable. The reduction should be 100% overlap at the fracture site. Even if there is a 25% loss of fracture opposition anteriorly, there will be 25% more loss posteriorly, leading to translation at the fracture site, leading to less area for the fracture to unite with one another. I always compare the anterior cortex with the first button of your. The first buttocks are the also come in alignment without any problem. When there is a combination or there is a butterfly fragment, this is the place where these compressive forces are passing from the hip while the patient is loading the hip. So if there is a banana fragment like this, it's better to reduce them by closed wiring technique or open wiring technique and then go ahead with the nailing. Regarding the reduction of the intertrochanteric fracture, we have a beautiful terminology: neutral, positive, and negative cortical support. This is a negative cortical support, which is bad. This is a neutral cortical support, which is okay. This is positive cortical support. The beak can never slip into the medullary canal distally. This is the one which we all should aim. This positive cortical support should be not only in AP, but also it should be in lateral picture. You can see that if this is in negative in lateral also, then the fracture can go into problems in spite of positive cortical support in AP picture. So positive cortical support is both in AP as well as lateral is very, very important. If there is avulsion of the lesser trochanter or fracture of the lesser trochanter, it's better to get more valgus. As you can see, in the void created due to the lesser trochanter avulsion, the beak can still slip in spite of the positive cortical support. So in such cases, I try to get the valgus by about 10 degrees, and it can see there is medial opening of the fracture, but in due course of time, fracture heals without any problem. Never ever accept a beak of the proximal fragment into the distal medullary canal. That's a varus reduction. So in this case, what I did was I used the bone hook and pulled the trochanter out and got a neutral cortical support and then carried out the nailing. This very old X-ray of 2011. And you can see, in spite of a lot of combination, I did the close nailing in this patient, and in due course of time, beautiful callus formed all around the nail. Entry should be proper is the next point. Though we take the tip of the trochanter as the entry, bone on the outer side is more softer. Hence, we inadvertently end reaming more on the lateral side, leading to varus, or the screw position will be improper. If the entry is proper, screw position will be proper. If the entry gets lateralized, screw will be more centrally placed instead of inferiorly being placed. Never ever shovel the nail through the fracture site. This will act as a wedge and this will prevent the fracture surfaces to come in contact. So always make space for the nail by reaming it properly. Then only you pass the nail. Otherwise, it will act as a distractor and cause lateralization of the shaft. As the bone is more stronger on the inner side, it's better to ream with a curved out more on the neck, or even you can use a cheese cutter to ream more on the neck. Take out little bone from the medial side on the neck. Then only use the 15 millimeter or the specific reamer which comes with the set, and then only you pass the nail. So without that, never shovel the nail just through the fracture site. Otherwise, it will cause distraction at the fracture site. So that is very, very important point. This is a 93-year-old lady, the case which I showed the intro picture just now, and you can see that beautifully the nail could be passed and the fracture could be reduced and the patient was comfortable sitting. proper position of the screw is next point. We all know that in the AP, it should be in the center or slightly inferior to the center. In the lateral, it should be in the center or slightly posterior is also acceptable. As this is very well known, I don't want to spend more time on this, talking on this topic. The seventh point is TAD should be less. As you can see in the picture, the most important point is always a subchondral fixation. And since I advocate inferior calcar kissing screw, the TAD might be more if you measure from fovea centralis. So always measure it from calcar, where the extrapolated line of the screw touches the anticlass surface. If you measure, the distance in both in AP and lateral put together should be less than 25 millimeter. The length of the screw is also very, very important. Both the screw, if you are using a two-screw system, should be at the same horizontal level. This article by Julia Henschel, where she has studied different screw position, concludes saying that smooth sliding and least varus malformation happens when both the screws are at the same horizontal level and the next screw is subchondrally placed. So this is the diagrammatic representation. When the hip is loaded eccentrically, what happens is if both the screws are at the same horizontal level, both of them slide simultaneously. If the superior is longer and the inferior is shorter, the brunt of the load will be taken when the hip is loaded by the superior screw. That will lead to varus deforming forces, especially if the lesser trochanter is avulsed or if there is a gap medially. Then these varus forces pushes the inferior screw out, and that will cause jamming of the superior screw, and in due course of time, that superior screw migrates inside, and that will cause the Z effect. So if you are using two-screw system, both the screws should be at the same horizontal level. The eighth point is fracture should be well compressed. You can see on day one, the fracture has been adequately compressed. The screw heads are resting against the lateral wall. And at 14 months, when the fracture had consolidated, you can see that the screw heads are still resting against the lateral wall. That indicates that the fracture, whatever the fracture was begging, that compression was achieved on table on the first day itself while doing the surgery. Another example, on the immediate postoperative picture, you can see the screw heads are resting against the lateral wall. At 4 months, when the patient came for follow-up, you can see that there is no backing out of the screw head. That indicates that the fracture has been adequately compressed. If the fracture is not adequately compressed, the screw will be loose. They can toggle and lead to all the complications. Variety of complication can happen. This screw also in immediate postoperative period, it is slightly out. In due course of time, you can see that there is further collapse and the screw breakage has happened in this patient. How I compress the fracture? Adequately after putting the screw, I compress both superior and inferior screw one after the other, and I also release that foot and traction of the orthopedic table at this stage before doing this final compression. I can compress till the time I am very, very happy, and I will be very happy to compress as much as possible in this fashion. This is a case, a 85-year-old elderly osteoporotic patient. The lateral wall is precarious. I pierced through the lateral wall and my screw heads are resting against the lateral wall. Patient was walking comfortably in the immediate postoperative period. When he came for follow-up at 3 months' time, you can see that the screw heads are still resting against the nail, and the nail is working at the lateral wall, and the patient had an excellent outcome, and he was very, very thankful. I got the permission to show his face. He was literally crying when he came for follow-up. If there is lateral wall combination or lateral wall is missing, then what you can do is you can use the nail itself as the lateral wall. So here I can see that I use the cervical screw, the nail itself as the lateral wall, and I have tightened again the nail, and the fracture heals in due course of time. This I call it as Shivshankar's Solapur technique of tackling deficit lateral wall. This is a case of comminuted lateral wall, and again I use the nail itself as the lateral wall. As you can see the intraoperative picture, my screw heads are resting against the nail. This is after 4.5 years when the patient came for follow-up. You can see that the screw heads are still resting against the nail and united well. This case, you can see I'm using a headless screw system. I compress the fracture. Then after compressing the fracture, I put the set screw to prevent the, to maintain the reduction and the compression. And then I remove the jig. as soon as I removed the jig, the fracture opened up, and that if there was a head for this neck screw, probably this would not have happened, and the compression, whatever I achieved on table, could have been retained. That is the reason why this indigenous PFN designed by me way back in 1999, I'm very, very happy. And I have already shown all these cases where I have used the nail itself as the lateral wall, and it has given me good results. This is all because the cervical screw has a head which can be compressed against the nail. Nail will work as the lateral wall. The newer systems like the PFN, PFNA2, Halifax nail, ZNN, all these nails, even the Trajan nail, they don't have the head. So though it is good implant for a stable fracture, for an unstable fracture with lateral wall combination, I don't think you can adequately compress the fracture as there is no head for these newer headless screws. So that is the reason why I'm happy in using PFN with a 2-screw system having head which has been designed by me almost 25 years back. Then the 9th point is the nail should be slightly projecting out at the entry site. Otherwise, it can migrate like a DHS, especially in subtrochanteric fracture. Here in this case, you can see there is toggling of the nail, which led to the further breakage of the implant in this case. So you can build up the nail by using end caps so that it is slightly out at the entry side. The last point is a headless screw, which I don't like normally. If you are using that for whatever the reason, the back end should be slightly out at the entry side so that it can slide when the fracture gets collapsed. If it is inside the medullary canal, then the hole in the lateral cortex may not match and they can cause problem. Here you can see if the back end is slightly outside, it can slide easily. If the back end is inside the bone, it will cause jamming and it will not allow the collapse to happen. This happened in one of my own case where you can see that back end of the screw went inside while I was doing a ZNN type of implant. Friends, if you give importance to all the 10 points which I just now enumerated, you definitely will get good results. Here are some few examples. A 86-year-old man, I used a PFN, and in due course of time, after 3 years, you can see that the fracture has beautifully consolidated and the anatomy has been restored. And the patient is walking comfortably at home without any support. Another badly comminuted fracture, his CT scan was done to know the comminution, and I did the good reduction with good placement of the implant. His immediate postoperative picture, immediate postoperative X-ray, and just to show the bad comminuted trochanteric area in this patient. And this is at 1 month follow-up. You can see beautiful restoration of the anatomy. This is at 4.5 months follow-up when the patient came. And the right side actually has got less functionally less because the neck of the hip has become less. But on the hip, where I have done the PF on the left side, patient is very, very happy with the outcome of the surgery. If the fracture is less comminuted or if the patient is younger, I normally use trochanteric buttress plate. So my screw heads will be resting against the trochanteric buttress plate instead of against the nail, because I might have to remove the implant in due course of time. If it is pushed inside, removal will be a bit difficult. Hence, I use the trochanteric buttress plate. This is after 2 years, you can see that the patient had an excellent outcome. Patient had a residual hemiplegia on the right side, and also there is an elbow contracture. But on the left hip I have operated, patient is walking comfortably. To conclude, I would like to say that give importance to all the 10 points which I enumerated, and I will thank Dr. Mohamed Elashhab as well as Dr. Srinivas Kambapati for the opportunity given to me to share this topic with you. Thank you very much.
Thank you so much, sir. Dr. Srinivas?
Thank you very much, sir. Dr. Shivshankar is actually traveling at the moment and will not be able to take questions. It was a wonderful talk. Thank you, sir, for all the tips.
Thank you very much, Srinivas. Thank you.
Sorry, sir, my picture was overlapping your...
yeah, that's fine. Okay, that's okay.
We'll try and put your picture in the saved format of the video.
Sure, so thank you.
We'll move on to the next talk, sir. So the next is Professor Vijay Jain from New Delhi. He is going to talk on post-COVID AVN of the hip. He is Professor of Orthopaedics at Atal Bihari Vajpayee Institute of Medical Sciences, New Delhi. Dr. Vijay Jain, please.
Good evening, everyone. At the outset, I would like to thank Professor Mohamed Elashhab and Dr. Srinivas for this international hip webinar. And my topic is post-COVID AVN of the hip. So as we all know that the COVID-19 was reported in 2019 and most of the cases were having the respiratory symptoms, but the pneumonia, severe pneumonia and acute respiratory distress was also reported. And most of the patient has received high doses of corticosteroids along with the antiviral drug and ventilating support in order to modulate and inflammation and mitigating the tissue and organ damage. But also they prevent the pneumonia and ARDS. But there are some complications like viral replication, immunosuppression, opportunistic infection, and osteonecrosis of the bone has been reported. So the etiology of the osteonecrosis include traumatic and non-traumatic, and the alcohol and the corticosteroid overuse have been a culprit in majority of cases. So who is the culprit? Basically, whether the COVID-19 or corticosteroid, they are either they are alone, the direct viral injury, or because of the improper use of the systemic corticosteroids, which is cumulative dose dependent or duration dependent. It has been shown by from the paper from the AIMS New Delhi that the low dose of the steroid and the moderate to severe COVID-19 infection produces the additive effect on the development of AVN. And it has also been shown that in the absence of the steroid therapy, patient may have avascular necrosis. So how the virus can cause? There's a virus, as we all know, it is a hypercoagulable state where the number of coagulable agents like fibrinogen, von Willebrand factors, and other factors are also increased, and there are also the inflammatory cytokines like TNF-alpha and interleukin 6 and interferon also increase. So hypercoagulable state causes leukocyte aggregation, and they causes the vessel inflammation and impairs the microvascular blood flow through formation of the microthrombi. Also, the virus can directly infect the some tissue because of the expression of the ACE2 and TMPRSS2 genes expression in various musculoskeletal disorder, which can cause the damage to the bone and musculoskeletal tissue. So the glucocorticoid is induced osteonecrosis is reported to between 5 to 40%, and the greater risk in when there's a higher doses are used, but the short-term exposure to a higher doses and intra-articular injection can also causes the osteonecrosis. So what is the mechanism behind the steroid-induced osteonecrosis is that it causes increased apoptosis and decreased osteoclastogenesis and osteoblastogenesis. Also, then it causes the decrease in the canicular circulation, which can causes the osteonecrosis. So this is a paper which is published after the severe SARS infection, and where the osteonecrosis rate was around 5 to 58% in the femoral head. And this study by the Zahor et al. Showed that at the 7-month follow-up, almost 100% prevalence of the osteonecrosis, and the earliest time to the osteonecrosis was just 2.2 months. Another study showed the increased incidence of osteonecrosis of the femoral head occurs in the male gender with a younger age and total dose of the steroid, and also the use of more than one type of steroid has implicated as a cause of increased incidence of osteonecrosis. And the author suggested that the steroid can only be used in a septic shock or in a critical cases, and those should be minimized, and use of the multiple types of steroid should be avoided. So these also, it has been shown that the osteonecrosis can occur within first month, which is an early osteonecrosis, which is a severe and occurs usually in the hip, or it occurs late within 3 years, which is less serious and can involve the other hips. Also, the risk factor for the progression of the osteonecrosis include larger lesions and less viable lateral column. So, as we all know, the corticosteroid was used. Many patients were hospitalized due to COVID-19, and approximately 1 million of patients received steroid according to the CDC report. And this is the study which is published by the Chinese group, showed overall 40% of the patients of the COVID-19 have received the corticosteroids. So during the COVID pandemic period, several studies were published which cautioned about the use of the corticosteroids in COVID-19 because of the risk of osteonecrosis, and several other studies were published which also describe the musculoskeletal consequences of corticosteroid osteonecrosis. So the concern about the post-COVID avascular necrosis is that the osteonecrosis is usually early onset, and even at very relatively low doses of cumulative doses of corticosteroid can cause post-COVID AVN, and these cases are usually rapidly progressive, and majority of cases they reported are bilateral hip pains, and also the severe patients presented with the higher rates of the femoral head AVN and greater pain. So it is not known that after how many days AVN can develop in a COVID-19 patient with or without the corticosteroid, and also at what doses and durations of the corticosteroid AVN can occur. So there is a marked variability, and I have searched some literature and found that the hip pain or the avascular necrosis can start from as early as 7 to 10 days to it may go up to the 6.5 months in various studies. And also the dose and duration is also very variable for the development of the risk factor for developing avascular necrosis. And even a low dose of 200 milligram can cause the osteonecrosis. And also the duration of the steroid can be just for 3 weeks to 4 weeks. So the first case description, when this paper was published in 2021 by the Sanjay Agarwala, and they have reported 3 cases where the very low dose of the steroid causes the avascular necrosis, and the early AVN presentation was occurred at the 58 days after the COVID-19 diagnosis. So these were the 3 cases, and all these 3 cases were stage 2 avascular necrosis and were treated conservatively by the using bisphosphonates. So this is another study which showed that in COVID-19 patients with or without corticosteroids and 2 years follow-up, they found that the more painful joints occur in the corticosteroid groups, and there was also osteonecrosis was found in 8 of their cases. But they found no relationship between the duration of the treatment, cumulative dose, maximum 1-day dose, and the presence of osteonecrosis. So the osteonecrosis after the COVID-19 can have varied presentation. They can have a classical presentation, or they may have an aggressive presentation with the rapid progression as described by the Dr. Dhanshir Raja in the study. And these rapidly destructive arthrosis can have an acute onset and can have acetabular changes, diffuse periarticular bone and soft tissue edema, and the inflammatory markers are usually high in these cases. And in this study, the author suggested that the low cumulative dose of the steroid in these cases suggests that the COVID-19 vasculitis may have a role in the pathogenesis of the osteonecrosis. So whether in these cases the screening is required or not, there are 2 studies which have recently showed that the screening may have some role in patients who have a high risk, who have received steroid, but it should be done on a case-to-case basis. So this guidelines were made in 2021 by the Chinese group, where the glucocorticoid-induced osteonecrosis, but in which the higher doses were mentioned, but this has no values because even in a relatively lower doses also, the many cases are these days published in the literature, So according to this, they have described the 3 groups: low, medium, and high risk group, depending upon the use of the corticosteroid or not. And in medium and high risk group, they advise for the regular and intensive follow-up and MRI if it is required. So the treatment of the osteonecrosis can be the conservative or operative. So the non-operative management can be non-weight bearing and medical management, including the bisphosphonates, statins, and anticoagulation therapy, vasodilators, and some biophysical management can also be done. But there are early operative treatment options are available, like core decompression with or without some BMAC or PRP or BMP7, or with using the bone grafts, vascularized or non-vascularized bone graft, and late operative options like total hip replacement, arthrodesis, and femoral osteotomies has been described. And these the classification of the osteonecrosis, and depending on the classification, one can decide at which stage the patient is presented. So in stage 1, one can use the bisphosphonate. In stage 2, several other options can be utilized, and in stage 3 and stage 4, patient can have hip replacement. So this is the study published by the Sanjay Agarwala group, and where they shows that 88 of the hips they have received IV zoledronic acid at the initiation of therapy and oral alendronate twice a weekly 35 milligram, and they followed a patient for the 6 months, and they found that only a small number of patients have radiographic collapse and radiographic progression. And a small number of patients, only 4 patients in this study required hip surgery. And majority of the patients at 10 months follow-up had a good clinical outcome, and there's a decrease in the VASC score, and there's an improvement in the Harris score. So it has also been found that there's a likely increase more THR after the post-COVID. There as an indication for the osteonecrosis, and the study showed between 2016 to 2019, 2021, there are increase in the number of the total hip arthroplasty as an indication for the total hip arthroplasty, and most of these cases have the COVID-19 diagnosis. Also, this is a systematic review recently published, has reported that 104 patients, they included 14 studies from 4 databases, and they found that the most of the cases were treated non-surgically and have received medical management, and also the surgery is required in very less number of patients. So, according to the cases, this is
ഇവയൊക്കെ അയൽവാസികളിൽ നിന്നും മുത്തുകുമാർ കഴിഞ്ഞ ദിവസങ്ങളാണ്. എന്നാൽ പോലീസ് സംശയിക്കുന്ന കൊലപാതകം എന്ന നിലയിലുള്ള യാതൊരു സൂചനകളോ ഒന്നും
COVID-19 in 2021 has a rate implemented just in the same, and this has a stage 2 bilateral and has got 12 months for decompression. He consulted, and he had no relief and has started with a bisphosphonate. This is the X-ray at and ultimately autologous cultured osteoblast transplantation in February 2023. And this is a MRI in the July 23 showing improvement. And this is the MRI at December 23, where this boy has joined the duty and has no rest pain, and there is no pain on activities, and has a full range of motion. Another case, this is case given by one of my friend. He shows there's a osteonecrosis of the bilateral hip. Is a 33-year-old male, and he was hospitalized for the COVID-19 and has received a steroid, both oral and in the injectable form, and this patient underwent hip arthroplasty. Another of the same 66-year-old male also hospitalized for the COVID-19 and developed avascular necrosis and undergo the hip replacement. So the take-home message is the incidence of osteonecrosis after the use of steroid is on rise, and early suspicion and detections are mandatory. Screening can be done on the case-to-case basis, and conservative management if done, has a good outcome, and it should be done in the early stages, and surgical intervention is required in the progressive collapse or later stages. Thank you.
Thank you very much, sir, for the excellent talk. I think there are a couple of questions. I would request you to answer in the chat box if that is okay. Please stop the screen sharing. Thank you very much. So we'll, for want of time, actually, we'll have to move on to the next speaker. It's Professor Vivek Trikha from New Delhi, AIIMS New Delhi. He'll be talking on safe surgical dislocation of the hip. Dr. Vivek Trikha, please. Thank you.
Okay, so thank you, Srinivas and Professor Elashhab.
You are very welcome, sir.
It's nice to see you again out here. So my topic is on safe surgical dislocation of hip. And first of all, let's understand why the anatomy is there and what is the vascular anatomy of the hip, which is going to affect the osteotomies. What we want to understand is that the medial circumflex femoral artery has got a greater contribution than the LFCA. In the head, it is mostly predominantly supplied by the medial circumflex, whereas in the neck part, it is slightly equivocal, and both lateral and the medial ones are the ones which are providing it. Where and how the surgical dislocation of hip, it was covered by Dr. Mandaragashe for a part of his in the Dunn's method as well in the pediatric, but in the adult, what we see is when we do a Cocker-Langenbeck approach or a posterior approach, our access to the posterior columns is like this. Whereas if we go with a trochanteric flip extension, our exposure increases tremendously over the supraacetabular region. While if we do a surgical dislocation of the hip as well, then our exposure is of the acetabulum joint itself, the supraacetabular, the posterior column area, as well as a part of the anterior column, which can be seen by the intraacetabular part. Hence, a safe surgical dislocation gives us unlimited access to the entire hip joint. And hence, we can have all the pathologies, be it a bony pathology or a soft tissue pathology. Both of them can be addressed. Why is it considered safe? Because when we are doing it, the integrity of the obturator externus muscle, which is having that supply of the medial circumflex femoral, is maintained. And as we have just discussed, the medial circumflex is the main blood supply to the femoral head. And when we are doing a safe surgical dislocation, we are protecting the integrity of obturator externus. Hence, it is not disturbing the vascular supply of the femoral head and the neck. And that's the reason why it is safe surgical dislocation. Indications, as we just discussed, it can be any intra-articular pathology of the femoral head, head-neck junction, or the acetabulum. It provides us complete 360-degree access. These are the various indications for which safe surgical dislocation can be done. It includes soft tissue pathologies like labral FAI, Perthes, we just saw that, synovial pathologies, exostosis, scaphes, and the most commonly for which it is used are in trauma, where it is used for the femoral head and acetabular fractures. Most of the rest which are there in the soft tissue pathologies will be subsequently covered by my next speaker, the expert of the hip arthroscopy, who will be covering them. So, any posterior wall fracture which is superior, any of the fractures which are transverse with posterior wall, and the femoral head fractures, intra-articular fragments which are there, which sometimes are quite big and cannot be removed by arthroscopy. These are the ones which will be and can be done by safe surgical in traumatic situations. The soft tissues will be covered subsequently. What is the technique for an adult? We do it in a lateral position. Usually, if it is associated with a acetabular fracture, we do it in a Cocker-Langenbeck. Else, we use a Gibson approach. And in Gibson, we are going between the medius and the maximus and not disturbing any of the abductors out there. Radiolucent table and Shyam from the opposite side is required. First of all, once you have done the regular procedure of the facial artery removal, then you need to mark the osteotomy site. And this is you are making sure that from the insertion of the vastus lateralis, you are having a straight line when you have taken care of the anteversion of the femoral head and neck, and going and marking it right up to the place where the gluteus medius is attached. You just go posterior to the most anterior fibers of the gluteus medius, so that you can prevent any damage to the piriformis as well, which is also giving some vascular supply. You can pre-drill the osteotomy beforehand and mark the things, because it helps to bring back the osteotomy back when you are fixing that. Creating an osteotomy, you can do it with the oscillating saw. You normally nowadays we put in 2 K wires which are holding that area so that we know where exactly the osteotomy needs to be made. And over that we put in our saws so that it is at a level playing field and it does not go too anterior and catch the neck of the femur. And that's a precaution which we need to take. It is a digastric osteotomy because you are maintaining the continuity of the vastus lateralis with the gluteus medius, and in between you have the trochanter. Hence, once you put it back, it's quite a stable fracture fixation which is done. You can use an osteotome to flip the things, and once you flip it anteriorly, you can see the thickness is around 1 to 1.5 centimeter thick. You can do a step cut osteotomy also, but in Indian situations, we normally use a transverse or a flat one. And after the osteotomy, you can do the flexion, abduction, and the external rotation part. And you can go and do the anterior part and watch the anterior capsule and do the subsequent safe surgical dislocation, which can be done by a Z-shaped capsulotomy. The trick out here is to maintain that your incision should not be going towards the piriformis. It should be at the acetabular region at the piriformis, and lower down towards the lesser trochanter, you are going along the neck intertransverse zone. Then you can easily relocate or dislocate the safe surgical or the hip, and you can now see the acetabulum inside. You can see the supraacetabular region. You can see the entire femoral head as well as a part of the anterior corner. Once you have done the procedure which you want, you can then fix it with the screws which you had already marked before, and that's how a proper safe surgical dislocation or a trochanteric flip can be done. The trick is that you need to ensure in Gibson interval to preserve the maximus. Make sure your osteotomy is 1 to 1.5 centimeter and does not break in between. As I said, you are going just posterior to the anterior most fibers of the gluteus medius, so that the osteotomy is posterior to piriformis, preventing and preserving the vascular supply. And you can easily fix it later once you have done and pre-drilled it, because it's a digastric and balanced osteotomy, hence it prevents non-union. I'll show you some case studies where this can be used properly and is being used frequently. This is a 70-year-old male who had a Pipkin's fracture or a femoral head fracture with a dislocation and subsequently other fractures as well. And here we had gone in from a trochanteric flip osteotomy, and you can see clearly that the entire 360-degree view of the femoral head can be had. And wherever the fracture is, any impingement, anything can be taken care by this. This is his follow-up after 5 years, and you can see that everything is united and the hip is as pristine as it was even in the age of 70, 75. Another case having a dislocation with a femoral head fracture again, which is dislocated. You can see that the fractures are quite big enough, the fragments are comminuted, and the same thing was done with the trochanteric flip. You can see the fracture again and fix it with the K-wires and fix with the HCS screws, which are headless screws, and you can get a good fixation with this. Pipkin's 4 are the ones which are the real fractures where you normally need to go from a Cocker-Langenbeck approach and combine the trochanteric flip and sometimes a surgical dislocation, where the acetabulum is also fractured and you have a femoral head fracture as well. Now this is a fracture where you can see a small part of posterior wall as well as the femoral head is fractured, and this was fixed again with headless screws. The posterior part of the wall was also fixed, and with one incision, you can go and fix both the fractures, be it anterior or posterior, of the acetabulum and the femoral head. The movements are quite good. It's a very uninsulting, or you can say that it does not damage the things much. This is a rare condition where sometimes you see that the posterior wall fracture is lying anterior to the femoral head because the dislocation. Now this is looks very easy, but if you will not be seeing that posterior wall fragment from the posterior part. And if you distract your femoral head, you will not be able to bring out that fragment without damaging the soft tissues of it. Hence, this is an approach where you want to fix the posterior wall, but you need to extricate that fragment from anterior side. And these are the fragments which will be done with the help of a trochanteric flip, where you take out that fragment after distraction from the anterior capsulotomy, bring that fragment from the top along with the soft tissues back to its place to preserve the vascularity and then fix the posterior wall. And this is what the follow-up shows. Another similar fracture, which I'm showing, you can see that the femoral posterior wall is lying way down antero-inferior now. And again, you cannot go back from posterior side and see this fragment and remove it without the soft tissues. So this is what we had done. You can see the damage to the femoral head on the antero-inferior part of the femoral head, which is roughened. But that is a thing which we cannot do much about. But the posterior wall fragment was removed with the forceps. You can see the pickup, removing that from the top along with its soft tissues. And then subsequently, this is the follow-up where you can see that it has united without having any vascularity and partly a damage or a heterotrophic ossification, which you can see. We published this as an unusual presentation of the posterior wall, which lies anterior to the femoral head. And we found in our 8 or 9 cases that wherever we used trochanteric flip and a surgical dislocation, those were the cases where the vascularity remained. However, where we just tried to remove them forcibly without the soft tissues, AVN had happened in them and they needed to be changed to total hip. Post-op protocol, when you are doing a safe surgical dislocation, you need to have toe touch, avoid active abduction, passive adduction, and flexion, which is in the initial 6 weeks. After 8 weeks, start the abductor strengthening, and bicycling and swimming can be done. And if he has to go to heavy sports, he can do it around 4 months or so in a traumatic case where everything has united by that. This is our own paper where in the Hip International in 2017, where we had around 32 cases regarding the safe surgical dislocation and the trochanteric flip osteotomy, and we could get a better intra-articular assessment, accurate reduction, and it did not compromise the head vascularity, as was proven by Reinhold Gans also in his landmark pioneer paper in 2010 or so. This is another paper from India, where again they have shown that surgical dislocation is a very viable option for the operative treatment of Pipkins, and it gives same results as the anterior Hutter's approach. So in the end, safe surgical dislocation is a useful tool in a periarticular fracture. Femoral head fractures and acetabular fractures of the posterior wall can be managed easily by SSDs without damaging further the vascularity of that area. That is the most important benefit which you can get, along with the adequate exposure and 360-degree exposure which you get. And remember that non-union of this digastric flip, which is balanced on both the sides, is a rare entity because of its balanced nature, where both the muscles are there on the either side. I thank you for your patient listening.
Thank you so much, sir.
Thank you very much for the excellent presentation. No questions at the moment. We'll move on to the next speaker. It's Dr. Dinsha Pardiwala from, sorry, it's in my presentation actually. Dr. Pardiwala is a consultant orthopedic surgeon and head of Center of Sports Medicine and director of arthroscopy service at the Kokilaben Dhirubhai Ambani Hospital in Mumbai. And his special interest is arthroscopy and sports injuries. Dr. Pardiwala, please.
Thank you. So I'm going to take hip arthroscopy and cover a few of the aspects that you wouldn't have seen with the first lecture, which was Vikas Khanduja's lecture on femoroacetabular impingement.
You never know.
Okay, so despite rapid advances in arthroscopy, the hip joint traditionally has eluded endoscopic intervention. So unlike the knee and shoulder and other joints, which
that era is a golden era.
Professor Mohanty, I think you kindly mute your link, please. I'm sorry, Dr. Pardiwala. I think there's a... Yes.
No problem.
Proceed.
No
Thank
problem.
you.
Okay, so despite rapid advances in arthroscopy, the hip joint has traditionally eluded endoscopic intervention. And that's primarily because of multiple factors. Unlike the knee and the shoulder, which are relatively superficial joints, the hip joint is less accessible than the other joints. It's a deep joint. And there are numerous surrounding neurovascular structures that are at risk if you place inaccurate portals. And also that the femoral head is deeply recessed within the acetabulum. So that's the reason why hip arthroscopy was really the last joint to be introduced into endoscopic, diagnostic, and therapeutic interventions. And as technology has advanced, it's been more and more scoped as a joint, and more procedures are being performed with hip arthroscopy. Hip arthroscopy has obvious advantages over arthrotomy. It's less invasive than an arthrotomy, and therefore, especially for athletes, allows a quicker recovery and return to activities. It also avoids a femoral head dislocation and the risk of osteonecrosis. We just saw that if you do have to do a dislocation, it certainly has to be a surgical dislocation. And in today's day and age, I think except for a periacetabular osteotomy, most other conditions, at least which are intra-articular, would be taken care of with hip arthroscopy. So let's see the technique for someone who wants to start off with hip arthroscopy. You're going to need a hip distraction device. This could be a commercially available device, or you could also use your fracture table. Make sure that you've got something that can give you a fair amount of assessment of the amount of distraction that you're giving. You don't want to be causing any skin damage or any neurovascular damage because of excessive traction. You also need some special instrumentation. You need the 70-degree scope as against the standard 30-degree scope. And you need some special instrumentation to get your secondary portals in. Besides that, most of the other instruments are like any arthroscopy, but they're just longer and a little sturdier. It will also be useful if you had some curved devices. So if you have a curved shaver or a curved radio frequency device, this is useful because this can go around the head, because there's a limit to how much accessibility you're going to have. And therefore, your instrumentation is going to help you in reaching those areas. So this is the sort of position that you would normally use. So you could do that in either the lateral position, or you could do this in the supine position with a fracture table, and you'll use a post which will then give you that distraction. So typically you would distract the hip, and when you're starting off, there's going to be a central compartment and a peripheral compartment. So we normally start over the central compartment. You distract the hip, and once you've distracted the hip, you put a needle in under fluoroscopy. Once you put that needle in, you can inject some air and confirm that you've got an air arthrogram, you're within the joint, and with a cannulated trocar and cannula, you can put your scope in. Once your scope is in, then you'll get your view, and you are now in the central compartment. What you're seeing on the left is the femoral head, and what you're seeing on the left is the femoral head, and what you're seeing on the right is the acetabulum. So you can now get into the joint, and from intra-articular in the central compartment, you can see the ligamentum teres, the fovea, the labrum anteriorly. So all of the intra-articular aspects you can see. And so what you're seeing here superiorly is the labrum, and you've got the lateral labrum, and then you're going to the posterior and the inferior aspects of the labrum. So intra-articularly, this is the sort of picture that you can get. Once you've done this, you'll stop the distraction and go into the peripheral compartment. So for the peripheral compartment, you need a peripheral compartment portal, put your scope in, and now in the peripheral compartment, you can see that that's the femoral head, that's the labrum there, and you can do some dynamic movements too, because this is not under traction now. So you can actually flex the hip, check for impingement, check for any sort of catching or locking, any loose bodies. And once you've distended it, you can get a fair idea of the folds, synovium, and aspects of the peripheral compartment of the joint. Let's now see the indications for hip arthroscopy in today's day and age. So there are diagnostic indications and therapeutic ones, and we'll go through some of these. So take the first one. This is a patient who's had pain in the hip and has a significant synovitis, but all of the blood parameters don't seem to indicate what it is. It's only going to be an arthroscopic synovial biopsy with a synovectomy, which is going to let you know what it is. And in this situation, this was a tuberculous hip, a tuberculous synovitis. And unless you've got a tissue diagnosis in these situations, starting off antituberculous treatment is sometimes difficult. So you're going to do a complete synovectomy, remove all that tissue, send it off for biopsy, culture, and antibiotic sensitivity. And once you've done that, of course, the patient is going to be relatively pain-free, but temporarily. Of course, you're going to have to start off the medical line of treatment. So you could do a synovectomy, and then this would be a useful indication for arthroscopy. In certain situations, like this pigmented villonodular synovitis of the hip, this would in fact be therapeutic. You could do a complete total synovectomy, both from the peripheral compartment and the central compartment. And this would really be a therapeutic procedure. It's not really for diagnostic procedure. And sometimes when you've got a significantly destroyed hip, again, monoarticular, again, you're not too sure what it is. If this monoarticular hip requires a biopsy, you could do it quite easily. This one turned out to be a monoarticular inflammatory arthropathy. And sometimes you'll also get these rare sort of secondary tumors, and it's difficult to do a biopsy, even a CT-guided biopsy in this site, and sometimes just a simple hip arthroscopy because that tumor has broken into the walls of the acetabulum. So just doing a hip arthroscopy, a dry arthroscopy so that you don't contaminate the field, and taking a biopsy there arthroscopically will give you a diagnosis. And this was a secondary from a adenocarcinoma of the lung. Therapeutic indications. The initial indication was a locked fragment or a loose body. So if you have a traumatic, so a fracture dislocation or a fracture with a small fragment, which is a dislocation with a small fragment that's fractured, and if there's an incarcerated fragment that's stuck there in the hip causing an incomplete reduction, then this is a good indication for a hip arthroscopy. Do a hip arthroscopy, get that fragment out, and that makes it really simple as compared to doing an open procedure for such a small reason. Sometimes you will also have multiple synovial bodies. So synovial chondromatosis. Again, this is a relatively simpler procedure to do arthroscopically as compared to an open procedure. And some of these patients will have these large synovial osteochondromatosis. Again, this you can approach both the central and the peripheral compartment and then individually take all of these fragments out and then do a total synovectomy. So again, a useful indication for hip arthroscopy, which would otherwise warrant quite a major open morbid procedure. Aspiral labral tears, especially in athletes, is something that was really detected with the era of hip arthroscopy. And we know that these tears can be quite symptomatic to patients who have high demands, who require to flex their hip significantly, and therefore repair or sometimes resection, if it's irreparable, is an option for labral tears. We also do labral reconstructions with the IT band for patients who've got deficient labra in today's day and age. And often these are associated with femoroacetabular impingement, but you could get traumatic ones in the absence of any bony abnormalities too. You could sometimes get paralabral cyst or ganglia, and this patient had a paralabral ganglion that was aspirated and injected thrice. Every time it kept recurring. Every time he had that aspiration, he was symptomatically better. Ultimately, at some point of time, when it had recurred too many times, it required an arthroscopic excision. So arthroscopically, you can approach these cysts, get that mucus fluid out, resect the cyst wall. Often these are associated with labral tears, so you'd go ahead and do a labral repair at the same time. These are very similar to lateral meniscus tears and lateral meniscus cysts, where you'd get the same pathology in the knee. This is very similar to that in the hip with these perilabral ganglia and cysts. And then, of course, the labral repair. So what do you do for the labral repair? You put your anchor in. And once you've put your suture anchor in, using instrumentation very similar to what's seen with shoulder labral repair, you can then repair the labrum back, and then stabilize it. And if you've stabilized it, you can look at it from within the joint. So that's the central compartment. And then you can look at it from the peripheral compartment where the cyst was. You could also have chondral and osteochondral fractures. So this young athlete who's had a slight tackle as a footballer, he's landed up with some osteochondral fragments that have then got locked in his hip. The hip arthroscopy is quite useful to not only remove these fragments, but sometimes fix them or sometimes do a cartilage repair procedure. This was a large fragment, and we did a microfracture cartilage repair because this was not in the weight-bearing portion. It's worthwhile to do just a microfracture and get a fibrocartilaginous sort of repair. If you do have a weight-bearing portion, that may be worthwhile to actually do something more extensive like an autologous chondrocyte implantation. Pediatric conditions too. So sometimes a sequelae of Perthes and hinged abductions. You can excise the hinge and make sure that you land up with good range. Patients who've had a slipped capital femoral epiphysis with metaphyseal bony structure there causing impingement. So that's your CAM type. You could go ahead and excise the CAM, again, arthroscopically. And all of these become simple indications for hip arthroscopy. In the past, early osteoarthritis debridements were quite popular, but we know today that these debridements arthroscopically really have limited usage. They're going to give you temporary pain relief. And unless there's something mechanical that's catching or locking in that hip, like a labral flap or a loose body, it's probably best not to do a hip arthroscopy on a patient that's already having significant osteoarthritis. Sometimes you can get intra-articular lesions, such as this osteoid osteoma in the quadrilateral plate of the acetabulum there, the hotspot. Again, this is very easily approached hip arthroscopically and excised hip arthroscopically. But if you had to do this open, this would be quite a task. Now, femoroacetabular impingement, FAI, was covered by Professor Vikas Khanduja. And this is really, in today's day and age, the main indication for hip arthroscopy. You've got the CAM lesions, which are the head-neck junction, and you've got the pincer lesions, which are the acetabular rim. You can excise these pincer lesions, and you can do an osteochondroplasty and make sure that your femoroacetabular impingement there's no further impingement, and these patients can get back their full range. And I won't repeat everything that he's just gone through. I'm going to end with a case, and this is a 19-year-old male. He's a cricketer, and he's had insidious onset left hip pain of 8 months duration. And this has not been relieved with non-operative treatment, and this has prevented him from a return to cricket. And as you can see out here, in that left hip, he has a femoroacetabular impingement. He's got a CAM. You can see the oblong head, but you'd also note that he's got either a stress fracture or an os acetabuli. Now, normally when you get these combined femoroacetabular impingements, CAM with a pincer, typically you're going to do an osteochondroplasty, and you're going to excise that os acetabuli. But if you excise this os, this hip is going to be unstable because the center edge angle will be completely distorted. And that's seen there in the CT scan. That's quite a large fragment, again seen in the CT scan and the MRI. So how would we address this? So arthroscopically, we would first go ahead and do the osteochondroplasty. So for the osteochondroplasty, what are we doing? We're making that oblong head completely round. And you're making sure that you've got no further impingement. And for these large CAMs, you need to go right up to the neck and not just the head-neck junction. We're then doing an impingement test, try and see, is this having any residual impingement there? And I feel that there is some residual impingement. That's the labrum there. So I'm going to do a little further, and I'm going to go and make this a little more round. So you need a nice convex and a concave structure here. You check that on the C-arm. You've now converted that oblong head to a nice round head with no further impingement. You then get into the joint, the central compartment, and you're checking for any labral detachment there. The labrum itself was intact and therefore didn't require any repair. Now, this is the fragment, which is almost like a stress fracture. And this is something that I'm going to repair. So you'll note where exactly it is. That's the head-neck junction, labrum, and that's the os acetabular that's there. Now, this is with the scoop, freshen the edges. Once I freshen the edges, I'm going to do an arthroscopic fixation for this. So I put my guide wire. I'm going to check this under the C-arm, make sure that I'm not intra-articular. This is just in the subchondral bone. So under C-arm guidance, I then put a bioabsorbable screw, and this is like a Herbert screw. It's a compression screw. And then put bone graft there at the edges and try and pack that bone graft in as much as possible. And then finally do a capsular closure. So with that, because this is a large capsulotomy, I would normally do a capsular closure with these large capsulotomies. So once you've done that, you've completed your procedure, and this patient, that's his post-op. So you have a nice concavity, which then progresses into the convexity. So you've got a nice head-neck junction and no residual impingement. And more importantly, that fragment out there, that's a CT scan at the 3-month mark. You can see that that bone graft is already healing in there. That's a stable os now, so he can get back to his cricket. Thank you very much.
Thank you very much, Dr. Pardiwala. That was a great presentation. We don't have questions at the moment. I hope we have time for these, maybe in a future forum, for all these wonderful talks. We'll move on to Professor Lalit. Our next talk will be by Professor Lalit Maini from Maulana Azad Medical College, New Delhi. He's editor-in-chief of Indian Journal of Orthopaedics. He'll be talking on hip surgery using 3D printing and newer technologies. Professor Maini, please. Thank you.
Thanks, Srinivas. I'll just share my screen.
Yes, sir.
Is my screen visible now?
Yes, sir.
Yes, sir.
So thanks a lot to the organizers to include this topic, which is slightly different from most of the other topics covered till now, in the way that it's going to be addressing newer technologies which are going to be having an effect in all type of hip pathologies. So I'm going to be talking about hip reconstruction using 3D printing and also touch upon newer technologies in the way of augmented reality. So I had written these two editorials a few years back when these technologies were coming into orthopedics, and there was a thought that they might take away, the surgeon's expertise in giving more technology into the surgery. However, we've seen over times that what it has ended up is giving more improvement in the outcome of hip surgeries. What it has done is it has helped us understand anatomy a bit more clearly, and we are able to plan surgeries, and we are able to actually introduce newer surgeries which previously were not imagined. There is a possibility of customized implants coming in and also customized instruments, especially like jigs for total hip arthroplasty or total knee arthroplasty and spine surgery. So let me take you through a few examples which are in various applications in hip surgery. So this is a young patient, post-traumatic hip arthritis, secondary to a fracture acetabular. And as you can see in the X-ray, on the right side, there are issues which you sort of think of when you're going to plan him about what is the distortion in the anatomy, what sort of fracture pattern is there, what would be the bone defects like, and how to go about it. And I'm very sure in all protocols all around the globe, a CT scan would be done to further evaluate this patient. So now when we have a CT scan in our hand, there's a possibility of converting that CT into a real size patient-specific model, which gives us a three-dimensional understanding of the whole pathology. So that's what we did in this patient. We created a bone model, and that's the bone model you can see. And you can see now that there's a large posterior wall fragment. And we actually osteotomized it in our office, reduced it, fixed it with clay. And the red dots that you can see are actually the residual bone graft which you would be requiring in a contained defect. So we were able to pre-contour a plate in the office and then use it intraoperatively to recreate the acetabulum and convert a complex type of a defect into a simpler one. So it's a very, very simple application of 3D printing to understand the problem in hand and execute it. So Dinsha is a master in hip arthroscopy, and there would be scenarios when not very skilled people would have to handle similar patients. And in very large cam and pincer effects, you might have to do a surgical dislocation. There is one situation where we had created a jig which would guide us in the extent of osteochondroplasty which is needed, which was created using the normal hip on the opposite side. So when there are very large cam and pincers, there is an issue on how much to remove. If you remove less, you might end up in incomplete treatment, and if you remove more, you might end up in fractures. So another simple application. Now this is an adolescent patient, most probably post-infective sequelae of the hip, and as you can see in the X-rays and the AP and the lateral view, it gives you a fair idea about what you're dealing with. But if you get a 3D printed model of the exact same size of the patient, your understanding of the disease is much more. And then you can end up in doing the surgery in your office by doing the osteotomy and seeing what sort of a correction can happen and what would be the targeted implant. You can actually pre-contour your plates and then use them intraoperatively. So what happens in this way that you are very clear while doing your surgery in what is your target, and with a pre-contoured plate which can help you achieve that target, you are almost recreating what you had planned pre-operatively. So the surgeon's brain, surgeon's planning becomes more efficient. It's not taken away by the technology, but it is only adding on a better outcome. So another case, fracture, neglected fracture of the acetabulum, 2-year-old, and patient was referred for a total hip arthroplasty. Being a T type of a fracture, the transverse acetabular ligament would also be disrupted, so the landmarks become a bit more tricky to handle. So we did a CT scan, and we did a virtual assessment of the whole pathology in this patient, and try to create a acetabulum position on the computer screen. So we created a cup on the normal side, and we brought it to the disease side, and we created a ring which would guide us on where to put the cup. So to recreate the center of it, which would be similar to the opposite side, the opposite side became a template. And then we created this jig which would sit on the supraacetabular area on the patient's contour, and then we can exactly get the correct hip center. So you can call this a poor man's navigation, and the availability of such things could be global. You could create the solution sitting in any part of the world and get the solution printed in your city and get it autoclaved and use it. So various steps where we are reaming, doing the trialing, and finally putting our cup. So that's the hip center recreated in a complex acetabular fracture patient. Similarly, for creating customized cement spacer, you can use this technology. And this last example, it's a chondrosarcoma of the ileum. A large one, you can see it is almost touching the subcostal area. You do your CT and MRI, and now you can actually fuse all these images. There's a possibility of fusion of CT and MRs, and that creates such an image. Now, in this, a CT angio was used with the MR to recreate the pathology, and it gave us an understanding and guided us on how to go about it. We created a very small jig which will help us in resecting the large tumor and then getting this tumor out. So the whole planning was on the computer and by using the newer technologies, and it really helped us in getting this tumor out. So that's the jig and that's the tumor out, and that's the post-operative X-ray. We could salvage the acetabulum and also take the tumor out totally. So 3D printing has now, I think, found a place in education, in patient counseling, in understanding very complex problems. It has a very great role in congenital anomalies, which might not be available in the textbook, and you can actually rehearse your surgeries, create customized jigs, create customized implants, and have a solution. So the second part which I would like to touch in this talk is augmented reality, which is again transforming orthopedic surgery and in quite a few ways which are similar to 3D printing. It helps in preoperative planning, surgical navigation, implant sizing, training, and education. And let me tell you, the starting point in all these technologies is an image which would be coming from a CT or an MRI. So what exactly happens in a augmented reality? It works through a headgear which has, you can see, a small mini computer in it. It has few cameras which have depth perception, which has projectors, and the purpose of this is that it can re-superimpose the patient's imaging which was done preoperatively, as well as the preoperative planning. If you have planned positioning of a cup in a particular place, once you expose the acetabulum during surgery, you can recreate the positioning of the cup using augmented reality. So various types of headgears are available. This is from Microsoft, which we have an experience of, HoloLens 2. So it has various small little components which are used to superimpose the virtual plan which you have created in your office over the real time during surgery. So let me take you quickly through this video, which tells you that we started long back with X-rays, and then we went on to CT scans. And from CT scans, we got the understanding on how to create 3D out of them. So these were steps which are around a decade back, and now we can actually segment our pathologies into different parts. We can reduce the fractures on the screen. We can create our plates on the screen and do a virtual surgery. And then you can actually use augmented reality to bend your plates using the plan created on your computer. So a few years back, the headgears were not good enough for doing the computing on the go during surgery. So we used to print the templates to then bend our plates. But today, these headgears are good enough that you can actually look at the plan during surgery in thin air and bend the plate with maybe your routine benders. And it saves a lot of time, and you are sure that you're very close to what you had planned. And another example, this is on hip arthroplasty, which I told you that cup placement and total hip replacement. You can say that this can become a substitute for navigation. So when you wear this headgear and you have planned your cup position, this is a bone model actually, a black colored bone model. And as the headgear identifies the bone, it would project the blue colored plan which you had created in the computer, as well as the acetabular place. Upon color of the projection into white or other colors, different people would have different color perceptions to understand the projection during surgery. You can hide the bone then, and then just look at the plan which you had created. And now that black is a bone model and white is a projection through the augmented reality headgear. So once that is there, you just have to make your instruments collinear with the plan which has been projected. So the reamer can come just in line with the shaft which is being shown there, and also overlap with the cup. It also guides you to the amount of depth you are supposed to be going, like in the normal navigation process. And then the subsequent steps like, trying out your trial, as well as the final implantation of the cup can be done using these virtual guides, which are projected over normal human forms. So this is an amazing future which we are looking into, and this can revolutionize placement of orthopedic implants by the precision of the CT scan which we have used in preoperative planning, and with no OT clutter. We are just going to be wearing these glasses, which I'm sure as time passes are going to get less and less heavier and more easier to use. So that's the bone model, and this is one example in which I'm using the same augmented reality. This is a different type of a headgear, and it is being used in identifying the correct positioning of the implant during surgery. It is helping me in creating the mechanical axis of the lower limb in total knee replacement. Now here an additional tool which is being used in between is that blue cross which you can see, which is a QR code, you can say a tracker. So it helps the augmented reality guide to position where the tracker would lie. So the future has already entered the operation theaters with these technologies. And I think imagination should be used not to escape reality, but to create it. And these newer technologies are definitely going to enhance precision in surgery and definitely in hip surgery. Thank you very much.
Thank you very much, sir, for giving us a glimpse of these awesome technologies. And we have an exciting future ahead with these technologies. We'll move on to the next talk by Professor Rajesh Malhotra on hip resurfacing. He is Professor of Orthopaedics and Clinical Lead at Indraprastha Apollo Hospital, New Delhi, and former Chief of Orthopaedics at AIIMS, New Delhi. Professor Malhotra, please. Thank you.
Thank you. Thanks, Dr. Elashhab and Dr. Srinivas. I'm really grateful for this invitation. Can you see my screen, please?
Yes, sir. Yes, sir. We can see it, sir.
So it's very interesting when you asked me to talk about hip resurfacing, because nobody talks about resurfacing today, because very few are being done. If you see in last about 5-6 years, there hardly been any publications except for those who are following up their cases and giving the long-term result. It is expensive. There are reports of catastrophic failure. Metal lines and hypersensitivity are the issues, technically demanding. And you think if it is even worth. So it is limited to patients with good bone stock, limited capacity to equalize the leg length, lack of acetabular screw fixation, which can be a technical challenge, risk of femoral neck fracture. So with all these, and the fact that you retain femoral head and then prepare the acetabulum, and you have to do capsular releases, and it is very important to have proper component positioning, otherwise you'll have catastrophic failure. So why do we still talk about it? It's because now we are doing hip replacement in younger and younger patients who have long life expectancy, who need multiple revisions, and then that becomes an outstanding problem. A young patient with arthritic hip who wants to play sports, he wants to engage in physical activity, he will not abstain from high impact activities. And also because we don't have an ideal choice of total hip for these very young, very active athletes who are looking for multiple revisions. The metal on metal resurfacing actually made a lot of sense because it conserves bone, it loads the bones physiologically, it is optimized, optimizes the stability, it's a low wear bearing, and there are improved future options. And this was designed so that there is enough bone left for the future revisions. That was the whole idea about this. And then what these people want to do with their hip, they can win medals in the judo, or they can do stunts and action fighting. They can be fitness icons. After resurfacing, they can be the kickboxing champions, they can be triathletes, or they can be tennis players like Andy Murray. But hold your breath. I'll show you this video of one of my own patients. Honestly, I threw a fit when I saw this. I called him to India. He was in Japan at that time. I'd asked him to send X-rays. He sent me this video and I got his metal lines done, and fortunately they were normal. These are two leading orthopedic surgeons in Australia and in South Africa who have had a resurfacing done for them for more than 20 years, and they have been following a very active lifestyle. So is it worth? Yes, it is worth in young patients with osteoarthritis. It has some advantages over hip replacement because of the improved return to high-level activities and stores restoration of biomechanics and decreased stress shielding. So these are the reasons why the resurfacing is still being talked about. There's less wear, better hip biomechanics, better gait pattern, high activity scores. All these patients score very high on all the athletic activities and all the scores which are used to measure the physical activity. They have higher function, higher patient satisfaction, and less revision rate. And note this condition supply, because it is actually, if you take out badly performing joints which are actually design flaws. And it is of course more stable because the dislocation rates are 0.27 per 1,000 prosthesis years compared to 0.84 with the total hip replacement. So hip resurfacing is not yet out. It is still very much in the game. So where the conventional hips have failed to deliver is you advise patient to have activity limitation. You advise them to avoid high impact activities. The function and range of motion are limited. The stability is a risk, and there's a revision or osteolysis which is often seen. Now, when the patients started shying away from metal-on-metal articulation, I have been using this large head ceramic-on-ceramic articulation, which is like, this is delta motion from DPU. And this has an implication about the young patients, which I'm going to tell towards the end of my talk. This is an example of a young patient who had this kind of activity, another avian who had core decompression and fibular grafting and delta motion. Large head ceramic on ceramic articulation has been the bailout. But then what the resurfacing promises is basically, it is something which is very suitable for younger patients with a durable bearing material, and you are actually taking out minimum amount of bone, and a very high strength alloy allows you to make a very thin acetabular cup, and then you can have a porous coating on the outside. And the advantages, of course, are of better function, better biomechanics, lesser morbidity at the time of revision, and reduced dislocation rate. Even if you were to get an infection, the implications are much less with the resurfacing. So the different authors have actually talked about normal loading and reduced stress shielding, easier management with proximal femoral deformity, improved outcome in the event of infection, easier first-time revision with less comorbidities, and reduced prevalence of thromboembolic phenomena. This is one of my own cases which had a severe deformity, and you can see that it is a nightmare to try and do a hip replacement in this, and could get away just with the resurfacing in this case. And look at the osteoarthritis in young male patients younger than 55 years, and look at the survivorship with resurfacing. 98.5% at 10 years and 98.5% at 14 years. And look at the survivorship of the total hip, 81% at 10 years and 33% at 16 years. The patient satisfaction at 8 years has been reported in this paper, which said that it provides pain relief, high level of patient satisfaction, improvement of function, and well-being in the medium term. And in this interesting study from the National Joint Registry, it showed that the BHR had lesser mortality compared to both cemented as well as the cementless hip replacement. The McMaster group have published 12 to 15 years results of BHR, and you can see it was 97.4% at 10 years and 95.8% the 15 years. However, since they are the innovator surgeons, let's look at some other studies. This is after the introduction of the resurfacing in US. They actually showed the results comparable to those of literature. Another paper where the 97.9% survivorship at more than 7 years was reported in Hip International. Then the resurfacing does preserve the bone. It conserves the bone and also preserves the bone. And although there is initially some reduction in the bone density at 6 weeks and 3 months, but it becomes to preoperative levels at 1 year and maintains at 2 years. And that has been shown that their bone mineral density does actually increase, and that increase continues for 5 years. And this is a letter we published in response to a publication that bone remodeling is not uniform across the entire femoral neck, and it's the superior lateral area which does have some stretch shielding. But the problem is that all resurfacings are not the same. If you look at these designs in the red, they have not done so well, particularly the ASR, it has been recalled. And these are the various problems which had actually led to the failure of ASR. So ASR doesn't represent the resurfacing generally. And I would just quickly take you through the causes why the ASR failed. So the Birmingham hip resurfacing is as cast. It has no heat treatment. And many of them have got heat treatment, which actually affects the carbide. Now, carbides are twice as hard as the metal. They prevent wear. The more carbides you have, the better it is. The bigger particles you have, the better it is. So this is how the carbide microstructure looks like in BHR. Now, what happens is if you give it heat treatment, it actually gets melted and becomes smaller. It redissolves, and then they redistribute. They become smaller and weaker, and they are poorer in the wear properties. So this is the heated versus non-heated metal used for resurfacing. And if you see that the revision risk is lower than in BHR with any other resurfacing, because this is the only one which is not treated with heat. So that is why they have twice to thrice failure rates. Then the socket design. The resurfacing sockets are not like total hip. They have complex geometry. They move the head laterally, and ASR was extreme. So if you have a total hip, it is like this. So if you put it in 45 degrees, it is 45 degrees. But because they lateralize it like this, a 45 degree in a Birmingham resurfacing is 53 degree. But look at this. In ASR, it is actually equal to 62 degrees, which moves this contact here, and it leads to a patch of wear here. And that is actually the area which causes edge wear. Also, there was a groove inside the ASR, which gave rise to less coverage and worse wear. So clearance of the ASR was only half the clearance of BHR, which was 100 micron. And this clearance allows the fluid lubrication. When the cup deforms on impaction, the 100 micron actually becomes nearly zero. So there is no lubrication, which enlarges the wear patch, and it's easier to reach the wear patch. So the wear patch occurs here, and that's what starts causing the edge wear. So it has no tolerance for malposition. Also, the sphericity of the BHR was much better than others. Again, it has got a role on resurfacing, because when there is a better round shape, there is less wear. So this is the comparison of the different resurfacing, and you can see the difference. And that's what decides the success or failure of a resurfacing. And this is the pseudo tumors, again, were seen in cases which had socket angle of 22 to 75 degrees, mainly in females, and inflammatory mass was seen in 17 cases. So these were the factors which gave rise to more pseudo tumors in the ASR. And the high metal ion levels also showed a change in the activated T cells, which showed that this process is possibly immune mediated. So they are not all the same. So you have to look at the resurfacing, which have been done in large number with large follow-up, and with the results they have given. So the three designs which have done relatively better is BHR, Conserve Plus, and the Comet. And these have been studied at the Hospital for Special Surgery in nearly 1,000 cases, and then they showed they all performed equally well. So if you look at this, BHR did very well, followed by Comet, then Conserve Plus, and ASR is the worst. And again, this is another other designs like ASR have got poor results. Durom again gave poor results. So resurfacing is successful only if you have the right patient, the right surgeon, and the right implant. That's the message. So ideal patient is young male, good bone quality, little or no deformity, active, healthy patient. He should not have femoral head bone loss or acetabular bone loss. Should not be more than 1 centimeter limb length discrepancy. There should be no osteoporosis. Females more than 55, males more than 60 should not be taken up. AVN is not a good idea. Less than 50 millimeter femoral component is not a good idea. And obesity is not a good idea. So older female, poor bone quality, AVN, femoral nexus, significant deformity, significant limb length discrepancy, and also the contraindications for metal on metal, particularly females of childbearing age, should be avoided. So these are the hips to avoid. This is intraoperative picture, something you should avoid. Other considerations are experience of surgeon and the technical ease of the procedure. And even with the good indication, you should always have to have a backup plan. Pick a winner, which I have told you. So strict component position is absolutely necessary in resurfacing. We have actually published our results of resurfacing in inflammatory arthritis in Journal of Arthroplasty. This is just for some examples for ankylosing spondylitis, which is very common in India, acetabular fracture. And it has been a journey where we have seen extremely good results with resurfacing in Indian patients. This is the athlete who just showed you his work, and this is his X-rays, basically FAI, which led to this. And then we have also worked on the femoral head vascularity and shown that almost 1/3 of the patients showed reduced vascularity of the remaining femoral head. And then we have had a share of two fractures in the patients who had inflammatory arthritis, and they were actually revised. These are the reported complications, but they depend on the learning curve and experience. You look at the top, that's the inventors and all other surgeons. Similarly, femoral neck fracture is less with the experienced surgeons. There is a European multidisciplinary consensus statement on monitoring metal on metal bearing. You have to closely follow them. And if the metal levels are high, you have to do imaging. And then, of course, you should discuss the revision with the patient. And those algorithms have been published, and they are readily available. So unmet need and future perspectives include what is the ideal articulation, what is the ideal head size, what are the mechanisms which create particles or ions, what is their potential impact, what is the testing method. And now, again, ceramic on ceramic and metal or ceramic on highly cross-linked polyethylene resurfacings are coming back. They are able to resist the wear under standard conditions. So hip resurfacing is likely to be back now with a bang, with the large head ceramic on ceramic like Delta Motion, which we already had experience with. So that is the future of the resurfacing. To conclude, hip resurfacing is successful when the design is good, diagnosis is correct, surgeon is experienced, head size is proper, young and active patient is the ideal patient, and must know the reasons for failure which are under your control. And then, of course, men have more favorable outcome than women. And there is a significant learning curve, so you should be properly trained. It is still not out of the game, and engineers with surgeon will provide better designs, and it will be back. Thank you very much for your attention.
Thank you very much, sir, for this comprehensive presentation on hip resurfacing. We'll move on to the next speaker. It's Dr. Professor Jagdish Menon from JIPMER, Puducherry. His special interest is on orthopedic oncology. He'll talk on tumors of the hip. Over to you, please, Jagdish.
Neeraj, I'm unable to share the screen. I think you have to permit me.
Oh, shall we move on to the next speaker? If you...
I'm ready.
See your screen.
We can see it, sir.
So good evening, and it's wonderful to be back again and to be part of the Indian as well as the Egyptian Orthopaedic Association meetings like this. I must confess, this is a very unusual topic on hip tumors. Today's webinar has essentially been regional, focused around the hip region. And unfortunately, tumors really do not behave in that pattern. So when we speak about tumors, the first patient that you see on the left is actually a patient who was finally diagnosed as a giant cell tumor. The second was a lady with metastasis from a breast carcinoma. And the third one is a patient from suffering from multiple myeloma. Now, all these tumors are housed in the bone and essentially are part of the overall family of bone tumors. But generally speaking, we remove out the hematological malignancies. And when we speak about bone tumors, we limit ourselves to the benign and malignant tumors that are seen in bone. Since the topic is very extensive and I think I will not be able to do justice over 15 minutes, I will just limit my talk to what might interest a general orthopedic surgeon in identifying and probably understanding the principles of oncological treatment. So, since this is a regional webinar on the hip, there is an obvious question, that is the tumor from the hip any different from the other? Now, if we take a biopsy from let's say the femur, the acetabulum, the radius, tibia, and all put them together under a microscope and understand, you will see that there is no difference. You would not be able to differentiate vis-a-vis location. And this microarchitecture and cellular element of bone is the soil in which the tumor grows. However, there is a cellular environment and various environmental and genetic factors which play and make some tumors common at certain areas. In the hip, there is nothing like an adamantinoma of the tibia, tibial diaphysis, which is almost exclusive. So the hip gets a spattering of tumors which are found elsewhere in different percentages. But structurally, the hip is unique. The hip has about 3.5 times the body weight in stance phase, and it goes up to 7.5 during movement. Also, probably the true cantilever in the body is that the proximal femur. And that this gives you a magnification of the stresses that pass through this area. And this has a greater role when the bone is already weakened by the tumor. The chance for you getting a fracture is very high. And that is why when we had the Mirrell scoring for which was basically for the indication of prophylactic nailing in lytic lesions, Mirrell, if you see, said that if the location is in the proximal femur, it would give the maximum points. It is more likely to fail and hence require prophylactic fixation. The same is true for the acetabulum because the entire body weight gets distributed about the dome, and any tumor in the acetabular area is likely to have catastrophic mechanical failure also. So just like any other tumor, it's important to understand that the hip region also has its own do not touch lesions. So what are these lesions? These lesions are very typically picked up on an X-ray or a CT scan, and they do not require any further diagnostic tests. Also, if an unnecessary biopsy is done, the reports would be very misleading and may cause unnecessary surgery. So the surgeon and the orthopedic surgeon should be very clear and we should be able to identify these lesions. These are just examples: avulsion of the anterior inferior iliac spine, of the superior iliac spine, sometimes are mistaken for tumors. Heterotrophic ossification in its pattern, which shows woven bone. The hip is a very common location and typically tends to follow a stroke or a paralytic illness. These are the one on the left, which is the bone island or anostosis, is just look like a little bit of chalk which has been plastered onto the femur. Again, this is just a normal osteoid in a greater quantity at a location. They need to be left alone, as must be the distribution of more bone like osteoporosis. This is again a dysplastic condition which has no clinical relevance. Staying on to dysplastic conditions, an unusual one that we sometimes see, very rarely see, maybe we've seen a couple of them, is meloriostosis. Again, these are not tumors. These are just excessive ossifications which cause these patterns. So it is important to distinguish these points. This is another example of the synovial pit, which is at the base of the neck trochanter junction. You can see what is called a lytic lesion. These are called synovial pits and are best left alone. A geode, usually seen if there is articular pathology, again, they are connected to the joint pathology and not a standalone bone tumor. This is another which may be missed, especially if it is located to one bone, a Page's disease, which is essentially metabolic and has a treatment which is totally different. So I'll just pick up a couple of tumors in the benign and malignant because of want of time. Benign tumors usually will destroy bone. And the treatment is based on stopping the destruction by whatever method which may be ideal, and also then to scaffold, to mechanically augment the bone so that it doesn't suffer a pathological fracture. The simple bone cysts may very small, may be observed, or may be treated with injections, hydrocortisone, DBM, stem cells, all have been used. Sometimes curettage also, especially if it is large, or drainage of a tumor may also be done. The other thing which we encounter quite often around the hip is an aneurysmal bone cyst, which causes more expansion. And again, the treatment here could depend on the location and the size of the tumor. A very popular method is using sclerotherapy with polydocanol, which permits less invasive percutaneous method of treatment. Now, one of the few bone tumors that do not cause lysis is an osteoid osteoma. This patient of ours was just operated last month and typically complains of pain and sclerosis and needs obliteration of the nidus for treatment. Now, when you come to malignant tumors in and around the hip, the far commoner ones are the secondaries. In the pelvic bones, chondrosarcomas dominate, whereas the conventional primary tumors are also found on the femoral side of the hip joint. Here, the importance is to understand the concept of biopsy, because the entire diagnosis of a tumor hinges on it. And though it may seem as a easy technical procedure, it requires a lot of planning and execution. In the proximal femur, it is important to avoid the greater trochanteric bursa, be away from the neurovascular bundles, and the transverse branch of the LCFA, which is unusual, but you might hit it. The acetabulum, again, the biopsies of the pelvis can be done. It is very amenable to CT scan located biopsies, both the posterior as well as the anterior part of the pelvic rim, both the iliac and the sacral part of the SI joints. Similarly, the anterior part, the acetabular, retroacetabular part, as well as the part above the acetabulum, can be easily accessed by biopsies. Now, just putting across the importance of a biopsy, this patient came to us about 6 months ago, and a biopsy was done, which came out as a fibrous dysplasia. We felt that the rate of destruction was too far, and we asked the pathologist for a second opinion. And since the rate of destruction was very rapid, the entire progress was in 1 month's time. And we did a second biopsy, which actually showed an osteosarcoma. And further, as the patient came back, you can see the osteodeposition, which is classical of an osteosarcoma. Therefore, the need of a biopsy to be done and to be discussed with pathologists who are specialists in musculoskeletal oncology also has an important role to play. Then coming to metastatic skeletal related events, which is by far the commonest that you see in the hip, and they usually present with pathological fractures, pain, or hypercalcemia. Again, this is a very neglected part of treatment of tumor management, and most patients with malignant with metastasis are usually condemned to morphine and very little treatment. But they do deserve treatment, and most of the palliation must exceed the expected survival. They could be treated with both internal fixation, reconstruction, and whatever should be done should outlive the patient. usually, if the patient is has multiple medical problems, is very moribund, palliative therapy is also being used. So these are just some cases which we have seen. Intramedullary fixation of the metastasis. For solitary metastasis, you can do a replacement or augmentation by cement. This is a newer concept which is called ablation, osteoplasty, reinforcement, and internal fixation, where first, I must confess, we don't have experience in this, and this is from published literature, where the tumor is first percutaneously ablated, then cement is injected into the cavity, it is reinforced with screws, and this gives pain relief as well as structural relief. So all metastatic patients deserve other forms of treatment, which include thromboprophylaxis, analgesia, the use of bisphosphonates, denosumab, chemotherapy, as well as hormone therapy. Just one word on primary tumors before I end is the chondrosarcoma is a common tumor that we encounter in the pelvis, and these are treated by wide excision. They don't have any role for chemo or radiotherapy for these patients, and are essentially surgical. Whereas tumors like osteocytes or Ewing's, which respond to chemotherapy, are typically treated by a custom-made megaprosthesis. There are multiple ways to treat it, which is probably outside the scope of this discussion. The last slide is the hip also can have tumors as well as tumor-like conditions, and because of the high stresses, the incidence of pathological fractures is very high. It requires a good interpretation of radiological findings and a biopsy to diagnose hip hip tumors. Thank you. That's all.
Thank you very much, Jagdish. That was a wonderful summary of a big topic, actually. Please share. Yes. Thank you very much. We'll move on to the next talk. The next speaker is Professor S.S. Mohanty. He's a professor of orthopedics at St. G.S. and King Edward Memorial Hospital in Mumbai. And he'll be talking on complex primary total hip replacements. Over to you, Professor Mohanty. Thank you very much.
Thank you.
And he's taken the time to give us the talk.
Thank you so much, Dr. Srinivas. I'm really thankful to Professor Elashhab and Dr. Srinivas for this opportunity. And this is the second time I'm presenting in this forum for the Egyptian orthopedic surgeons.
It's an honor for us, sir.
Sorry?
It's an honor for us, sir.
Thank you. Thank you, Professor
Thank you so much.
So today I will share about my experiences about complex primary total hip arthroplasty. So what is complex primary total hip arthroplasty? It's a procedure where the total hip arthroplasty that increases the functional, infectious, and neurological risks, or that involves technical difficulties. So as a beginner, one should not try to do this complex total hip arthroplasty from the beginning. At least after doing, minimum 50 to 100, straightforward hips, then they should touch upon this complex total hip arthroplasties. There are basically three groups of conditions. First is the complex soft tissue anomalies. Naturally, it can't be seen in the X-ray. So one has to be proper clinical examination to assess the patient in terms of obesity. Is there any cutaneous complications or skin problems, or is there any neurological conditions which are associated, which require special attention? The second group of conditions are biomechanical abnormalities, which patients have significant lateral offset or coxavara or ankylosed hips or arthrodesed hips. And the third group essentially is the biggest group, which involves bone morphology abnormalities. Those are maybe dysplastic hips, post-traumatic conditions, protrusia, post-osteotomy, many bone dystrophies or osteoporosis. But often patients, there may be combination of all these three conditions. So worst case scenario will be obese patient with some cutaneous complication, which has got a maybe ankylosed or arthrodesed hip, or there may be protrusio. So all these various permutation and combinations are possible. And this group of patients, they require special surgical attention. So it requires a meticulous planning. Essentially, the planning, it involves that one must aim to restore the vertical offset, the horizontal offset, and as well as the femoral neck anteversion, or what is known as anterior offset. So in all the three directions, like X, Y, and Z axis, if you have restored the center of rotation in a proper way, then you have restored the biomechanics of the hip, and that will have a good functional outcome as well as good long-term outcome. So after you have planned your X-ray, next one has to plan that what is the surgical approach you are going to take for that particular condition, what implant you are going to use, and now next step is while executing the surgery, the implant position in relation to the patient's particular anatomy is extremely important. So if you have planned all these things and execute your plan properly, then it will have a good successful outcome. Now I'll sweep you through a couple of cases and just explain that how to plan and how to execute your planning. And this is one of the post-traumatic situation which many surgeons face. This is after dynamic screw for an intertrochanteric fracture, the fracture is united, but there is collapse of the head, avascular necrosis, the center of rotation of the hip has shifted superiorly, and there is an implant to be removed, and hence there are chances of infection. So one should rule out infection in this earlier operated patients by doing ESR, CRP, or sometimes hip aspiration as well. Next, what is the approach? And normally I approach through a posterolateral approach in most of the hips, but sometimes it may require a transtrochanteric approach if the hip is stiff and it is not a mobile hip. Next, the golden principle is that one has to dislocate the hip, then relocate it, and then take out the implant. Otherwise, there's a possibility of spiral fracture. And after that, then you can dislocate again the hip after removing the implant and do the rest of the surgeries. So implant removal is important. So one has to keep the typical sets to take out that particular implant. So as I told you earlier, you have to restore the horizontal offset, vertical offset. And as you can see in this particular X-ray, there is severe osteopenia. So this is a Dors type C canal. So one should prefer to do a cemented type of hip rather than any other, uncemented kind of hip. Moreover, lateral view, if you see there is an anterior femoral bowing there. So that may not take a long prosthesis there. So one has to be very careful about that. Moreover, there are screw holes after taking on the implant. So one should, if you are aiming for an uncemented hip, one has to bypass the last screw holes. Otherwise, there will be stress fracture. So, or else one can prefer to use a cemented hip, which can obliterate the screw holes with the cement. So that is the implant removal after dislocation, again relocation, then implant removal. And after taking out the implant, always curate out. There will be a beautiful membrane there below the implant, and send that membrane for culture and sensitivity and histopathological examination to rule out the infection. And here you have done a hybrid type of hip, as you can see here. So the vertical offset, the horizontal offset is restored. Hence, the center of rotation of the hip and biomechanics of the hip is restored. We prefer to use a cemented type of stem. So where the screw holes has been, obliterated, and also because of this osteoporotic bone. Next, you face a common situation like this, post-hemiarthroplasty. This osteotomy prosthesis has been done, 65 years old male. Osteotomy prosthesis was done 2.5 years back, painful since 5 months, and inability to do activities of daily living. So if you analyze this X-ray, the problems here is, first thing is the protrusio. This is the ilioischial line or Kohler's line. So there is protrusio, and there is subsidence of the prosthesis and leading to limb length discrepancy. So there is a considerable amount of shortening which needs to be addressed. And if you see compared to the opposite corticomedullary ratio, there is osteoporosis, and because of the placement of the prosthesis laterally, so there is a cortical defect there. So one should bypass that cortical defect. So intraoperatively, exposure is a problem because of the protrusion. The sciatic nerve remains very close, so one has to be very careful about the sciatic nerve. And if you are unable to approach the hip, then it's preferable to do a trochanteric osteotomy in order to take out that implant. Then dislocation becomes a problem. So one has to give a lateral traction, then they deliver the head and the shaft as a single unit. Otherwise, there is a possibility of spiral fracture. So it's known as delivering the head rather than dislocating the hip. Then extraction of the prosthesis, one has to clear the piriformis fossa and may put a hook and just give a couple of blows in order to take out that osteoinward prosthesis. And after taking out the prosthesis, always there's a beautiful membrane which is present. One should use this, reverse curate which is provided in the Moreland set. Take out that membrane from the endosteal surface or use long scoops to take out membrane from the acetabular side. Next, one should do impaction grafting of the acetabulum by taking grafts from the iliac crest or allograft one can take and do a reverse rimming in order to impact the graft medially so that to lateralize the center of rotation, and always keep a multi-hole cup in your armamentarium so that you can have a couple of screw fixation. On the femoral side, one should pass a guide wire and then do a rimming under image intensifier guidance so that you bypass that cortical defect and prefer to use a long uncemented stem or a long cemented stem. So let's see this X-ray. This is 4.5 years follow-up of this patient. So now the protrusion has been corrected, center of rotation has been lateralized, and you have restored the limb length there, and you have bypassed the cortical defect, and hence the center of rotation of the hip is restored, and biomechanism of the hip is restored, and hence the function of the patient is restored there. Next, the third group is a dysplastic hip. There are no classification, and usually the type 1, which is less than 50% of the subluxation, is like a primary hip. You can restore the center of rotation easily. Type 2 and type 3, they are subluxation within 50 to 75% or less than 100% subluxation, and type 4 is 100% dislocation, and this requires a special surgical planning. So how you will plan? First, draw the intertioral line there. Next, you look for the shortening by drawing a perpendicular from the medialmost point of the lesser trochanter. Next, this is the alignment of the cup from the teardrop, that this is the inclination of the cup, and next you draw the line in the supraacetabular margin. As you can see, these two lines are converging. So draw a line perpendicular, parallel to the supraacetabular margin of the unaffected hip, and that shows this much amount of defect which needs to be filled up, and that has to be filled up with a graft or a augment or whatever in order to restore the center of the hip, which needs to be brought down and out. So this is the execution of the planning. In type 2 and 3 cases, try to restore the center of rotation. If not possible, you can leave the high center of rotation, which is acceptable. So here you first dislocate the hip. Next, put the graft in the superolateral aspect by taking it from the head, then fix with couple of the screws, then put the cup, and next do the femoral side and reduce the hip. And that is the outcome there. So with the bone graft, you should direct your screws towards the sacroiliac joint so that it is along the trabeculae of the bone, providing good compression of the graft. For that, graft uptake will be good. In type 4 cases where it is 100% dislocated, it requires subtrochanteric shortening and realignment. So do a subtrochanteric osteotomy, then approach the cup and now fix the cup with a graft or whatever way, whatever I described it before. And next, you prepare the proximal part of the femur and put your prosthesis in, then reduce the hip, then give a traction and see that how much femur is overlapping there, then excise that part, and next reduce the hip and align like that. This graft may be used, you can split this graft and use it as a bone graft and do a wiring. Here is a case where there is a type 4 dislocation in a CDH, and that is the outcome after putting the graft and restoring the center of rotation to an anatomical position with a subtrochanteric osteotomy on both the sides. Next group of conditions which are known as protrusio. There's a classification by Sotelo and Chanley. So mild is within 5 millimeter, moderate is within 15 millimeter, and severe is more than 15 millimeter. So you have basically the protrusio, the center of hip not only displaces laterally, medially, it also displaces superiorly. So in order to restore the center of rotation, you can go beyond the Kohler's line, which is ilioischial line. This is the Kohler's line. One can prefer the Ranauer's method, which is for precise location of the socket. So this is the triangle, which is 1/5 of the height of the pelvis. And you can follow the Gates teardrop method, where you can draw this Kohler's line and the center's line, and the cross section is the inferior margin of the teardrop. So with respect to the teardrop, you can put the cup. So that will give you an idea that where you are going to put the cup. Here is a patient. So we have drawn these lines. So this is the Kohler's line, and this is the line parallel to the acetabulum on the opposite side. So these are the area needs to be filled up with the bone grafts in order to bring the center of rotation down and out. So bone graft has been put, cementless type of cup, like a multi-hull cup, and center of rotation down and out. That 7 years follow-up, so it's a good graft uptake there. So here the center of rotation moves in and goes up, so you have to bring it down and out. Here is another post-acetabular fracture which is neglected. So when the host bone contact of the uncemented cup is less than 50%, it's preferable to use a cemented type of cup. And here whatever you have used a cemented type of cup. So here first we have put a bone graft from the head, superiorly the bulk graft fixed with 2 screws, and medially we mixed a combination of autograft as well as allograft and impacted it medially, then put a cemented type of cup. And that is a 10 years follow-up of this patient with the Elite Plus cup, Elite Plus stem, which is not being used nowadays, and that bone graft has taken up and center of rotation has been restored. Then another group of conditions is post-acetabular fracture, where there's a pelvic discontinuity. These are complex situations when there's a pelvic discontinuity. Then you have to put bone grafts medially, then put a cemented case like this, then put cement and a cemented cup like that in a desired direction of inclination and eversion. These are the Buch-Schneider case. This is anterior protrusio case. So this is a transverse fracture with posterior wall and Pipkin's type 2 fracture, which was neglected. So here we had to put bone grafts there. Then the case was fixed, Buch-Schneider case. Then a cemented cup was cemented in desired degree of inclination and eversion. That a Buch-Schneider case, and that is the post-operative X-ray. And as almost 8 years follow-up of this patient, the graft has completely taken up, and whenever you want to do a revision, it will be like a primary cup will be there, and that is a function of this patient after 8 years. And finally, a case of ankylosing spondylitis. As you can see here, 32 years young man who is 15 years bedridden. This is a wind-shaped type of deformity, one side abducted, one side adducted, with a complete bony ankylosing. Her knees were also bony ankylosed in different ankles. So we'll discuss about the hips only. So the challenges of the anesthesia is there for anesthetics. Which joint to be done first? The positioning of the patient, the approach is important, and the severe osteoporosis which is associated. And there's a narrow canal and very narrow canal there. And there are very thin bones, and implant positioning is an issue there. So first surgery, we did a left total hip replacement. So by giving this kind of positioning where the right leg remains out, so it is fixed on a stool there within a strapping, and the left hip was addressed. And this was a dual approach which was used. So first we went anteriorly, did a napkin ring osteotomy. So a segment of the neck was taken out. So hip was free. Then we did everything posteriorly. So posteriorly you go, so that is the part of the head which is remaining in the acetabulum. Then you go on rimming till you find this fat pad. This is a fat pad sign which has been described by Dr. Dholakia from India. That is, even if it is bony ankylosed, there is always a fat pad remains between the native acetabulum and the ankylosed bone. So once you reach the fat pad, that is the floor of the acetabulum. And after rimming, then you put a cup there. And always keep an image anticipatory in order to see the positioning of the cup there. Next, you put the liner, and finally do the femoral side, and that is the ceramic and polyethylene hip. And at the post-operative X-ray for this patient, very thin stem, size 6 stem was used in this case. Then we did the right side. So as you can see here, the right side hip is remaining in abducted position. And in the right side hip, the dual approach was not possible. So here you have to select a trochanteric osteotomy in order to reach the hip. So did a trochanteric osteotomy, then do the acetabular part and check with the imaging transfer, then put the uncemented stem and do the wearing of the trochanter there. So that is after doing both the hips. This is the AP and the lateral view. And finally, we did both the knees also. So rehabilitation in these kind of patients becomes extremely important. The truncal balance has been poor. So after so many years of bedridden, so after doing all the 4 joint replacement could be mobilized with walker, and that is 1 year post-operative X-ray after doing both the all 4 joints arthroplasty. Finally, a word about dual mobility hip. In this kind of complex situation, whenever you feel that the chances of dislocation is high, then one can prefer to use a dual mobility hip in this kind of cases. So take home message to your friends. So this complex primary total hip replacement, it involves varied etiology. The cause of complexity could be soft tissues, maybe biomechanical complexity or morphology of the bone may be a problem. So meticulous planning is the key. And you must select what surgical approach you are going to do, posterolateral approach or going a dual approach, or you may prefer to do a trochanteric osteotomy primarily. You have to have proper implant selection, whether you want to use a long stem, whether you have to use a stem in different version. Implant placement related to patient anatomy is extremely important, and these patients usually require little prolonged rehabilitation. And these are technically difficult surgeries, but all the technical difficult surgeries does not necessarily transform into a poorer outcome. I thank you again for a patient hearing.
Thank you very much, sir. That was a wonderful presentation. We'll move on to the next talk. The next speaker will be Professor Ramesh Sen. He's Professor of Orthopaedics at, he's working at Fortis Hospital, Mohali. He's well-known surgeon nationally and internationally on pelviacetabular courses and primary and revision arthroplasty courses. He's going to talk on revision total hip replacement. Over to you, Professor Ramesh Sen. Thank you. He's also been traveling, actually. We are very grateful, sir, for you to join us and deliver your talk.
Very good evening, Professor Elashhab, Dr. Shyam. It is always a pleasure to talk to our Egyptian friends, and definitely this is a golden opportunity which we are using. Thanks a lot for all that program. So my take is on revision hip arthroplasty. And we all understand, as Dr. Mohanty described, a lot of issues with the primary. Accordingly, when we talk about revision, they are likely to be quite a complex procedures. And incidentally, the incidence is now increasing day by day. You can see in US that one of the reports is 137% increase by the year of 2030. Considering the revisions, they could be early revisions or late revisions, and primarily they are the aseptic loosenings, infection, instability as the primary cause for these loosenings, for these revisions. So when we have to manage, we need to have a proper tools for implant removal. We need to have appropriate graft also, and likewise the components which will be required for. So for the femur side as well as for the sternum side, all these instruments are likely to help us. Then how to fill up the gaps? We can use the impaction grafting, a standard technique which Dr. Mohanty also just showed about it, or in that kind of a need, we may use the augments which are now available, which can help along with the cages, which can give us a stability. So all these things now are available and can be used for. As for the specific cups are required, yes, we have now various type of cups which provide better biocompatibility. They are better for the physiological status of the bones also. So whether we use a Gription, whether we use a titanium, whether it is a trabecular metal, they provide good porosity also, and we have got a better outcomes from these. Now we talk about acetabular defects. the Peprosky classification, as we all understand, is the best known classification. And if we go with the algorithm, that's always safer. That when we talk about a type of 1 defect, we are talking about a situation when there is no migration, there is no lysis, collar line is not violated, just a bigger size, and a standard cup with the bigger size cup can give us a reasonable amount of stability and the outcome. There could be a situation like this, that the previous cemented cup is getting loosened, and now because this implant is very old, which has been put over this side of it, and then we change it out, take it out and put a bigger implant and again add a cemented stem on the other side of it. Here, one of those BHRs which has actually lost its position, again this could be removed and again we change it over from both the sides by getting this kind of a cup over there and having a proper stem in there. Now, if we talk about a defect type 2, meaning by a little superior migration, which is not too much, less than 3 centimeter, but ischium, there is no lysis, our columns are intact, and there is a reasonable area for the host bone to get. Now, here we definitely have to avoid any elevation of the hip center, but half a centimeter, if we are getting a better kind of a contact, can be accepted. We may use a bone graft to support it. We have done these cases with the impaction grafting also, where we put graft, he can use a mesh, and this is the subsequent follow-up. This can take over, give a reasonable outcome in these cases. When needed, in these kind of a defects where we do not have any kind of a graft, we can use, and right now they are much vogue in use, is the augments which can be put in the superior side of it to get the cup positioned properly along with the teardrop. And this kind of a situations can help us to avoid the higher positioning also and give us a reasonable amount of stability in the hip also. We had been using this Berkshire cage, as Dr. Mahathi also told in the previous talk. These cages have also been used for this kind of a revisions at some time, and if they are supported well by the graft, they can behave better also, though it has been observed that they do not last more than a few years, 5 or 6 or 7 years, but probably it is the kind of a grafting which done adequately can help it. Now, if these defects go further and the lysis is too much, now our buildup has to be accordingly more than that. Again, we do have the options of using augments so that they bear the load bearing from the cup itself also. And with this kind of a situation, this is our own case where we had initially used a allograft which failed, and then we have gone for the augment. That augment stayed over there, and thereafter we could get the cup over to the proper position. So material wise, augments give us a much better outcome as compared to the allograft which we used to earlier. Though there are few papers, even the recent literature, which says that allograft as a bulk can sometimes be used. When the loss of the bone is too much, we might use the other augments also, which provides a reasonable amount of stability to bring down as much as we can bring down the cup. And it's also important that all these patients are likely to have a weakness in the muscle. The dislocation rates are higher, so dual mobility cups are supposed to be better. If the defect is more on the medial side of it, again, we need a medial build-up. And so again, the augments can be used, or we can sometimes use a graft along with the jumbo cups, meaning by a cup much bigger than the original sizes on the opposite side, which can give us a reasonable stability. And as was talked earlier, multi-hole cups give us much better stability because we can put screw fixation to other sides also, not only the superior side. So appropriate graft and multi-hole cups to have. The problem comes when we have a discontinuity, as was talked in the previous talk also. Now, this is a situation when we have to say whether it is an acute kind of a discontinuity or a chronic kind of it. In an acute kind, it definitely need a stability, maybe with a plate, then a cage, and then probably the cup can be put inside it, or we may use a trabecular metal. In a chronic situation, the things are got of fibrosis there. They do provide an inherent stability, whereby a distraction or by that kind of a technique, we can have the stability without taking much of the fixations. Now here it is a discontinuity. Actually, this was a case of a radiation necrosis where there was a discontinuity. Here we put a cage to stabilize the discontinuity, added a lot of graft, and we could have a reasonable outcome. This is another case which was a traumatic. Initially, some acetabulum fracture was fixed, and the THR was done, but it disrupted inside. And this is old kind of a cage which we used to have at one time, an uncemented cup which it used to give, but it has been used in, I think it was 2006 or 7, and thereafter we have been able to get a reasonable amount of stability in that with the adequate graft over that area. If the loss is significant, the advice is to use a cup cage construct. Here you can say after that removal of that kind of a thing where you require angiography and all those things to be careful while retrieval of the implant, you get a significant back area. Now this is the situation where you need a kind of a trabecular cup to go first inside to step up with the original residual bone, and over that you apply the cage, and over that you apply a cup according to the proper positioning and the versor at that place. So this is that example of using a cup cage construct which can be done. There could be a situation that if that area has been there with the fibrosis, a lot of fibrosis, you can use a kind of a jumbo cup in that situation, which will be used as a distraction also, and it will give us a stability also. And here we can have a purchase proximally as well as medially or distally also to get this thing. Now with the availability of 3D printed technology, we can have these models according to the defect. This is one of the defect where there was a multiple surgeries in this patient. So in that kind of a situation, we got a specific defect analyzed, 3D printed, customized implant made. And this is the use of this implant where we have been able to get a replacement done with the stability provided into this area. This is the another case with a similar kind of a problem where we had a loss of the bone also, where we had used this 3D printed cage and the 3D printed defect along with the place for putting a cup, and this is that cup, and where we have done a replacement subsequently. Looking toward the femur side, again we have used the Periprosthetic classification, which gives a reasonable amount of the advice regarding that. And in the femur side, extended trochanteric osteotomy is one of the most common procedure to get access for removal of the previous stem in these cases. And in these cases, we have used cemented stems also, which has been seen to give a good outcome in these cases. These are the two examples of using of a cemented stem in Periprosthetic, one type of a femoral defect, where the metaphyseal area, there is not much of the loss. But if this is a bigger loss of the metaphyseal area, in that case, we will have to use a longer kind of a stems, which can give us a reasonable access. Now, we do have uncemented stems also, where we have got the cylindrical kind of the stem, which we had been using in the past. And these stems also were extensively used, and they used to give us a reasonable kind of a outcome with the purchase into the diaphyseal area, where the proximal area is not too much, for various indications, whether it is revising a bipolar or whether it is doing all sort of things. But if the femur proximal area is destroyed, just like in this case, we have got a reasonable amount of a loss. Again, we have used this kind of a stem, and we have been able to get the outcome. And here, when the two sides were broken, both the stems, so we went on the two sides, a long kind of a cylindrical stem. Here on one side, the ETO had failed us, but the patient is able to walk around. Then there were modular stems also available, where we could match the area of stability with the diaphysis as well as metaphysis. But whenever the defects were significant, it required a lot of grafting in between also along with these stems. So here, to build up the diaphyseal area, we added a graft along with the mesh into this kind of a situations. Another situation where we had lost all the metaphyseal area, we had to depend upon the diaphyseal stability, and here we have used these long cylindrical diaphyseal stems. And as said earlier, we believe in using this dual mobility cups in all these situations due to the higher chances of this. This is another case of the similar kind of the stem coming out. Again, the same kind of a cylindrical stem we have been able to use in these situations. The problem with these stems have been the failure. They tend to break, they tend to cause a stress, the concentration, and they used to break it up. So this is another such case where the previous stem was broken and they need a kind of a adequate grafting into the proximal area also. And with adequate kind of a grafting in the this diaphyseal area, the patient was able to have a reasonable outcome in this situation. But now we have got taper stems available, and these taper stems definitely are good in their elasticity also. They are titanium made, and these kind of a situations, they give us a better outcome. Just like in this Peprosky 3 kind of femoral defect as a periprosthetic fracture, this is the taper stem. And this here also the short stem was removed and a longer taper stem has been used in this case. Or when we have got a significant involvement of the loss of metaphyseal as well as diaphyseal area, again a tapered stem in the distal area does give us a reasonable amount of stability. Another situation again with the same kind of a thing, and again setwise going for a taper stem in that area is given. If there is a significant involvement of the proximal, there is another option, that is to use a coral stem also, and this is a coral stem which is little bigger kind of an implant but has got a locking facility to get better purchase in the distally, and this is what we have used in this kind of a situation. So while we are concluding, we understand that we are talking about revision scenario, we have to go with the algorithm defining the defect on whether on the acetabular side and the femoral side, because that is likely to help us in planning the kind of construct we can do, whether we require a graft, mesh, cage, metal cups, or the type of stems they required. And then the modularity in these cups is likely to also further help us in making and addressing the defects. Cylindrical stems have yielded better results, but it's better to have a tapered stem now because of the stress shielding with cylindrical stems. Thank you.
Thank you so much, Professor Ramesh, my dear Professor Ramesh. And thank you for your great support and great help, sir. It's an honor for us, sir.
Thank you. It's my privilege also. Thanks.
Thank you so much, sir. Thank you so much. Now we come to the last speaker in this very, very beneficial session, which is the Indian session. Many thanks to all our dear Indian professors and consultants. And now we come to the last session, last presentation in this session, which is the presentation of my dear friend, Dr. Srinivas Kamphanti. Dr. Srinivas, besides being an eminent Indian specialist in knee and hip surgeon, in knee and hip replacement and surgery, he is one of the cornerstones for more than 3 years in the Indian-Egyptian cooperation. My dear friend, thank you for everything.
Thank you very much, sir. I'm very grateful to all the speakers who have actually accepted, despite their very busy schedules, clinical as well as academic schedules, to participate in this program. And also, I would like to thank Professor Elashhab and the Egyptian Orthopaedic Association for this opportunity to organize this program. It has been a wonderful program. So much of knowledge has been shared. So my topic is a small one. It's on traumatic posterior dislocation of the hip, persistent and reduction issues. I have nothing to disclose about pertaining to this talk. Hip dislocation occurs in 5% of all dislocations, and posterior dislocation is the most common, and associated femoral head fractures are uncommon. And there are multiple classifications of dislocation of the hip. This talk is not about dislocation itself, but some complications associated with the dislocations. 35% of dislocations occur in the third decade of life, and 75% occur in males, and 5% have associated neck or femur fractures. Simple posterior dislocations have higher rates of hip dysplasia. The size of impaction, acetabular fracture or femoral head fracture are related to amount of abduction and flexion of the hip at the time of injury, and there is minimal flattening at head and neck junction at lower level, which is a normal finding. So we need to differentiate this from an impaction fracture. Posterior wall includes the rim and retroacetabular surface and articular cartilage according to the AO Foundation. In the dictionary, the rim is the edge of something in the shape of a circle. So some arthroscopy literature is present on rim fractures when excision of the osseous fragment results in a lateral center edge angle of less than 25 degrees in AP and anterior center edge angle of less than 20 in the false profile view. Then it is recommended that the osseous fragment should be repaired in order to prevent instability of the hip. We have seen this in Dr. Pardiwala's talk as well. There can be multiple complications in hip dislocation. In this talk, we focus on three aspects, which are acetabular rim fractures, femoral head impaction fractures, and labral injury. Algorithms have been published on how to approach a patient with dislocation in order to manage issues. And this is one such algorithm. After attempted relocation, if the hip remains dislocated or subluxed, check if there is a femoral neck fracture or concentric reduction. Our issues are related to concentric reduction. If the reduction is not concentric, patient needs to go to OR for achieving concentric reduction. And if the reduction is concentric, look for associated fracture. And if there's no fracture, assess stability. And if there is a fracture, evaluate if it is a femoral head fracture or an acetabular fracture. But the literature does not delve deeper much into the following injuries: the acetabular rim and impaction fractures of the femoral head, also called the Hill-Sachs type lesion of the head, and also labral injuries. We will be looking just some cases and explore management options for these injuries. So reduction outcomes can be concentric and stable, for which conservative management is advised, and eccentric or unstable, which needs to be assessed further. Here is a 25-year-old man who sustained posterior dislocation, and post-reduction, the hip was found to be eccentrically reduced. The joint space is increased and the Shenton's line is disrupted. MRI scan and CT scan confirm presence of bone chips within the joint, and an open arthrotomy was done through a posterior approach and pieces of bone removed. This can also be done through an arthroscopic approach to the hip. Postoperative radiograph showed a congruent hip with restored Shenton's line. This is another case. A 26-year-old sustained fracture of the proximal femur on the right side and dislocated the hip posteriorly on the left. Coronal section showed incongruency, and in this case, it appears to be a single large fragment that is interposed in the joint with the distracted joint. 3D reconstruction showed the distraction and fragment posteriorly, and this is after proximal femur fixation with attempted reduction. It is still not reduced, closed. So he was taken to theater for open reduction and fixation. A large fragment was interposed in the joint, but it would not take 2 screws to fix this, as the inferior part of the fragment had a long area of thin bone which would split if the screw is used to fix. So these are the intraoperative CM images and postoperative radiographs with good reduction. I used 1 screw in the thick part and anchored the thin flat bone with an anchor. And he was kept non-weight bearing for 4 weeks with gentle range of movement exercises. This is a lateral view. These images were at 6 weeks with good reduction. At 4 months, he was doing well with functionally walking independently, and fracture appears united. This is a 43-year-old lady who sustained dislocated hip with which was reduced closed and given traction for 10 days and discharged elsewhere. She presented to me about 5 months after injury, complaining of persistent pain in the hip, difficulty walking stairs, and clinically there was pain specifically more than 90-degree flexion and internal rotation. As you can see, the MRI shows an impaction fracture of the femoral head anteriorly. This is actually a deep impaction. She also has a labral injury posteriorly. It's possible that on internal rotation, the lack of capsular restraint possibly engages the impaction partially, causing pain. I did an open posterior labral repair, and the impaction was untouched. This is the postoperative radiograph. She is doing well clinically and no more pain on flexion and internal rotation. There are some similarities with shoulder in the hip. These are acetabular fractures with bony Bankart lesions and labral tears with Bankart tears. and femoral head impactions with Hill-Sachs lesions. But the differences are hip is inherently stable, unlike shoulder. Acetabulum is deep, so low incidence of recurrence. Labral tear and deep impaction could be an issue, as we have seen, and rim fractures, specifically including wall, could cause instability and persistent symptoms. Femoral head impaction fractures are common. However, most are minor and have little clinical impact, and these are not seen on X-rays. Well, they have to be seen on scans, either MRI or CT. Deep femoral head impactions might engage the rim, and there is little literature on this topic. Hence, a multi-center study or a multinational collaboration even to examine more instances would be optimal. So it is possible that large dents could occur in slightly older osteoporotic bone or females, like in our third case, and potentially cause symptoms. Measurement and classification of these are unclear, and literature from Hill-Sachs lesion could be borrowed for evaluating and managing these. Management of symptomatic and engaging deep impactions require femoral head and distal tibial allograft reconstructions. Retroacetabular impaction, which happens when the head hits the posterior acetabulum and causes an impaction fracture, is rare and only recorded as case reports. The gull wing sign has been described with rim fractures. Any loose fragment in the joint is an indication for surgery, whether in or out of the weight-bearing zone. And fractures can have different configuration, and management depends on the configuration. For comminuted ones, excise, like we have seen in case 1, small fragments may be fixed with 2 anchors if screws cannot be used. Medium fragments may require a screw and an anchor, like in our second case. Large fragments may hold 2 or more screws or even hook plates to fix with the acetabulum. A labral tear with significant head impaction fracture may be symptomatic, and treatment may include labral tear repair with or without impaction injury management. Like the remplissage procedure in shoulder, restricting internal rotation by advancing short external rotation could be an option. Again, trials can evaluate these options. And impaction fractures of femoral head are common and should be checked looked for in every posterior dislocation. To summarize, femoral head impaction fractures are relatively common and should be looked for after posterior dislocation. Management of these is unclear, and further studies are required to evaluate options. And acetabular rim fractures are less common. Management depends on the size of the fragment, and options include excision, screw fixation with or without anchor fixation. And look out for impaction injuries in labral tears after dislocation. Persistent symptoms would require repair, either open or arthroscopic, and multicenter studies are required to establish treatment algorithms. Thank you very much.
Thank you so much, Dr. Srinivas. We have one question, sir, from Dr. Gamal Qasim. Time elapsed for rim healing and how we deal with acute impaction.
So I think most impactions, there's not much literature on it. Most impactions are harmless. Very deep impactions could have problems in the future, and they do not fill up when they heal. So they have to be filled up with bone graft if it is a deep impaction fracture.
Yes, sir.
This is
Thank you
like
so much,
we
sir.
see in the Hill-Sachs lesion in the shoulder, sir.
Yes, sir. I think we have no more questions, sir. Finally, I would like to thank, first of all, I would like to thank Dr. Srinivas for his great effort to arrange this very fruitful scientific session, the Indian experience in hip surgery. And many, many thanks to all our eminent guest speakers from India. And happy Republic Day, sir. And hope to see you, all of you, again and again in many scientific cooperations and scientific webinars. Thank you so much for being with us. It was an honor for us, sir. Thank you so much, sir.
Thank you very much, sir. Thank you very much. The honor was mine as well. Thank you very much.
Thank you, sir. Thank you, sir. Professor Amish, thank you, sir. It was an honor, sir. Thank you so much, sir. Sir, now we will move to the UK session. We will start the UK session by a live workshop for the short and long gamma nail, the workshop will be presented. Thank you. You would like to continue with us, sir?
Just one this thing. Unfortunately, Professor Amarnath is not able to join us because he is in a place where the connectivity is very poor. So that talk had to be cancelled. Sorry about that. We'll try to get
have his video, sir, and we will put it on the YouTube channel.
Okay, sir. Thank you. Thank you.
Thank you so much, sir. Thank you, sir. If you would like to continue with us as you like, Dr. Srinivas, we will have the UK session, and we will start with a workshop done by Professor Ayman Suryal, a consultant of orthopedic surgery, Peterborough, UK. It will be a live transmission on the long and short gamma nail in proximal femoral fractures, and sponsored by Stryker Company. Dr. Ayman, Professor Suryal, please.
Can you hear me, Dr. Mohamed?
Yeah, I can hear you, sir. You're very welcome, sir.
Thank you very much for the kind invitation. It is my privilege to present this live workshop from the United Kingdom. We are in Cambridgeshire, UK, and we are sponsored today by Stryker to present to you the gamma nail fixation. So to the best of our ability, we are going to present the techniques for successful fixation using the gamma nail. I'll be broadcasting from a webcam to show the methods and techniques, and there will be a presentation. I'm going to be switching between both laptop and camera to showcase as much as we can. You're happy for us to start? So first things first, this is the International Hip Symposium, and we are broadcasting from the UK as described. My name is Ayman Suryal. I'm a consultant in trauma and orthopedics. My specialty is hip fractures, arthroplasty, and reconstruction. So to start off with, this is the AO classification. The gamma nail or any short intramedullary cephalomedullary nail can be used to fix the fractures. We've got the AO classification, starts with an A1 fracture, simple trochanteric fractures, to the more complex trochanteric fractures, which is the A2 fractures, and then ending with the subtrochanteric and reverse oblique fractures. For the short nail, the fractures should not extend beyond the lesser trochanter. And this is the design of the gamma nail. The gamma nail, we're currently using the gamma nail 3. It's made of titanium and alloy. The lens is got a spectrum of lens. For the short nail, we've got in the UK, we've got 180 millimeter lens, which are not sided. The longer nails are sided with the arc of curvature that is roughly equivalent to the femoral anterior bow. The nail diameters available for us to use are the 11 millimeters and the 13 millimeters. The proximal lag screw, we've got a range. We've got the 120 degrees, 125, and 130. There is a bend in the proximal femur, which is 4 degrees in the coronal plane, and that allows us to use a trochanteric entry point. We've got a built-in 10 degrees of antiversion, and the distal locking bolt is 5 millimeters. For the short nail fixation, the fracture should not extend beyond the lesser trochanter distally to have a successful fixation. We have different techniques to align the fracture. One of them is traction table, correction of the sagittal plane displacement through the use of traction or pressure or bone elevators. And correction and prevention of neck rotation is an important aspect of this. So this is a diagram showing the traction, how we should apply traction. Bear in mind that we should adduct the leg a little bit to be able to have the trajectory of the nail not impeded by any other kind of traction or by the table. And the image intensifier will come from this angle to show us the hip fracture. Now, first things first, we are looking at the entry point. The correct entry point, which is really important for successful fixation, should be at the junction of the anterior third and posterior two-thirds of the trochanteric region. When we look at the femoral neck sits in an offset position, occupying roughly the anterior two-thirds of that region. Therefore, targeting that area would put us roughly in the center of the femoral neck. This is a trochanteric entry point. It's not a piriformis entry point because we got the 4 degrees bend, and we can achieve that through either an awl or through a guide pin, which is 3.2 millimeters in diameter. So the entry point can be also done by the guide pin, and in case we want to correct that to achieve the optimal position, then we can go for this multi-hole aiming device that could center us in the perfect position. Okay, so back to
Dr. Ayman. Not see your presentation, sir.
Okay, so we've
we can see the workshop just only the theater, but we cannot see the presentation.
Yeah. Okay. Can you see the workshop from the theater? That's what we're going to be sharing now.
But the slides stopped, sir.
Yes, we've stopped the slides. We're going to go for the live workshop now, Dr. Mohamed.
Can you make it? Can you make it a bigger screen, sir? Full screen. If we can make it full screen and concentrate on the instrument, sir, this will be good. We cannot see the instrument.
Mohammed, it was working, but now it is not for some reason.
Okay, we are waiting, sir. Yes, we can see it now, sir. We can see it now.
Okay, good. So we can use the awl to create our entry points, aiming, and that should get us inside the medullary cavity. That's one way of doing it. Okay, and that could help us to avoid, the skin in some bigger patients. Another way of doing it is using the guide wire. Using the guide wire to go inside the medullary cavity. That's one way of creating the entry portal. And then we've got the tissue protector. And we can use this tool to go into the medullary cavity. that takes us as deep as we would like, because the proximal nail is 15.5 millimeters in diameter, and that basically allows us to insert our nail. So this is again entry portal, okay? Just bear in mind that when we're creating our entry portal, we are creating it into the proximal fragment, not to the fracture site. If we go to the fracture site, we'll end up with a fracture being aligned in varus, and we will never be able to get in a good position in the head. So always get in the proximal fragment, because this will give you another fixation point. And when you look at this view, we are in a good position inside the femoral neck and a good alignment with the femur. So, going to go back to the presentation for now. So next is the nail assembly. To assemble the nail, we have to be aware that the gamma nail has a number of settings regarding the angle of the lag screw. We are using today 125 degrees nail, so we're going to set it as such. So back to the live. What have we done last time? Stop sharing. Yeah. So this is our jig. This is the gamma 3 jig, and it starts with holding onto the nail. The nail goes into the jig at there's the serrations that can only be assembled in one angle, and that would fix that to the jig. Then that needs to be tightened. Make sure it's properly tightened, otherwise you can end up with that going not in the desired direction. So an important part of this is the sleeve. There's this gentle lock there, and then it's turned to the 125 degree, and then it's locked into place. And then the sleeve goes on, and it is tested to make sure that we are in the right place. And next step is nail insertion. So we go to the desired depth. And that is locked again. There is a separate sleeve to align this in the center, the femoral head. And then the guide wire is used again to get us where we want. Before we go there, just want to show you, we are aiming to using the image intensifier, which we can't use on the saw bone today because this is not radio opaque enough to show us much. But we have got a targeting tool that we can use, which is this tool that you can see in the demonstration there, to be able to get us to our tip apex distance. Tip apex distance is one of the most important criteria to be able to get the lag screw in a position that would limit the chances of cutout with the patient early weight bearing after surgery. So let's go back to the live. Stop share. Okay. Dr. Mohammed, can you see us okay?
Yes, sir, I can see you. I can see you clearly, sir.
So using this tool with the image intensifier can be used in both AP and lateral projections to be able to make sure that your guide wire is going where you expect it to go to be able to achieve your tip apex distance. So we'll take the guide wire now. So guide wire in place, I went beyond the femoral head to show everyone where we ended. So I'm going to get my camera to go closer. So this is where the nail, the guide pin ended, and this is very close to my tip apex distance. Following that, we're going to measure the depth, which is measuring 100 millimeters. The next step is to use the triple reamer to be able to create a path for the lag screw. This is the equivalent of the triple reamer and the DHS. Go down to 95. Yeah. So that's being done. What is left now is to insert the lag screw. This is a 10.5 millimeter lag screw, and it goes on top of the guide pin, and that should go equally in the same track around the guide pin. So we have gone down as far as we need to be. There's 4 grooves in the lag screw, and therefore it needs to be stopped at right angles, so you can use it parallel to the body or perpendicular. We've got 2 positions as long as we go within 5 millimeters of the subchondral bone. We've got some other tools that we can use. We've got this very useful tool here. It's a reduction tool. And this tool we can use to be able to compress the fracture on table. I use this quite often. It enables me to collapse the fracture on table, gives me much more reproducible means of doing that. Now, back to our presentation to show you something. So the next step is the set screw. The set screw is a very important adjunct to the gamma nail. And that basically what it does, it creates more rotational stability and allows controlled lateral displacement of the screw. You can use this tool. So let's go back to the screen. So back to the screen. This tool enables me to apply the set screw without it sliding out of the medullary cavity. So this is our set screw, and this keys into our lag screw, and it travels quite a distance down. So you have to make sure it goes down and it starts and it becomes really solid all the way. Until this is unable to rotate, and then you can turn back quarter of a turn to allow gradual sliding of your short nail lag screw. Following that, we can disengage the applicator from a sheet, and we can take this out, and then that is pretty much, after that, we're going to do the distal locking, which can be done through the jig as well. Yes, thank you. Let's remove the lag screw. Any questions for this stage, Dr. Mohamed?
We have just one question, Dr. Ayman. From Dr. Sanjoy. He's asking, is it open or closed the procedure?
This is, we are doing this procedure as mainly as a closed procedure. And basically, the benefits you get from a nail fixation over a DHS fixation is less soft tissue damage, less morbidity, quicker recovery as per the latest Cochrane review. And I have presented that in the SICO conference in Egypt in November. So there is really no benefit in doing an open procedure here. You can do this procedure through 3 small stab wounds, one for the entry point, one for the lag screw, one for the distal locking. So this is meant to be a closed procedure. I would recommend doing that.
I have another question, Dr. Ayman. What's your solution for, what's your solution for obese patients?
So positioning on table is very important. You remember the first slide about the patient positioning. You have to have your patient in a position that will allow you to get access to the greater trochanter. My incision is about 2 to 5 centimeters above the greater trochanter, and you have to have a trajectory that would allow you to get in there. You might need to make a bigger incision, but still the jig does allow you quite a distance. So I have not needed yet, and we do see some really big patients. I've not needed yet to do a fully open procedure. I might need a slightly bigger entry point to get the correct position for my entry point, but I would still not recommend a totally open procedure. Any other questions, Dr. Mohamed?
No, please allow me to send my greetings to your fellows. I think they were with you in the SICOT in Egypt. I'm right?
They were. And I have here with me, I have a representative, David from Stryker. I've got Alex, I've got Santosh, who are our surgeons and our registrars. And they help massively with this.
Thank you, sir.
Lovely. Shall we now move on to the long nail?
Yes.
So before we speak about the long nail, let me just share a couple of points within my presentation. So the main issue with more distal fractures long nail fixations are a little bit different. Now, because the long nail is slightly different in terms of the anatomy, you've got a fracture which is distal to the lesser trochanter up to 5 centimeters. And some people, even with proximal femoral fractures in elderly patients, they would prefer still to put a gamma nail or similar for the risk to minimize the risk of a neck or femur fracture after fixing the long fracture of a long bone. the classic deformities, an abduction deformity which is driven by the abductors, a flexion deformity which is driven by the iliopsoas, and the distal fragment is adducted by the adductor muscles. It is very, very important in subtrochanteric fractures, while you're using the long nail fixation, is to reduce the fracture. Some experienced surgeon can reduce using the nail or can reduce with indirect technique using a reduction tool such as this. So we can use this reduction tool. And we can use this to reduce the fracture. My recommendation is try to reduce the fracture through traction, or even if you want to put a clamp on the fracture, again, it is not something that would be frowned upon. You will make a small incision for the lag screw anyway. So imagine that is where your incision will be.
Sir, would you please stop your sharing screen to see the technique?
Yes, we will.
And we have just one question, Dr. Ayman, before we go to the long nail, from one of our attendees, tips and tricks for avoiding varus reduction.
Yes, absolutely. So, again, traction is the way forward. You can avoid varus reduction. A good traction will avoid that. You can use a number of techniques, including joystick of the proximal femur through a pin or a nail. You can even, if your lag screw is going through this area and you make a slightly bigger incision and you apply a clamp, it is not the end of the world. The most important problem, and thank you for this question, is your entry point will be an ongoing reason for failure of reduction. Because if you create your entry point too anterior, this is going to be a problem. If you create it too posterior, again, it's not going to work for you. A too lateral entry point will keep your fracture in varus and you will not be able to correct it. So try as much as possible to reduce your fracture before creating your entry point, because once you've created the entry point, you're committed. You can't really play with it anymore. So these are my advice. So we're going to try to start again. So can we have this? Going to start on power again. Again, entry point to conteric entry point. It's funny how sawbone can be really tough. Usually we're dealing with very old osteopenic bone, and this is not a problem. Just gonna take this wire out for a second. With long nails, it's reasonable to run a reamer down the medullary cavity, because you never know If it's a very wide medullary cavity, then that's fine. But sometimes we are not that lucky. The long nail, I always go in this direction. So with the nail pointing up, I think it's still a little bit too tight. So let's have the ring back. And if you need to ream the medullary cavity, you need to flex the reamers. By all means, I think it's a reasonable thing to do. Okay, now let's see. We can go in with our nail. So nail is going in smoothly. I'm going to remove the clamp now, because obviously it's holding. And again, as you do with a short nail, same angle, 125. Okay. Are we out yet? Yeah. Again, it's in a reasonable position in terms of tip apex distance. And then same happens again. We measure and then we apply. I mean, we don't normally go out of the cortex. This is just for demonstration purposes. And the same applies for the long nail. And then the lag screw again. I pull back the sheets to see how much depth, but we can check this with the image intensifier. Normally, we go as far as 5 millimeters off the subchondral bone. Again, that sits square, and then we can do the set screw. I normally use the set screw without the sheath. And check that my lag screw is locked. With the subtrochanteric fracture, if there's no fracture in the trochanteric region, you can lock your screw completely because you're not expecting any movement in that. You just want something to prevent varus collapse with the nail. In terms of the distal locking is done under image intensifier. So for the nail, there is a distal locking targeting device, but in most cases, we just do it freehand. So remove the jig. C-arm will be placed to show us a perfect view of the distal locking. Have a drill. And we don't have the use of the C-arm, but the screws are done under C-arm guidance in that direction. And we always aim to get perfect visualization on the distal. I mean, this is another indirect reduction technique there. But as I said, be very careful, because if you don't have an intact tube and you can't get the entry point in the right direction, it becomes a very difficult thing. Once you've created the entry point, you're committed and you can't change it afterwards. And the lateral perfect view of the distal locking allows you to get the distal locking screws. And thank you very much.
Thank you so much, Dr. Ayman, for this very interesting workshop. Thank you so much, sir.
We tried our best, because I've done many workshops, but the first time to do a workshop online is just tried to show as much as possible, given the limitations of an online workshop.
Thank you, sir. I think we will have many questions. First question from Dr. Osama Tadros. What if the greater trochanter point of entry is broken in a coronal plane, or if it is busy cervical fracture or 4 parts rather than intertrochanteric one? Do I am still using a nail, or I should convert it to DHS?
Well, using a extramedullary versus intramedullary, there is many centers like this center who use the intramedullary device for A1 type of fractures. It is not a the advantages is mainly soft tissue, and that's fine. However, if the entry point fracture or comminution is not on its own independent point that would allow you to change between a nail and the DHS, there are more important factors. If the lateral cortex is not intact, that's a better case for a nail. Okay. If the lateral cortex thickness is less than 17 millimeters, that's a better case for a nail. If the entry portal for the DHS, there's a fracture extending to it, that's a better case for a nail. In these circumstances, the nail will prevent the medialization of the femoral stem and will give you a better support. When the greater trochanter is comminuted, it makes the choice of the entry portals a little bit difficult, because you're not actually choosing an entry point. You're kind of going through the fracture site. But because it's comminuted, it's not going to push your fracture in varus. So you have to align your entry point with the shaft in line of where you want your nail to be.
Another question, sir. What's your tips for subtrochanteric fracture reduction with traction table?
Again, for traction table, you have to have adequate traction. You have to balance the adduction to be able to get the nail in, with the fact that you don't want your fracture to end in varus. Traction in abduction is better. You will notice that it's easier to achieve a reduction for a DHS, for instance, because you're pulling the leg in abduction. So you're not working against your abductors. So you have to try to balance yourself to get in a position between enough adduction to get your trajectory for the nail going in and to get your alignment right. Varus is a very poor thing for fracture. Sometimes if you have to accept a little bit of varus to start, then you can accept a little bit of varus, get your entry portal right, get into the medullary cavity, and once you get the nail in, once the, can I have the tick, please? Still there. Once you got your nail in and you are inside the medullary cavity, you can now put your leg into abduction, because you already got your nail in, and then you can correct your varus. Sometimes you can adopt these techniques where you start in a slightly off position, like you can sometimes accept a little bit of fracture distraction because the overall alignment is very well. Once you get your lag screw in, you can release your traction and do controlled compression of the fracture site, and then you've overcome this. So you have to consider where you want to be and use as much experience you have and the tools you have to be able to get the best alignment. As I said, a joystick technique with a rush pin is a way to improve it. Homan retractors under or over to correct the sagittal plane deformity is useful. And these are as much tools I can tell you to reduce a fracture on the traction table.
One question from me, Dr. Ayman. Some doctors use not the rush nail as a joystick, they use the nail itself as a joystick, and after they obtain reduction, they introduce it in the correct manner. You are not afraid of fracture of the neck of the femur in doing such a technique?
We're always afraid of fracturing the neck of the femur. Yeah. I'm aware, at least in my practice, one case where there was a coronal split of the head of the femur, and then that becomes very difficult to salvage from this point. As per my last slide in the presentation I've shown you, you can use the proximal femur as your entry point. If you've got a flexed proximal fragment, you can go really posteriorly, create your entry point perfectly well, and then use your nail to reduce it. But that requires somebody who's very experienced with these kind of procedures. As I said, once you're committed, once you've done your entry point, you can't go back and say, this entry point is not perfect, I'm going to redo it, because you can't do that. Once you're committed, you're committed. And if in doubt, I always say, make a slightly bigger incision, like a 3 centimeter, 4 centimeter, put a clamp, and then you've got your...
much better, yes.
You've got your tube intact, and then it should be straightforward nailing from that point.
Yes, sir. Another question, sir. The sleeve for the lag screw, how can you make sure it's pressed against the lateral cortex just by pressing with hand?
By pressing with hands, when you're creating the portal for your lag screw, you need to bear in mind that you're using a knife and you're using your scissors in the direction of the lag screw. You can check the position by image intensifier to make sure you're against the lateral cortex, because if you're not against the lateral cortex, you will not get the measurement right for your nail. You will have a measurement which is too long or too short. In subtrochanteric fractures, you can push it. If you've got a defect in the lateral cortex, you might find that your guide and your sheath is in the fracture site, and you might measure incorrectly. So the right position is just straight outside the lateral cortex, and you need to check it with X-ray.
Yes, sir. Another question, how far the long nail should reach?
Very good question. I always aim for the superior border of the patella as my guide. I know some people use the long nail to go like 2/3 down the way of the femur. I think either you're using a short nail, which will end at 180 millimeters from the GT, that's the length of the nail. If you're using a long nail, I think you should go all the way down to around the superior border of the patella.
Another question, do you use a direct distal screw 90 degree or switch method with 45 degree?
I'm not really sure I understand this question. Can you repeat again?
Do you use the direct method with 90 degree for the distal screws or the switch method for 45 degrees?
You mean like drill at an angle to get your... I'd rather if you get... can I get a drill, please? Yes. So basically, with the bone in that position, and my C-arm is coming from the other side, okay, I lower my hand to check that I'm spot on the screw hole, and then that's okay. And then I lift my hand and make sure that both views show the same, and then I get my hand down 90 degrees in line with the X-ray tube and just go across, and that will give me a very square drill hole that will get the screw in smoothly, because using a bit of an angle to get yourself in and then getting the nail to correct you, yes, it can work. However, when you're putting the screw in, you will notice a lot of squeaking noises And if you get the screw out, if the screw is not the right length, you pull it out, you will notice a lot of metal filings or even some of the threads being taken off. So I always like to X-ray a slight angle the other direction, and then before I put my drill in, I get it square in line with the X-ray C-arm and then go across.
Yes.
It's a very good question.
Dr. Ayman, I saw some of the companies using, I think it's a very useful technique for freehand installation of the distal locking screws. They put something like light source inside the nail, and when it reaches the distal locking screws, you see through the holes light coming out, so you can make a drill on this light. You can follow it.
Yes,
right?
I'm aware of.
What's your opinion about this technique, sir?
I'm aware of the technique, and we've used it in practice back home, but I seldom use something like that. It's just we're getting in another equipment and a light source fiber optic, and for me at the moment, it takes me 2 minutes to create 2 distal locking screws. It comes with the territory. I'm a hip fracture specialist, and I do, on average, a number of hip fixations a week. So I don't necessarily use it, but me and my team here, we go through a big number. We get about 15 neck and femur fractures done here in an average week.
Yes, sir. We have some more questions. One of our attendees asking, where is the starting point in intertrochanteric fracture involving greater trochanter?
Yes, again, we would always start with an entry point, which is, so can I have the drill, please? So my entry point, this is for a gamma nail. Every nail is different. There's some nails who use a more lateral entry point, but my entry point is the junction of the anterior third and posterior 2/3, roughly in that region. And that is my entry point. If there is comminution, yes, you can ignore the comminution because parts of the gluteus medius will still be attached there, so don't worry about that. But you have to choose and think where the entry point was and go for that.
Yes, sir. Dr. Samah is asking a question. I think you have mentioned it, sir. Can we use chance pins in reduction tools? I think
yes,
you have mentioned.
You can use the chance pin as a joystick to reduce varus malalignment or flexion deformity. As I said, you use the minimal intervention because we are talking about elderly patients with very poor soft tissue. The main advantage of the nail over the DHS is that we don't open a big incision. So you want to limit the amount of intervention. You need to get this done with the least intervention possible.
Yes, sir. The last question is from Dr. Gamal Qasim. How can you assess the screw entry in the neck to prevent penetration?
To prevent penetration to the femoral head.
Yeah.
So I do that through the image intensifier. I stop short of 5 millimeters of the subcondylar bone. If the bone is really hard, I can use a tap. We've got a tap associated with the gamma nail. But normally the bone is soft, and I just stop short of 5 millimeters on the X-ray.
Yes, sir.
In terms of the guide pin, we've penetrated the femoral head on this occasion in the sawbone because we don't have access to an image intensifier. But on the true operating, we can just allow it to go just to the subcondylar bone, nothing further.
Yes, sir. I think we have no more questions. Thank you so much, Dr. Ayman Suriel, for this very interesting online virtual workshop. For the first time you have did it.
It's been my pleasure.
I hope you can do another one in Cairo, sir.
Bismillah.
Bismillah. Thank you so much, Dr. Ayman. and thank you for the good preparation, and many thanks to Stryker Company team. Thank you so much.
Lovely. Okay.
Thank you so much, sir. Thank you. Now we will move to the next speaker in the UK session. I think Dr. Ashwin is not yet with us. Yes, he's not with us. So, Dr. Michael, you are ready with the record of Professor Peter?
Yes, doctor.
Yes, please. Our next speaker will be Professor Peter Giannoudis, the eminent hip surgeon in UK and all over the world. Professor Peter is a professor in Leeds University, and he's the editor of Injury Journal, and we hope him a very rapid recovery. Best wishes for him. Please, Dr. Michael.
First of all, I would like to express my appreciation to Professor Elashhab for the invitation to participate in this very interesting international hip webinar. I'm Peter Giannoudis. I work in Leeds, England.
يحضروا يا فندم.
واحنا بيحضر عندنا من في ده من 30 ل في حد شغل يا فندم مايكل. Dr. Michael, please.
I don't think.
Can you play Professor Peter again?
Yeah, sure, doctor. Other one, someone played.
Someone please make all our dear panelists mute, please.
Sure.
Can you start it from the start, please, again?
Yes, just 1 second.
First of all, I would like to express my appreciation to Professor Elashhab for the invitation to participate in this very interesting international hip webinar. I'm Peter Giannoudis. I work in Leeds, England, and it's my pleasure to contribute to this educational event. This is the outline of my talk, and let's start with some facts about hip fractures. 2 billion pounds is the third most expensive diagnosis with 1.5% of healthcare budget. 1 in 3 females older than 50 years of age are associated with this injury. 50% of orthopedic trauma beds are occupied as a result of hip fractures, and this injury is associated with a greater bed occupancy than any other disease. Moreover, the mean age of this patient population is about 84 years of age. 20% of these patients present being unfit for surgery. 30% are diagnosed with dementia. 20% they've got at least one episode of related delirium. The overall mortality rate at 1 year is about 22%. Just under 8% die within 30 days of surgery. And of interest is the fact that 5% of them usually present with an associated fracture to another part of the human skeleton. If we look now what was happening with these patients in relation to their treatment in the past, one could say that these patients were of low priority amongst emergencies, often treated by junior staff on out-of-hours emergency lists. Wait for surgery on average was about 4 days. There was poor rehabilitation available, and in general terms, poor outcomes. Let's go now to the UK story of improving hip fracture management. what actually made the difference in the management of these patients in the UK was, first of all, professional engagement, political engagement, NICE hip fracture guidelines and BOA guidelines that became available, the implementation of a national hip fracture database, and also the changing the tariff for hip fracture, an initiative by the Department of Health, by the government in the UK. So professional engagement. It was very important to ensure that all the related disciplines were sitting around the table to be able to discuss this topic and be able to agree on some important issues in regards to the management of these patients. So a dialogue for a patient care, for a better patient care, was of paramount importance with all the stakeholders. Political engagement, that was also very, very important for a change to take place. Elderly patients, they are usually a sensitive topic for politicians to listen and to implement policies for improvement of patient care. Professional standards of care, the British Orthopaedic Association was also very important. We, in the UK, as part of the work that was done within my association, the British Orthopaedic Association, we developed a leaflet about the care of patients with fragility fractures, hip fractures, very, very important. But we also developed a boast which basically describes the facts and the guidelines how these patients should be managed in an ideal scenario when they present to the units that will manage the hip fracture. NICE, the National Institute of Clinical Excellence, engagement was also very important because the hip fracture guidelines were produced by this organization, and you can see that there have been at least 3 reports the past decade. The objective was to stop variation of treatment amongst different hospitals, different areas of the country, standardize the care, and improve patient outcome. It was the major focus of this initiative. So if we look into the hip fracture guidelines in terms of the timing of surgery, the guideline is to perform surgery on the day of or the day after admission, and we must identify and treat and correct comorbidities immediately so that surgery is not delayed by anemia, anticoagulation, volume depletion, electrolyte imbalance, uncontrolled diabetes, uncontrolled heart failure, correctable cardiac arrhythmia, or ischemia. If we look into the hip fracture registry that we've got, it was clear that out of analyzing 65,000 patients, that the 30-day mortality rate was 7.4% with GA, 8% with spinal. That appeared to show a statistical significant difference. And for this reason, it was down to the anaesthetists to offer a choice to the patient in terms of GA or a spinal after discussing the risks and benefit. If we look into the other guidelines published by NICE for displaced intracapsular fracture in terms of fixation or replacement, the recommendation was to perform replacement arthroplasty, hemiarthroplasty, or total hip replacement in patients with a displaced intracapsular fracture. And in each kind of guideline that NICE provides, it also allows the clinician to evaluate the available evidence. And in the interest of time, I'm not going to go through the evidence for each recommendation. In terms of the recommendation of replacement, the guideline is to offer total hip replacement to patients with a displaced intracapsular fracture who were able to walk independently out of doors with no more than the use of a stick and are not cognitively impaired and are medically fit for anesthesia and for the procedure. NICE also provided guidelines in terms of whether we should use a cemented or an uncemented stem. The recommendation is to use cemented implants in patients undergoing surgery with arthroplasty. In terms of the recommendation to use an extramedullary or intramedullary implant to stabilize the fracture, the recommendation was to use extramedullary implants such as Leiden hip screw in preference to an intramedullary nail in patients with trochanteric fractures above and including the lesser trochanter AO classification types A1 and A2. Also, part of the guidelines of the NICE, it was clearly reported that we involve at a very early stage the emergency department, the radiology department, the orthogeriatric department, the anesthetic department, the critical care team in theaters, the orthopedic department, physiotherapy, occupational therapy, social worker, intermediate care, family and carers, and primary care, etc. So it was clear that all the disciplines that they could have a positive impact in the management of these patients should be informed very, very early in the clinical pathway of these elderly patients. The summary hip fracture guidelines by NICE are that time to surgery should be performed within 36 hours. Preoperative optimization with orthogeriatrician input must take place. Sliding hip screw for trochanteric fractures should be the choice of implant. Cemented replacement for displaced intracapsular fractures should be the standard of care. Early multidisciplinary rehabilitation is essential to improve outcomes, and also falls and bone health review must take place prior to the patient being discharged at home. Now, another important factor that had a positive impact in the change that took place in managing these patients was the UK National Hip Fracture Database. Started collecting data in 2007. Currently, 186 hospitals have been registered and they provide data input. And right now, there are over 750,000 cases recorded in the hip fracture database. So this database is government funded, is independent, is prospective, it captures a common data set, is a real-time initiative, it captures population of patients 60 plus, and it provides the opportunity to do an epidemiological level 1 study in this patient cohort. This is how the database looks. The National Hip Fracture Database, it's easy accessible, and you can see the different domains that exist when one visits this web site and the information that one can collect. Another important factor that contributed positively into the care of the management of these patients was the change in the tariff for hip fractures. The government assign a tariff, 6 key standards, admissions protocol, joint orthogeriatric care, surgery less than 36 hours, falls and rehabilitation assessment, mental test score, osteoporosis assessment, and treatment. And as you can see, if you are able to achieve within your unit all these requests, then the tariff from year 1 goes from £440 to £1,335. So in other words, if you tick these boxes, then the government gives you money back, because like that you should be able to send the patient back to their care home or house as quickly as possible, and like that it will be cost saving more than what the government pays to the hospital, because the cost of treatment will be less. Now, if we look in terms of evaluating the need for hip fracture and the need to treat the underlying fragility and osteoporosis, as you can see, we've got also in our institution the fracture liaison service. This exists now in every unit in the UK, because unless you've got this service available, obviously you will not tick the box and you will not be able to claim for the money that can come to your unit as a result of the hip tariff. Now, a lot of information can be given in terms of the fracture liaison service from the Fragility Fracture Network. For those of you that you don't have such a service in your institution, you can visit this website and you can learn more about how to set up such a service in your institution. Now, let's look into the hip pathway and what we did in Leeds. So you need, in order to develop a hip pathway, you need to apply the integrated concept. Structured multidisciplinary care plans detailing essential steps in the care of patients with a specific clinical problem. This is what it's all about. They have been proposed as a way of encouraging the translation of national guidelines into local protocols and their subsequent application to clinical practice. They are also a means of improving systematic collection and abstraction of clinical data for audit and of promoting change in practice. So you can see here an integrated care pathway for hip fracture that we use in my institution. It's a very detailed one in terms of all the pit stops and how in each pit stop from the home, the site of the injury, to the ambulance, to the emergency department, to the admission, to the ward, and what should take place in each of these steps in terms of professional engagement, discipline engagement, and how the patient can be shifted from one pit stop of the pathway to the next one safely in a timely fashion. Always at the center of these integrated care pathways is the patient for an early, safe discharge to a safe place. There are different forms that have been filled in each step of the pathway. So you can see here the nurse assessment emergency department form. This is the day 1 postoperative form that the nurse has to fill in terms of the morning, the evening, the afternoon, what has been done, who has been involved, who needs to be engaged, etc. This is the physiotherapy assessment. This is an index in terms of progression to physiotherapy. And this is the integrated care pathway. Rehabilitation is very, very important. How after surgery the patient can be mobilized safely and can be optimized in terms of his condition to have an early discharge home. So the current status in the UK in terms of this integrated care pathway, every unit must have one for hip fractures. Minor differences may exist due to local variations. Objective is to standardize treatment across the nation. and the National Hip Fracture Database monitor performance and gives feedback to hospitals underperforming. So the Leeds story, the integrated care fracture hip pathway in Leeds, we got engagement of patients and their families to make sure that all we plan would be approved by them. They would like it. We would listen to them, and we would do some changes if we felt it was necessary based on the feedback that was given. And you can see how, by applying this integrated care pathway, how we managed to the length of hospital stay within our unit. And these green bars demonstrate the length of hospital stay, and the long bars demonstrate the admission every month in terms of numbers of patients presenting with hip fractures. And you can see here that we managed to achieve on the green, by applying this integrated care pathway, all the boxes that one has to tick in order to be able to get the tariff. We were a bit on the red, mobilizing out of bed. By the day of surgery, we managed to engage only 86 patients, but everything else, and that has been improved now, is above 90. And you can see here all the team being involved in this integrated care pathway, from senior management staff, nursing staff, surgical team, geriatric team, patients, administrators, etc. So, to conclude, it took several years to improve the management of hip fractures in the UK. It required a coordinated effort by the relevant professional societies, clinicians, government, the Fragility Fracture Network, and obviously it was very important to have patient engagement. Every hospital has a hip pathway to comply with the guidelines set by NICE and the professional societies. The National Hip Fracture Database has facilitated improvements in the care of frail and older people with hip fractures. Deaths have been halved since 2007 as a result of the monitoring and giving feedback to the units. Surveillance is ongoing to ensure that there is no drop of standards and quality or of performance. Finally, I would like to share this with you, the fragility fracture patient, the different pit stops, the engagement of the different disciplines, and to thank you once more for the invitation to contribute to this very exciting and interesting educational event. Thank you very much for listening.
Thank you so much, Professor Peter Giannoudis, for being with us, sir, and hoping for you a very rapid recovery and going back with us in every webinar. Thank you so much, sir. Our next speaker will be Dr. Ashwin Yonathan from Ashford and St. Peter Hospital. Dr. Ashwin, happy birthday for your son, sir.
Thank you. That's very kind of you. There's a lot of noise in the background. They've got 14 kids in the house. So please bear with us.
Happy birthday, sir. Happy birthday.
Thank you very much. Thank you for reminding. Can I start?
Yes, please, sir.
Okay. Thank you very much for giving me a second opportunity. I remember the last time was just during Christmas, on the day of Christmas. Right. Please bear with me. I just need to understand how to screen share. Give me 2 seconds. I've got my presentation ready to go.
Just open your screen, your presentation, sir, and press on the green button, sharing slide share down there.
Okay, green button. Green button. Sorry, so I don't use Zoom. Green button.
Open the presentation, sir, please, first.
I have opened the presentation. Yes, the
presentation. And then you will find a green icon down there, share screen. Green icon down there. Green icon with an arrow, share screen.
Okay, 1 second. Sorry, apologies.
Just move with your mouse, Professor Ashwin. Move the mouse on the faces, and you will find a toolbar downside share screen.
Okay. So, do I go to the setting buttons?
You have the buttons down there, and you will find the many buttons, and one of them is green with an arrow inside it. It's share screen. You can see it
in the Zoom. In the Zoom, you're talking about in the Zoom.
Yeah.
No is the answer.
Okay, no problem. Can you send me your presentation, sir, and we will make it live from our side, and you can comment on it.
Okay, I can send it to you. I'm so sorry about this.
I can show you, Professor Ashwin. I will share my screen now and show you where is the button.
Okay, fine. Please do that.
I can. Okay. No, okay, I'm trying. Okay. No, it didn't share the room. So please send the presentation to me or Dr. Elashhab, and we will share from our side.
Can you send it to me?
Yeah. Could you just put on your email address on the chat by any chance, please?
Okay. Okay. Can the next speaker make his presentation as we prepare your presentation, sir?
Yeah, I'm ready, Professor Ashok, if you want.
Dr. Mohamed, how are you?
Yeah, hi.
Okay, I'll send to you my email, Dr. Ashwin, and you can send your presentation to me. And after Dr. Mohamed finishes his presentation, your presentation will be the next. Okay, sir? Dr. Ashwin?
He's mute.
Yes, I'm sending it the presentation. Yeah, I'm sending it to you.
Okay.
Thank you.
We will start with the presentation of Dr. Mohamed Hashim, Dr. Mohamed Suleiman Hashim. Dr. Mohamed, your presentation will be about, I think, periprosthetic fracture.
Yeah.
Okay. Dr. Mohamed is a consultant in Frimley Park Hospital. Please, sir.
Good evening, everyone. Thank you so much, Professor Elashhab, for inviting me for this. I'll be speaking this evening about Vancouver B2 periprosthetic fracture. It's a very common presentation for every arthroplasty unit, and we hope we can find something to offer before revision. It's actually a long case series. I'll be showing the early results only. We have reached the end of the results. We recruited about 16 patients, and we have very good findings. I'll be presenting in the next effort. My name is Mohamed Hashim. I'm a consultant orthopedic surgeon. I'm working at Wexham Park and Frimley NHS Trust at the Tetherwood Hospital. I have nothing to disclose, and I have to acknowledge the team that has working on the study, Professor Mr. Hosseini, Mr. Hasni, and Mr. Menon. So periprosthetic fracture is a big topic with a lot of debates and a lot of conflicts, and we're just trying through this series to put a light on what can we do before revising the stem. So the problem is a major problem financially and scientifically, as the NGR has reported about 100,000 annual primary total hip replacement to 2019. This number is elected to increase up to 130,000 THR cases by 2060, according to the British Hip Society. The median age at 2017 was about 69 years old, which has increased to 73. With increasing the age, is increasing the life expectancy of the prosthesis and puts this at risk of getting periprosthetic fracture. That's why it's becoming a challenging problem for the arthroplasty community. Cases revised for periprosthetic fracture has increased in the last 5 years from 18.3% compared to 12.4% in 5 years ago. And this puts a financial impact of treating such a femoral periprosthetic fracture about £23,000 for every patient. This was by Phillips 2011, is 12 years ago or 13 years ago, which has definitely doubled this amount now. Brady et al. In 1990 has published his novel paper about the Vancouver classification, and Lind has accepted that the Vancouver B2 fractures is the most common type when you have a fracture around the stem with good bone cement and the stem become unstable. So the current debate is how shall we treat Vancouver B2 periprosthetic hip fractures? Shall we revise, as Professor Martin in 2022? There's a systematic review by Khan et al. In BJJ 2017 on 22 studies showing that 343 B2 Vancouver fractures and B3 with a mean follow-up of 32 months to 74 months. And he has shown that significant proportion, particularly if B2 fracture, were treated without revising the stem. And this was associated by a higher rate of reoperation. Then the evidence start to develop more. So Justin has shown that open reduction utilizing an LCB system is a valid treatment option for Vancouver B2 fractures. The key of successful treatment in his hand was anatomical fracture reduction of the femoral shaft in order to ensure that the bone cement interface is maintained and there is no secondary migration of the prosthesis. Then Fleury in 2020 has shown that patients treated with open reduction internal fixation alone had shown a shorter surgical time, low intraoperative blood loss, less RPCs transfusion, and decreased mortality compared to stem revision. So restabilization seems to be possible irrespective of the stem or the fixation technique. Then this study has shown that revision didn't exhibit better radiological results. Moreover, internal fixation is significantly less perioperative blood loss with shorter operative time, so has shown that open reduction internal fixation is a valid alternative to revision arthroplasty. Then Haider in GVGS 2021 has shown a meta-analysis to say that revision arthroplasty continue to be considered the gold standard. However, open reduction internal fixation has been associated with satisfactory results, and there is an ongoing discussion about the optimal surgical strategy to treat these fractures. In this very good paper in BJJ in 2021 has shown that bone cement interface was intact. If the bone cement interface is intact and the fracture is anatomically reduced, we can treat all Vancouver B fractures around external stem with open reduction internal fixation without revising the stem. He brought these two requests to have a bone cement interface intact and to have the fracture anatomically reduced. And he has shown on the other side, the good side of it, that the fixation is associated with less blood transfusion and less revision surgery. And actually, in our series, we debating this a bit. So we treating even uncemented stems, periprosthetic fracture around uncemented stems with still open reduction internal fixation is not only the cemented one. So we received between 10 to 15 cases of Vancouver B2 periprosthetic fracture a year. And based on the evidence, we started to fix this fracture if we have a solid construct and the cement mantle is intact without cement mantle fracture. We have, through the series, had to change that and start to try treating every fracture, even uncemented, and even if the cement mantle has a fracture, and it does seem to work, and we have very good results. So the options to use to open reduction internal fixation of a Vancouver B2 fracture, either on the left side, the NCB plate from Zimmer, which we started to use early before we started the study, and on the right side, the VA-LCB periprosthetic plate from Synthesis. And when we compare, we found that most of the poor results in the literature coming was from using the NCB from Zimmer plate, which it has a lot of screws, has a very rigid fixation, very short working length, and this end by failure of the fixation, especially most of these patients are frail, have a very poor bone quality, have a very prone to non-union and delayed union. But on the other side, the VA-LCB from Zimmer offer you different modes of fixation. So you can use cables on the blade or out of the blade. You can use locking and non-locking screws, and you can actually keep a long working length of the blade, avoid stress shielding on the bone, give the bone a better biological situation to heal. And this can be done by a MIBO technique, so fix proximally and fix distally and keep the other bone non-exposed, all superiosteally, and give that very good chance to heal. So the early results I'm showing today is between May 2022 to October 2022. So over these 6 months, we have received 8 patients with Vancouver B2 periprosthetic hip fracture. Age of the patient range from 80 to 93 years old. 6 of them were females and 2 were males. 5 were total hip replacement. 2 of them were uncemented, 3 were cemented, and the 3 hemi arthroplasty we had were cemented hemis. Most of them have a very low-grade injury, so domestic falls at home. They have reasonable mobility before fall, and Vancouver B2 periprosthetic fracture in all the cases was variable degree of stem loosening or stem subsidence. We operated on them within 1 to 3 days post-trauma. Only 1 case has been delayed because of a delayed diagnosis of the patient admitted under medics for a long time, and they didn't notice that because the patient was bed-bound, they didn't notice that he has periprosthetic fracture. For this series, we have used VA-LCB for all periprosthetic proximal femoral plating system for all cases. We use cables through the plate and under the plate. All of them were anesthetized by spinal anesthesia, done under image intensifier. We do all of them in a lateral position with side supports. And as per the NICE guidelines, we give all of them antibiotics and tranexamic acid on induction. So this is the setup. We start with a lateral vastus splitting approach to the femur, direct approach to the femur. We do a professional reduction and stabilization with cables before we put our plate, just to try to achieve a reduction for the semen mantle and cortical continuity. And we normally measure the blade before we start, and 10 holes blade was the most commonly used one. There is an option in this plate to have an hook plate if you have an GT fracture, but we don't normally routinely use an hook plate. We put more screws in the proximal fragment. We aim for 6 cortices on each side. So 3 on this side, 3 on this side, and these locking screws give you the option to put unicortical or bicortical. And you start with your screw, you go with the screw, start to negotiate the stem until you reach the cement until you reach the stem. And if you reach the stem, you have the VE option to change the angle and try to catch the other cortex. We put them closer to the stem, anterior and posterior through the VE holes, achieving absolute stability at this segment. Then we reinforce from outside with 2-3 cables over the blade, fix it to the blade by this magic eye or buttons. We keep a good working length of the blade. We just fix distally by 3 locking screws. So very rigid fixation up, very rigid fixation down, and a very long working length for the blade. We get them to mobilize day 1 full weight bearing with no precautions. They go under orthogeriatric and physiotherapy care. We discharge them once they are safe and mobile. And we see them, they normally see the GB in 2 weeks just to remove the suture and check the wound. And then we see them in the clinic at 6 weeks and at 12 weeks. And once we achieve proper radiological union and good mobility of the patient, we discharge them from the clinic. The early results we now have the final result, but the early results we had was no major post-operative complication in 7 of the 8 patients, so 88%. Only 1 patient has a deep infection of the proximal wound, and to be honest, this patient has a complex medical history and a lot of problems and low immunity. We did wash him out with antibiotics. We didn't do a DAR. We didn't touch the fixation. It was only wound infection. 7 patient has a normal baseline mobility back, 88%. 1 patient only is still admitted under medics at that time, but mobilizing with a frame. Discharge was delayed for some social and occupational health reasons. 6 of them were medically fit for discharge from day 3 post-op. 1 patient only was not medically fit for discharge, and this was stayed there for 14 days, and this was because of the deep infection. 6 patients, 75% of them have regular follow-up visits with us. 1 patient only missed the follow-up for some social reason, and at that time, 1 patient only was still inpatient. We had no hip pain or mobility concerns in the 6 patients who did a full follow-up. From 7 patients on regular follow-up, we have radiological union in 4 patients between 12 to 20 weeks. 1 patient, even the 3 patients who didn't have a full follow-up, the follow-up went after that and ended by a full union in around 16 to 20 weeks. 3 patients were discharged from the clinic by week 12 when they are completely united and they have satisfactory clinical and radiological progress. So I'll just show you some of the cases. So case number 1 was an 89-year-old lady who has a background of hypertension, AF on apex span. She lives alone and mobilized independently indoors and uses a stick only outdoors. She fell at home and when intraoperative, same protocol, same plate, when everything uneventful, and the post-operative period was uneventful as well. This is her pre-op X-rays, and as you see, she has a cemented stem total hip, and there is a cemented fracture. And we do the same technique, do a proper primary reduction using 2 cables, and we applied our plate by the same principles. And day 2 post-op, this is the immediate post-op picture. Everything will heal nicely. Everything is in place, hold nicely. There is no problems. Then follow her up 3 weeks. Healing was going on. There is no subsidence or varus malalignment of the stem. Implant is in place, holding everything. Then 12 weeks post-op, there's a good union, achieved good union. This lady was walking nicely, has no problem using one stick. And achieved radiological union by after this time, and we discharged her from the clinic. This is her clinical video at 12 weeks. So walking in the clinic, has no problem, very confident. The only issue with her was just a bit of instability. That's why she hasn't get rid of the crutch. Case 2 was an 80-year-old lady with a background, just arthritis, well and fit. Her hip has been replaced 5 years before. She lives with husband, mobilized independent indoors. She had a fall in the garden, and intraoperatively, post-operative, there was no event. As you see, it's an accolade, and the people who use Stryker accolade stem know how much this stem is nicely fixed. It's uncemented stem with proximal coating, which has a very good grip proximally. And as you see, fracture is an comminuted fracture, loss of the medial calcar with a GT fracture. We managed to reduce the fracture as before, hold everything in place with the plate, and achieve the same principle, long working length, rigid fixation proximal. And this lady followed at 12 weeks with a very good union, doing well, mobilizing, has no problem or concerns. Case number 3 was an 83-year-old gentleman, has a background of hypertension and type 2 diabetes, cancer prostate, lives in a care home, and mobilized with Zimmer frame indoors and outdoors. One of the patients who has a poor mobility. He fell at the care home, has an intraoperative and post-intraoperative uneventful periods. Just post-operative, he has some delirium based on his background. So it's an cemented hemi, and as you see, it's a big fracture. The stem is loose, has sunk a bit if compared to the pre-fracture or pre-injury X-rays. Applied the same technique, so proximal fixation, VA plate, holding with cables, and reduced in place. 12 weeks post-op has a complete radiological healing, and the patient was mobilizing back to his normal baseline mobility. Case 4 is an 82-year-old lady with a background of hypertension and type 2 diabetes. She lives with husband and mobilized independent indoors. She fell at home, has an uneventful intraoperative time, and post-operatively just a bit of OZ wound, which has controlled without intervention. Again, it's an accolade, stem, a bit unstable, loss of calcar support. And this is the intraoperative pictures for her. We achieved a good reduction, ensure that we achieved a proper stability of the stem, applied the plate with the same principles. And just, this is the only case we had a medial, very minimal varus collapse, which hasn't affected the final results. The lady was mobilizing well, and the radiological healing has achieved, even with mild varus collapse. And again, this especially the accolade, we expect this because it holds the whole fixation is a proximal fixation. Then 6 weeks post-op and 20 weeks post-op achieved full fixation, full healing, and fixation is maintained in place, achieved the same principle, and the lady is happy with the results. So the message is fixation of Vancouver P2 periprosthetic fracture around the hip with a stable construct. Even if you have a loose stem, even the semen-mantle fracture, there is still a valid option with less cost, blood loss, less surgical risk, less operative time, and early rehabilitation. VALCB synthesis plate offers a good fixation principles and results. Studies limited by the small sample and shorter follow-up. We have continued the study, and we have now 16 patients in the final results, and the final results are still promising, giving the same idea of the valid option of using the fixation in these type of fractures. More studies definitely is needed, and more constructed study on a larger sample patient is needed to confirm the results. Thank you so much.
Thank you so much, my dear friend, Dr. Mohamed Hashim, for this very interesting presentation. Thank you so much for joining us, sir. Our next speaker will be Dr. Metwalli Saeed Ahmed. Dr. Metwalli will speak about fractured neck femur in young adults, fixation perils, and pitfalls. Dr. Metwalli, please.
You hear me, Mr. Mohammed?
Yes, I hear you, sir. Yes, sir. Yes, full screen, sir, please. Yes, sir.
Okay.
Yes, sir. Thank you.
Thank you so much, Dr. Mohammed, for inviting me. In fact, this talk become too hard after the talks of the experts like Dr. Meza Sharia and the Indian professors. Thank you so much for inviting me. I will talk about fixation of fractured neck femur in young adults, perils and pitfalls. There is the controversies in fixation of fractured neck femur are everywhere, like timing of fixation. Shall we go at the middle of the night to push the patient for theater for open reduction or closed reduction internal fixation? What we'll do? How we will fix using cannulated screws or fixed angle implants like DHS? Shall we do capsulotomy or not? The controversies are everywhere, but there is one consensus, which is the quality of reduction. The quality of reduction is the single most important factor within the surgeon's control that influences the rate of healing complications. The aim is to make the hip look like a normal hip, which is, in fact, is difficult. But in the literature, the answer for this question is not clear. What is an acceptable reduction? In fact, what is an acceptable reduction? Number one, the varus alignment is total. Sorry? Sounds clear?
Yes, clear, sir. Go ahead, sir.
Yeah. What is an acceptable reduction? The answer for this question in the literature is not clear. But there is some agreement that the varus alignment is totally not accepted. As stated by Arnold in GBJS 1984, 90 degree of varus reduction leads to 55% fixation failure. Schatzker in Journal of Orthopaedic Trauma in 1988 said that any varus reduction leads to increase of fixation failure about 13-fold. Number two, less than 10 degrees of valgus alignment is unacceptable instead of varus. Less than 10 degree of angulation in the axial bone, either anterior angulation or posterior angulation, is accepted. Less than 1 millimeter superior translation of the head fragment in relation to the neck fragment is accepted. Less than 2 millimeter translation either anteriorly or posteriorly. The other important thing is that there is the inferior translation of the head fragment in relation to the neck is totally not accepted. This study is done by Gottfried in 2013, and he proposed that non-anatomical reduction of displayed subcapital neck fractures is accepted if we achieved what he called Gottfried reduction. He proposed negative and positive Patterson principles, that if the head fragment is medially located relatively to the neck fragment like this, like the picture on the left side, he called it negative Patterson, which is not accepted. But if the head fragment is laterally translated relative to the neck fragment, he called it positive Patterson, which is accepted. If we look this patient on the left-hand side, after 45 days, gradually the head fragment collapsed and subsided inferiorly until the screws cut out and the fixation failed. But if we look for the X-ray on the right-hand side, the positive Patterson, the fracture healed unevenly. How to assess the quality of reduction? There are two main parameters used to assess the quality of reduction. One invented by Drennan and Lowell's criterion, published in New England Journal of Medicine in 1966. He states that the relationship between the head and the neck is like smooth curves or lazy S, like as shown in the picture. If it is acute angled, this means there is malalignment or malreduction. The other parameter is the Gardner alignment index. We look for the head in ideal lateral view. The trabecular pattern of the head and neck is 180 degree aligned with the shaft of the femur, and in the AV view, it is 160 degrees. The controversy regarding the timing of fixation. The study done by Peter Genodis in 2017, it was a meta-analysis assessing the timing of internal fixation of femoral and neck fractures. This study failed to prove any essential association between timing of fixation of femoral neck fractures, but in relation to the non-union. But regarding the incidence of, regarding the vascular necrosis, with respect to the non-union, it indicates that a delay in fixation more than 24 hours could lead to an increase in the incidence of non-union. There is a study done by Obatai and published in BJJ 2004 about delayed internal fixation of fractures of neck of femur in young adult, and this study showed a delay of more than 48 hours before surgery didn't influence the rate of union or the development of a vascular necrosis when compared with operation done after 48 hours. This means that the time factor, as all the concept, the patient should be pushed at the middle of the night for open reduction or closed reduction internal fixation, where the availability of the experienced team and the nursing staff and radiology technicians are not available. This is not an ideal situation because the time factor is not clear. Either to do open, the controversy regarding open reduction or closed reduction, the evidence-based update regarding open versus closed reduction meta-analysis done by Boria Gayome showed that this systematic review includes 21 studies comparing operative versus non-operative open reduction internal fixation versus closed reduction internal fixation of femoral neck fracture in young adult less than 6 weeks from injury, at least 1 year of follow-up, and the primary outcome measure was non-union of vascular necrosis and deep infections. They found that there was no evidence in support of open reduction internal fixation versus closed reduction internal fixation, and the surgical site infection may be lower with closed reduction and internal fixation. What type of implant to use for fixation of displaced fractured neck of femurs? The famous FACE trial published in 2017 in Lancet. It was a multinational study, RCT, done in 81 centers. It was level 1 evidence, well-powered study, include over 1,100 patients, comparing the results of fixation of neck of femur, either DHS versus cannulated screws. Includes patients above the age of 50 years. The primary outcome measure of this study was the hip reoperation of any cause within 24 months after intervention. They found no difference in reoperation rates for the cases who received either DHS or cannulated screws. there was higher EVN rate with DHS, but the DHS shows lower reoperation rates in certain types of fractures like basicervical fractures, badly displaced fractured neck of femurs, and in smokers. The results, this is a study done by Frank Liborash and George Hajdekovic, assessing the results of internal fixation of bowel type 3 vertical femoral neck fractures where there is shearing force along the fracture through the fracture site. They found that mechanical failure rates was higher for fracture treated with cannulated screws compared to those treated with fixed angle device like a sliding hip screw. The rate of failure was 19% for cannulated screws in comparison to the DHS, which is 8%. Cannulated screws are not recommended in bowel type 3 fractures, according to Liborash and Hajdekovic, basal neck fractures, and patient with poor bone quality. This case example is a 17-year-old male. He survived an RT fall from height and his badly displaced basal neck fracture that was reduced and fixed with cannulated screws, partial serrated screws, and gradually the fixation failed with sequential failure of the screws. All the screws broken. Unfortunately, I have only this X-ray, the last X-ray for the patient, but all the screws get broken, and it was revised by large head ceramic and ceramic in this young age. Because the surgeon, because we failed to revise the fixation as the head was full of metal work of the broken screws. Another example, 48-year-old male, he survived a motorcycle accident and he sustained displaced intracapsular basal neck fracture that was fixed with, this fracture was fixed with cannulated screws. I think it's acceptable reduction. But again, the same scenario, the head subsided into varus with sequential failure of the screws. The principle of the principle of cannulated screws needs the screws should be well buttressed inside the femoral neck through the proper entry. Number one, the screw entry is the courtesy of Dr. Pospula. If we choose a correct starting point of the guide wire, but the angle is not accepted, the pilot hole should be expanded with a larger drill bit to allow to readjust the guide wire inside the core created by the proper entry. Again, the screw in the femoral neck should be well buttressed, especially, number one, the inferior screw should be well buttressed by the calcar of the femur to create the third point of fixation. One point at the lateral cortex, second point at the femoral at the head fragment, and the third point should be at the inferior calcar of the neck. Otherwise, the screw will toggle down. This is a study done by Lindquist in 1985. It is a biomechanical study, and it shows that the result of this study underlies the importance of achieving cortical support for the fixating screws of the femoral neck fracture. The inferior screw should be well buttressed by the calcar. The posterior screw should be buttressed by the posterior cortex of the neck, and the anterior screw should be maximum anteriorly and superiorly to achieve the three-point principle of fixation. The technique of cannulated screws. This patient has displaced the intracapsular neck fracture of femur. We put the patient in the traction table, and we achieve this reduction in slight valgus malalignment in the AV view. We start firing the first wire maximally inferior, touching the inferior calcar of the neck, the calcar of the inferior cortex of the neck, and it is central in the lateral view. This is the first screw, or the first guide wire for the first screw, achieving the medial the inferior patris through the calcar. Screw number two, guide wire number 2 and number 3. The guide number 2 should be buttressed by the posterior cortex, and the anterior wire should be buttressed by the anterior cortex, and the posterior wire buttressed by the posterior cortex of the neck. This is the final results. So intraoperatively by C-arm, all the screws are well buttressed, and the post-operative X-ray, and this is the results after 9 months. For vertical or bowel type 3 fractures, or this shearing force through the fracture site, after reduction, we can use what's called bowel screw, which is transverse screw applied transversely across the fracture site to neutralize the shearing force, or to convert the shearing force into a compressive force. This is the reduction we achieved on table. The fracture shows shearing force. I start putting the partial threaded screw almost perpendicular to the fracture site to pull the head fragment and decompress it. Then we proceed for the definitive fixation by DHS. And this is a video sent by the patient from his country. Another case, this is 48 years old male. He survived an RTA and he sustained displaced intercapsular fracture neck of femur. And this after reduction, we put the bowel screw across the fracture and we fix it definitively by sliding hip screw. And this is the results, the fracture chip fully united. Another example of this badly displaced intracapsular fracture neck of femur in 22 years old male after an RTA. The decision here is very difficult, either to go for total hip replacement with this badly displaced fracture in this young age, which this scenario is not accepted, but the decision is difficult. We proceed for collision reduction and fix the fracture with DHS. There is a varus reduction, but the fracture at the end united. And unfortunately, the patient developed AVN, and we removed the DHS as a form of decompression or in preparation for total hip later on. The last case is this 46-year-old lady. She's working as a teacher. She has a displaced fracture neck of femur, clavicle fracture, terrible triad injury, and PCL avulsion from the tibial attachment. The advice for this patient, or the decision, was to proceed direct for total hip replacement as the fracture is comminuted and is badly displaced. This is the results after fixation after 54 months, the fracture fully united. And this is the lateral view. And the patient is walking normally without pain, no Trendelenburg gait, no limping. In conclusion, the least accepted in femoral neck fracture is anatomical reduction. Whatever the method you achieved it, either open or closed. The implants will not differ, either cannulated screws or DHS, but there is contraindication. There are contraindications for cannulated screws, like a patient with poor mineral density, basal neck fractures, and bowel type 3 fractures. The screws should be wide. The principles of cannulated screws necessitates the screws should be widely displaced in the femoral neck, well buttressed by the endosteal surface of the neck. And lastly, the timing of fixation of fractured neck of femur still it is controversial. There is no definite conclusion, either to go at the middle of the night and to push the patient for theater, or to wait for the next coming list. Thank you.
Thank you so much, Dr. Mutwalli, for this very interesting presentation. And we have just one question for you, sir. Dr. Aydros, yes. Please, how to assess negative buttress? Yeah, the negative buttress means the medial cortex of the head fragment is medial to the neck fragment. If I can go backward for the slides. It is just a step. Where the step is, either the head fragment is lateral or medial. It's as simple as that. Is it clear? This is yes, sir. We can see the slides coming. I'm sorry for that. Yes. Yes. If you look for the X-ray on the left-hand side, the medial cortex of the head is medial to the neck fragment. I will use the pointer here. Yes. This is the immediate post X-ray. This is the head fragment here. There is a step. It is minimal. But if you look here, it is quite obvious. This is the negative buttress. Regarding the positive buttress, the head fragment is intramedullary. You can say the head fragment, the medial cortex of the head is intramedullary or lateral to the neck fragment, like this. This is called the positive buttress. Yes. Yes, sir. Thank you, sir. Thank you. Thank you, sir, very much for your interesting presentation. And the last speaker in the UK session will be again Dr. Ashwin Yanathan. Dr. Ashwin, you are with us? Mr. Ashwin? Dr. Mutwali, would you please stop sharing your screen, sir?
Yes, sure. How can I stop it, sir? It's already stopped, Dr. Mohamed.
No, it's in front of us, sir.
From where can I stop it? Sorry.
Dr. Michael? You press on the button stopping share. Yes, yes, sir. Thank you, sir.
Yes.
Dr. Ashwin, you are with us? Mr. Ashwin? Mr. Ashwin, you are with us, sir? Okay, we will move to the next speaker, and I think next speaker will be Professor Paspola. You are with us, sir. Dr. Mitwali, would you please introduce Professor Paspola?
Dr. Paspola is a consultant of orthopedic surgery and trauma in Faronia Hospital in Kuwait. He's from Poland. He is my mentor and my good father.
Good evening.
Good evening, sir.
Thank you first of all, thank you very much for inviting me for this conference. I want to make some short presentation about minimally invasive plate osteosynthesis, so-called MIPO, in proximal comminuted proximal femoral fractures. How to progress this? Come here. How to progress the slides? Yeah. So I have, sorry for this delay. I have no disclosures regarding this material. And we can say generally that fixation of fracture with restoration of anatomy and soft tissue preservation is the objective of all system of internal fixation. However, in comminuted diaphyseal fractures, and also especially in the subtrochanteric metaphyseal, this principle is difficult to implement, and anatomical reduction of fragments had been achieved at the expense of tissue, soft tissue violation, with resulting delayed union, non-union, failure of infection. And as we know, not all of the structures are suitable for nailing. And we can see that this comminuted fracture in the nail, you cannot provide sufficient stability to allow early weight bearing. The so-called biological osteosynthesis. Can you hear me?
Yes, sir. Please, everybody's muted, please. Please, everybody's muted. Please, everybody's muted, my dear professors. Please, sir, everybody's muted. Please, sir.
So can I continue?
Please, sir, everybody's muted. My dear professors, please mute everybody.
Okay.
Yes, sir, you can continue, sir.
So biological osteosynthesis was first proposed in Germany in early 1980s and became popular, addressing problem of comminuted diaphyseal fractures. and alignment of fragment without anatomical reduction and use of percutaneous plate became principle of biological fixation. My initial experience, including the MIPO in comminuted diaphyseal fractures and humerus and tibia, was published previously. And in this presentation, I want to comment about result of treatment of comminuted proximal fracture using MIPO technique between 2009 and 21 in our hospital, which is the big primary trauma center. The number of patients, 31, and mostly males, 96%, and one female patient. The age of the patient, average 35 years. DCS was used in 24 cases, the proximal femoral hook plate in 7 cases. The mechanism of injury was mostly RTA, high energy trauma, in 29 cases, one gunshot injury, and simple fall in patient who was 68 years old. Time of union was average 5 to 6 months and follow up to 36 months. And I will proceed with case presentation. Case 1, it is the 29 years old male, a victim of road traffic accident, proximal femoral fracture. According to AO, this will be 31 A3 fracture. And treatment was by minimally invasive pain osteosynthesis using DCS, long DCS. And this is the final result after 6 months. The second case is a gunshot injury with comminuted proximal femoral fracture, initially immobilized by external fixator, and followed by minimally invasive plate osteosynthesis using the proximal femoral lock plate, using distractor and external fixator during the reduction. And initially after fixation, I maintained the external fixator anteriorly to increase the stability. Then fixator was removed, and this is the outcome after 3 years. And patient decided to remove the plate, which was done 3 years after the trauma. The third case is also RTA patient, proximal femoral fracture. I would say the 31 A3 type, treated by long DCS. This is the incisions, 2 small incisions, and plate was done under the muscles. This is the result of fixation and final results. Another patient, young patient, 19 years old, also road traffic accident, comminuted proximal segmental fracture, proximal femoral segmental fracture. It is used with the same technique, and this is the result. As you see on the middle X-ray, that there is a plastic deformation of the plate, which indicates the result of loading. And in most of these patients, I allowed early full or partial weight bearing from in the first week after surgery. And this patient, he wanted to remove the metal, so it was done after 2 years after surgery. This is the next patient, similar case, comminuted femoral fracture, used with the same technique, using the distractor and external fixator to maintain the reduction, and using the proximal femoral lock plate, long lock plate. This is the intermediate result, and this is the final result. Another patient, similar situation, used by fixed by the DCS, fracture united. Another case, used by the same plate with the same technique. Another case, proximal femoral fracture, using the same technique. This is the final result. And the last case is the 68 years old female patient with multiple medical problems, including the pacemaker, very comminuted proximal femoral fractures. In the previous X-ray study, I found she had the X-ray before the fracture, and as you see, there is significant bowing of the femur, which makes nailing either very difficult or impossible. Use the same technique, so using the DCS, there are the steps of the operation, and this is the incisions, and this is the final result. So in discussion, I would stress that the use of the long plate was based on results of experimental studies, provided significantly higher axial and torsional stiffness compared with the short plate. Biomechanical studies indicate that the length of the plate had been a good predictor of success, and number of screws should not be more than 2 or 3 at each side of the plate. And in this series of highly comminuted fractures, despite non-anatomical reduction and poor contact of fragments, good callus formation and remodeling occurred within average of period, and in most of the patients, I allowed early partial to full weight bearing after surgery. Bone grafting was not required, neither are primary or secondary procedure, and I didn't have in this series even one case of failure of fixation. In conclusion, I would say that in cases of biological fixation, anatomical reduction of comminuted fracture is not necessary on the condition that alignment and rotation is maintained. Fracture consolidation proceeds rapidly, and early partial to full weight bearing was allowed according to clinical circumstances. There is no need for bone grafting, and I consider this fixation is a useful alternative. However, in some cases, the nail can be used, but if the nail cannot be used for the different reasons, this is one of the options for fracture. Thank you.
Thank you so much, Dr. Pospola, for this very interesting talk about such difficult cases. And sir, we have 2 questions for you from 2 of our dear attendees. The first question, do your patient have full weight bearing after operation?
Yes, not all. According to actually, I feel more safe in full weight bearing with DCS. Young patient is good bone quality, I allow full weight bearing. If the patient is older or very obese, then I delay weight bearing or start partial weight bearing. But yes, in many cases, which I didn't show here, I had bilateral fracture, which I allowed full weight bearing from the beginning.
Yes, sir. The second question, sir, how you decide shortening and rotation is adequate intraoperatively?
By visual assessment. By visual assessment. There is option of preparing both sides on the translucent table, and by clinical assessment you can compare the length and the rotation having the normal side sterile.
Yes, sir. Thank you so much, sir. Would you please, sir, stop your sharing your screen, please, sir? Thank you, sir.
Where is the sharing? Where is the sharing?
Mr. Ashwin is with us again. I hope your technical problem has been solved, Mr. Ashwin.
Can you hear me now?
Yeah, I can hear you. Just one moment, and Dr. Pospola will stop his sharing his screen, and you can share your screen. Thank you so much, sir. Dr. Ashwin, you can share your screen now, sir.
Doing share, open system preference. Okay. Right. Can you see my screen? Bear with me 1 second. I'm sharing. Can you see the screen at all by any chance?
No, no, sir. It's not shared. You're sharing from iPad or from what, sir?
Okay, can you see now?
Yes, 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 okay, it's shared. Full screen, please, sir.
Okay, sorry. I'm so sorry.
No, not a problem at all. Full screen, please, sir.
Okay. Sorry. I'm trying to find out 1 second.
Slideshow.
A slideshow, okay. Yes. Participants, new share, annotation. In full screen now.
Yes, sir.
Okay. Sorry, I'm so sorry. So,
not a problem.
All right. So, I'm going to show us. Thank you indeed for inviting me, and sorry for this. So, I'm going to show you various X-rays and take you through my experience. Now, what I would like to let you know is that there is no one fixed rule. I started this process maybe 8-10 years ago, thinking that periprosthetic fracture, you should treat them in a fixed rule. Periprosthetic fracture is a beast of its own, and sometimes you have to use common sense. The most important success of the periprosthetic fracture is the patient is alive at the end.
Sir, these slides are not moving, sir. These slides are not moving.
Okay, so so this is the first patient I wanted to show. That this patient has got a Charnley hip done maybe 30 years ago, and he has a loose acetabular component, and he has now developed a periprosthetic fracture. Now, he's in his 80s. He is not the best fit guy on the earth, and he's an ASA 3 patient. So you could discuss which is the best way to treat this patient. Now, what I have done is now that he's already on the list for loose acetabular. So this is how it looks. And I put a dual mobility in, took the cup out, the cup was loose, and the argument, I'm presenting only controversial cases to have a conversation. I put the same stem back. Well, I did not put a long stem. I put a trochanteric plate and put a cement in cement revision, because if I had taken out the cement and put a long stem, that could have caused problems for the patient. This operation took about an hour and a half, and the patient is doing well. My point of this, showing this slide, is that one could argue that one should have put a long stem in and probably take the cement out. By the time if you've taken the cement out and put a distally fitting stem, probably it would have taken me 2.5 hours with a good amount of blood loss. The whole point of this presentation is to appreciate that the patients should be alive at the end and mobile. The second patient, which is an interesting case, is a neck of femur fracture, had a nail put in. I don't think one could criticize that nail. And he was doing well. Sick about 3 months down the line, it was a 13 millimeter ream nail was used. He came in with a fracture. Now one could argue that, you see this, you should go back and nail it. But he had a big enough nail to go in. It was not infected. So why did he have this fracture? So we discussed this in the MDT, and he lives on his own, and his mobility has deteriorated very much after surgery. So whatever operation I offer him, I need to make sure that he is fit to look after himself at home. So I went in and put a hemi-arthroplasty for him. Now one could argue that is a bit of a controversial to directly go and sacrifice his head, but he's in his 75, and his head is already pepper coated. So giving him a hemi was an easy and a fast way of getting him to mobile, and he was up and about, and he was mobilizing the next day. My third case is a very young patient, 1975 born patient. If you closely look, she has got a small fracture distal to where the taper stem is. Now this happened about a year and a half after she had the primary replacement, and that replacement was done for neck of femur fracture. Now just to give you an idea of patient on the other side, the patient has got number of failed fractures, and she suffers from hypophosphatasia. Now what I did was put a MIPO technique plate on, and which allowed her to mobilize. Now if you look very closely, I've put some unicortical screws, and I've reviewed her nearly 6 months down the line, and she is doing well. So I've shown you 3 different patterns of fractures and how they were fixed based on what the patient factors were. Now this is especially controversial. She's 1937 born, ASA 3 patient, dementia, and in a lot of pain, and she is not very mobile. This is a fully coated, uncemented stem. It can't be difficult to take out, and this is what I did. I put plate and cables. One could say this is a very controversial thing to do, and probably I should have taken the stem off. The proof is she is sitting out. The operation took me about less than about an hour, and the blood loss was about 100 mils, and she's sitting out the next day without in pain, and that is enough for her to mobilize. Now I'm not advocating you to do this, but what I'm trying to explain is the same mantra: periprosthetic fracture, individualize your care on the patient. Next patient, this is a 1935 born gentleman, and he has he's got a resurfacing. In our area, we had lots of resurfacings, and he has not only developed alveol, but now he has a neck of femur fracture. So here, this is his condition is he has got ischemic heart disease, is pre-diabetic, is complete heart block, and I'm afraid in NHS the ITU beds are quite precious, and based on his age, he was not somebody who they thought an ITU would be an appropriate place for him to go. And I put a dual mobility with a cemented cup and a cemented stem, and he was up and about the next day, and I've seen him now 4 times, and he is doing well. Now, this is slightly different from a periprosthetic fracture, but this all comes under the one umbrella. This gentleman has a metal on metal hip with a stem. This is the worst of the conditions because he has got alveol floating everywhere. He has metal ions coming out from the head. He has metal ions coming from the taper, this you can see the amount of metal ions that is there. And he was unwell. He had lots of pus in it, and I gave him, there's no way I could have done anything different, otherwise the patient would have died. Gave him a badly cemented cup and a badly cemented stem, and he is not doing badly currently. Another example is an example of a periprosthetic fracture in a patient who already had a revision hip, okay, and she already in the past before that had a plate there. Okay, and this is where this patient is, and now has a periprosthetic fracture. I put a long stem in. I normally put a trochanteric plate because I worry, though the trochanteric, what I wanted to show is on the X-ray, the trochanteric plate looks a bit difficult to appreciate, or it is not on the right place. But the point is, the trochanteric plate is just to make sure the abductors are kept well, that does not dislocate. Okay, and this is her walking 6 weeks post-op independently. You note the hip which was done and which is on the right side, and she is swinging on the left side because she has got some problems there. Okay, now similar approach. A periprosthetic fracture, Vancouver B with bone loss. I gave her a hip, but look at the trochanter. I want you to watch. I did not put a plate on, and the trochanter is slightly off piece here. Okay, so you got to remember that if you do a periprosthetic fracture, you have to be absolutely certain that you mobilize the patient, and the end result is not the X-ray, but the end result is patient is alive and is pain free. Similar fracture in an uncemented stem. Okay, I put a long stem in, and I put a trochanteric plate, which, if you look very carefully, I was looking at an alignment why the patient was in pain, and the trochanteric plate kept the GT from flying off. Now, this is my, I've got a series of patients, but I think this patient is important, which I remember. So this gentleman during the COVID did not want to come on time, and he came with a fractured base metal piece. And on operating, this is what I found. You can see the amount of soft tissue damage that has happened for this patient. Okay, and I put a hinged knee replacement for him. Similar, this is another patient who has come with almost about to break the metal piece, and look at the soft tissue damage that has caused around, and the tibia that is causing there. And we went, and this is how you can see intraoperatively the amount of loss, and he has got and he's walking. This is him walking, maybe 6 weeks down the line. Okay, and Now, this will be my last slide. This for me to show you. This was done maybe 10, 15 years ago from my predecessor, not by my team. So this is the fracture. You can see this was fixed. Okay. Now the thought process has not gone into the fixation process. I'm not saying this is a bad thing to do, but the thought process has not gone into the fixation process. It's a quite a rigid fixation. The fracture fails, okay, or the proximal bit comes off. Okay. The patient gets an infection. The plate is taken off. Okay, in 2014, and then the patient has to finally go and have a very big surgery. Okay, now this is a very similar case. That would be my end of presentation. Thank you indeed for letting me show my cases. Any questions? I'll be delighted to answer.
Thank you so much, Mr. Ashwin. Would you please stop sharing your screen, sir? Thank you so much, sir. I think we have no more questions, and we are short of time, so we have to move to the next speaker. The next speaker will be Dr. Ibrahim Sayed Kamar from Sligo University, Ireland. Professor Ibrahim, you are with us?
حضرتك فندم السلام عليكم.
حضرتك السلام ورحمة الله وبركاته.
Thank you, Professor Elashhab, for this invitation. I'm honored to be with you.
Thank you for joining us, sir.
So we'll make it fast because of the time thing. So today we'll talk about a very common thing, is the cephalomedullary nail, which we doing it every day, nearly every day. So today our talk about how to plan not to fail. So our objectives today is why we are using cephalomedullary nail, what are the common causes of implant failure, and how to avoid failure in such cases. I wrote one example. This is introduction about the cephalomedullary nail. We know the proximal femoral fracture, the periprosthetic fracture is a common thing, and usually most of patients is in aging population more than above age of 75 is expected to reach about up to 7 million cases by 2050. And the goal of the care is to achieve a stable fixation and restore function and ability to weight bear as early as we can. And the cephalomedullary nail have become a common implant used to treat various types of proximal femoral fracture. So we usually indicated an extracapsular proximal femoral fracture, and this is the AO classification. I think it's mentioned by my colleagues before. So why we are using cephalomedullary nail? So no clear advantage over traditional extramedullary devices like the sliding hip screw DHS, except in certain circumstances, like the NICE guidelines. The intramedullary device has better outcome in the subtrochanteric fracture pattern, which is also agreed by the AOS guidelines. But also there is an amazing study done in China in 2023 in Shanghai in People's Hospital, with sharing with the engineering department in Shanghai, talking about also the make a module using the computer aided design, the CAD program, and finite elements. And they analyzed the lateral wall thickness, and they found the cephalomedullary nail is more stable in the cases with lower thickness of the lateral wall to lack of the buttress of the DHS or sliding hip screw. So this is one of our cases. This lady, she was 88 years old. She had an intertrochanteric fracture, which is treated with proximal femoral nail. I think our mistake at that stage was the tip apex distance. That's why the patient came in 3 months with pain. And when we had X-ray, it showed the cutout of the blade. So after discussion of the available options, we removed the implant and we give her a cemented hemiarthroplasty as a salvage procedure. So what are the common causes of implant failure? So the preoperative, we need to focus on the patient and fracture factors, like in the case of pathological fractures and the like bisphosphonate, atypical type of fractures, or malignancy in metastatic cases, or unstable fracture pattern like subtrochanteric or reverse obliquity fractures. So this is one of the putting a lot of mechanical load on the implant. And also the intraoperative failure, implant failure factors, which is depending on our technique. Like sometimes we do a direct damage to the aperture of the cephalomodulary nail for the leg screw aperture, and this is during the handling of the nail, or also botting the sleeve. Sliding failure, like when using the gamma nail, for example, there is something called thin screw to allow controlled collapse. If we bought it so tight and we prevent and stop the sliding technique, then it can lead to early failure of the implant. And also the reduction. The varus position of the femoral neck is one of the cause of failure, and also malreduction, large osseous gaps, especially in the reverse oblique fractures. And also we talk about the tip apex distance, which is a very important thing to avoid the cutout. In general, the cephalomodulary nail breakage of the nail itself is less than 1%, and the cutout can reach up to 5% in some series. So how to avoid failure? The tips and tricks we can do pre-operatively, intraoperatively. Pre-operatively, the planning is crucial. So we need to choose our patient and the characteristics of the fracture itself. The type of the fracture is subtrochanteric, reverse oblique, pathological, and also the implant choice. When we use the long one, short one, when we aiming to reach to maximum diameter of the nail, in such cases. Like in the fracture configuration, if we have unstable fracture, we prefer to use the long cephalomodulary nail to distribute the stresses in a more surface area. In pathological fracture, we aiming to support this with largest possible diameter. Also the intraoperative, it starts from the patient positioning, and this is explained in the AO in reference. We need we using the traction table. At that time, we need to do some adduction to the limb to aid of the reduction, and pushing the trunk of the patient to the contralateral side to allow us to have freedom during making our entry point, to not affecting our entry point. And also reduction will lower theory of reduction. I think Professor Mutwalli mentioned it in his lecture about the fractured neck femur. And I bought something called the triple H. We'll talk about what the meaning of triple H. So the triple H is not the guy in the WWE. It is the handle and handling. So to keep your hand steady and put your entry point in a proper position to avoid the varus malalignment. So if you went to more lateral position in the entry point, more trochanteric, more lateral, then you lead to varus malposition. And also to reassess the femoral bowing of the patient to avoid putting your entry point too much posterior to don't hit the anterior cortex. And the handling. So usually when we advancing the nails, sometimes the handle become loose, and then when we putting our sleeve through to put the leg screw or the blade, then we hit the aperture and weaken it, and that will lead to the breakage of the nail. Handling the soft tissue. This is also when we're putting our sleeve, to be sure our sleeve is resting on the bone and not deviated by the effect of the soft tissue pressure. So what to avoid? To avoid incomplete fracture reduction, to avoid large osseous gaps, and the varus position of the femoral neck. Also remember, old is gold. The Baumgartner paper published in 1995, he talked about the tip apex distance ideally to be less than 25.3 millimeter, and he found the relation between increasing the tip apex distance and the cutout incidence. So we try to achieve to decrease the tip apex distance as much as we can. Especially we are dealing with old patient with poor bone quality. Talk about some literature. I think it would be nice. The value of tip apex distance, Baumgartner, which still is the golden paper. Also, the risk factors of intramedullary nail breakage. This done in the Royal College of Surgeons, and this is talking about the common causes. And then a nice paper published also by Joseph Betfield about the tips and tricks to avoid the failure of proximal femoral nailing fixation. So what take-home message? Proximal femoral fractures remain a challenge due to the typical poor bone quality and diminished physiological reserve of the typical patients. Implant-related failure, as we mentioned, is about 1%, with the patient treated with the cephalomedullary nailing. Also, this is related to the preoperative patient fracture characteristics. The understanding of implant biomechanics, adequate fracture reduction, and proper instrumentation technique optimize the patient outcomes by reducing the risk of implant failure. Thank you.
Thank you so much, my dear brother, Dr. Ibrahim Said Kamar from Ireland. Thank you so much, and hoping to see you in Cairo soon, sir.
Inshallah. Shukran.
Thank you so much. Our next speaker will be Dr. Ahmed Yassin from Germany. Dr. Ahmed will speak about a very interesting topic. I leave him to explain this topic. Dr. Ahmed, you are very welcome.
Thank you very much for giving me this invitation, Professor Elashhab.
It's
nice to be with you all here. So I will share my screen.
Please, sir.
Could you see my screen?
Yes, sir. Full screen, sir, please.
Yes.
Thank you, sir.
So I would like to talk about de-escalation revision hip arthroplasty. How far could we go with downsizing with the femoral stem? Actually, de-escalation in revision hip surgery has been introduced by Pierre Vives in 1987. And at that time, they did revise interlocked revision stems with primary hip stems. If we take a look at this systematic review of the literature, in which 9 papers have been included with more than 400 patients, and in 4 studies, the femoral defect has been classified with Paprosky classification to be a femoral bone defect between 1 and 2, and the end result was that stem-related survival rate was about 95% at 5 years follow-up. On the other side, the most important finding of this nice analyzing study of the German arthroplasty registry was that there is no difference in uncemented THA between comparable groups in short and conventional stems. This leads to the question if we could use a short stem in revision hip arthroplasty. Let me show you a case example. This is a 63 years old male patient, got this hip replacement on the left side 5 years ago, presented at our clinic with limping gait, pain on weight bearing and leg rotation. Laboratory results were negative for infection, and we excluded PGI with aspiration. If we take a look at the X-ray, we could see osteolysis lines at the proximal part of the femur, and we did the revision in this way. We revised him with the short stem. This is the Optimus short stem, and we can see 2 years follow-up, there is a very good bone remodeling at the greater trochanter, which was resorbed with the spinomolar stem. So, however, not every short stem is actually a short stem when it is to be claimed that is a one. And we can see at this study, this is a comparable study with of all short stems regarding the biomechanical restoration of hip joint. And what came out was the calcar-guided, partially preserving femoral neck short stem is the best short stem with regards better restoration of joint biomechanics, high primary stability, because of the concept of fit and fill and optimal bone loading, so you don't see any stress shielding with these stems. We'll show you another case example. We have here a 64 years old female patient has got this hip replacement on the right side 1 year ago, presented with limping gait, pain on weight bearing, gluteal pain. Labs were normal, PGI excluded. Radiological finds, we can see that the stem is inverus. She has also increased offset on the right side. We suspected that the cup is loose. And we revised it in this way. We did put a cementless cup and revised the stem with a short stem. As you can see here, we shouldn't take all the cement out of the canal. And 2 years post-operative, she is doing very well, and the stem is stable, no subsidence or loosening. So what could we find in the literature regarding this? This is a very nice study with the case series of 6 cases. They have been revised with the same stem, the Optimus stem, and you can see at 4 years follow-up, patient satisfaction and pain scores are very good. Another study which came out last year from Professor Stoffel in Basel, they included 31 patients, 26 patients have been follow-up for 1 year at least, and the stem was the same stem, the Optimus stem. They showed the good clinical and radiological results with about 19% complication rate, which is comparable with what is in the literature. I will show a last case. This is a 71 years old female patient, has got this hip replacement on the right side 18 years ago, and she presented with pain. The same have been done, lab results negative, aspiration, excluded PGI, and intraoperative, we can see that there was metallosis and this tenuosis of the conus, and we revised it with another cemented short stem. In conclusion, we can say that the pros of revision surgery with short stem, it gives us the possibility to do minimal surgical trauma bone preserving surgery. It is an off-label use to get detailed patient consent, and there is no strong evidence regarding this. So in revision cases in highly experience. Thank you very much.
Thank you so much, Dr. Ahmed, for this very interesting presentation, and thank you for joining us. Before we go to the last part of this webinar, which is a surprise, it's a live workshop from Canada presented by Professor Waleed Kishta, Professor and Head of Orthopedic Department, McMaster University, about osteotomies around the hip. We will have a short presentation from the sponsoring company, Eva Pharma company. Dr. Michael will present the presentation. Dr. Michael, please.
Thank you, Professor. Is my screen is clear?
Yes, sir. Full screen, sir.
Thank you. Thank you, Professor Elashhab. Actually, if I thank you a million times, I wouldn't give you your right. You're always keen on organizing such an innovative scientific events. And thank you for giving us a chance to present our products. Actually, in Eva Pharma, we have a variety of products, chondroprotective products, products for rheumatoid arthritis, but in this night I will be presenting neuropathy and the pain domain products. This is a rehearse from the last webinar, so I will be so fast in going through my slides. And for your notice, our products are present not only in Egypt, but it's also present in other countries worldwide. So that will be my first slide. I would like to let you all know that in Eva Pharma we have European Medicine Agency approval, and this approval we got since 2014, and up to 10 years we get the European Medicine Agency approval, which is an inspection which comes from the European Federation, which inspect all our manufacturing techniques, our pharmaceutical manufacturing techniques, and our source of active ingredients, which makes us unique and allow us to export all our products to the European Union and other countries. So we always believe that no one size fits all, but every product from Eva Pharma is of high quality product. In my presentation, I will be going through the pathogenetic treatment in case of entrapment in neuropathies, and then symptomatic neuropathic pain treatments. And lastly, I will be going through the nociceptive treatments. Let's begin with our hero in the pathogenetic treatment, which is thiotacid, our alpha-lipoic acid, which is present in more than 40 countries worldwide. So actually, if you are present in one of these countries, you will find thiotacid by name, but in Canada, its name is diapathic. Actually, we are talking in these cases, sciatica, low back pain, trigeminal neuralgia, carpal tunnel syndrome, all kinds of entrapment in neuropathies. You have to give a pathogenetic treatment along with a symptomatic treatment. What is the pathogenesis of any entrapment in neuropathy? Actually, what happened is microvascular changes. Any entrapment like low back pain and sciatica will lead to low blood supply to the nerve, like sciatic nerve or the median nerve in case of carpal tunnel, and that will lead to nerve hypoxia, which will lead to inflammation and oxidative stress, the release of free radicals, which led to the activation of nuclear factor kappa beta, the transcription factor, which will increase the interleukins, the cytokines, and tumor necrosing factor, which will lead to inflammation and lastly pain. And that will lead to demyelination of the nerve, which actually makes the excessive firing from the nerve and led to the pain the patient experience and the drive to your clinic with. That's where it comes the role of thiotacid, our alpha-lipoic acid, which works as an antioxidant, which stops the process of the pathogenesis from the beginning. It also works as anti-inflammatory, which suppresses the inflammatory activity from interleukins, tumor necrosing factor, nuclear factor kappa beta. It also works as a neuroprotective by increasing the nerve growth factor, which allows the maintenance and remyelination of the deteriorated nerve. And it also works as a vasoprotective, which improves the nerve blood supply. Whatever you give a symptomatic treatment to this patient, whatever the kind of the neuropathic painkiller to give in the patients of entrapment in neuropathies, there will be no improvement without a pathogenetic treatment. That's why we recommend thiotacid in doses of 3 tablets per day in case of severe cases, 2 tablets per day in case of mild to moderate cases, and maintenance dose with a once daily tablet. Our other hero in case of entrapment in neuropathies is Melga Advance, which is a synergistic combination of pemphotiamine and vitamin B6, vitamin B12. The pemphotiamine here is the synthetic lipophilic form from vitamin B1. As you all know that vitamin B1 is hydrophilic, so the patient, it has a very poor absorption, poor bioavailability, and the patient will not get the maximum benefit from it. So the pemphotiamine is the lipophilic form of vitamin B1. Here is Melga Advance, which is an alternative for the injections from vitamin B1s. The WHO recommended only the injections from vitamins, from multivitamins, in case of patients who have inability to swallow, who have vomiting in case of serious and life-threatening illness. So Melga Advance you can use in alternative to the injections from vitamin B1. And here is a study which carried out in the Diabetic Institute here in Egypt, which compares Melga Advance versus the vitamin B1 injections. And actually, the levels of vitamin B1 in the blood were higher after taking Melga Advance versus the other injections. And the results was carried out after 2.5 hours and after 6 days, and there was a significant difference between Melga Advance and the injections. Here is another hero in Eva Pharma, which is limitless vitamin B12, which is mainly a vitamin B12 product, plus folic acid, biotin, vitamin B1, vitamin B6, which is made in a new technology, which is an oral dispersible film. It's easy to use, and it works and dissolves within 15 seconds only. Let's move to the symptomatic neuropathic pain treatment. and you know all conventin, our gabapentin in Eva Pharma, but here is the latest technique in gabapentin, which is gabapentin gastro-retentive tablets. As you can see, when the tablet of conventin XR or gabapentin XR enters the stomach, it swells to a size which allows it to retain in the stomach for up to 15 hours. It continues release of the gabapentin from 8 to 10 hours, and then the tablet dissolves within 15 hours. So you have to take it just once daily, and it covers 24 hours. And here is the pharmacokinetic curve, which reveals this process in details. Here is the blue curve represents the gabapentin IR or gabapentin immediate release. And in case of gabapentin immediate release, there are 3 peaks during the day, which were the main cause of the gabapentin side effects: sedation, abuse, any somnolence, any other side effect of gabapentin. But in case of gabapentin gastro-retentive, here is the curve covering 24 hours, and there is only 1 peak, which is during the patient's sleep. So you will not find any side effect in case of gabapentin gastro-retentive. Actually, this allows a better absorption, minimizes the saturation of the uptake of the gabapentin, and better tolerability for the patient. Our another hero is duloxetine. As I said in the beginning, we always believe that there is no one size fits all. We have Sympatex in a molecule called duloxetine, which works in another mechanism of action rather than gabapentin. But the main benefit of duloxetine is that it doesn't work only as a neuropathic painkiller, but it also works as antidepressant. And we all know that patients like chronic low back pain patients are suffering from sleep disturbance and anxiety. So Sympatex reduces not only pain, but also improves the sleep quality and improves the mood of the patient. Duloxetine or Sympatex is recognized by many international organizations like EFNS, NICE, Canadian Pain Society, as a first-line treatment for treatment of neuropathic pain in case of intermittent neuropathies. Actually, what makes Sympatex unique is that the molecule duloxetine is always subjected for phototransformation. So Sympatex is the only brand which is made by allo technique, which prevents it from the phototransformation deterioration and protects it from moisture. Then we will move to our nociceptive pain products, which is the Stopadol range. I know that the paracetamol molecule. Stopadol here is in Egypt. Paracetamol 1000 milligram, which is Stopadol form in the form of effervescent tablet in orange taste. You can use it in case of acute cases in orthopedic management. And we have also Stopadol extended release, paracetamol 650 milligram for chronic cases, osteoarthritis, and other joints pain. In case of Stopadol extended release, it's made with a technology which allows its release on 2-pi layer, a fast releasing within 15 minutes, immediate release top layer, and a long-lasting or extended release bottom layer. So it have 2 layers of release. One of them is fast and the other is long-lasting. It's advised to be used in case of chronic cases. Our last brand in case of nociceptive pain is Lepradeclan, which is a diclofenac sodium patch, one medicated plaster, which is applied twice daily every 12 hours. Actually, what makes it unique is that the diclofenac sodium in form of patches or Lepradeclan absorption is 2 to 10 times the absorption of the oral diclofenac. So we actually have a negligible side effect because diclofenac doesn't reach the systemic circulation. It works only on the site of its action. Thank you, and I hope that I was concise. Thank you, Professor Ashok.
Thank you so much, Dr. Michael. واحنا كده احنا يعني وصلنا لاخر حاجه the big surprise in the webinar. It's a live workshop transmitted live from Canada, from McMaster University, about osteotomies around the hip, and presented by Professor Waleed Kishta, professor and head of orthopedic department, McMaster University. Professor Waleed is joining now. And after Professor Waleed will finish his workshop, we will again replay the workshop of Professor Gamal Hosni in the start because of some technical errors during making it live. So we will again replay it as a recorded workshop. And if anyone wants to see it, he will be ready after Professor Waleed. Professor Waleed is joining. Professor Waleed, you are with us, sir? Has just finished his work because of the time difference with Canada. He's saying he's joining at once. Professor Waleed is joining in just 1 minute. There is 7 hours time difference between Egypt and Canada.
السلام عليكم دكتور محمد.
عليكم السلام ورحمة الله وبركاته. دكتور وليد ازي حضرتك يا فندم؟
الحمد لله تمام.
منور يا فندم معانا.
ده نور حضرتك.
ربنا يبارك في سيادتك يا فندم.
شكرا على الدعوة الجميلة ومعذرة على التأخير. طول ما أنا قاعد مستني أفكر في حالات تيجي في بالي عايز أضيفها عشان نتناقش فيها.
ربنا يبارك في حضرتك يا فندم، جزاكم الله كل خير يا فندم.
I know this is a workshop, but let's start with the case and then we'll go with the case solving. So this patient is 18-month-old, presented with left hip dysplasia. Patient is normal, so this is non-syndromic hip dislocation or not a neuromuscular hip dislocation. She's completely normal, healthy. She just had a history of breech presentation. She's the first child and she's female and there is no family history of DDH. I would like to see what you guys think in the comments. Just write to me what will be your decision for the treatment, and then we'll go through the treatment technique step by step afterwards.
You can write in the question and answer box, my dear friends.
Yeah.
What's the optimum way of management of such a case? Yeah, open reduction left hip.
Open reduction.
CT is required.
CT required. Acetabular osteotomy, excellent. Close the reduction. Open reduction and stability test. Open reduction, capsulorrhaphy, pelvic osteotomy, femur osteotomy on need if needed. DEGA osteotomy if needed. Perfect. Open reduction plus acetabular plus or minus femur osteotomy. Open reduction plus pelvic osteotomy plus minus femur osteotomy. Open reduction plus minus femur osteotomy. Perfect. So this is most of the answers running towards open reduction, capsulorrhaphy, which I agree, plus pelvic osteotomy. There's a lot of controversy about adding pelvic osteotomy at this age versus not capsulorrhaphy, pelvic osteotomy. So that's very good. Thank you for all your answers. Some people say standard of care 18 months do pelvic osteotomy, open reduction pelvic osteotomy. And I go even beyond this. I do open reduction pelvic osteotomy even at the age of 12 months. They sound too aggressive to some people, but in my practice, I found if I do everything in one attack, it's fine. Sometimes I see a patient young enough not to have enough bone to do the pelvic osteotomy. This is a patient I would wait, but if they have enough LM, then I feel free, because the only block for you to do pelvic osteotomy if needed is if you don't have enough bone stock. But if I have enough bone stock, the child is big, so I don't mind the age. And this way, I feel like I save them from another surgery in the future. There is a study done recently showing the percentage of cases that has done closed reduction versus just open reduction in young age. They found 60% of them needed pelvic osteotomy for the age of 4. So I want to save this. But it's still controversial. And a lot of people just do
open reduction. But 18 months, I would do open reduction, pelvic osteotomy, plus or minus femur shortening. And I agree if needed. From this X-ray, I feel like I don't need it because it's 2:2. But if it's very high dislocation, then shortening will be helpful for the reduction and decrease the tension on the femur head to avoid the AVN. I totally agree with this. So let's talk about the technique. So now my plan is open reduction. I'm ready for Dega osteotomy or pelvic osteotomy. I said Dega, but because it's my favorite, this is biased, but any osteotomy would be fine. If you want to do Salter, it's okay. If you want to do Pemberton, it's fine. If you want to do Dega, it's okay. So any of them is fine. So now, in your booking sheet, what do you want to ask for in this similar case? So please write your comments. What kind of plate? What kind of bed? Do you need a hip spica table? Do you want to use the arthrogram? Do you need C-arm? People work in the private. You think about which private hospital that has the equipment you need. Pediatric anesthesia. So what do you guys think? Or what do you use for femur shortening?
Yeah. Do you ask for CT?
Do you ask for CT scan to measure neck anteversion? Thanks, Dr. Ali, for this question. I don't, especially at this age. So number one, it's too much radiation for this age. And the question, is it really needed or not? It's not needed. Anteversion is common at this age in normal kids. So I don't consider this as important point to deal with. Even if I need to do femur shortening, I don't change the version. So I don't do derotation. So I avoid the word VDRO. I had von Rosen view, but because of the time, I just uploaded the X-ray. So I just uploaded the AP, but it didn't add anything. It's still dislocated with false acetabulum. Interoperative arthrogram, Dr. Ayman, it's a good point. Because I usually plan at this age for open reduction, pelvic osteotomy, I don't do arthrogram for them, but I do arthrogram for the cases with possible cross reduction. So usually at the age of 6 months to 1 year. So in my booking sheet, I asked for a flat top table, so I will be able to do X-ray with on the table, and I also ask for small fragment plate and screws in case if we do shortening. I asked for K-wires. I asked for the osteotomes, straight and curved osteotomes. What about the acetabular index? Yeah, so we know this is acetabular dysplasia, and we go with acetabular index to measure the acetabular dysplasia. And in this patient, the acetabular index was 35 degrees. I'm just trying to focus on surgical technique today more than the clinical case itself. We have done some discussions before about similar cases, but want to try to focus on the technical parts for surgery. So yeah, I asked for straight osteotome and curved osteotome, half-inch lamina spreader. I asked for Garrison, number 3, and periosteal elevators, K-wires, and small fragment plate and the C-arm. Any comments or before we go to the surgical technique? Vicryl nylon size 2 sutures, that's a very good point. I use something called Ortho cord, which is kind of fiber wire, but it dissolves in about 3 to 6 months. But you can use Vicryl number 2. That's a very good option for the capsulorrhaphy. Excellent point. Perfect. So I took the child to the OR. They usually have done pre-operative anesthesia. They see anesthesia 1 week before surgery. They go through all the vital system, and we discuss epidural versus caudal versus just general anesthesia. Do you use bone allograft for the DEGA osteotomy? I don't use allograft for DEGA osteotomy. I use the iliac bone itself. And we'll come to this point. What else? And I also booked the spica table because in our hospital we have to book the spica table. So this is a patient in the OR with a fluoro. Examined the hip before we start the opening, and I did examination under anesthesia. I found the hip is actually reducible when I asked the anesthetist to give paralysis to the patient or muscle relaxant, just avoid the word paralysis, but this is what we use here. And I found the adductor tendon is very tight, so I planned for adductor tenotomy. Do you guys do adductor tenotomy with open or with percutaneous with a needle? I just go down to the basement. We have some noise here, Dr. Mohamed.
Please, everybody's muted, please.
No, it's in my house. Those kids came back from the exams. امتحانات نص السنة.
بالتوفيق إن شاء الله دكتور وليد.
الله يخليك. I'm Muhammad Elashhab. Yeah. No, it's okay. So open, use open adductor, percutaneous, open tenotomy, open adductor tenotomy. So there is a mixed answers. I found that percutaneous with a needle works with me recently. I used to do open, but sometimes you get complication with a small incision. If I get the same results, I would do it with the needle. So I actually get the same results. I get the same abduction I need with percutaneous. I get the 18 gauge small needle, and I make a small incision. And inside the small incision, just get the tip of the needle while the patient in abduction. And I start to scratch the tendon until I feel like I get enough abduction. And then I put steer strips. We don't need to have a big incision with a hematoma and infection later on. I feel like I need the open adductor tenotomy for the CP kids because they need the adductor longus, brevis, sometimes the gracilis, so they need more. That's a good point, Dr. Emma. That's similar to the question. It's Achilles tenotomy needed for the club feet. So it's mostly needed with the DDH because the adductor is tight. But again, examine the patient first, do as the patient need. If the patient doesn't have tight adductor, so you don't have to do it. Excellent. And next will be the position, patient positioning. What do you guys do for the positioning? Position and the drape. Supine was a pump under the gluteal region. Excellent. Supine. Perfect. So supine, I bought just a folded green towel under the gluteal region and a little bit proximal, so wouldn't affect the gluteus. And also I avoid the sandbag, to be honest, because sometimes it affects the X-ray radiation and the view. Perfect. And then draping, I use split sheets. So I use about a green towel. If we have a Foley catheter, which usually have a Foley catheter, get the Foley catheter. If the case is unilateral, I move the Foley catheter above the abdomen and more towards the right side. And when we prep, use a chlorhexidine for prep. I don't know what, it depends on your hospital, guys, but use a chlorhexidine. Except for the perineal areas and around the vagina or the penis, we use clear alcohol. Recently, we had a back order for the clear alcohol, so we use betadine. It's like the old technique because the chlorhexidine is sometimes causes irritation and inflammation to the perineal area. Then we put the sterile green towel at the middle to cover the Foley catheter and stuff. We put the split sheet, and it's all different from hospital to hospital, but most of North America use the split sheet. Make sure you prep the whole femur and the pelvis as high as you can and go up to the nipples, and also make sure it's been prepped even back, posterior, all the femur, the gluteus part, in case if you need to do femur shortening, so you don't have to struggle later on. So make sure you have a very good preparation and positioning for the patient, and this is the position you're going to stay with for a long time. Then we'll move to the incision. So we did the adductor tenotomy either with percutaneous or with the needle, whatever you're comfortable with. Recently, I'm very happy with the needle, especially for DDH, except for the CP. And how about the incision, bikini incisions? So, thank you, Dr. Harris. So bikini incision and how we mark the bikini incision. So there is a landmark. You just don't imagine how the bikini looks like and makes a line. But as Dr. Ahmed said, iliofemoral. So yeah, I prefer the bikini incision because especially for these young kids, they need cosmetic incision and it's very ilioinguinal. And it's very easy to reach out to the pelvis, very easy to reach out to the hip joint. It's very versatile incision. There are two ways to mark the bikini incision. So one way is depends on your fingers. So 1 or 2 finger breadth lateral. Yeah, so Dr. Harris, iliac crest, ACES 2 centimeter below to the femoral and below to the femoral artery. 2 centimeter below to the femoral artery. Yeah, I go parallel to the iliac crest, which is 2 centimeters from the ACES, and I extended medially. You mean extended medially to the femoral artery? Yeah, I stop at before the femoral artery. There is another way. At Texas Coach Right, they make it in a way midway between the ACES and the GT. But yeah, you can see the crease, and based on the GT or the iliac crest, you go 2 centimeters distal to it. Then we open the skin, and what will be the structure you guys looking for after you open the skin? Lateral cutaneous nerve, fascia, lateral cutaneous nerve. So I make the skin incision. So when I do the skin incision, usually distal to the ACES, the skin is very thin and the subcutaneous tissue is very thin, but more proximal. Whenever you go proximal close to the iliac crest, there is more thickness and more fat. So it's okay to go deeper with a knife proximally, except you get some bleeding. But be careful when you go distal to the anterior superior iliac spine, because it's very thin and it's easy to cut the nerve in this stage. I use the bovie after the skin incision to stop the bleeding. And again, I use the tenotomy scissors distal to the anterior superior iliac spine, just to be careful. Then you look at the lateral cutaneous nerve of the thigh. If you don't see it, if you don't find it, don't spend or waste your time looking for it. If you don't see it, just start a little bit lateral. So what will be the interval you're looking for at this stage? I've seen Dr. Noor mentioned looking at the fascia. That's a good point. But what will be the interval at this stage distal to the ACES? Tensor fasciate lata, sartorius tensor. So there is excellent agreement. So we identify the sartorius and identify the tensor fasciae lata. Sometimes these cases are not straightforward and confusing. So to make some landmarks, if you get confused, because I see a lot of cases get congenital external rotation. So all the structures are external rotated. Even the sartorius is external rotated. So either you start to find the sartorius from the origin at the anterior superior spine, or you straighten the knee, hold the patella, then this will be the straight line of the rectus, and the interval will be above the rectus between the sartorius and the tensor fasciae lata. If you don't find the lateral cutaneous nerve, make a small incision at the fascia over the tensor fasciae lata and start from there. Don't try to go through the muscles. Try to find interval. It's amazing interval at this part, and usually you see some fat on it. Actually, at this dissection, I use retractors. And so I put 2 right angle retractors, one to retract the sartorius medially, and the other one is to retract the TFL or tensor fasciae lata laterally. This would be enough to give you the interval dissection. You'll see some fat. If you go a little bit deeper with your retractor, you'll see the rectus muscle. Yeah, you feel the interval by your finger. So either with your finger, you want to feel the sartorius, you can get the interval, or if you want to start lateral to be safe from the nerve, then you get it from the lateral. But the trick, don't go through the muscle, otherwise you lose the interval. Tensor for your need femoral osteotomy. Can you proceed through bikini incision? No, if I need femoral shortening, I do a separate incision. I know some do the curved incisions or iliofemoral, but I don't do it in young children. I do separate incision if needed. Perfect. So now we did the bikini incision, we did the adductor tenotomy. We feel that the hip is going into the joint more easy with a close reduction. and we found the interval between the sartorius and the TFL. What will be your next step? Straight rectus head. Perfect. Splitting the apophysis. Long head of rectus sternotomy. Opening the apophysis plus rectus. Perfect. So there is some sort of agreement for the next step. For my next step, I usually move up. So once I found the interval, I take a deep breath and then I go to the iliac crest. At the iliac crest, there will be the abdominis obliquus muscle covering, overlapping the crest, and it's very close to the abductor muscle. So I will open the fascia with Bouvi, and then I will peel off the muscle. Not completely from the iliac crest, abdominis obliquus, not complete peeling, but it's 3/4 of it from lateral to medial, making sure I have to repair this at the end. So peeling off the muscle to expose the iliac crest. Once I expose the iliac crest, then I will do the subperiosteal dissection. There are two ways to do subperiosteal dissection. One, the most common one and the famous one is you split at the middle of the apophysis with a strong knife, and then I put some sort of sponges at the inner table and outer table. Inner table usually bleeds a lot because there is a feeding artery, and if this artery is not stopping, you can put a bone wax until you complete your dissection. Same thing. Make sure when you split the apophysis is to stay midline. And remember, the iliac crest is curving, so it's not straight. I'll answer you, Dr. Abdullah, but if I found the lateral thinus nerve of the thigh, I use a Sergi loop. But if I don't find it, so I just stay careful and I don't go sharp at this area. I have a pelvis model just to show you the iliac crest is curving. So every time you're going posterior, there's a curvature. So keep feeling it before you cut. Otherwise, you'll fall into the abdomen or you fall lateral. Then once you go into the muscles, it will bleed, especially with a knife. So after I split the apophysis, and now I go all the way down. Make sure when you go down, you see still the anterior superior iliac spine, and I go with the cob or periosteal elevator, whatever you have. I prefer the cob. So go subperiosteal until you go to the sciatic notch, the greater sciatic notch. One thing, avoid to go proximal. So sometimes you fell into the SI joint, so you don't want to do this. You wanna stay vertical and a little bit distal. So always your direction with the pelvic osteotomy is distal. And be careful and go easy. Use two hands on the cob so things will not slip posteriorly, and all the vital structures are in the sciatic notch. Same thing on the outer table. Subperiosteal, control the bleeding. Keep packing this with sponges. I use 4x8 sponges, and make sure you count them with the nurses for the final count at the end. Osteotomor jiggly. We'll come to this, Dr. Noor. Let's go step by step until we come to the osteotomy. I use Homans, blunt Homans at the sciatic notch. Make sure you stay subperiosteum. There are some steps in DDH or the pelvic osteotomies that can go very quick, and there are some steps that you have to slow down. So when you go at the sciatic notch, make sure you slow down, make sure you're careful, make sure you're subperiosteum. Use the homens, make sure the tips of the homens at the sciatic notch are touching each other from the inside and from the outside. And here's a sciatic notch. I'm not sure if you can see it. It's a small camera. So this is the inner table. Sciatic notch. We put the homen in. And because of the background, I see the picture is not stable, but in sciatic notch, make sure both metals meet each other. And some people use radio translucent homens, which will be very helpful. We don't have it in our institute. For the pelvic osteotomy, jugular saw versus osteotome, if you do Salter osteotomy, so jugular saw will be better option. But if you do Dega or Pemberton osteotomy, then you need straight and curved osteotomes. Once I reach at this point, then I'll go back to the first interval. We found the interval between the sartorius and the tensor fasciae lata. Then you go deep, and as you guys mentioned that you'll see the rectus tendon. So the rectus tendon has two heads. So there is a straight and the curved head. So both of them are doing like Y. So I'm doing Y. So most of the time when I cut the rectus to reflected, so I go distal to the delta, all the Y, so I get to the main part before the straight and reflected head. So when I reflect the main branch, then it's easy for me to repair it after. So you find the tendon, make sure I use peanuts to find the tendon both medial and lateral, and you expose it nicely, and you suture it. So either from the distal side only, I put a stay suture in the distal and the proximal side, because sometimes I lose the proximal when I do the correction. So it's easy for me to find it, or sometimes I tie both of them together at the same time at the end. And then when you hold it with the sutures, you start to peel it off from underneath using the peanuts. So at this stage, you'll clean some of the capsule. You'll see the capsule. Your guide will be the femur head because it's dislocated. So it will be under your dissection, and it will be your guide. And you start to peel off the rectus. What will be your next step, guys, after this stage? So now you have the iliac crest exposed. You reach the capsule, and you reflected the rectus femoris, straight head. Iliopsoas, and identify the femoral nerve, iliopsoas tendon, tenotomy. Dr. Ali said arthrotomy. Iliopsoas release, capsulotomy, removes the abductor from the capsule. Excellent point. So, do you guys clean off the small muscles on the capsule, or you just do the capsulotomy right away? Capsule open. Perfect. I take my time to clean off the capsule from the small muscles, iliocapsularis or whatever muscles, and clean all. We clean it. Excellent. Remove the muscle first. Some surgeons do it, not do iliopsoas tenotomy, as anterior chagrin or barrier to anterior dislocation after capsulorrhaphy. So yeah, I clean the muscles of the capsule, and this is before I do the capsulotomy. So the next step after I clean the muscles, I found the psoas tendon, and the psoas tendon. Usually you see the iliacus muscle, and then the tendon is inside the iliacus muscle, and it's very important. I never done DDH case without cutting the iliopsoas tendon. It's very important to cut it, and because it's a block to your reduction. So I found it. It's inside the muscle. I used to. So in Egypt, you call it gallbladder, Dr. Mohamed. Okay, use a gallbladder forceps. So I used two of them. So I start to use them. They shoka وسكينة. Go inside the muscle, peel off the muscle, find the tendon, then get the gallbladder from the other side until you deliver the tendon out of the muscle. And I just cut the tendon. I tested to differentiate it from the femoral nerve with a little bit of Bovie touch to see if there is any jump, and then I cut it completely. Usually it's intramuscular and it's a glistening tendon. You guys know the tendon and you can differentiate it from the nerve. Femoral nerve is more superficial, and the psoas is more deep and lying on the capsule, so you can feel it. Excellent. Perfect. So we're going to the next step. With once I cut the iliopsoas tendon, it gives me a huge room to go inferior and medial. Make sure you continue dissecting around the capsule as far inferior and as far medial. And if you look at the picture here, will be at this area. So focus on this area. The capsule usually is hanging around there. So keep cleaning and at the top of the capsule all the way down. And you make separation of the capsule. I use the cob also to separate it from the abductors at the top. And I go a little bit all over the top, but not too much posterior, so it won't affect the blood supply. So I go all the way there. And for the capsulotomy, I do the T capsulotomy. So first cut is vertical. So here's a femoral head. It's larger than what we see in the X-ray because there's a lot of cartilage on top of it. So I can just mark it here. But be careful when you start your first incision. You ask your assistant to do flexion. So the femur head will go more posterior. So I do a snip with the knife to start to open the capsule. And to remember, capsule is very thick, so don't injure the femur head. And once I do the snip, I bought a Kelly or Howard or septum or whatever you call it under the capsule, so it can protect the femur head. And I go all around with the knife, so it can make a straight cut here. So straight cut all the way inferior, medial, and almost all the way superior. Then the transverse cut is parallel to the femur neck. So I do the transverse cut, start from here and do the transverse cut. It will stop you the intertrochlear or the intertrochanteric notch will stop you. So it's going to be a very short T cut. What do you think about the tongue shape capsulotomy? Recently, there is a lot of new shapes of capsulotomy, tongue shape, rectangular shape, doing only one cut and get this over. I'm still with, McDonald retractor is helpful. Yeah, we call it here septum, Dr. Ayman, or Howard's, but it's a McDonald. How can you determine the site of vertical limb of T capsulotomy? It's just to stay, I would say 1 centimeter lateral to the labrum, so you don't cut the labrum. Perfect. So now where we did the capsulotomy, which is a T, and we need to open the pelvis. So what will be the surprises when you open the pelvis? So first thing you will see is the femur head, intracapsular obstacles. So you see the femur head, and the first thing you will see is the ligamentum teres. So ligamentum teres hypertrophy, and also ligamentum teres is helpful to me because this is my guide to the true acetabulum, because here is a false acetabulum, so not to get confused. So I hold the ligamentum teres with a coker from here, from the head, and I cut it with a knife. Again, don't injure the femur head. And while holding it, I put my finger sliding parallel to it. This will be my guide to the true acetabulum. Then I use a long curved mayo to cut it very deep. So I go with the long curved mayo parallel to it until I go inside the acetabulum and I hit the bone. And with the curve, I cut the ligamentum teres. After we do this step, then we keep the hip dislocated, so we'll give you more view to the acetabulum. You can also use deeper right angles at the anterior acetabulum. Make sure you see everything and visualize it. Visualize the bulvinar fat, and once you see the bulvinar fat with the carisson or with a pituitary rongier, so we start to peel off the bulvinar fat very gently. Don't injure the cartilage, but just anything that comes easy in your hand, this is what you need to dig out. Excellent. We have very good questions, but I will just continue to go through the steps, and then we'll determine the redundancy. Dr. Noor mentioned that there is the transverse acetabular ligaments. Now I clean the ligamentum, hypertrophied ligamentum teres, and before that we cut the iliopsoas tendon, and I remove the bulvinar fat. Use the peanuts, gently look inside. Always remember this is a joint that has cartilage in, so don't like be rough inside. Just use the gentle stuff and save it for the future, because our main goal is not to make the X-ray look good, but also we need to protect the skid from having osteoarthritis in the future, so we're doing our best. And the transverse acetabular ligament is holding the acetabulum from the inferior part. So carefully with the McDonald retractor, go around it until you feel it, and that's usually very tight. And the McDonald retractor itself can protect you. So I go around it and from inferior hold the McDonald retractor. Once I make sure that I'm safe, I use the bulvinar fat, then I use the knife to cut on top of the McDonald retractor as a protector. After this, I will see how the reduction looks like. So we get the hip into the joint, and we know the deficiency is usually anterior and lateral. So most of these kids, the disease is, no, I never need to do a radial incision to the labrum, Dr. Ahmed. So we do the reduction and then assess the safe range of motion and or the safe zone of Ramsey, and we'll see how at what degrees the hip is going to dislocate, and the amount of adduction and also the amount of extension and flexion. If you feel the reduction is super tight or you're not able to reduce it, then this is the time that you open lateral approach and do the femur shortening. If we need to do this, always a question, what's the amount of femur shortening needed to be done? I go with the overlap technique. I know some people do pre-op planning, but I go with intraoperative decision. I bought a plate. I get a 4-hole small fragment plate, and I bought or 5-hole. So I bought 2 screws at the top, and I drill before cutting. And after I drill them, then I remove 1 screw, and I loosen the second one. I flip that plate at the top, and then we do the first cut. Then they get the overlap. We do the reduction. The amount of overlap was the reduction. This is the amount I need to cut. So it's usually a centimeter, maximum 2 centimeters in older kids. I don't excise the redundant capsule, Dr. Ali. No, I don't do colonna procedure, and I'm not sure if anyone is still doing it. So once I do the open reduction and I make sure there is no obstacles from anywhere that's blocking the reduction, and it's okay to get X-ray done, then I'm happy with this. Then I start to put my sutures for the capsularity. As I mentioned, I use something called Ortho cord, and I use number 2. So I pass the sutures. The first suture is very far inferomedial. I get a very good bite. Even feel free to bite the bone as well. This will be the most important suture for you. And if you imagine with me that you have a T capsules and you have a triangle of capsule here remaining. This tip of the triangle, I wish I have pictures. This tip is the one that you want to shift it down there. So you get this tip here to be shifted all the way down. And this is what Dr. Salter used to say, capsular shift. Or the capsularity is like capsular shift. This will tighten the whole thing to come more medial. So you get the superolateral to the inferomedial. And this is the main suture. Then we do another suture here to get above it, and a third suture there. I forgot to tell you, when I do the subperiosteal dissection laterally, I like to do with the cob, I peel off the capsule that's attached to the false acetabulum. This will help me for 2 things. Number 1, I found I have less patient need femur shortening. Number 2, I found it easy to find the entry for the cut for my pelvic osteotomy. And I use 1 suture, and that's me only, but you feel free not to use it. And that's a good answer for the redundant capsule. I'm not a big fan of excising the capsule, but I do a strong suture at the part that I remove the labrum from here down there. So I do 1 suture from proximal to distal at the end. So I use 4 sutures for the capsularity. In case when the head is double size, the acetabulum, what's the solution? So if the head is double size or large, which is it's quite uncommon, so there should be something happen. So either it's a revision, or patient had kind of AVN after closed reduction or something. So I'll go case by case. But and that's another good reason to do these cases as soon as possible. It makes a big difference. I'm very rarely faced a large head. So if you say large head reducible and it's concentrically reduced, then I will try to do a very good pelvic osteotomy to cover it, or shelf. If it's irreducible, then I do shelf or carry. Do you make release of abductor from capsule to prevent recurrence? So when I go with the cob to clean the capsule of the muscles and at the front, I also go a little bit superior or proximal to make a little bit of interval easily. I'm very sensitive to the abductors because abductors are super sensitive and they get weakness very quickly. So I don't do aggressive dissection, but if this is your primary surgeon, this patient hasn't done any surgery before, it's super easy to go through the interval gently, bluntly with peanuts or with cob. You guys are asking very good questions. It seems like most of the people are doing DDH a lot. So DDH are just too many steps. Every single step needs to be done perfectly, so we can get good outcomes for the future. And there are some steps you have to be very careful, especially going at the backward or posterior and the blood supply. And there are some other steps that you can go very quick. Perfect. Now I tried the open reduction and I reduce the hip and I do a picture with the X-ray. And then some people do the capsulorrhaphy now and then do the DEGA after. I prefer to do the DEGA first and then capsulorrhaphy for deficient posterior acetabulum. I would leave it to the next case. So we can, this is a pure DDH and the deficiency is anterolateral, but I have a case with posterior deficiency. I will show you right now, if you guys are still awake. So I did tried the open reduction, then I dislocated again. Some people argue, say, it's better to keep it reduced, so when you do the DEGA, it will reshape on top of the head of the femur and also will guide you for the limits. Sometimes I'm very aggressive with the DEGA to make it more horizontal. I'm fine with the dislocation. It gives me more freedom to do the DEGA and put the graft. And then, but I put the sutures first. So once I do the DEGA, I'm ready to do the reduction and do the capsulorrhaphy right away. So go to the next slide. When we do the DEGA osteotomy, so I go a centimeter above the edge of the acetabulum. Some people go a little bit more lower. I just, I will answer you, Dr. Ayman. So some people go a little bit lower, close to the acetabulum. Just be careful to go close to this edge because you have the secondary ossification centers here. And this might affect the remodeling. And that's why some people wonder why this patient, I did a very good DEGA and they had a recurrence and the acetabular index went back high. So just don't go too low. I used to go 5 millimeters above and you get nice, decent acetabular index. But recently I started to go a little bit higher. This gives me a little bit of kind of shelf at the top of the DEGA. So I get extra coverage in some cases. So go with the straight osteotome first. I wish I have the steps, but I go with the straight osteotome until the middle of the ilium. And I take it out. And then I go with the curved osteotome and I stop about 5 millimeters above the triradiate cartilage at this corner. So aim it to this corner. And you stop there. And because from the outer edge of the pelvis, not sure if you guys can see this. It's very wide. So the osteotome goes at the middle first.
دكتور وليد بيه، انا ممكن اكلم الشركه توقف الخلفيه بحيث ان حضرتك نقدر نشوف. ايه راي حضرتك؟
يا ريت.
دكتور مايكل حضرتك معانا؟
يس دكتور مع حضرتك.
ممكن نلغي الخلفيه بتاع دكتور وليد بيه عشان نشوف الهيب بون؟
هو دكتور وليد يقدر يعمل ده من عنده.
Screen.
مساء الخير دكتور وليد، مساء الخير دكتور محمد أشهب، شكرا جزيلا.
ازيك يا استاذنا؟ اهلا بيك يا فندم.
الله يخليك، سعداء بالمحاضره الجميله دي واليوم العلمي الرائع.
محمد ازي حضرتك؟
ازيك يا حبيبي، ربنا يديك الصحه، كل سنه وانتم طيبين. اقترح على حضرتك اسهل تخليها قدامك على صدرك لانك لبسك غامق فممكن تظهر. ايوه
اوكي
كده. اسهل
حتى لو عملت
كله ده واضح تماما.
يس سر.
شكرا دكتور محمد.
الله يخليكم.
هنا الاستابلر. When you do the osteotome, you need like the osteotome usually the half inch goes for 1/3. So I start at the middle third, and once I finish the cut, I use a little bit bigger osteotome, and I start to go more posterior to do the posterior part, and the posterior part has most of the bone, and that's very important. That's why I prefer DEGA, and that answers the question for Dr. Ayman. Even if you have, or Dr. Ahmed, if you have posterior deficiency, DEGA is very versatile. If you want to cover more posterior, cover more anterior, then I put the graft either anterior or posterior. I use Carrison, so I can cut the anterior part of the iliac crest and line with my DEGA cut. And I use the Carrison posteriorly. I make sure that I'm safe, subperiosteum, using your Homans, and I do a bite to cut the posterior edge at the sciatic node. So one bite at the top, one bite at the bottom, at the posterior part. And that's the difference between DEGA and San Diego. And people doing San Diego are doing this part to make it a different technique. After you complete your cut, then I use the osteotome to stretch it slowly. I don't do Salter anymore, Dr. Ahmed. Although our neighbors in Sick Kids in Toronto, they still like to do Salter because this is his home. So I go with the osteotome, I go down. And then I replace it with the lamina spreader. There are too many types of the lamina spreader. Try to get the non-toothed lamina spreader so you won't crush the bone, and go very, very gently and be very careful. Then how to get the graft. So I use autograft from the pelvis. If I do femur shortening, I use the segment of the femur to use it as a graft, which will be very easy. But if I don't do shortening, I take the graft from the iliac crest. There are two ways to take the graft, either horizontal, like this, to get a triangle after you measure the distance that you need to do, or some people do it vertical, this way. And it's a very nice size of the graft. You measure the size, width, and depth from here, and also the length. So I use the intraoperative measuring tape. It comes in our drapes anyway. So I have tape, white paper tape, so we can use it intraoperative. You hold it with a mosquito. Then I measure the graft and I mark with the saw, and then I do my V-cut. I like the vertical one because over time it doesn't cause deformity. And it's gonna be filled with bone. So cosmetically it's better. Although when you do the horizontal part, it's not bad idea as well, because after you move everything, you feel like the ACES is more prominent than before surgery. But anyways, it's not a controversial point. Once you get the graft, you put the graft inside and you fill it. And once you get a decent correction of the acetabular index. I kind of tend to get overcorrection a little bit for the acetabular index. Although I measure the index that needed from the normal hip, so I can try to match it. But if you go a little bit more, it's better. But not too much more, because there are some reports of subsidence of the grafts and can get crushed a little bit, so you lose it if you do too much tension. The graft is in, it's from the ileum, and I did X-ray for it's very hard with C-arm, but you try to match the acetabular index and make sure it's very stable. And after this, we do the capsulorrhaphy. So the same suture we did, the 3, I suture them tight. When I get to the edge of the capsule here, I try to slide it more medial. So don't try to slide things medial to lateral, because it won't, but slide things from lateral to medial. And this is what Dr. Salter initially mentioned as a capsular shift. DEGA start 1 centimeter proximal to IIS. So I start DEGA with a fluoro. So I go 1 centimeter above the proximal edge of the acetabulum. So I don't mark it with the IIS, but I think this is the start point of Pemberton. So start 1 centimeter from the AIS because it's more anterior. But DEGA, it's more lateral. So I mark it with a fluoro. Once I feel things are tight now, I'm very careful with the stability test after capsulorrhaphy because I don't want to weaken or loosen the knots I did. But once you do every step careful, you're fine. Unless it's very unstable, it's going to be very unstable. And if it's very unstable, I know some people put a pin. I hate it. Some people put the pin from the GT to supraacetabulum. I never had to do this. I hope not to do it until the end of my career, but it's one option. Another option, which is being mentioned, is to do a kind of tightrope in certain cases of Down syndrome or really unstable hips or in congenital short femur. Then you wash and irrigate. I use normal saline for wash. I use 1 liter of irrigation, and then I start closure. I start with the apophysis, get the apophysis back, make sure it's matching nicely. Start from the anterior superior iliac spine. Some people use a towel clip to bring it together and do your sutures. Use number 1 vicryl to close it and make sure it's matching, not inverted, not externally rotated, because this is a growth plate and this is apophysis and this needs to grow. And there are some reports that causes deformity in the future for the pelvis, especially a new paper came from San Diego recently as a long term, but it's cosmetic mainly. One of the other cosmetic things that I would advise you not to do is to do the incision at the iliac crest itself. It causes very bad scar, and you see how deep it is going down, and the people will hate this. Once I close the apophysis, then I start to close the abdominis obliquus muscle. So get the deep layer to the muscle as far lateral, close to the abductor, and then I get the fascia also separately. Just try to avoid any hernia that happen from this defect. After that, I will get the straight head of the rectus tendon to be the one that I reflected. Then I suture it back. Doesn't have to be super tight, and then you suture it back to the origin or the small part that you mark. But as I mentioned at the beginning, I mark both ends, and then you get a careful couple of sutures at the interval that you did for the fascia. Don't do it super tight because you might not see the lateral cutaneous nerve of the thigh, and then you do some impingement with your suture. Then I use 2 ovicral for the subcutaneous tissue, and I use 3 omonocral subcuticular closure. We use monocral subcuticular closure for all children up to the age of 18. And then I leave the tails out. Some people do not, which is fine. Use the steer strips and then sterile dressing. I keep holding the hips. I don't let go. And then I get a picture before we take the drape off. I'm the person who will keep holding the hips. My fellows and residents will take the drape off gently, and also making sure we're safe, taking the Foley off. And this step has to be very careful with it. And then get the spica table underneath. You lift the patient with them, get the spica table under, let the anesthesia guide this and lead this and count when you lift the patient up, so you can take care of the tube. Then once I get the hip spica up, if you have a cast technician will help you, or your fellow is very good, then they will do the cast for you. Spica cast done. Salter said 30, 30, 30, 30 abduction, 30 flexion, and 30 internal rotation. I do a little bit more, so I go to almost 60 degrees of flexion, and I go to about 30 degrees of abduction and 15 degrees of internal rotation. The reason I go with flexion more, because a lot of people here ask for the car seat and stuff, so I can make it easy for them, and I don't have any problem. Is it mandatory the fluoroscopy when do DEGA osteotomy? Yeah, I use fluoroscopy when I do DEGA, and I know some people try to do it percutaneously. I try to avoid injuring the triradiate cartilage, and it's good also to get your entrance point and mark it. So I use the fluoro for it. We applied the spica. And so good padding, I do 1.5, so I don't do bar between them. Some people do. I go as high to the nipples, and I keep the spica on for 6 weeks. I see the patient in 2 weeks, get x-ray through the cast, and then in 6 weeks, we take the spica off. I have a ready abduction brace at the clinic, so I apply the abduction brace right away because they cry, scream because of the stiffness once we take the spica off. And I keep it for 23 hours for about 2 weeks until they feel better. And then they start walking. I delay physiotherapy for about 3 weeks until they're comfortable. And physiotherapy mostly is hydrotherapy to get the range of motion and avoid the stiffness. In certain cases, when I feel that they're very unstable, I use the abduction brace at night for 6 months. If they're fine, I don't use anything afterwards. I don't do the A-frame after with the cast and or the broomsticks cast afterwards, because I found it causes more troubles more than the benefits. And I prefer if we get flexible, more range of motion of the hips than stiff hips. Also, one of the disadvantages of the A-frame and the broomstick cast, it causes weak supracondylar. So when they go to physio and start range of motion of the knee, they come back to you with a supracondylar femur fracture. Most of the cases we faced excessive femur anteversion. So for femur osteotomy, I don't think so. Most of the kids already have femur anteversion at this age, and we call it physiologic femur anteversion. So it's either the length or not. The cases I do derotation osteotomy usually are recurrent and revision cases, and they get excessive femur anteversion that stays usually above the age of 8. And it causes significant discomfort and sometimes anterior labral tear. So these are the cases I do derotation. There is the X-ray of the patient at 5 months post-operative, which has a lot of constipation. Any questions?
Professor Waleed, after such cases, you don't get some form of femoroacetabular impingement in the older age?
In these cases, usually not, because they get remodeling and here's the sourcilius top there. But in some cases, I found the cases that get femoroacetabular impingement who are mostly Berthies cases that had Salter. So they do excessive Salter in older age, and then they get acetabular impingement. Or if you do, like, as I mentioned, sometimes I do DEGA plus a little bit of shelf. So if I go too much with the shelf, it might cause impingement. But it's very rare with the young kids. They remodel. They have a very good time with very powerful remodeling. But yes, for the older kids, I would say be careful for kids above age of 6. Thank you, Dr. Ayman. You guys are experts. What about of percentage of AVN? So AVN reports are very variable because there are different degrees. So if we think about the bad AVN, type 4 are very rare. The most common is type 1, which is something very small. Most of the kids you see over time, their femur head becomes bigger over time and larger. The worst one, in my opinion, is type 2 because they get stop of growth laterally and they keep growing medially and causes caput valga and they get dislocation at the age of 11. So keep following them. Type 3 is very rare. Type 4 is very rare. And I think if we have type 4 a lot, we have to revise our technique and we need to be more gentle because it can be iatrogenic. There is a debate, is it AVN or is it growth issues? So Dr. Salter, the classification came from Kalamshi Salter in 1981, and Kalamshi was his fellow at the time, and he made the classification of type 1, 2, 3, 4, and there was a debate at the time that it's more growth issues more than AVN. Do you face post-reduction hip stiffness? I have very, very low percentage of hip stiffness, Dr. Ahmed, and that's why I'm saying 6 weeks is enough. Don't do cast more than 6 weeks. You feel like you get more stability, but stiffness is too bad. It causes limping, and it's very difficult for physiotherapy to deal with children, and also very difficult for kids to respond to stiffness for a long time. I believe, but I have no evidence that hip stiffness is something can be racial, because I see some sort of nationalities are more prone to stiffness more than the others. I feel like I see some nationalities are more prone to redundancy and laxity and hypermobility more. So I don't know if genetics can do some good work on this. Any other questions on DDH? So in summary, I do the surgery as soon as possible. If there's 6 months to 1 year, I do close the reduction arthrogram. And these are the kids. I take 1 shot of CT with our arm intraoperative just to with a very, very low dose, so can make sure that Shenton line is reduced anteriorly in the axial cut. And then these are the kids I keep the spica on for 3 months when I do close the reduction. I change it in 6 weeks. But I have low threshold to do open reduction pelvic osteotomy at the age of 1, starting from the age of 1. This might look too aggressive and compared to the other people, even here in Canada, but I still believe on this. What's the earliest age you can do pelvic ostomy? I just mentioned 1 year at the age of 12 months. They get pushed by the wait list anyways, but try to box them by 1 year. Does radiological irregularity at the superior edge acetabulum means something about prognosis? No, that's a very good question, Dr. Mohamed. So these irregularities in 5 months are expected. So things are not looking great in the first year, but this is normal to me. What about causes of reduction, failure, post-operative, and failure of remodeling? So that's another topic. So one of the things, try to get, when you do the DEGA osteotomy, try to do a little bit of overcorrection. Germans make it horizontal. Like the person who taught me DEGA was teaching me to go horizontal because he said the remodeling. Then I followed him for some time. Then I start to see when I go too much, then they get more subsidence. I found it's reasonable to get like reasonable acetabular index, and then I don't do too much stress on the graft and then remodel. Doesn't mean he's wrong, but this is what works with me. I feel happy when I see this edge. That means the center of growth, secondary ossification center, is working, and this is causing more remodeling. There is a lot of debate how to measure the acetabular index. Is it to the sourcil or to the tip? And I was a reviewer for a study recently, and I was happy that they provided evidence that the tip is more accurate than the sourcil, especially at this age for the acetabular index. You get these irregularities. These are from the graft because the cut started from here and you opened, and this is a graft. So usually this remodels. You see some irregularity from the graft itself. This is the one that the study came out, said some people complain from some growth disturbance, and it's mainly cosmetic. So that's why people want to change splitting the apophysis and go from lateral and get the apophysis as one piece. They found this less cosmetically causes a problem in the future. And also some people recommend getting the V more vertical than horizontal. But again, these are not functional issues. I've seen a couple of kids get myositis ossificans around the graft. But again, once you're careful for the abductors, treat the abductors with a big respect because the abductors are super sensitive and can cause significant functional abnormality. So ideal acetabular index, there is a table with matching with the age. So it's under the age of 1, it's under 30, and by 24, it has to be 24 months. It has to be 24, and it keeps going down over time. Intraoperative, preoperative decision to do femur or pelvic osteotomy. I always do pelvic osteotomy, and the femur osteotomy, I do it only if the reduction is impossible or it's after reduction it's very tight. Which one is more important determinant of the need of femur osteotomy? Upward migration or femur anteversion? The upward migration, Dr. Bassem. Don't worry about the femur anteversion. How much a Degas osteotomy can decrease acetabular index? It can get it down to about 25, sometimes 30 degrees. Perfect. So are we good to move to the next case? So this patient is 12 years old. She is a cerebral palsy GMFCS level 2. She's very functioning. She's walking. She did SDR surgery before, selective dorsal rhizotomy, and that made her function amazing. She less spasticity in the lower extremity, although she came with the right hip pain. So how you guys approach this case? Really open reduction. Pelvic osteotomy, walker, yes, GMFCS level 2. She's ambulatory. Why in little bit of cases show failure of remodeling many years postoperative, like subluxation or coxa magna? Coxa magna can be AVN, and subluxation, this can be lack of intraoperative judgment, or if it's early postoperative, it can be due to confusion of the follow-up X-rays and examination. So back to this case, coxa valga, VDR over plus shelf, adductor tenotomy, pelvic osteotomy, varus osteotomy with DEGA, right side, CT scan first, triple osteotomy, coxa valga. Yeah, there is coxa valga, Dr. Ahmed. So in CP, these are the cases we do VDRO. These are the cases we treat the anteversion and also the valgus. But can you imagine here if I do varus, this will be enough for this acetabulum? As some mentioned that pelvic osteotomy. So adductor, iliopsoas, STO. So yeah, I took the patient to the OR, patient sleep. Actually, unfortunately, this patient, I took her in December, and when she sleep, she had bronchospasm, anesthesia was very concerned, and then we canceled surgery. And then we did the surgery 2 weeks ago. Typically for these kids, they have posterior acetabular deficiencies. They have significant coxa valga, but this kid is ambulatory. So I usually go aggressive with the varus osteotomy, get them down to 100 or 90 degrees of varus, but not in this one, because if I do significant varus in her case, she might not be able to walk. So adductor tenotomy, and in these cases I do it open because they're CP. And because she's ambulatory, I only do the adductor longus. I avoid the adductor brevis, so she can continue in a good function. Thanks, Dr. Abdullah. So yeah, that's excellent. There is retroversion and acetabular posterior deficiency. So after you do the adductor tenotomy, and sometimes the gracilis are tight as well, but I try to do the minimum for adductor release in ambulatory kids if she's a walker. Then we did the varus osteotomy. Before you do the varus osteotomy, I did the range of motion under fluoro to see what amount of abduction I need to do to get enough coverage. And I do a little bit less than what I see because she's ambulatory. So always keep in mind that she's ambulatory. Even for the psoas release, don't do it from the distal part, do it from the pelvic brim because she needs some flexion for the function. Subtrochondric varus derotation, and triple or PO. Excellent, Dr. Ayman. And this is what I thought of doing triple or PO because her triradiate cartilage is closed. So DEGA might not work. Some people say DEGA works in CP because their bone is soft, and then you can do hinge on itself, even with the triradiate closed. But it seems to be very mature. So triple or PAO or Gonzo osteotomy would be ideal for me to get this coverage. But the primary disease in these cases, actually not the acetabular. The acetabular dysplasia here is secondary, but it compares this to the first case. The primary pathology in the first case is pelvis, the acetabulum. The primary disease in these cases is the femur. So if you want to start with something and the anesthesia stops you because of any complication risk, start with the femur. So you did something to this patient. So I did the intraoperative fluoro. This is amount of abduction. So I was able to get to 30 degrees abduction to get a decent coverage, but you see the acetabular index is very shallow and it's almost vertical. It's about 70 degrees. So I started with the VDRO. So I did the same angle as I measured. I did about 20 degrees of varus. So I didn't go all the way to 30 degrees. And I did derotation as well. And when you do the derotation, there are too many techniques. I'm not a big fan of CT to measure the amount of anteversion, retroversion, or whatever. But I go clinically. So after I put the screws, I make sure I put these screws at the normal anteversion angle. And then I put the screwdrivers on it, and I measure the angle of the screwdriver to the femur condyles. So this will be the amount of anteversion I needed. But at the end, I want to make the patella facing the ceiling, not internal rotated. Primary pathology of CP patient is a muscle imbalance. Thank you. And then after that, I felt like this patient needs pelvic osteotomy, and I feel like DEGA wouldn't be working in this case because there is no triradiate cartilage open, so there is nothing to hinge on. So triple is a good option, and Gons is a good option. I felt like Gons is better because it keeps the posterior column intact, so it's good for the stability. So with the Gons osteotomy, it's simply 4 cuts. So when you guys ask me if I do Salter, so part of Gons.
دكتور وليد. لا سوري يا فندم. دكتور وليد الشحن بتاع اللابتوب خلص، بس بيجيب الشاحن ثواني يا فندم. He will recharge his laptop. Just 2 minutes. Dr. Fadl, just 1 minute. Dr. Waleed is bringing his charger. واحنا بعد ما نخلص ان شاء الله محاضره الدكتور وليد، يعني بناء على رغبه بعض الزملاء ان احنا هنعيد الورك شوب بتاع الدكتور جمال حسني. We will replay it again. كان في technical problems فيه. We will play it again.
So sorry again for what happened.
Thank you, sir.
صح كان يظهر على الآخر وأنا I didn't notice. So if you guys want to continue, so this is what we did. So was a PO, and as you know, PO simply is kind of modified triple. So we do the first cut at the superior periprocremus. Second cut is actually half cut at the ischium, very proximal, and we directed more proximal but incomplete. And then the third cut is kind of incomplete Salter. We stop 1 centimeter just more superficial to the iliac brim. And then the fourth cut is connecting the ilium to the ischial cut, maintaining the posterior column intact. Just to summarize, pelvic osteotomies can be redirectional osteotomies, or reshaping osteotomies, or salvage or augmentation osteotomies. So if you have a case that you can get a concentric reduction and the hip can be inside the joint, so we can do redirectional or reshaping osteotomies. But if the case is irreducible, this is the time we do salvage, and salvage can be either shelf or carry osteotomies. A little bit about Salter osteotomy. Salter osteotomy, as I mentioned, I don't do it anymore, but it's still a good osteotomy, and it's a valid osteotomy. What you do is the same approach as we did for the first case, but you use a jiggly saw, so you can do a complete cut. People say between the ACIS and AIIS, or a centimeter and a half above the AIIS. And then you do the anterolateral coverage by moving this distal piece down. Hinge is the symphysis, and it can give you about 10 to 15 degrees. Dr. Sorter said he was able to get to 20 degrees, and then you have to fix it with pins. Make sure you're not interarticular, and when you fix with the pins, you probably need to remove the pins at certain time. Here's the graft, and he's taking it from the iliac crest as we did in the first case. Here's an example of bilateral Salter. It looks nice, and there is a nice remodeling. Triple osteotomy went through different stages. So when Salter is the redirectional osteotomy, it depends on the symphysis. But if the kids get older and you're not able to get a hinge, because this hinge starts to be stiff by the age of 8. So it's very hard to get a good coverage by only Salter. People did double osteotomy and didn't work. And then they talk about the triple osteotomy. Still did the first triple osteotomy, but he did the ischial cut very medial. And then he found that there is some limitation to get coverage. And then Lucour did the second one a little bit proximal for the ischial cut. Although it's interesting, the superior periprocremus one usually is the same. And then Tunis from Germany, which is an interesting name. His name is Tunis, but he's not Arabic. So he did the proximal cut, very proximal, and he got the best coverage. And when he got this coverage, the reason was because of the ischospinal ligament was here. So people used to do the osteotomy distal to the ischospinal ligament, and then this ligament is super tight. So it affected the correction. So you were not able to do it. Tunis was a good friend with Gans, and Gans from Switzerland, Tunis from Germany. They used to do a lot of cadaveric labs, and Gans thought about the Gans or PO osteotomy by saying, oh, how about if we do this incomplete and do this incomplete and connect both of them and get this rectangle out. And this is how it came out with the Gans osteotomy. So the Gans osteotomy is so you do one like Salter, but you stop above the pelvic brim, and one pubic ramus cut, similar to the triple. and one incomplete ischial cut, and then you connect both of them, the iliac to the ischial cut with a vertical one. So once you do these cuts, you have a free segment. But if you notice here, you have this free segment that covers the head of the femur, but the posterior column is intact, and that's the advantage. So these people have more stable, see the posterior column intact, so they have more stable osteotomy compared to triple osteotomy. Another advantage of Gans osteotomy compared to triple is it's very hard with the triple to manage the retroversion of the acetabulum, but it's much easier with the Gans, and Gans is very powerful. So when we do the correction, we use pins here, threaded pins, to do internal rotation first before I get the lateral and anterior posterior coverage based on what's the case I have. In CP, I do more posterior coverage, and it's very, very malleable in your hand. It's very good, versatile osteotomy, although it needs some sort of training. Approach with this, I did a bikini approach similar to the first case, and I did rectus sparing technique, so I don't remove or peel off the rectus. And I didn't open the capsule, so that was not open reduction. And to reach to the ischial cut, to use the Gans osteotome, you make sure you go to the inferior part of the capsule. It's a soft spot. I go inside with the cob until I hit the bone. I confirm with the fluoro, and Switzerland, they say they don't use fluoro. I found it very complex to me if I don't. So I use the fluoro. I get the ischium incomplete cut with the Gans osteotome. You do the cut posterior and then middle and then anterior. When you do posterior, you're so close to the sciatic nerve. There is a high chance to get a sciatic nerve injury. So you make sure you do it in extension. When you come anterior, you're close to the femoral nerve. So make sure you do it in flexion to relax the femoral nerve. When you do the iliac cut with superior pubicularis, the superior pubicularis cut, you feel like it's the safest one. The obturator nerve is at risk, and also the corona mortis is here, so it's very risky and needs a long training. So I use a saw to do this cut, which is a vertical incomplete cut, and then another Gans osteotome. I use it for the vertical cut. I use a fluoro oblique in about 55 degrees. That shows me the true pelvic brim and the pelvis from the inside. Here is other pictures of the Gans osteotomy, and see how it is very powerful and gives you a lot of coverage. Here's a approach, iliacus muscle, and iliocapsularis around the capsule. This is what we talk about at the beginning. Gans osteotome used anteriorly, and this is the one for the ischial cut, and this is infromedial to the capsule. Then I use the saw to do the Salter cut, if you want to name it, incomplete Salter. So use the saw. Then another osteotome to make it vertical. This is a very perfect view, and this is a cut we did initially. And superior pubicularis cut is you do it through the same approach. So I do all from the same incision, as a bikini incision, and I do the rectus sparing. So I keep the rectus and I keep the sartorius. So I do a little bit of ACES, get a little bit of the anterior superior spine chip of bone, then I repair it again. Be careful with this part because you can get inguinal ligament and you can get inguinal hernia. Here is a triple osteotomy, which is, if you do Gans, it's easy to do triple. So instead of doing the incomplete cut, you do complete Salter, and you do complete superior pubicularis, and you do complete ischial cut, and then this whole piece is freed for you to get the coverage.
No, we're talking about laser. Is that it?
Pemberton osteotomy, as someone asked me, so said the entrance is above the anterior inferior iliac spine. So anterior inferior iliac spine 1 centimeter above. And this is the one that you probably can do it without fluoro, but I do with the fluoro. So you start your cut from the anterior part of the acetabulum, and you cut the anterior table, the inner table, sorry, and the outer table, and you stop above the triradiate cartilage by about 5 millimeters. I try to stop even more. There are some reports saying when you stop close and you do extensive Pemberton, and then you can get a risk of facial closure. And if you get facial closure, it can cause different dysplasia in the future. And these are the cases you might see a larger head in a smaller acetabulum, as I get the question from Dr. Iman. Patient position for guns. It's the same supine position with the pump underneath. In case of hip dislocation, CP dislocation, you need to open reduction like DDH. So most of the cases in CP, you don't need to do open reduction. You just do VDRO first. Is do examination under anesthesia. You do the soft tissue, and most of them don't need open reduction. If you see your reduction after VDRO is not optimum, it's okay to do arthrogram, and a few cases needs open reduction, but it's not the standard. Then the advantage of Pemberton is you can get anterior coverage. It's already in the same plane of the anterior. Your hinge is the triradiate cartilage, so you need young kids to do it. So you can get a hinge, a soft hinge, and then you get the graft again and apply the graft inside. You don't need bends for the Pemberton osteotomy, but in this demonstration, it shows bends, but you don't have to because it's a very stable osteotomy, similar to DEGA. DEGA osteotomy or San Diego or whatever you call it, Paley modification of DEGA, it's all DEGA osteotomy. It's all the same, and this is what we described in the first case. So here's a patient position, and you do the DEGA. I start with straight osteotome. I start a little bit higher than this demonstration because as I mentioned, I get better coverage. And but Professor Elashhab mentioned a very good point that try not to get over coverage so you can face femoroacetabular impingement in the future. So you do your cut curved, make it parallel to the acetabulum. I stop 5 millimeters above the triradiate cartilage, and then with the osteotome I bring it down there. And if you see from the side, and that's a difference. So you cut only the outer table, not the outer and inner, but you cut the outer and inner at the top and at the posterior. So anterior and posterior was the Carrison number 3, the one that the spine people use. And this will make it San Diego. If you don't cut anterior or posterior, this is it, simply DEGA. So there is no big difference. With Paley, he did extension of this more posterior, so he made this more vertical. So he thinks that he can get more posterior coverage, a true posterior coverage, and he named it Paley modification of DEGA. And so we get the cut, oblique cut. It's beautiful to do DEGA because it makes a acetabulum looks curved, so it looks like a socket. Compared to Salter, when you do Salter at the beginning, it doesn't look as nice, but Salter remodels at the end and it looks nice at the end. Then once you do this opening, you measure for the graft, you measure the width, depth, and length, and then you cut the graft from the ilium. And you put the graft in. You have the chance to put more graft anterior, more graft posterior based on the case. That's why I said I'm old enough now. I want to stick to one technique that fits DDH and CP and everything. So I found DEGA is the one. So what's the difference between DEGA and Pemberton? So the difference is Dega is only outer table, and Pemberton is outer and inner table. So it's only the trajectory and the direction of the cut. So Dega you start lateral, and Pemberton you start anterior. Inner and outer table incompletely. Dega you only cut the outer table, and you don't cut the inner table. With advantage, Pemberton only gives you anterior coverage, doesn't give you posterior coverage. Dega can give you both because your cut is coming from the horizontal direction. Again, so redirectional is like Salter, triple, and guns. Reshaping is anything hinges on the triradiate cartilage, and there is a lot of argument about reshaping decreases the size or the volume or increases the volume. We think this is decreases the acetabular volume, although there is a study published in JPO 2006 from Turkey saying that volume actually increased with Dega, but it's based on less than 10 cases. So it's there is no much power in the study, but again, it's a very interesting finding. But I found this very academic discussion from the clinical experience. They're doing excellent with Dega or any kind of osteotomy. If I want to focus on one thing in DDH, I focus on the open reduction. The type of osteotomy is not my main concern. If I want to focus on one thing on CP, I will focus on VDRO, varus derotation osteotomy of the femur. This is the main one. Then the salvage or augmentation osteotomies, I think it's too late to talk about this. I think we talk about the most important two topics and the most common two topics of reshaping and the redirectional today. For CP cases, did you do hip spica? I don't do hip spica and CP because they have a lot of complications with the spica. So I either use the A-frame, and recently I use the abduction pillow. How you hold the graft in Dega osteotomy in its position. The graft is very stable, so you don't need bends because it's incomplete cut. So they hinge on the graft and they hold it. If you're casting for how long and when you start with weight bearing, that's for DDH or Dega or CP. So I assume it's a DDH. So I cast a hip spica for 6 weeks, and I start weight bearing when the kids decide. So anytime, usually after 2 weeks. In CP, I don't do cast. So weight bearing usually at 6 weeks when I see radiological signs of healing.
حضرتك فكرتني يا دكتور وليد دي اول ايبوس حضرته من حوالي، اعتقد دكتور فاضل بيه كان معانا من حوالي 17 او 18 سنه، كان في سورنتو في ايطالي، وكان الورك شوب الاساسي فيه كان على ديجا اوستيوتومي.
ان شاء الله.
هي طبعا دي باين لحضرتك مدى الاهميه بتاع ديجا اوستيوتومي. طبعا اتس فيري
مظبوط يا دكتور محمد.
فاكر يا استاذنا؟
لا، وكان في كمان لو تفتكروا انا عندي مازال كان في تقول مثلا ايه هاند اوت كان ممتاز جدا في كل التايبس بتاع الاوستيوتوميز.
بالظبط.
موجود عندي لسه فعلا.
ربنا يدي لحضرتك الصحه يا فندم.
لا موجود فعلا صح.
كان من حوالي 18 سنه يا فندم.
مظبوط. تمام. وعندي الصور بتاعتنا احنا والدكتور احمد معانا، احمد علام.
ربنا يبارك في سيادتك يا فندم.
الله يبارك فيك. ولا كان مؤتمر رائع. ولو تفتكر حضرتك برضو كان اول مره ينزل فيها الايت بليت نفسه ستيفنسون كان موجود نفسه وعمل الورك شوب بتاعه.
ان شاء الله. وحشتنا يا دكتور محمد.
الله يخليك دكتور حبيبي. الله يخليك يا حبيبي. مساعدة بالمحاضرة يعني بتاعتك الجميلة.
احنا يعني مش عارفين نقول لحضرتك الا جزاك الله خيرا يا دكتور وليد. والله
جزاكم الله خير محمد.
يعني ربنا يبارك في حضرتك. دايما محاضرات حضرتك ممتعة، اي حاجة حضرتك تعملها ممتعة، سواء كان محاضرات ورك شوبس اي حاجة الحمد لله يعني فيها كم من الاستفادة يعني نسال الله سبحانه وتعالى ان يجعلها في ميزان حسناتك يا دكتور وليد.
امين يا رب. I hope ان احنا
رغم اننا مش محترفين بيدياتريك يعني.
لا ازاي ده حضراتكم اساتذتنا
من باب العظام يعني. دكتور محمد فكرنا الميتنج بتاع الايبوس، فكان فعلا كان في فعلا حاجتين جداد في وقتها، وكان حاجتين فيهم اهتمام فعلا يعني.
هو يعني for بس the new staff or young fellows أهم حاجة في البيدياتريك is to be careful. Just be meticulous and be careful. Do the right thing. These are the cases ما ينفعش فيها استعجال. كل ما تدي more efforts to the patient, you get better outcomes. Over time, you feel like, I'm still doing DDH in 2 hours or 3 hours or 4 hours. It's okay as long as you're doing the right thing. And don't skip a step. You say, أنا عايز أخلص بدري النهاردة. أنا عايز. Never. Imagine this is your kid and you want to do a good job. This is the most important thing in pediatrics. It's easy to describe the techniques. It's easy to go through it. The other thing is the right indication. It's good to have a good protocol. في عندنا جروب في المنصورة في التأمين الصحي في المنصورة في صندوق دكتور خالد ودكتور إيهاب عثمان. بدأنا بروتوكول من سنة 2012 على الدي دي اتش، ماشيين على الديجا. They're doing amazing. خلاص once you focus on one technique. وانا صغير كنت اقعد انا عايز اعمل سولتر النهارده، بكره هعمل بيمبرتون، بعده هعمل ديجا. كل تفكيري ان انا عايز اجرب كل التكنيكس. بس think about the patient. Think what will benefit the patient. Since 2012 they have amazing results and less EVN, less growth issues. Because they focus, there's nothing new they added, but one system, make one system that fits and you'll be fine. We introduced morsure osteotomy in Mansoura التأمين الصحي. They did way better than what I'm doing. درجة عاملين morsure في osteogenesis imperfecta and the volume موجود في مصر، بس we need شوية system، شوية نظام and بروتوكول موحد نمشي عليه. حتى في الفولو اب، حتى في when you remove the cast, discuss, think. I'm very happy today with the questions. It means the people are working and thinking for the better care for their patient. And you might find some of what I'm saying today is only related to my practice, and because this is what I feel. I'm doing the best for my patient. But you might talk to someone else, says, no, I do different. That's fine. They might have better outcome with their way. But this is after I tried too many techniques, and I'm very happy with this. Thank you for your questions.
I think we have 2 questions.
TP any place for sharp procedure in DDH? Shared. I don't know shared procedure, Dr. Ahmed. I only remember shared textbook. واحنا بنسجل الدكتوراه قالوا لنا لازم تقروا شارد، بس ما قريتش منه. بس yeah, it might be something I do, but I'm not matching the name.
I think we have no more questions.
I think we're good.
Yes. Thank you so much, Professor. Yeah, we have one question.
GMFCS versus bilateral DDH, what you do? GMFC versus bilateral. I don't know what's the GMFC. It's GMFCS level, you mean? So GMFCS level 5 by CP, is that my understanding? Bilateral DDH? Okay, so yes, so GMFCS level 5 bilateral DDH, I try to do them as soon as possible if they get migration index 40% or above. If they're younger than 5 years, and they're less than 40%, I do guided growth with a screw. Transfer of oleosoas to the greater trochanter. Yes, Dr. Ahmed. I don't do it. I have seen it في الكتب في المذاكرة بس I've never done it. Selective rhizotomy is a good option. It's done by neurosurgery. In CP with DDH, no recumbent, non-ambulatory, do you think pelvic osteotomy to improve hygiene handling can be stable and beneficial? So yes. As I mentioned, the primary bone issue is the femur. So get the femur into the socket. This will prevent arthritis. Studies showing that arthritis and pain in the future is expected in more than 90%. They have horrible reaction to pain. We do have a team here is called the QALA team, the quality of life for end-stage salvage. It's horrible. It's a very horrible practice when they get into end-stage pain. Paralytic DDH is the same procedure. So it depends on what type of paralytic, but most of the neuromuscular primary bony issue comes from the femur, and usually the acetabulum is secondary because you're born normal or you're born with normal anatomy, and then over time the paralysis is the thing that causes secondary acetabular dysplasia. So most of them, I can't say all of them, but most of them, we start with the femur, usually you get coxa valga, and even with the non-spastic CP, I do even more virus for them because you don't know what the pathology is, what's the muscle imbalance. All their muscles are hypotonic, and the hypotonic CP, I do more virus. And they might benefit from shared procedure, but I have no experience with it. I used to read about it from textbook بالقصر العيني دكتور بدير او دكتور كان في كتاب القرص دكتور
صالح بدير يا فندم.
صالح بدير دكتور صالح بدير. كنت اقرا all this muscle transfer and اساتذتنا طبعا اللي عملوا حالات كتير للبوليو. before the polio كان في كل الحالات السوتر والشارد والياونت these old techniques that people don't do anymore, although I believe we missed this chance and opportunity to learn these techniques because they were amazing and studying biomechanics and studying all these things. عشان كده اتعمل معهد شلل الأطفال في إمبابة, and until now they have amazing professors understanding the pediatric orthopedics more than anyone else.
I think we come to the end, Professor Waleed. Thank you so much, and hoping to see you again and again and again.
Thanks so much, Dr. Mohamed, and it's always my pleasure.
It's an honor for us, sir. Thank you so much, sir.
Thank you.
جزاك الله خير يا فندم.
نشوفك على خير ان شاء الله حبيبي.
نشوفك على خير دكتور محمد. السلام عليكم.
احنا بنستاذن حضراتكم وعليكم السلام طبعا كده. جزاكم الله كل خير يا فندم. احنا هنعرض مره ثانيه التسجيل بتاع الدكتور جمال حسني الورك شوب اوف external fixation and proximal femoral fractures. كان في some technical problems لا اي حد حب يشوفه لان هو في العديد من الزملاء طلبوا انه يعاد ثاني. دكتور مايكل.
Yes, doctor, one second.
Can we prepare it, please, to be replayed?
Today, we are going to discuss the external fixation of the proximal femur, the tips and tricks. Why external fixation is not popular in proximal femoral fractures? Because of the stability. They always talk about the frames, which are quite unstable. Also, when we see the cases, you can have reduction, unstable reduction. Also, they always talk about standard external fixation. There is no standard external fixation. So I think the companies and some people, they design a frame and they want to fix all the fractures with this frame. And this is not applicable. And I will show you how to fix the proximal fractures. And we put the frame last, not first. So our technique is not frame first technique, because the problem comes if you apply the frame first. What are the indications of external fixation proximal femur? We can use it in proximal fractures, in open fractures, osteoporotic fractures, firearm injuries, infected fractures, infected non-union, and these are examples. You can use it not only as a temporary fixator, but you can use it as a definitive fixator. Like this case of trochanteric and subtrochanteric fracture. And the other case, we have a fractured trochanteric fracture after fixation with external fixator. Also, we can use the closed reduction techniques in fractures. I'm going to explain them during the workshop by putting the wires, doing pulling or moving the fragments like this case. And this is an example of the closed reduction technique of this method using serrated wires, half pins in different directions. Also infected fractures. If you have failure of internal fixation, like this case, you have failure of DCS, you can apply external fixator in the direction of the neck. Infected non-union, same. The methods of fixation of the proximal femur. Wire or half pin application first. We put wires or half pins first. The methods of fixation, number one, serrated wires, chance pins, cannulated chance pins, Elashhab wires, joint bridging. And these are the example of the serrated wires. We push the serrated wires in the direction of the neck till they hold the subchondral bone. Multiple wires, 2, 3, or 4 millimeters. And here also the same method, 2 chance screws. You can use chance pins in this way, in the direction of DCS. And this is an example, chance pins. You don't have to have them parallel, because this patient had external fixator before. And this is another method of fixation by half pins. This is a cannulated chance pin. You can put a wire in the direction of the head and neck, and then you put cannulated wire. And also you can have Elashhab wires from the front to posterior in severe osteoporosis. You can palpate the anterior sphenic spine, and remember that the vessels lies 2 centimeters medial to the anterior sphenic spines. So you go lateral and put your wires from anterior to posterior and take care of the sciatic nerve also in severe osteoporosis. Bridging fixator, you can do crossover. Like this patient, we have only 1 half pins in the direction of the neck, but this is not enough. So we did supraacetabular fixation, and we are going to discuss the supraacetabular fixation. Also, we can use the closed reduction techniques. You can do the closed reduction techniques. You don't need open reduction. So in each case, they say that you do open reduction, minimal invasive techniques. No, we don't need to do reduction because you can do closed reduction techniques. And this is an example, trochanteric fracture over the proximal half pin, 1 week after removal of the dislocated infected total knee prosthesis and debridement and temporary external fixator, but the patient had this trochanteric, subtrochanteric fractures. And severe osteoporosis and infection, and the patient is very fat. So remember that you can have the cantilever effect if you apply only half pins. So we have to use the subchondral bone for fixation. So we use the multiple threaded wires technique. And this is how to apply them under image intensifier. And this is the half pin. As you see here, we use multiple threaded wires in the direction of the neck and traction to close the gap. Then more wires and half pins in different directions to increase the stability, like this patient. And this is the picture after application of the frame. So we don't talk about the frame. You can use any frame you want. We talk about the fixation and the reduction. And this is the opposite to exactly what's going on in the literature. They always talk about the frame. We don't talk about the frame. We talk about the method of closed reduction. We talk about the methods of fixation. And this is with follow-up, as you see the follow-up, complete union of the trochanteric fracture. So in conclusion, Our technique is called frame loss technique. That means we apply the half pins, the wires, and finally we put the frame in the direction we want. And the closed reduction of fracture. It's a very important principle. If we talk about application of external fixation of the proximal femur, because we don't want to do open reduction, we want closed treatment. Now we finish the presentation, and we go now to the sawbone to show you how to apply it in the proximal femoral fractures in the sawbones. Thank you. Good afternoon, dear colleagues. Today I'm going to discuss how to fix the proximal femur by external fixation. The problem with fixation of the proximal femur, when you read the English literature, they always speak about the frame and how to have a fixed frame for each case. And this is the real problem. Because if you have a fixed frame, it's very difficult to fix the proximal femur. Today I'm going to discuss how to fix it in the opposite way. That means frame loss. We apply the frame as the last step of the operation because the frame is not that important. What's more important, how to fix the proximal femur, whether you have fracture neck femur, trochanteric fracture, subtrochanteric fracture, or you have non-union, infected non-union, malunion of the proximal femur, you can apply these principles in all these indications. I'm going to discuss 5 methods. It's not one method like they discussed you, that you have to have 2 half pins above and 2 half pins below in a fixed fixator or something like this. This is not true. This is not practical. I'm going to tell you the tips and tricks of the fixation of the proximal femur using 5 methods. The first method is the serrated wire method. You can use serrated wire, 2, 3, or 4 millimeters wire. We have serrations for about 1 centimeter near the tip of the wire. And this is the first method. And usually when you put the wires, we put them in the direction of the neck. You see, this is the direction of the neck. We can put 2, 3, 4, 5, 6 wires. And you can put them in the fracture neck femur, and after you put them, you pull the proximal segment and induce the reduction. The same you can do it for trochanteric fracture. The second method is using the half pins, like this one, solid half pins. And the solid half pins, you can use them in the direction of the head and neck, again, like you put the DHS or something like this. The third method is the use cannulated half pins. You can put a wire first under image intensifier, and you check it by the image in the anteroposterior and frog position, the lateral position, and then you apply the half pin in the same direction. The fourth method, you can use half pin in this vertical position, from the trochanter that way, like DCS. And you can use any combination together. So you can use serrated wires, half pins that direction, another pin this direction, and so on. The fifth method, sometimes you cannot have enough fixation on the proximal femur. You apply supraacetabular half pins. So we have 5 methods of fixation of the proximal femur. Then you apply the frame. You can apply Elazhab frame, you can apply any type of frames after you do the reductions. Which type of tables you use? You use a translucent table, but you don't need to have a traction table. You can use a traction table, but usually I don't need a traction table to do it. The first step is the first method using the serrated wires like this one. I will show you how to use it. This is the thin one. And you put it here in the subtrochanteric area. And you take the direction of the neck. You see, this is the direction. Move it. Put another one. This is one of them. When do you stop? I usually stop at the subchondral bone. Remember, some patients with trochanteric fractures or neck fracture, neck femur, they have very osteoporotic bone. So you have to go till you catch with the serrations like this one. You see, this is the second one. You take the anteversion. You can use image intensifier. This is the second one. Third one. This is 2 millimeters wires. We use a third one, and you use a third. You need stability, so you need more and more stability. Again, this is, you see the third one. We can go below this, and you change the direction, and this is, so this is the third one. Now we are going to use 4 millimeters wire with the serrations like this one, and we go from, again, yes. So we have 1, 2, 3, 4 points of fixation. This can be enough. In many cases, if you have a neck femur, if you have, put a wire here. So this is the first method. The first method is to apply serrated wire technique, where the serrations stop in the subchondral bone. Now you can pull to induce compression. The second method is to use the half pins, the 6 millimeter half pin. How to use the half pins? Again, under image intensifier, you can put wire, and with the 6 millimeters half pin, you can put the half pin in the direction of the head and neck. Again, yes, this is the first one. And we can use a second one. So you can have 2 half pins in the direction of the neck. You can have more if you want to. The neck is wide, you can have more. So this is the second one. So the second method is to apply 2 Shan's screws. The third method, you can put one of these wires like ditches, then you introduce the cannulated half pin. The fourth method, we are going to use the Shan's screws or the half pins in the direction of the DCS, like this. So it's about 90 degrees. Yes. Why we use it that way? Because sometimes you need to have more proximal fixation, because there is a problem with this area, because the patient has, you have removed external fixator before, so the patient has many holes here. So this area is very difficult, and perhaps you are going to have subtrochanteric fracture. So you need to have very proximal fixation. So you can apply it in that direction. How to apply the half pin in that direction? First, you introduce a wire in front of the bone, as you feel it, just in front of the bone, under the image intensifier. And now it's in front of the bone. We leave it just like this. This is in front of the bone. Give me now with the drill bit. We go the same direction like the drill bit in the middle of the trochanter, like this one. We'll go through the middle of the trochanter, and we go with the drill bit in the same direction. And this way, you can change the angle of anteversion. We knew the angle of anteversion from this wire, the superficial wire, so it's about 15 degrees Yes, so you can move it up and down to correct the anteversion. Then you go with the drill bit. You see, you went through the bone. Then we remove it. Then manually you introduce your Schanze screw. Take care that sometimes it's a very soft bone. So it's better to avoid too much heat. So we go manually, bit by bit. You see, it's okay. You see the whole length. Till we finish the serrations. Yes, we finished the serrations. Take care, you need long serrations. That means you need 6 centimeters, 6.5 centimeters, 7 centimeters. So you have a big length. It's longer than normal. So you need to have half pins with longer serrations. It's not just 3 or 4 or 5. If you manage to fix this in that direction, 90 degrees direction, or the direction of the neck, you can use both. In some cases, we used both of them. In some cases, we can use wires and this half pin and chin. And I will show you on the slides. You can make any mixture. As I've told you, you can have very good fixation of the proximal femur. Because the people, they always complain that it's very difficult to fix by external fixation the proximal femur, and they warn you from fixing the proximal femur if you have osteoporosis. This is not true. For every problem, you need a solution. Now, this is the fourth. I've told you the 4 methods of fixation: using the serrated wires till you reach the subchondral bone, using half pins in the direction of the neck, using cannulated half pins, using half pins in the direction of DCS, like this one, any combination. The 5th method, if you have rare problem of the proximal femur, you can add supraacetabular fixation. And I will show you how to fix the supraacetabular area. The supraacetabular area is very important. It's good, it's hard, it's easy to apply, and you just have an image, and you can put your half pins in this direction. So you can augment the fixation of the proximal femur by adding supraacetabular half pins. And I will show you